Is there an issue? It being 9 a.m, I declare open this meeting of the Senate Community Affairs Legislation Committee. I begin by acknowledging the traditional custodians of the land on which we meet today and pay my respects to their elders, past, present and emerging. I extend that respect to Aboriginal and Torres Strait Islander peoples here today. The committee is due to report to the Senate on Tuesday 29 November 2022 and it is fixed Friday 16 December 2022 as the date for the return of answers to questions taken on notice. The committee would appreciate if senators could provide any written questions on notice to the Secretariat by Friday 18 November 2022. The committee's proceedings today will begin with the health policy, access and support outcome of the health and aged care portfolio. Under Standing Order 26, the committee must take all evidence in public session. This includes answers to questions on notice. I remind all witnesses that in giving evidence to the committee, they are protected by parliamentary privilege. It is unlawful for anyone to threaten or disadvantage a witness on account of evidence given to a committee, and such action may be treated by the Senate as a contempt. It is also a contempt to give false or misleading evidence. The Senate has endorsed the following test of relevance of questions at estimates hearings. Any questions going to the operations or financial positions of the departments and agencies which are seeking funds in estimates are relevant questions for the purpose of estimates hearings. I remind officers that the Senate has resolved that there are no areas in connection with the expenditure of public funds where any person has a discretion to withhold details or explanations from the Parliament or its committees unless the Parliament has expressly provided otherwise. The Senate has resolved also that an officer of a department of the Commonwealth shall not be asked to give opinions on matters of policy and shall be given reasonable opportunity to refer questions asked of the officer to superior officers or to a minister. This resolution does not preclude questions asking for explanations of policies or factual questions about when and how policies were adopted. Witnesses are reminded of the Senate order specifying the process by which a claim of public interest immunity should be raised. I incorporate the public immunity statement into the Hansard. An officer called to answer a question for the first time should state their full name and the capacity in which they appear. We do have witnesses appearing via video conference today, and I remind committee members and witnesses who are appearing in this way, who are not speaking, to please mute your microphones many years into the pandemic. I now would like to welcome the Honourable Senator Malarndirri McCarthy, Assistant Minister for Indigenous Australians, Assistant Minister for Indigenous Health, representing the Minister for Health and Aged Care, the Honourable Mark Butler MP. Minister, do you have an opening statement for the committee?
Just want to say good morning, Chair, and also acknowledge the Ngunnawal and Ngambri peoples on whose country we come, and I pay my respects as well to their elders past and present.
Thank you, Senator McCarthy. I also welcome back to our committee Professor Brendan Murphy, the Secretary of the Department of Health and Aged Care. Dr Murphy, do you have an opening statement for the committee?
No, Chair, but we do have a little bit of information that we said we would report back to this committee from Tuesday night. So Mr Wanham and Mr Excel have got just some brief information to relay at the start. And the only other thing I would say, there are a lot of portfolio agency people in this outcome. Now, they're all very happy to wait around until their time, but if there's if any senator just has one question for one agency, that we'd be happy to accelerate that in the program if that suits, but otherwise we'll wait for their turn. But I might
Thank you, Professor Murphy. We will go to these colleagues. I just might, before we do that, if I can, just indicate how I intend to manage the program this morning. We do have a number of agencies which we are only seeing this morning. With the committee's agreement, I would like to work through those agencies first so that we can release them and then continue on with the outcome. So I intend to call APRA first. So whilst you're making those statements, if APRA wants to shuffle ahead. Thank you. Mr Wan.
Thank you, Chair. Charles Wan, Chief Operating Officer. There was a number of questions we said we'd try and come back to you today on with a bit more detail. First, in relation to terminations, we've examined the data of ongoing and non-ongoing staff for the period since 21 May 2022. In summary, there have been 20 staff terminated since 21 May 2022. 4 of these were non-ongoing staff, 16 were ongoing staff. For the non-ongoing staff, the reason for termination was the duties are no longer available. For example, the function was related to the pandemic response work. Most of the terminations of ongoing staff were actually voluntary redundancies. There were 10 of them. The remainder were performance-related or due to the staff member not having the ability to perform their duties because of physical or mental incapacity, or for failure to satisfy probation requirements. Senator, you also asked, Senator Ruston, you also asked in relation to contractors. Unfortunately, our systems don't enable us to report easily on contract terminations. It would take quite a lot of work to pull that together manually. We can look to do it, but we just have to see what's involved in trying to interrogate all the various systems to get that information.
Chair, what I'll do is I'll seek to try and define it down a little bit for you so that it's a little bit easier. While we're actually on this section, I have also got a couple of follow-up questions from some answers that were given on Tuesday night in this area. Do you want me to do them now?
I'm happy for you to do them now, and then we'll be moving to APRA.
Yep, sure. I was just wondering, in response to this line of questioning on Tuesday night, the department said that, to the best of your knowledge, you weren't aware of any, code of conduct complaints. To be really specific, have you received, and if so, how many, APS code of conduct that have been lodged by external stakeholders, say, for instance, by patient groups or the like, against departmental officials?
I believe, I think there was one external person, one external agency who claimed a code of conduct which is being investigated. Ms Belt, we can't really go into detail, but Ms Balmano might be able to provide some information on that. There certainly was one allegation of a code of conduct breach from an external party in relation to, I think, a funding arrangement. So I don't know whether Ms Balmano can come in.
Yeah, I'm not sure if it's Ms Balmano.
She is here.
Yeah. Well, I was going to say General Counsel.
Yeah. Oh, gosh.
Yeah, it's on
Sorry,
the
I
right.
can't touch the ground. No, it's not.
Just
On the right front?
on the right at the front.
Excellent.
Yeah, that's it. Yeah.
I can't touch the ground. Good morning, Rachel Balmano, First Assistant Secretary, People, Communication and Parliamentary Division. In terms of a code of conduct, only we can receive allegations or complaints from external parties, but that doesn't necessarily, and we look into those obviously, but in terms of the actual investigation of a code of conduct breach or the finding of a code of conduct breach, that happens within the department. So it's not a, they will allege certain behaviour and we will then investigate it against whether it be public interest disclosure or code of conduct or whatever we think it warrants.
So how many of those have been received?
There has been at least one. I would have to check if there's been any others.
Okay, well, if you could provide us with details of how many...
Certainly, yes.
I suppose complaints against officials that you have received
Okay.
from external...
Since
Yep.
over the last...
Look, if you could go back, I mean, it's pretty serious for somebody to make a complaint, and I'd also like to know if complaints were made with any findings made by the department
Certainly.
that would suggest... I'm somewhat more interested in whether the department actually found that the allegations were able to be substantiated and upheld, and then seek to know what the action of the department was in relation to that. And in investigating this, I mean, you're only talking about one, so clearly you'll be able to answer yes or no pretty easily on this one. Have you received a complaint in relation to the conduct of an official in your department who has either is currently in any of the minister's offices or was previously in any of the current minister's offices?
The one I have in mind, the answer is no. If there are others, I'd have to take that on notice.
Okay. Has the department engaged any external organisation to investigate any complaints?
Yes, we often engage external investigators to make sure that there is not a sense of bias within the organisation, with the organisation conducting its own investigation.
Has the department ever engaged Clayton Newts?
I would have to take that on notice.
If it'd be possible for us to get that back today, that would be great.
Certainly.
Yeah. So, does the department have any sort of conduct policy in terms of the department's expectation around how the officials of the department conduct themselves when they engage with external organisations?
Well, yes, in that we are bound by the Code of Conduct, the Australian Public Service Code of Conduct.
Okay, so I'm assuming that the department would take it particularly seriously, an allegation that came from an external
Definitely.
stakeholder?
Yes.
Okay, well, if we could get some information specifically back around that today, that would be
Okay.
really good. Thank you. Thank you very much, Chair.
Senator, we'll now be moving to...
Mr. One hasn't finished his,
sorry.
his feedback.
Sorry.
Senator Ruston wouldn't want to miss out on.
The Senator also asked about some major structural changes since the version of since the annual report. In summary, the major changes are the three COVID vaccine program divisions moved from the Operation COVID Shield Task Force and reduced to 2 divisions. The First Nations Health Division moved to Strategy, Evidence and Research Group. Previously, the Indigenous was the Indigenous Health Division under the Primary and Community Care Group. The Chief Nursing and Midwifery Officer moved to the Health Resourcing Group. And Cancer Hearing and Program Support Division was renamed Cancer Hearing and Chronic Conditions Division. And a Health Equity Branch was established as a new branch in Population Health Division. Senator, you also asked if we could confirm detail of the movements of funds, which would take, and we took that on notice and said we'd try and get back to you today. I can confirm that it was quite a large movement. 2.35 billion was moved into 22-23. The main contributors were, as we thought, 1.8 billion in program 1.8 related to national medical stockpile, vaccines and treatments. There was a second large but significantly smaller movement of 274 million in aged care, program 2.3 related to sector support. And then the next largest was significantly smaller, 23 million in mental health, program 1.2 related to emergency response supports. Yes, and I'd just like to clarify some evidence provided in relation to departmental staff seconded to ministerial officers. I can confirm there are no departmental staff backfilling roles in Minister Wells's office. And they're all the questions that I had. My colleague had one on international travel.
Blair Excel, Deputy Secretary, Strategy, Evidence and Research Group. The Senator asked a question about international travel. Mm-hmm. So, Assistant Minister for Mental Health and Suicide Prevention travelled to Italy via the UK for the World Health Organisation's Global Mental Health Summit. That was the 10th to the 17th of October. The Minister for Sport, Minister for Aged Care travelled to New Zealand 20th to the 23rd of October for the Australia-New Zealand Sports Law Association Conference and also participated in the FIFA Women's World Cup Australia-New Zealand 2023 official draw release. The Assistant Minister for Indigenous Australians and Assistant Minister for Indigenous Health travelled to Indonesia for the G20 Health Ministers meeting from the 26th to the 29th of October. And then in non-portfolio travel, the Assistant Minister for Indigenous Australians and Assistant Minister for Indigenous Health travelled to Fiji from the 12th to the 15th of October for the Pacific Women Leaders Governance Board meeting. That's it. Thank you, Senator.
Thank you. And are you
Thank you.
able to provide, also ask for the costs associated, but you don't have to do that now.
Yeah, I don't have the cost, but we can do that. Yeah.
Yeah, just provide that on notice, that's fine.
Thank you very much. I'm keen to move to APRA at the moment. We do have 2 senators with single blocks of question, which I'll seek to deal with first, and then I'll come to you, Senator Ruston, once we've cleared those. So we have Senator Urquhart has a quick few, and then Senator Antic. Then I'll be coming to Senator Ruston. If senators do have questions for APRA, could you let me know so we can dismiss them after now? Senator Urquhart, you have the call.
Right, thanks very much. Thank you. Look, I just got a few questions around a couple of subjects. So can you tell me what actions AHPRA has taken to ensure patient safety is a priority for cosmetic procedures? We've all seen a lot of stories about the disastrous outcomes. So can you tell me what actions you've taken to ensure the safety of patients?
Thank you, Senator, for your question. Martin Fletcher, Chief Executive Officer of the Australian Health Practitioner Regulation Agency. So, like you, Senator, we were deeply concerned about a number of the media reports some 12 months ago in relation to patients being harmed by cosmetic surgery, and I also want to acknowledge the bravery of the people who came forward to speak about their experience. In the wake of that media reporting, we commissioned an independent review led by Mr Andrew Brown, the former Health Ombudsman from Queensland.
Sorry, I'm just...
Could senators, just if they want to have conversations, just step away from the
just
table,
a little bit
please?
hard to hear with the conversations happening. Thank you.
That review reported and was published in full on the 1st of September this year. It made 16 recommendations to both AHPRA and the Medical Board of Australia for actions that we should take to address these patient safety issues in the cosmetic surgery industry, and we've accepted all of those recommendations. And we're also very pleased to get strong support from health ministers across Australia for that response as well.
Can you tell me what the timeline of the implementation of those recommendations is?
So essentially what we've done, Senator, is establish within AHPRA a cosmetic surgery enforcement unit, and we've put $4.5 million of our resourcing into that unit. And essentially what that is doing is really now spearheading all of our work in relation to the response to the recommendations. So, for example, we've established a cosmetic surgery hotline and are doing a lot of promotion with the community to make sure that people are telling us about their bad experiences, because one of the features of the industry is that bad things were happening and they weren't necessarily being raised with us. There is work underway on strengthening the guidelines around things like advertising, the expectations of medical practitioners, and they'll be going to public consultation this month with the expectation that they'll be finalised early next year. We've written to every doctor already in Australia, 133,000 medical practitioners, reminding of their obligations in relation to reporting any unsafe care that they see, so that we can look at whether we need to take action. And then there's also work underway through the Medical Board of Australia and the Australian Medical Council to develop an area of practice endorsement, and essentially what that will do is set a minimum standard in relation to training and qualifications, which would allow a medical practitioner who was doing cosmetic surgery to actually apply for and meet those requirements. That would then be on the public register, so that would help the public in terms of knowing people who have met certain minimum requirements. And again, that will ultimately need to be something approved by all health ministers in Australia through the Medical Board of Australia, and we expect to have that finalised for ministers' consideration early next year.
Right, great, okay. I was going to ask you about there's been criticism of the pace of response, to AHPRA. I think you've covered off on a lot of that, and hopefully that pace is now ramped up with all those things you've just talked about. Can I just very quickly, because I'm conscious of time, can you tell me what's the annual budget of AHPRA? If it's easier to take this on notice, I'm happy for you to do that, but if you have it there...
I'll quote from our 2021
Yep.
audited financial statements in our annual report, which will be tabled in the Parliament. Our expenditure in 2021 was $232 million.
And how many staff does it employ?
Our total FTE staff is 1,163.
And how many of those would be classified as senior staff?
I'd have to take that on notice, Senator.
And how many are currently dedicated to compliance activities?
When you say compliance, what do you mean by compliance?
Well, in terms of looking at how, I guess, the medical profession are dealing with the issues that you're responsible for.
Well, if we look at, say, our work on notifications, compliance, our legal services, our sort of frontline customer service response to queries, our registration work, and I should make the point this is across 16 regulated professions, that 67% of our staff are involved in that
And
work.
just a couple of really quick ones. Can you tell me what AFRA is doing to tackle the barriers in relation to migration? So I guess what role do the colleges play, such as the Royal College of General Practice, to assist with migration, and how could they assist to improve the process? And I'm talking obviously about GPs and other specialists coming from overseas.
So, Senator, you're talking about our work in relation to registration of health
Yes.
practitioners, essentially? Yeah.
Yes.
So, sorry, I'm just going to turn to the right page in my brief so I can give you the accurate numbers.
I guess I don't want just raw numbers. I also want to know what things you're doing to tackle the barriers that are there in relation to people migrating.
Senator, just while Mr Fletcher's finding his page, we should point out that the barriers are much broader than just APRA.
Absolutely, I
and
understand
we
that.
have a task force
Yeah.
under the direction of Health Ministers working on all of those barriers, visas and all the like. But APRA
Yeah,
is
no, I
APRA is an
understand
important
that,
part.
Professor
Yeah.
Murphy. I guess I'm interested in what AFRA's role is in that.
So our particular role is in relation to the registration of health practitioners who are seeking to practice in Australia. And when we are registering, it's more than just an administrative process. We first of all have to make sure that the qualification they have is equivalent to a qualification that an Australian trained graduate from an approved program of study would have. Secondly, we need to make sure that they meet the required standards of each of the 15 national boards, so English language would be an example there. And thirdly, we need to make sure they're suitable for registration in Australia. So we would look at things like criminal history. We would look at whether there was any sort of outstanding regulatory issues from the country to which they're coming from in Australia. So that's what's involved in the registration process. What we're doing is, in relation to the role of colleges, particularly as it relates to international medical graduates seeking specialists to work as a specialist in Australia, they have the role in assessing the equivalence of their qualification, and depending on their finding, there may be additional requirements placed on somebody to make up the gap between what the qualification they have is and what the equivalent would be in Australia. And then, as I say, once that's done and they come to us for registration, we are checking those requirements, confirming the qualification, confirming they meet the standards, and also confirming their suitability for registration.
And do you think there's anything more that AFRA could do in terms of assisting that process in the time frame?
Yes. So, for example, we have recently increased our staffing substantially in that international registration area, particularly around not only IMGs, international medical graduates, but also internationally qualified nurses, recognising the workforce pressures there are. Secondly, one of the things that we often find delays the registration process, Senator, is if we get an incomplete application and we have to go backwards and forwards to get all the information we need. So we've now turned all of our processes around and put our most senior staff at the front end of the process so that an applicant finds out very quickly if there's more information we need, rather than having to wait and then discover a few weeks later that there's information that we don't have that we need. And we've also done quite a lot of work with employers, particularly around IMGs, to make sure, because they're often supporting IMGs coming into positions in health services in Australia, they're very clear on what the requirements are and that they've got all the information they need. More widely, particularly as it relates to general practice, we're about to set up a joint working group with the RACGP, looking at just how the interface of what they do around the assessment of qualifications and what we do around registration, can be smoother. And so, for example, if I give you the example that sometimes there's information we need, there's information the college needs, and it's the same. So is there a way we could share that information safely? Can we make sure the information we're publishing to to people who are wanting to come to Australia is, clear and aligned and easy to read and easy to find? And also just looking at some of the sort of coordination issues that there are at times. So we're certainly looking to actively work to reduce any of those sources of preventable delay in relation to the registration of international.
I just want to clarify one quick thing. So the additional staff that you've put on, they are in that 1,113 that you talked about. Okay, great.
Senator,
Thank you. Thanks,
I just
Chair.
might make one clarification. National Cabinet has also, the First Ministers have commissioned an independent review of all of those regulatory settings for overseas trained practitioners to provide an independent view of whether there's anything else that could be done to speed up the regulatory process. So that will be happening over coming months.
Right, thank you. Thanks, Chair.
Thank you. I'll pass the call around. Committee members, we have, throughout the course of this committee, been working in roughly 10-minute blocks where we can. I'll give you a friendly nudge if you're getting close. Senator Antic.
Thanks, Chair. The complaint I hear from doctors routinely is that AHPRA has now fundamentally damaged the doctor-patient relationship by centralising control of COVID management with this so-called position statement on COVID, the 9 March statement. First of all, why did AHPRA see fit to do this now for COVID when it has never done it before? And I want to ask you some further questions about the position statement as well.
Thank you, Senator. So I want to start my comments by acknowledging the extraordinary work that registered health practitioners have done across Australia in relation to the COVID-19 pandemic, and we are very keen to support that work in any way we can. The joint position statement that was issued in March 2021 was actually issued by AHPRA and all of the 15 national boards collectively. So it's not just a view from AHPRA; it represents the view of the boards for all of the regulated health professions in Australia. And it was a response to queries that we were receiving about practitioner obligations in relation to COVID-19 vaccination, and that was at a time when a number of jurisdictions were also putting in place requirements around mandatory vaccination. The statement essentially aims to make clear that how national boards are applying existing regulatory frameworks in the context of COVID-19. So I think it's important to emphasise what the obligations in that statement were not new obligations. They are obligations that are entirely consistent with the code of conduct for each of the 15 national boards, and they obviously predate the pandemic. But at the core of that was an expectation, as it has always been, that health practitioners would use both their professional judgment and the best available evidence in practice, and that included providing information to patients and the public on things like social media. So,
can I just stop you there? That's not how it rolled out in practice, though, was it? Using the professional judgment, many doctors tried to use their professional judgment with respect to concerns raised about the vaccines and their safety and efficacy, which we now know is a nonsense. And in so doing, incurred the ire and the wrath of the regulator, and many have been deregistered for doing so. So my question to you is, do you accept that position statement has disenfranchised large elements of the medical profession and forever damaged the doctor-patient relationship?
Senator, I think it's important to separate.
Well, no, that's a question.
So
Sorry, excuse me, apologies to interrupt. Senator Antic, are you willing to table the media release you're referring to, just for the benefit
It's a
of
position
witnesses?
statement. It's on the website.
Sorry, the
Chair.
position statement.
Yeah. Well,
Are you happy for that to be tabled?
Yeah, it's their position statement. I mean, I can.
I've just had a request for the document to be tabled.
I don't have it with me, but
We could arrange for it to be tabled.
Thank you. Please proceed.
thanks. So the question was, has the doctor-patient relationship been fundamentally damaged?
So what I think is important to clarify here, Senator, is these extraordinary claims that AHPRA is actually deregistering or threatening to deregister doctors and other health practitioners who raise concerns about COVID-19. So I welcome this opportunity to set the record straight. And I think the first thing to say is that, in fact, AHPRA and national boards have no powers to deregister, under the national law, cancel the registration of any health practitioner. That is the decision of an independent state or territory tribunal or a court. It's only the case in very serious matters, and each case is decided on its own merits. And I can tell you today, to date, no health practitioner has had their registration cancelled in a tribunal in the jurisdictions in which we have responsibility for because of the views they've expressed about COVID-19.
How many doctors, medical professionals and allied healthcare professionals have been investigated during this period by AHPRA?
So let me give you the facts and figures for 21-22 for COVID-19 notifications. So during, and it's probably worth just reminding you that we do not deal with notifications in New South Wales. They're dealt with in a separate system, and we only deal with those notifications in Queensland that are referred to us by the Office of the Health Ombudsman. So noting that, we dealt with, or we received 1,303 notifications about the conduct of or health or performance of a registered health practitioner relating to COVID-19 during 21-22. That related to 1,006 practitioners, and they were across professions of medicine, nursing, chiropractic, dental, pharmacy, paramedicine and psychology. So that represented about 12% of all the notifications we received in 21-22. We dealt with about 10,800 notifications in that year. And if I just give you an idea of the flow, between September to December 2021, that averaged about 36 per week. By June 2022, it was about 5 per week.
Okay, so in relation to, this is a broader question then, it is very clear that medical professionals, healthcare professionals and others have not been in a position to express their professional judgment with respect to some of these issues. Many have balked at the vaccine rollout for good reason, in my view. Whether it be at the hand of the regulatory body or AHPRA, is it your position, is it AHPRA's position that there needs to be any amendment to the legislation to enable further freedom to doctors to prescribe in accordance with their own treating practices?
We are not seeking any amendment to the legislation.
So you are quite comfortable with doctors being silenced on this issue?
Well, I don't believe we are silencing doctors, and if I could perhaps just finish my answer and explain the type of concerns that we've dealt with. These are just to give you a flavour. So first of all, we've had concerns in relation to clinical care, which has typically related to things like vaccine exemptions that have not appropriately followed the ATAGI guidelines. We've had concerns from patients about not being able to access care because health practitioners have refused to treat them because of concerns about COVID-19. We've had concerns expressed to us about the behaviour or conduct of health practitioners. So, for example, refusals to wear masks, not complying with public health directions or lockdown requirements. We've had concerns about people practising while they are unwell and poor infection control. And we've also had concerns about the online conduct of health practitioners, for example, propagating what might be termed conspiracy theories.
Well, I want to stop you there. The position statement says that national boards expect health practitioners and students to provide accurate information and advice regarding the COVID-19 vaccination. Who exactly determines what accurate advice is?
So our reference point in relation to the accuracy of advice would be the public health guidance that was in place within each of the states and territories and the Commonwealth. If we were looking at issues around vaccine exemptions, we would look to the advice from ATAGI, and we would also look to TGA as our major sources of advice.
So in effect, this is a great big bureaucratic stitch-up over the top of medical practitioners. It's a cartel, if you will, a cartel of regulatory totalitarianism. Is that how you describe it?
I wouldn't describe it like that, Senator. No.
I didn't think you would.
It's a regulatory environment, Senator, that works on the basis of the best available evidence.
Yeah, but the chain of command ultimately has been stifling medical practitioners.
I don't accept that characterisation.
No,
I don't believe the data bear out what you're saying.
So what exactly constitutes an anti-vaccination statement?
What we would look at is the guidance that is in place at the time, so when the statement was being made, and decide whether there was any issue with the consistency, as I say, with those authoritative sources that we would look to in terms of jurisdictions, TGA and ATAGI.
You just do what the guys up the tree tell you, is that right?
Sorry, Senator.
Just do what the guys up the tree, the bureaucrats up the tree do?
No.
Follow in suit
So
like a
it's
conga line?
I think it's also important to note that it is not AHPRA making the regulatory decisions about these practitioners. We have boards for each of the 16 regulated professions, 15 national boards, and that is comprised of practitioner members and community members. So it is, and if needed, particularly if we were going to a tribunal with a matter, we would also probably seek expert opinion from a practitioner who is from within the profession of the practitioner that we're
So one last question.
about.
Why is it therefore that AHPRA and indeed all of the bureaucratic conga line that I discovered, why do they not trust healthcare workers enough to provide advice for their patients which they see every day in conjunction with their own medical expertise?
I don't believe that's the case, Senator. We do trust health practitioners, and the guidance that we issue, as I say, is entirely consistent with the Code of Conduct and is designed to make clear the obligations and expectations on registered health practitioners.
I think the whole system needs an overhaul. That's what I think. Thank you, Chair.
Thank you, Senator Antic. Senator Rennick, over to you.
Okay, cheers. Thanks, guys. Could I get the numbers of, if it's possible for you to provide on notice, the number of doctors and nurses and ambulance drivers or paramedics that have been registered from 2019, 2020, 21 and 22, just to get the last 4 years, if that's possible. And just in regards to, I'll pick up on that position statement, and I noticed Professor Murphy said the best available evidence, and that's a good point, because the FDA on December the 20th came out and actually said that Pfizer said that data was not available to make a determination about how long the vaccine will provide protection, nor is there evidence that the vaccine prevents transmission from person to person. Now, ATAGI has come out in updates from September to December 21, and ATAGI has stated that vaccination was an intervention to prevent infection transmission. So they have contradicted, ATAGI has contradicted what the FDA has said about transmission. Now, that is a good example of how the so-called experts, many of whom work for universities that receive significant funding from Big Pharma, as well as, the likes of Bill and Melinda Gates Foundation, who are heavily invested in vaccines, didn't get the data right. So why should we trust the regulatory experts over the expertise of individual doctors and nurses and paramedics, who quite rightly have raised the risks, and I've just spoken about this with the ACCC and the CIMA, why are they being suspended? So you've been clever with words when you're saying no one's been sacked, but plenty of people have been suspended, and there is a culture of fear amongst doctors and nurses.
Sorry, could senators at the table just allow Senator Rennick to ask his questions? It's just hard to follow. Thank you, Senator Rennick.
Thank you. So I guess my question is, what have you got to say when ATAGI gets it wrong? And they've clearly got it wrong in regards to transmission.
That's an appropriate question for the CEO of APRA about the veracity of ATAGI's advice, Chair.
Well, that's who there's advice they rely on.
Yeah, ATAGI's advice. We are very happy to defend ATAGI's advice and the evidence upon which it's based, but I don't think that's a question for the CEO of APRA, frankly.
So now you're running interference. My question
No,
wasn't
I'm not
to
running
you. My
interference.
question
You can
is to
ask
APRA.
questions about regulation, but I don't think you can ask
No,
questions
can you not
about
interrupt? The question isn't to you. The question is to you, Mr. Fletcher. There is a culture of fear, okay, because a lot of doctors who have much more expertise than many of the so-called experts on the ATAGI board have, knowledge about the risks of mRNA, etc., and they have been shut down, suspended, or threatened to be suspended. Why will you not take their advice or let them use their own discretion based on their significant expertise, as opposed to those in ATAGI who don't have the same level of advice? Expertise, sorry.
So, Senator, again, I think it's important that we sort the fact from the fiction here. So let me just go back to the data in relation to the notifications that we've dealt with. So if I can just complete my answer to the previous question. In fact, of those 1,300 notifications we received, around 50% of those, this is at June this year, had resulted in no further regulatory action. In other words, we'd looked at the matter, assessed it and decided there was nothing that we needed to do as a regulator. You're right to say there are practitioners that we have suspended from practice, and there are 28 practitioners who we have suspended from practitioner in relation to COVID-related matters. It's important to note, first of all, that suspension is an interim measure whilst we undertake an investigation, and we can only do it where there is a significant concern about public or patient safety or a public interest issue that requires us to take that action while we look further at the concerns being raised with us. And if I just give you the flavour of those, 11 of those suspensions were in relation to conduct related to spread of what you might consider COVID misinformation. So, for example, claims that COVID-19 was fake, that vaccine programs were government-led mind control, just to give you an example. 10 were suspended because of their failure to comply with public health orders, serious or at times fraudulent behaviour, so fake vaccination administration certificates or fake exemptions. Sorry, I should say that's 28 practitioners subject to immediate action, 21 suspended, 11 and 10, and then 7 are subject to restrictions or conditions such as supervision or limitations in relation to their vax exemption or prescribing.
Okay, thank you.
So can I just make the point, there are 830,000 registered health practitioners in Australia, so the vast majority of people
thank you. I'm
are
on
doing the
limited
right
time
thing.
here. Have you employed staff to look at doctors who have been writing exemptions or adverse events, and think very carefully about this statement, to actually been red flagging doctors who've been writing exemptions to the vaccine?
So because of the number of notifications that we received about COVID-19, we set up a special COVID task force within our existing staff, and we also worked particularly with the Medical Board of Australia to have a special committee that dealt with all of the COVID notifications in relation to medical
So you were
practitioners.
red flagging doctors who were
No,
writing?
we're not red flagging. That was in response to the notifications we were receiving. We were not out there doing surveillance, if that's what you're asking. We were responding to the notifications we were receiving.
Well, that's not what an APRA employee told me. But anyway, so I'll finish on this. I have been told by numerous doctors or numerous people with vaccine injuries that they have gone back to get an exemption. They've been forced into getting a second shot to keep their job. They have gone back to try and get an exemption and the doctor will not write it. They are afraid to write exemptions for people who are injured by the vaccine. And in response to, I know Professor Murphy didn't believe me last time when I said that, so I put up a post. I got 7,500 people who were sacked because they wouldn't get the second shot, and of that, 407 were both injured and sacked. So that's the culture of fear that is out there. You're going to have to live with that, and that is a shocking indictment that we are living in a country where people are being
Senator
forced
Rennick,
to get
can I
injured.
ask you to direct it as a question, please? Thank you.
Okay, so my question is that we have got doctors out there. Why have we got doctors out there who are afraid to write exemptions for people who've been injured by the vaccine?
Well, obviously we do not want doctors to be fearful of APRA and the regulatory scheme. We are here to support professional practice, but I don't step back from the fact that our fundamental focus is on public safety and patient safety, and if concerns are raised with us about risks to public and patient safety, we're obliged to look at those concerns. The law requires us to look at them, and if there's a need for us to take regulatory action, we will take it. Now, in the majority of notifications we deal with across the board, we don't need to take regulatory action, but we don't step back from needing to do it where there is that risk to public safety.
Okay, so you will defend the right of doctors to apply their own discretion to people who've been injured by the vaccine?
We defend the right of doctors to use their professional judgment and the best available evidence, and as I've said earlier, in our view, the best available evidence is that is provided by public health experts in each of the jurisdictions, ATAGI and TGA, and where needed, at the more serious end of concerns that are being raised, we would also seek expert opinion.
But evidence in a trial doesn't outweigh a diagnosis of an individual. It's the dignity and worth of every individual that matters. If a doctor diagnoses a patient, okay, so I've got a son who's allergic to penicillin. I know it's a commonly used drug. It's safe in most cases, right? Everyone has different allergies. Are you saying that the public evidence based on a trial is going to outweigh an individual doctor's diagnosis of a patient?
I'm saying that we refer to those sources of expertise if we've got concerns raised, but we look at the merits of the individual case. This isn't a one-size cookie-cutter-fits-all. We look at the individual circumstances, and that would determine whether we came to a view that there was a public safety risk that needed regulatory action.
Okay, thank you. That's all I need to know. Thank you.
Thank you, Senator Rennick. You
Chair.
finished? Great, excellent. Thank you. Senator Ruston, you have the call.
Thank you. Sorry. So, Mr. Fletcher, I'm just interested to understand the structure of APRA. Could you explain to me how your board is constituted?
Well, there are, in fact, 16 boards within the National Registration and Accreditation Scheme. So there is 15 of those boards are for each of the regulated health professions, and the reason there are more professions than boards is that although nursing and midwifery are considered to be two separate professions, they're regulated by one board, the Nursing and Midwifery Board of Australia. Each of those boards comprises 2/3 practitioner members, 1/3 community members. All of the vacancies on those boards are advertised, and we have 3-year terms. And the decision about appointments to national boards, those national boards are made by the Health Ministerial Council, which is all of the state and territory health ministers and the Commonwealth Health Minister. And most people can have up to 3 terms. Then the other board is the APRA board, which is the corporate board of APRA. The people on that board are also appointed by the Health Ministerial Council, also for 3-year terms, up to usually three-year terms, also advertised when vacancies arise. And they essentially are the corporate board of directors for AHPRA. So our role is to administer the National Registration Scheme, and essentially each of the national boards then set the relevant policy and standards and regulatory decision-making frameworks for each of the 16 registered professions.
Okay, so just unpack that a little bit. So we've got 16 boards, 15 of them, I'm assuming they're largely reflective of the wants of the colleges that represent the specialties plus nursing. And so have you got a list of the 15?
Yes, we can certainly
If you can
provide you
that.
with a list
Yep.
of the boards and
I
the
mean, it
membership.
could well be on your website. I had a look at it,
Yeah,
but it
yeah.
seemed to be
No,
more of a glossy
we can certainly
document than
provide that.
anything else. So in relation to the AHPRA board itself,
Yes.
how is that constituted? I mean, where do you get your board from?
So the national law says that there must be a minimum of 5 members of the AHPRA board, and there's particular expertise such as around education and administration and business. Those vacancies are advertised 3-year terms.
Yeah, who appoints them?
The Health Ministerial Council, so state and territory health ministers and the Commonwealth Health Minister.
So the 16, well, the 15 boards,
Yep.
do they provide advice, each of the boards provide advice as to who their representative would be on the main board? I'm just trying to understand how AHPRA actually works and where the chain of responsibility and the chain of authority goes, because I'm sort of, every time I try and dig into this, I end up at a dead end and I'm not really quite sure who's responsible for what. So we've got AHPRA as the national health regulator, and AHPRA has a board that's made up of these 16 boards. I mean, surely you don't have 16 boards turn up every time you have a meeting.
No, they're quite separate entities, Senator. So
You can call me Minister, everybody else does.
the 15 national boards essentially set the regulatory policy and standards in relation to the professions that they are responsible for. So,
Okay.
And they also set the framework for regulatory
Okay.
decision-making.
Okay, so if you've got an issue in relation to an area in health that is not necessarily the jurisdiction of one of the boards that you work with, how would you seek to resolve that? Would that go to the AHPRA board?
It would depend on the issue, but for example, we do a lot of work on multi-professional policy. So the statement that's been referred to, as I said, was actually a statement from all of the boards. It might be an issue where we actually seek to have a common position across all of the boards in relation to a policy piece or a piece of guidance or the like. Or if it was, so let's take, for example, the discussion that we've already had about workforce. That might be a more specific discussion with, say, the medical board or the nursing midwifery board, given the focus on those professions in relation to, say, for example, internationally trained practitioners coming to Australia. So AHPRA essentially administers the scheme on behalf of the boards. Boards delegate to AHPRA certain powers, but AHPRA also has some specific governance responsibilities in relation to the scheme. I can follow up with some information that explains how it all works, because there are quite a lot of moving parts.
Yeah.
You know.
So just going to the AHPRA board, so you said so you are a creation of the states and territories and the Commonwealth?
We're a creation of the states and territories. We are a national law model, so our legislation is state and territory legislation, not Commonwealth legislation. But
And
the Commonwealth Minister was.
And yet you seek to regulate jurisdictionally much that is financed by the Commonwealth?
The scheme is self-funded by the registration
No, I'm talking
fees.
about so you're regulating the health sector, and we all know that the health sector sits in various jurisdictions, and a significant amount of the funding that goes into the health sector sits within the Commonwealth. And yet, so is there another body that regulates on behalf of the Commonwealth, or is the entire regulation sit only with AHPRA?
We regulate registered health practitioners. We register registered health practitioners across Australia. In terms of regulation, where we're dealing with what we would call a notification, we deal with those in all jurisdictions except for New South Wales, where they're dealt with through a separate system. And in Queensland, we do that in conjunction with the Health Ombudsman in Queensland. So there are some matters that she deals with, there are some matters that we deal with, and we agree that as those matters come to our attention.
Okay. So back to the board. So you said within your guidelines or your requirements, operational. So I'm assuming you are formed under the national law, the legislation that sits under national law. It creates. I mean, what is the statutory structure of AHPRA?
So the national law. So essentially, when the scheme was created, ministers agreed the legislation. It was then passed in the Queensland Parliament as the host parliament. And is essentially adopted in every other jurisdiction, although in New South Wales and South Australia they need to pass a regulation. In Western Australia there is not mirror legislation, so they have to do corresponding legislation. So, for example, there's just been a package of amendments to the national law passed in the Queensland Parliament, and Western Australia will need to introduce their own legislation to pick up those amendments.
I'm just talking about the structure and the setup of AHPRA. So, the requirements in relation to your statutory existence are basically embedded in a piece of legislation that has gone into the Queensland Parliament and then been adopted by the various jurisdictions by whatever mechanism they need to adopt it. So in that piece of legislation, what does it say? It says the constituency of your board is determined by that legislation?
Of the AHPRA board?
Yes.
So it sets requirements around the expertise that needs to be on the AHPRA board. Yes.
Okay. And then who makes the determination as to who those people are?
Health ministers, the Health Ministerial Council.
Okay.
All health ministers have to
Including the
agree.
Commonwealth Health
Yep.
Minister.
Yep.
And what is the process that's normally undertaken in relation to that?
So those any vacancies are advertised extensively. The then health chief executives of jurisdictions on behalf of health ministers agree a selection panel that reviews those applications. We provide support for that process, administrative support, and then a recommendation ultimately would go through health chief executives to health ministers about either new appointments or reappointments.
And in that process, do the boards, the other 15 boards, have any involvement in that process, or is it
No.
entirely a bureaucratic process?
It's entirely, well, it's essentially it's a government-led process that AHPRA administers.
Yep. Can you provide us with a list of your current board members and their terms when they expire?
For the AHPRA board or
Yep.
all
Yeah,
of
just the AHPRA board.
Yep, yes, no, of course.
That would be great. Is it normal practice that the Health Ministers' Council accept the recommendations of that panel, or have there been occasions when health ministers haven't accepted the recommendations of the panel?
When you say panel, what do you...
Well, obviously there's a recommendation that goes up through the bureaucrats.
Oh, I see,
the
about
ministers.
appointments.
Yeah.
I'm not aware that there has been a recommendation that's not been accepted, but I probably have to double check that.
Yeah, that'd be great. So, you in advice to Senator Urquhart, you said that your annual budget's $202 million. Did I hear that correctly?
Let me just go back and make sure I give you the right number. Our expenditure last year was $232 million.
$232 million.
Yes.
Okay. Give you a breakdown of how that revenue comes about. I mean, you fund. How do you generate that revenue?
So that revenue is predominantly generated by the renewal fees that registered health practitioners have to pay. So you have to renew your registration on an annual basis, confirm you meet the standards, and there's a fee associated with that renewal. It's different for each profession because one of the design principles of the scheme agreed by ministers when it was established is that each profession essentially needs to pay their own way, so that we seek to minimise any cross-subsidisation between professions for the costs of regulation.
Okay. And of the $232 million that you generated in fees, how much of that was expended in activities that were undertaken by AHPRA?
So, Minister, the $232 million was our expenditure.
Oh, that was your expenditure?
Our income for the year was $249.7 million.
What happens to your excess funding?
So each of the national boards carry a reserve, an equity reserve. So depending on which profession it related to, it would go back to that equity reserve. And that equity reserve is used for things like significant capital investments. So, for example, after 12 years, we're upgrading all of our IT systems, so we would draw on that equity for that purpose. It also goes to uninsurable sort of catastrophic risks, if you like, which may be around practitioner matters, but it may also, I mean, obviously in the current environment, cybersecurity would be an example of something there potentially.
So who makes those decisions? I mean, do you have the delegated authority as the Chief Executive to make decisions about expenditure of that? I mean, I'm assuming that you put forward an annual budget.
That's correct.
Including a corporate plan to the health
correct.
ministers, and they sign off, and
Well-
that part of it is sort of just a standardised practice?
We don't put it to health ministers, so we put an annual budget and our strategic plan and our business plan to our board, our AHPRA board each year, and that's agreed through their corporate governance responsibilities. And part of that process, though, is that there is extensive consultation with each of the national boards in the development, because we also need to develop the budgets for each of those national boards, because there may well be initiatives that they are taking forward that are profession specific, that need to be funded, as well as the costs of running AHPRA.
Senator Ruston, we've got a number of others. Do you have many more questions?
I have a
AHPRA?
lot more questions.
Pardon?
I have a lot more questions.
Are there any you're able to put on
No.
notice so we can move to the rest? So can you give me an indication, please, of how much?
Probably got another 3/4 of an hour.
Okay, we might need to move to, we've just got a number of senators in the room and a number of
Please.
agencies.
No, I'm
so,
happy to speak to other senators as we go. Yep.
yeah, I was hoping to deal with this agency. If we've got to spend another 45 minutes here, we won't get to outcome one or the other agency. So we
It's
might.
just that I'm just delighted that we've got AHPRA here, because I mean they don't normally come,
Yes,
and I
as am
thank
I.
you very much for being here. But I'm fascinated by what you do, as you can see.
Okay, we might move to one of the other agencies now. We'll return to AHPRA shortly. I just want to give some other senators in the room the opportunity to ask some questions, and we will come back to you, Senator Ruston. We will work through in order of the small agencies. My hope is to dismiss as many as we can. So we'll start with the Food Standards Australia and New Zealand. I understand... Oh, sorry. It was highlighted. I missed it. Good pick up. Australian Institute for Health and Welfare, we will move to.
Welfare, I keep saying
Get the
welfare.
official
Thanks.
things coming. Just waiting for Mr. Heffron. Did he get his name back?
He's getting his name plate.
He wouldn't want to be unidentifiable.
No,
Yeah.
we certainly wouldn't. All right. While you're setting your name plate up, Mr. Heffernan, Senator Steele-John, please.
Thank you. Hello there. So these questions are, yes, they are absolutely for yourselves. And I just wanted to kick off by asking, how many people in Australia are on waiting lists for general dental care, denture care and assessment of dental services in Australia?
Thank you, sir. Rob Heffernan, Chief Executive Officer, Australian Institute of Health and Welfare. Sorry, just run in from the other...
No, take a breath.
Thank you for the question. That question, sorry?
Would you like a water?
Oh, I'd love a water. That's very kind of you, Senator.
That's all right. We're all about health today. And I hear water has some beneficial health effects.
Senator, the detail of that question we just don't have available. So if we could take that on notice and we'll provide an answer. To the extent we have that data, there's also a question of the data that we have available. It may be that we have information along those lines. We do some reporting on dental, so in our Australia's Health, where we update that as one of our biennial reports. Apologies, I just can't recall off the top of my head what level of detail we can go to on dental, but I can take that on notice to come back to the committee.
Could you, I'm just interested in terms of information you might have either to mind or to hand now, do you have any data you can provide us with as a committee in relation to how many people are on either, well, first of all, let me ask you this question. Is there a national, do you have a picture of what the national wait list looks like? Like, do you gather that information, or is that not something that you do?
So, Matthew James, Deputy CEO of the Australian Institute of Health and Welfare. I'll give you an example where we don't have wait lists, for example, on mental health. So we don't have a wait list, for example, of people waiting to see psychiatrists or psychologists. We do things like waiting times for elective surgery in hospitals and things like that, but often we don't have waiting times for particular medical professions. Often that data is not centrally collated.
Yeah, and certainly waiting times for dental, that's the one in particular.
Dental
waiting times for dental, I'm fairly sure we don't, but before I say a definite no, I'd like to take that on notice just to make sure we, that is correct.
Could I just, building on what Mr. James just said, do you have, in terms of the elective surgery, the surgery wait times that you have, do you break them down so that we might at least be able to identify the dental kind of surgeries captured within that?
We certainly cross-classify that data, and that's available by different types of things that people are waiting for, but I don't have that detail in front of me, but we can get that to you.
Okay. Look, you're for good reason. You're a well-respected organisation in the community. People, I think, trust your information that you provide. What would it take for you to know, to be able to? I know you're going to take it on notice, but if the answer is no, like, what would it take for you to be able to gather this data?
So the data we gather is typically the data that largely through the governance arrangements of the health ministers and the Health Chief Executives Forum. They would say, well, it's important to have information on this particular area. And so typically be the states and territories that will provide us information. In
Which
doing
forum
that,
was that?
so the health ministers.
So they would give you a directive. They would.
Yeah. So they as the way it normally goes, there's the health agreements are signed up. Within those health agreements, there'll be schedules about here is information and data that ought to be provided to, in our case, Australian Institute of Health and Welfare. When that happens, we would work with our state and territory colleagues to work on a consistent way of reporting, so that when we do report, it's on a nationally consistent basis. Now, that's the general model that in the hospitals environment, and when it comes to ones that are there is a large, there's a public element, but also a large private element. So with dental, it's then much more challenging. So with the public hospitals and indeed the private hospitals, we can get good data. They're large organisations, typically pretty sophisticated as far as their data requirements go and data capability. And so that's feasible.
It'd be complicated, but...
Yeah, but and then, sorry if I could just...
Yes.
So the idea of the Institute of its own volition going out and deciding to get information, when we do that, and it's and typically because we're governed by our board, if a board is keen for us to step into a particular area, what we would typically do is tap into reporting sources that are already there. We have no capacity to compel. Yeah, so reporting sources that are already there and bring material together and report in such a way that hopefully brings a synthesis and analysis to that.
So the first step to getting that information would be a directive or recommendation to come out of that ministerial meeting between state and territory and the Commonwealth Health Minister?
Certainly if there was some direction for us,
Yes.
and of course I'm not suggesting,
No, just
but,
trying to understand the
but if there
levers.
was a direction for
Yes.
the board to instruct us
Yes.
to do that, we would endeavour to do whatever we're instructed
endeavour
to
to take it
do.
on. When is the next one of those meetings?
I'm not aware.
That might be a question.
The health ministers are meeting next week, Senator. They meet every month. Minister Butler's driving a strong agenda for health ministers' meetings.
Just finally, to the Minister representing the Minister, do you know whether the Minister has indicated a willingness to put such an agenda item on a subsequent meeting of State and Territory Health Ministers, that the Institute undertake that work?
Thank you, Senator Steele-John, and thank you for your question. I'm not aware at the moment, but I can certainly take that on notice. Obviously, that would be a discussion with the Minister, and I'm more than happy to have that conversation and get back to you.
All right, and could you just take on notice for me, Mr Heffron, just in case there is information hanging around, although it seems that there isn't, but could you take on notice if you have information about the number of people that are on waiting lists for general dental care, denture care and the assessment of dental services in Australia? And additionally, if you have that information, how many are under the age of 18, how many are over the age of 65, and what the average time on the wait list is?
Senator, can I just clarify? I think you're getting at the public dental waiting list, are you? Because I think what Mr Heffron's saying, that to go into the private dentist is almost impossible. But
Yes.
Yeah.
Literally, I am seeking any information you can give me on dental care in Australia of any type. But yes, the public, if that's what you've got.
Senator, yep, we'll take that on notice, and we'll endeavour to provide you what we can.
There is some relevant information in the ABS Patient Experience Survey that gives you data on whether people face cost as a reason for not seeing a dentist, for example. That's published by the ABS. I've got that in front of me.
But public is great.
Yeah, we'll make sure we include that in the information we provide the
Senator Steele-John, I understand you're seeking to share your block with
Yeah,
Senator
I
Waters,
am
so let's
seeking
go.
to share
Thank
it
you.
with
Thank
Senator.
you
Very
very
much, both to Senator Steele-John and the Chair. Hi folks, appreciate your time this morning. Can I ask about maternity care, please? The latest AIHW maternity models of care data shows that only 31% of pregnant people are able to access continuity of care through their pregnancy. Can I just interrogate that 31% figure? I'm presuming that's a national figure, and that access to continuity of care would be, much lower in certain areas. Could you let me know if you've got any sort of regional breakdowns on that figure?
Senator, I'm afraid that you've landed on one that is outside immediate area of expertise. We do produce a lot of reports a year, so apologies.
They're very
that we don't
good.
Yeah,
Do you
well,
have the relevant officer perhaps to hand?
Not here today.
Not here, okay.
if there's something general, when was that report that you mentioned?
That is an excellent question.
Sorry?
I don't know.
Oh.
But you tell me, it's your report. I don't have the date here, I'm sorry. I've got the link to it, but I haven't printed that, so.
Look, rather than...
if you need to take it on notice,
yeah, I think we'll take that on notice, Senator.
And I'm also interested in, and I'm not sure if this is a question for you or for the department, do you have figures on how many public hospitals offer birthing centres and midwife-supported birth models?
Yes, we will have that
You do.
information.
Great.
But I'll
Take
have
that on
in
notice
due-
also.
take on notice.
Okay, lovely. Thank you. And what is, this one definitely is for the department, what is the department doing or the government doing to increase access to continuity of care models across the public system?
I might see if Professor McMillan, who's doing our work on midwifery, is here. Yes, Professor McMillan, you can come to
Thank
the
you.
table. It is a very important issue for government.
I'm pleased to hear it.
Good morning, Senator
Hello.
Alice McMillan, the Chief Nursing and Midwifery Officer. The access to continuity of care, as you know, is based in how maternity services are provided predominantly through the jurisdictions. All of the states and territories and the Commonwealth committed to a woman-centred care programme of work that commenced in 2018. As a part of that, there is a commitment to further advancing access to continuity care models, but that the responsibility for the delivery of these services predominantly lies with the jurisdictions for whom run the public hospital system.
Okay, so that was a strategy in, I've got here that it was released in 2019, but 2018 is close enough. That's several years ago now. I hear that you're wanting to enhance access, but what actions have been taken to do that by the federal level of government?
So again, the action to address and increase the access to continuity of care does lie with the jurisdictions. We have recently re-established a senior officials group who are looking at all of the elements and recommendations of the women-centred care strategy and looking at the progress they've made in relation to a number of those actions required. And we're at the moment working with all of the jurisdictions to look at a monitoring framework that will tell us better the progress of those. But again, Senator, ultimately it is the jurisdictions who need to do the work predominantly in the maternity hospitals to expand that access.
Okay. I'll come back to that point, but just on that monitoring and evaluation framework, when will that be finalised?
We're aiming to complete that. I'll probably best take that on notice, Senator, just so I don't I have accurate.
And will consumers be involved in co-designing that monitoring and evaluation framework?
Again, I will need to take that on notice just to check the consultation process on that monitoring and evaluation framework.
Okay, and I just want to push back a little on your contention that the continuity of care is primarily state and territory responsibility, given the role that MBS and PBS, for that matter, could play. Perhaps this is one for, I'm not sure who this is relevant for, but can you tell me about any advancements in listing MBS items? I did attempt to ask this the other day, and I think it might have been you that I spoke with, Ms McMillan, over the video link.
Yes, so,
if you can expand on what you told me then, because I still don't have the answer in my head.
So, Senator, the provision of continuity of care models in public hospitals is a public hospital health system. It's not funded by the MBS. It's funded through a set of arrangements between states and Commonwealth in relation to funding public hospitals. Access to MBS is available for what we know as endorsed or eligible midwives who can then work independently through a set of arrangements through the Nursing and Midwifery Board of Australia. And they are therefore, in fact, women or patients of theirs can access MBS as a reimbursement system for care. There's work underway with the department on reviewing a number of MBS items that relate to midwifery. That is still underway, but we hope to have that completed either later this year or early next year, that will address a number of areas of anomaly in relation to eligible midwives or endorsed midwives accessing MBS items.
Thank you. That was nice and clear. And I'm recalling now that when I asked a different official, they said that those previously agreed items under the Strengthening Medicare Task Force were actually being rebriefed to government and essentially were under consideration. So thanks for giving me the timeframes on that consideration.
Ms Rishnew has some more information
Oh,
on
yes,
what the
please.
Commonwealth is
I think
doing
it was
on
you.
continuity
Yes,
of
It was,
care.
Senator. Tanya Rishnew, Deputy Secretary, Primary and Community Care. We did talk about the Strengthening Medicare Task Force and the work underway there. I thought it was also worth mentioning there are some other investments that came through in this budget, particularly around living guidelines for pregnancy care and postnatal care. So $5.9 million invested in actually doing living evidence guidelines to improve the care for pregnancy and postnatal care. And also, obviously, 22.9, I think, for Waminda, a centre of excellence for birthing on country, which will obviously provide excellent support, evidence and best practice for First Nations women and birthing on country experiences as well. So I just wanted to add that to the
Just
list.
one to follow up since the
I'm loath to
officer-
interrupt you
I
because
know,
I'm
it's such
finding this
great
fascinating,
content.
but we
I'll be
need
very
to move
quick.
on.
Thank you
Thanks.
for raising that. That was on my list of questions. I'd like to know what time frame the Wominda Nowra Centre, when will it be operational, and whether or not the department's developing a work plan for a national rollout of Birthing on Country initiatives.
So, Senator, if you can give me some time to take that on notice, I'll be able to get you some detail
Thank you.
after the break.
Appreciate
but that Centre of Excellence is really looking at how do you develop best practice to be able to roll out best practice birthing on country initiatives across the country nationally. So it is very much designed to be an evidence-based birthing on country centre for a whole range of birthing on country initiatives. But I'll come back with timelines.
Thank you very much. Thank you, Chair.
Another senator had questions, have kindly agreed to put them on notice. Can I just confirm, are we ready to release this agency? Does anyone have any further questions? Great. Thank you very much. Okay, we're going to try and move through the remainder of the agencies listed for this morning session now and then come back for a decent block with APRA before we go to the tea break, is my intention. We'll see how we go. So we're going to move to food standards now. Senator Ruston, you have the call for this. No?
Call, I think. No, I want the National Rural Health Commissioner.
Okay, does anyone have questions? Another senator's agreed to put theirs on notice for this agency. Is anyone
I'm happy to
seeking-
ask a couple of questions since you've come all this way. So just by way of just a bit of explanation, Food Standards Australia is made up of all the states and territories plus New Zealand and the Commonwealth.
Food Standards
Sorry,
Australia-
Food
sorry.
Standards Australia is governed by a sort of a federated model of Australian states and territories, the federal government and New Zealand.
Thank you, Senator. Sandra Cuthbert, Chief Executive, Food Standards Australia, New Zealand. The food regulatory system does comprise quite a broad remit. We report through ministers up to the food ministers meeting, and that minute food ministers does...
What are food ministers? Health ministers?
Not always. There is Minister Watt, for example, is also at the food ministers table.
So in terms of your ministerial body, is that constituted under some sort of statutory arrangement in terms of it has a power outside of being an advisory body?
So there's the FSANZ Act,
Yep.
which articulates our role and how the board is made up, so how the board is comprised. And then there's also the Food Regulation System Agreement. Sorry, I can't remember the title of it. But that also articulates how it all works together and includes a treaty between Australia and New Zealand as well.
Senator, sorry,
Yeah, please.
if it's useful, from the department's perspective that has responsibility. So the Food Regulation Agreement, so the FRA, is the agreement that Ms Cuthbert was referring to, which sets up the arrangements between states and territory, and you're right, the Commonwealth and New Zealand is a party to that. The Food Standards Australia and New Zealand Act 1991 actually regulates FSANZ, establishes FSANZ, the board, and a food ministers meeting. Food ministers attending that meeting include both health ministers and agriculture ministers quite often, and it's jurisdictional. So there's New Zealand is represented, all of the states and territories are represented, and often there's 2 ministers per jurisdiction.
So does it require a consensus in terms of getting decisions, or is it a majority vote in terms of any propositions that, in terms of regulatory change, that you would put to that ministerial council?
So that's another question for the
Oh,
department. Sorry, sorry, Senator. It is a majority consensus. Food ministers obviously operates on the basis, a majority vote rather than consensus, but tries a majority.
Yeah, so you need a majority of them.
Of food ministers, but they operate to try and reach consensus on issues.
Okay. So, so you've got always you have 2 ministers per jurisdiction, do you?
Generally.
Okay. So how does so the weight of the power that exists within that council is absolutely sits with the states and territories?
So the Food Ministers' meeting is chaired by the Commonwealth. There is a lead minister from each jurisdiction, and as I said, it operates to try and generate consensus as much as possible and has often been successful in doing so. But it has a majority weight, but the chair is the Commonwealth.
But the chair has no power outside of the fact that they run the meeting. I mean, clearly each and every one of the members of the board has equal voting capacity.
Yeah, that's right. They run the meeting, but as I said, generally issues of contention are resolved, constructively.
So, in terms of regulation that sits, say, for instance, within the domain of the Commonwealth, as opposed to the states and territories, is there any mechanism by which, if the jurisdiction is the one that is likely to be most impacted, that jurisdiction has an ability to exert greater influence over the outcome, as opposed to something that was more set across all jurisdictions? It just seems like a really weird model where the states and territories are wagging this dog, and I'm sort of feeling a bit sorry for New Zealand in all this. If they've only got one person, how do they ever, if something was impacting New Zealand, how does that get sorted?
So the Act actually has fairly prescriptive roles for the board, for FSANZ, for food ministers, and as I mentioned, in general, it's a really constructive discussion. There are very few issues that would impact on one jurisdiction. It operates to be a national food regulatory system and tries to drive consistency. With New Zealand, with that binational system, they operate and rely very heavily on the kind of scientific evidence and the evidence-based policy and standards that FSANZ actually delivers. And so there's absolute recognition of the independence of FSANZ and the evidence-based advice there. And so, as I say, it's very rare for a national food issue to only impact on one jurisdiction disproportionately. It's exactly why the legislation and the organisation exists.
I mean, just as an example, Dr. Cuthbert, can you give me an example of a time when you haven't been able to reach consensus, like on a particular regulation?
A lot of the work that we do requires a lot of consultation throughout our processes. All of our proposals and applications go through rigorous consultation, and most times there's differing views as to where we should go with those. So I can think of many examples where we have to work through and understand the issues that face each stakeholder in the system, and we work through that very transparently, very openly, and listen to everybody's points of views. And oftentimes on the significant pieces of work, we go through more than one round of consultation to make sure that we've heard those views and we're moving forward in a way that will suit the majority.
If I can just add to that, sorry,
Yeah, sure.
Crystal Lemus, General Manager of Science and Risk Assessment. New Zealand actually does have an opt-out of standards, so probably an example that you're looking for was one around folic acid, and I can't remember the timeframes of that, it was a number of years ago, but New Zealand opted out of that standard at the time, so it only came into play in Australia. Of course, the Food Standards Code is set up in chapters, so you have chapters 1 and 2, which are across the binational system, and chapters 3 and 4, which just relate to the Australian system. So folic acid is an example where New Zealand did opt out, but more recently they're looking to introduce that standard.
You said there were lead ministers, so am I assuming that the so-called voting, whatever you want to call it, there's only one person from each jurisdiction, or one minister from each jurisdiction that gets to be the person who casts the vote?
So generally, all ministers attend. The jurisdictions will caucus, between ministers. But yes, there's one vote per jurisdiction.
And so, is it up to the jurisdiction to decide which of the two ministers is that?
It is.
So, is there an even balance between being the Ag Minister and the Health Minister, or is it more predominantly one or the other?
Senator, I'm going to have to take that on notice in terms of the current Food Ministers' meeting arrangements, if I can. But generally, it is well balanced.
Mm-hmm. Yeah, because I mean, I can see how that you'd have quite significant competing interests between health and agriculture. I find myself in that place often in this new job, having come from agriculture, in terms of how to assess the impact of a regulation in terms of the benefits versus the implications it has on, particularly on food. So to that end, you both made comment about evidence-based advice. Just interested to know, in the case of obviously one of the hot issues at the moment is the pregnancy labelling on wine. What was the evidence base that sits behind the decision to pursue these quite significant label requirements for the wine industry on pregnancy, and sort of wonder where what was the underlying evidence base that suggested that wine in a bottle was a significant issue in relation to pregnancy and medical implications of consumption of alcohol during pregnancy.
Thank you, Senator. I'll pass to Mr. Neil, General Manager of Risk Management and Intelligence on this one. Thanks, Glenn.
Yeah, thank you, Senator. Glenn Neil, General Manager for FSANZ. In terms of pregnancy warning labelling changes that came into play in 2020, they apply across the board for all alcoholic beverages, and essentially were the culmination of a ministerial request following a voluntary program that was in operation by the alcohol sector for about the last 10 years. So essentially the weight of evidence unified to the point where there is an undeniable link between consumption of alcohol during pregnancy and the sequelae known as fetal alcohol spectrum disorder, a range of...
Step back. I don't think I'm disputing that that alcohol in excessive quantities is probably not the smartest thing to be doing while you're pregnant. I was specifically asking what the evidence base was in relation to the consumption of wine from a bottle. Because, I mean, clearly alcohol comes in many forms, not just in a wine bottle. So why particularly was wine, so premium wine, targeted for this particular measure? What was the evidence base to suggest that that was the problem child in terms of alcohol-related pregnancy issues?
Well, the evidence base, if I may, Senator, the evidence base related to the amount of fetal alcohol spectrum disorder that was occurring in the community, the number of people, consumer literature around the number of people who didn't quite understand the connection between consumption of alcohol. There was nothing specific to wine. It was decided to apply the warning label to all types of alcoholic beverages in Australia and New Zealand.
So you're currently...
Is this the last one?
No.
I'm just trying to get back to APRA and deal through the other agencies, so if we could...
So I just, in my understanding is that you're currently reviewing the colour requirements in relation to this particular measure. I'm just interested to understand where, what was the nature of the determination in relation to the... Because this doesn't have to come into effect till next year, does it?
That's right. There is a 3-year transition that's in play for that rule. So 1 August 2023 is the deadline. And what has transpired is that for a small number of packages of alcohol, those particularly those transported and sold in a corrugated cardboard outer, there's a technical impediment to getting the 3-colour label design printed in a clear manner using that technology. So we're talking about exempting a small number of those cardboard outers that this relates to. So yeah, that's a particular application from the alcohol sector to find a solution around a very small number of those packages.
Yeah, I'd just be interested, do you do a cost-benefit analysis on these decisions?
Yes, absolutely. We're required by the Act to undertake a detailed cost-benefit assessment and prepare quite often a regulatory impact statement as well that receives the scrutiny of the Office of Best Practice Regulation.
Yeah, would it be possible to provide me with a specific cost-benefit analysis in relation to bottled wine as to why, you know, what the additional cost would be on manufacture and the cost of the changes of this regulation on that particular part of the sector, and what you believe the benefit analysis is on that? So
we have a cost benefit for the label changes. I don't know if our cost benefit went into the detail of specifically for bottled wine or not, but we'll look into that and we'll make sure that we provide what we have. It is publicly available and we'll circulate that.
So I suppose to my point, you know, I suppose I'm being critical of the one-size-fits-all approach because, you know, the damage to a particular subset of the industry that is being impacted may be significant, and yet their contribution to the problem may be negligible, and yet you've just taken a blanket, or you clearly take a blanket approach and just everybody gets put into the basket. You do your cost-benefit analysis across, you know, the entire sector, and you're not taking any regard for the fact that there could be a subset of that sector that really is not making any great contribution to the problem, and yet you know, you don't take into account the cost, the disproportionate impact of the cost on and the consequences on that sector. So I'd just be really interested to understand how you deal with that, why you don't deal with that, and you know, I'd be very interested to understand from the ministers as to why they're not requiring you to undertake that, and why our agriculture ministers aren't sticking up if that's the case in circumstances. So thank you, Chair.
Thank you, Senator Ruston. I believe that's all our questions for you. Thanks for your attendance today. You are free to leave us. We're now going to move to the National Rural Health Commissioner. Colleagues, we obviously have a lot to get through, and Senator Ruston's indicated a lot of questions for APRA. Are you happy to go to 5-minute blocks to get through the remainder of the session?
Not going to make any difference whether they're 5 minutes or 10 minutes. I've still got the same number of questions.
In terms of the follow-up, because it's, I don't want to speak for Anne, but 5 makes it harder to follow up.
I'm just, that's fine. I'm seeking the committee's assistance to manage the program. I appreciate we've got aged care coming up. Everyone's going to want to get to that as well, but we'll just keep running with the program at 10 minutes. I hope we can get to aged care today.
Chair, I just wonder whether the Rural Health Commissioner is obviously critical to the whole rural health workforce issue. We've got a whole health workforce division, so it may, if we start on rural health workforce, we could be really heading fully into workforce, but that's fine if the committee chooses to do that. But the Rural Health Commission would probably need to stay until workforce is completely finished. So she's probably someone you can't let go until we finish this outcome.
Not to worry, if you're happy to be in our company, we're happy to have you. Senator Waters is going to kick off here.
Thanks very much, Chair. Hello, thanks for joining us today. I'd like to ask some questions about rural and regional access to reproductive health care, predominantly about access to abortion, but also interested in access to the full range of maternal health options for pregnant people right across the country. So can I start off, please? And I'm actually not sure who's best placed to answer this, so forgive me, Professor Stewart, if I direct something to you that the department might need to answer. I'm interested in what data collection is done regarding abortion care, both medical and surgical, in Australia, and in particular whether you break that down for rural and regional areas.
Ruth Stewart, National Rural Health Commissioner. I am not the person who can answer the data collection, I'm sorry. I can answer workforce issues and matters that affect those, but not the data collection.
Oh, okay. Have we got? We've got someone here that can. Thank you very much.
Dealing with access to.
Okay. Well, look, I might. Whilst that person's joining us, I'm interested in. Do we keep data on how many abortions are performed in public hospitals?
We're just onto abortions.
No rest for you today, I'm afraid.
She's our expert on everything.
Thank you.
Hardly. Apologies, Senator. Sorry, could you repeat that?
Yes, sure. Thank you. I'm interested in what data collection is done regarding abortion care, both medical and surgical, across the country. Do you keep figures on how many abortions are performed in public hospitals? And is there a rural and regional breakdown for those figures?
So, Senator, my understanding is that there isn't any national collection that actually looks at terminations across, you know, in a statistical way across all jurisdictions and a breakdown, but I'm going to have to take that on notice if I can. I haven't seen any consistent data nationally on those figures.
Why is that data not collected?
Part of the problem, Senator, is that certainly the MBS data, the MBS codes, are not that they are used for more than just termination of pregnancy for abortion. Some of those codes are used for other indications. So the MBS is often our richest set of data for the private medical sector, but if you pull out the codes for the surgical abortion, in that database will be a number of other procedures that are done for other things. Now, the states and territories, obviously in the public system, there is rich data because that is coded under the National Health Reform Agreement, and that those data are reported through, and AHW could pull that together, and we could pull that data together from the states. But the states and territories certainly have data on their public abortions. Then there's of course these medical abortions, which is the other side of things, and we can get some data from that through the PBS in terms of the prescriptions of that.
Yes.
So it is possible to pull it together, but I think, as Ms Ritchie says, there isn't a comprehensive data set. This is certainly a very, very strong interest of Assistant Minister Carney, and she is very keen for us to do more work in this space. And it's clearly a program of work that we're commencing to expand our efforts in. Sorry, Professor
Senator,
Stewart.
Apologies. If we can take that on notice and we'll pull together the data that we can.
Thank you, that would be
do.
wonderful. And I share Minister Carney's commitment to this area, so let's hope we can improve access for women across the country. Professor Stewart?
I was just going to add another complication is that the PBS data looks at the provision of medical termination under PBS, but doesn't look at when those medications are given within a public hospital.
I see.
And particularly in rural and remote communities, it's far more likely that a medical termination will be managed by a hospital.
Required. Yes, okay, thank you. I'll really look forward to those figures. MSI International was forced to withdraw a number of regional abortion services in 2021 because government subsidies were not sufficient for the services to break even. Have you studied the impact of that removal of services on women's access to termination services?
I haven't conducted a formal study, but I've certainly received feedback that it has increased the difficulty for some women accessing termination services.
Has the Minister or the Government or the Department met with MSI since the election to discuss any funding model that would allow services to be increased?
So, Senator, I can't comment obviously on whether ministers have met with MSI. The department has had, and since the election, I'd need to take that on notice in terms of whether we had met with MSI, but we have met with MSI regularly with the department. One of the other things that was very clearly communicated by MSI, particularly during COVID, was access to telehealth services as well. So that was very specifically an initiative that was in response to some of the feedback from MSI. But I would need to take on notice whether we've had any meetings since the election, and as I said, couldn't comment on whether ministers have met.
Thank you, and it's really more about whether or not alternative funding models are under consideration by government or by the department. Is that work being done or not?
So a lot of the services obviously are state and territory run as well, so we've been talking to states and territories in that space, but in terms of specific modelling of MSI's, viability in that space, nothing specific yet.
Okay, thank you. Since the election, has the department briefed the Minister or the Assistant Minister on abortion access issues across the country or on models of delivery in other countries? Or indeed yourself, Professor Stewart, has anyone briefed the Minister on those issues?
No, I have not briefed the Minister on this matter.
Senator, we have briefed ministers in the normal course of briefing and providing advice to government.
Okay, thank you. And has the department asked, or the minister asked, the Strengthening Medicare Task Force to consider creating new Medicare items for abortion care?
So the Strengthening Medicare Task Force is primarily looking at primary care generally. So the Minister Butler has focused it on, you know, what he sees as rightly the crisis in general practice and getting primary care. So it's largely focused on that. It's not a broad review of the MBS as such. We do have an ongoing continuous MBS review, and as we talked before, looking at things like midwifery, and there's a process for further the Medical Services Advisory Committee, which Ms Shakespeare is responsible for, does look at MBS changes from time to time, and I don't know whether there's been any MSAC approaches about.
Not recent. Penny Shakespeare, Deputy Secretary Health Resourcing. No recent approaches to MSAC on this issue. Okay. I do think that there's currently an application into the TGA to expand the ARTG listing for the medical termination pharmaceuticals, which may then flow on to changes to the pharmaceutical benefits scheme.
Thank you. And unfortunately, I can't be here when TGA is on, so I appreciate you flagging that. I'll put some questions on notice for them.
The TGA DepSec is online from Dublin, just for you, if you want to ask him about that.
Oh, yes. Well, please, I'd love to know a bit more. Hello.
Yeah. Good morning, John Skerritt, Deputy Secretary, Health Products Regulation and Head of TGA. We have had discussions with MSI about changes to the conditions which would liberalise access, because currently there's a rather stringent training program.
Yes.
This is for doctors and pharmacists, and this is seen as a block. We have also met together with our advisory committee for women's health products that Assistant Minister Carney actively took part in just last month, and we discussed how medical abortion access could be widened. At least as of my most recent advice a week and a half ago, we haven't yet received an application from MSI. I should add, however, that these products are generic, and one thing that we have been talking about with the relevant peak bodies in this area is the ability for an alternative company to come forward with an application. Sometimes competition in the market may actually open up access to medical abortion more widely in Australia.
Thank you. And I will put some questions on notice because I've got quite a lot there, but I'm getting the look from the chair to finish up. So forgive me for not going down that path with you right now. Can I just finish up by asking, are there any commitments in the budget to address period poverty, abortion care, or the impacts of menopause?
So, Senator, there's a range of commitments, particularly around, as we were discussing, rather than menopause specifically, but there's the commitment and a recent announcement to open 16 clinics across the country around particularly pelvic pain.
Yes, thank you. I was at that announcement yesterday. I'm interested in period poverty, abortion care and the impacts of menopause.
So the government has committed to working alongside state and territory governments to improve standards of care and access. In terms of specifics in funding, nothing there, but obviously there's the consciousness of the Senate inquiry, particularly coming up, so the department would be making a submission to that. And in terms of, as I said, endometriosis and pelvic pain, certainly commitments there.
Yes, thank you, and I welcome those. It's not that they're not important, it's just that I'm already across those details. My final question, and thank you, Chair, for your patience, and Professor Stewart, perhaps this is one for you. Is there any data collection, or can you tell me about the state of access to maternity services for people across the country, particularly in rural and regional areas? Because the anecdotes that I hear are that pregnant people have to travel sometimes for hours, which is thoroughly impractical when you're about to give birth. So it's a real issue in the community.
Yes, it is a real issue, Senator. There is data. It does tend to be broken down according to each state and jurisdiction, and it can be found in various places, including published papers. But We do know that there has been a decrease in the number of maternity services, with particular decrease in rural and remote communities, and of smaller birthing services. There has been, in the last 5 years, a slight increase in the number of rural birthing services, however, with Queensland being particularly active in that space.
And is my final question, I promise, is the government doing anything to address that decrease in services?
So I think that there was, certainly in the recent budget, there was some money put aside to work with New South Wales Health on potentially re-establishing birthing services in Yass, which was an election commitment of the government. Then, of course, we heard about the Warminda Centre. So they are, again, they're fairly small issues, but the biggest challenge is the states and territories have generally closed these services because of, and it's quite an active debate. The basis for closing services is, they don't feel that there's necessarily safe to operate with low numbers of births. The rural generalists and Professor Stewart's colleagues would say that that's not necessarily an evidence-based assertion, and that the risks associated with travel can often outweigh the risks of having. Yes. So it's a matter of getting that critical mass of, midwives and GP obstetricians and to make those services viable. And I think many of the states and territories are trying to work to re-establish them, but it is largely their regulatory environment that's led to that. Obviously, what the Commonwealth is doing under the passion of Professor Stewart and her colleagues is trying to expand our rural generalist pool, and one of the most important rural generalists are those with obstetric trainee experience, and accompanying that people with rural generalists with anaesthetic experience. And so if we can get that medical workforce up, and then the other side of it is getting the midwifery workforce. So we're doing what we can in the workforce space, but in terms of whether those services are open or closed, it's ultimately a decision for the state and territory health governments.
In terms of specific investments, we do have some to support rural generalists to acquire those procedural skills, including obstetric skills. So in the recent budget that was announced, that included $10.7 million in funding to increase the number of procedural training places. So that's in working with states and territories so that we can increase the number of... There is existing training programs to support rural GPs to acquire procedural skills and to maintain those, but this is an additional investment. There's also an additional $74.1 million invested over 4 years to increase incentive payments to rural generalists who have procedural skills and are using those to deliver expanded skills in their communities, including obstetric skills. So there are some specific investments that will benefit obstetric care in rural areas. In the March budget this year, there was also an investment. I don't have the number here with me, but that has allowed us to employ a principal midwifery officer in the department who works to our chief nurse and midwifery officer, Professor McMillan, who is also doing work with the states and territories around rural maternity services access. So there are a few things happening at the moment.
Okay, could you take on notice for me the work scope of that most recent person? Thank you very much, Chair, for your generosity, and thanks for your time, everyone.
Thank you, Senator Ruston.
Thank you, and thank you very much.
Oh, sorry, before you continue, Senator Ruston, I do just need to alert the committee that the media have requested to have permission to film and take photographs of proceedings. I'm seeking your agreement. Nod, nod. I remind the media that this permission can be revoked at any time, and you must follow the direction of Secretariat staff. If a witness objects to filming, the committee will consider this request. The media are also reminded that they are not able to take images of senators or witnesses' documents or of the audience. Media activity may not occur during suspensions or after the adjournment of proceedings. Copies of Resolution 3 concerning the broadcasting of committee proceedings are available from the Secretariat. Senator Ruston.
Thank you, and thank you very much, Professor Stewart, and thank you very much for the amazing work you do on behalf of rural and regional Australia. I'm just wondering, do you have in your role, or maybe the department does, an analysis in terms of the workforce distribution and where we are seeing the greater do we actually have a map in terms of workforce shortages and vacancies as per geographical locations?
Thank you, Senator.
Would you, Mr Williams, answer, or would you prefer?
No. I was going to say, I thought the question was directed to me, but I was
Oh, no,
going
sorry,
to-
please, whoever is the most
Mr.
appropriate,
Williams might be
please
best.
respond. Mr Williams.
Good morning, Senators. Matthew Williams, First Assistant Secretary, Health Workforce. Yes, Senator, we have two efforts underway at the moment in terms of two key workforces, which is the medical workforce and the nursing workforce. We've done a supply and demand study for both workforces and are currently undergoing testing of the modelling externally to be able to identify exactly where the shortages are, and those shortages would be determined not only by vacancies and the workforce distribution, but also in terms of the conditions that Australians face and need to be treated. So the modelling that is being undertaken accounts for all the significant evolution in the chronic and other conditions in Australia. We do have the district distribution priority area program as well, which does.
Don't go to that. I'm going to come to that in a minute.
Sure.
Just stick with the modelling in relation to workforce shortage, if you wouldn't mind.
Yep. So that modelling is underway, Senator. We don't have that publicly available, but we are testing that externally. There's currently an agreement with the University of Adelaide that we've undertaken to test that modelling, and we will be.
And so when is it likely for that to be available?
It'll be a consultation will be undertaken with the sector as well as with academia and those who are relevant, and we're hoping soon for that to be publicly available, Senator.
Any idea of what soon means?
I think it will be different for different parts of the profession. So the nursing supply and demand study, we will need to work through with a range of employers and training organisations there to test the model.
So you're testing with the sector whether your research. So who actually undertook the research to determine workforce shortage?
So the modelling is being done by a team of health workforce modellers in the department,
So
but
it's
it needs to be tested with external experts first.
Yep.
We're doing a range of modelling across medical specialties under the National Medical Workforce Strategy. One of the key recommendations was that we needed to be doing supply and demand modelling for each of the professions, because we will need more of some professions in some locations, we'll need less of some professions in some locations. We also, for general practice, we also have the Heads Up data tool, which has been developed and tracks 5 years' worth of Medicare service provision, primary care service provision, where people are accessing their services. So it looks at both the location of the Medicare card holder and where they're accessing their services. That tool is available to people in state and territory governments to assist with workforce planning, and to some others that I think have been given access under arrangements that comply with the Health Insurance Act requirements for the protection of data.
Yep. So in terms of the research that you're doing on, we'll say for instance on GP, are you also analysing the use of MBS items per location? So will that give you an idea in terms of the level of potential underservicing that may well be occurring in rural, regional and remote areas?
Yes.
And when will that be available?
Well, so some of that Heads Up data modelling showing where people are accessing services and the level of service access is already available to staff in the department.
No, but like when will I be able to see it?
So there are difficulties that we have to work through in terms of public release of information at that level, because of provisions in the Health Insurance Act that make it a criminal offence to release information about individuals, whether that's providers or individuals who access health services, which could lead to re-identification. So We can certainly make more information available, but we have to make sure that it's not going to identify individuals, which can be a problem, particularly when you go to smaller remote locations.
I get that. So, but I mean, it is in the public interest, I would have thought, for a community, to understand what's actually happening in relation to the provision of health services within that community. I mean, you don't have to name Dr. Bloggs, but you in terms of postcodes, I mean, everybody knows in shallow markets who's there anyway. So I'm sort of interested to understand what would be your argument in relation to not providing.
Well, we do provide information through the distribution priority area updates as to which locations are underserved for primary care services.
Yeah, I get that, but we're talking about servicing, and equally it could show over-servicing as well, couldn't it? Or it would show a discrepancy in the servicing of particular communities, where they're in a city or whether they're in a country area. And I just wondered, like, in the case of, say, the urgent care clinics, I mean, how does a determination get made in relation to that if you don't know what the servicing of? I mean, like, it seems to me a very non-transparent way about going about things.
So we do have good information about Medicare services. We publish a lot of information at levels where you don't identify individuals. Providing more granular, detailed information, we can look into that. We do often get specific requests for information about Medicare services in particular locations, but we do have to assess them to make sure that we don't identify individuals.
So if I asked you, if I put a question on notice to the department and requested by postcode the workforce and MBS item numbers, would you be able to provide me with that data, or would you not?
I think we'd need to look at the request and make a decision based on, whether there were small cells involved.
Senator, we normally record data by general practice catchment, which is basically an analysis of where patients and individuals actually acquire and services are provided to them. So the geographic boundaries, we use general practice catchments, and we can provide that information for you.
General practice care, like through PHNs or?
There are 827 general practice catchments across Australia.
And you would provide the data at that level?
So I think at that level, it's usually fine. It's been...
Is it published?
So those are published for DPA, so we base distribution priority areas at the catchment level, so it will be in many cases, yes.
Okay. Going on to the DPA, could you explain to me when DPA was first conceived as an initiative, what was the purpose of it?
So I don't know exactly when Districts of Workforce Shortage was first conceived. I think it was probably the late 1990s, but I'd have to take that on notice. Distribution priority areas replaced District of Workforce Shortages for primary care practitioners in, I think, 2018 or 2019? 2019, my colleague here reminds me. And that was designed to take a far more targeted approach to distribution challenges faced in the primary care catchments. District of Workforce Shortage looks at overall service numbers compared to a national average, whereas the distribution priorities area looks more at the health needs within those 827 catchments. So it takes into account service level usage, socioeconomic data, to try and work out, what should be the service level for a community rather than just applying a national average. So it was an improvement on the earlier District of Workforce Shortage system.
So at the time that the DPA was implemented, was there any explicit requirement in relation to it being focused on rural, regional and remote?
So I guess the use for the distribution priority area is primarily for a couple of programs. One is Section 19AB of the Health Insurance Act,
I know exactly
which
what
is
I said. That wasn't the question I asked you, with the greatest amount of respect.
Well, it's for the use of those programs, you know, and those programs do...
To where? I'm just trying to understand, was there any...
No, it's for areas of workforce shortage, so it's not purely rural and remote areas.
Okay. So there was no intention at the time that DPA was put in place that it was there to solve a specific challenge in relation to the recruitment of workforce, particularly GP, in rural, regional and remote Australia.
It's there to support effective distribution of overseas trained doctors and foreign graduates of accredited medical schools to areas of workforce shortage, and also those that are completing return of service obligations under our bonded medical programs.
Yep. So just to be really clear, I heard exactly what you've just said. At the time it was introduced, was there any intention for it to be focused on rural, regional and remote work areas?
So, I mean, distribution priority areas is a system of classification that is based on
Ms. Shakespeare,
827 GP catchments.
I understand. All I want you to say is yes or no, or maybe if the Secretary wants to, if he wants to take it up to that level. I just clearly want to understand whether, when the program was put in place, it was targeted at rural, regional and remote areas, or was it at the time it was targeted at all areas of workforce shortage? There just didn't happen to be any workforce shortages anywhere apart from rural, regional and remote. So
I think we have to go back to the history, Senator. But I think what you're saying is right. It was targeted at areas, the name of the original measure, Districts of Workforce Shortage, was targeted at areas where there were clearly an undersupply of either any sort of medical specialist, GPs or other specialists. In the main, probably at the time when it was introduced, they would have been more prevalent in rural and regional areas, but there have always been some districts of workforce shortages. For example, the whole of, sometimes parts of major towns, and even in Tasmania, or all of Tasmania, I think it was classified at some stage. So clearly rural and regional is the most important part where we have shortages, but they are also very prevalent in other places. But in terms of the original intent of the measure that preceded DPA, we'd have to go back and look at the history of it.
I'm sort of really more dealing with DPA. So to that point, when DPA was introduced in 3 or 4, 5 years ago, were there any DPA areas that would have been considered parts of major capital city populations? Obviously, I understand the Northern Territory is quite a unique case, but I mean, did Sydney or Melbourne or Brisbane have any DPA classifications when it was first introduced?
Yes, in outer metro areas. Now, that depends on the level of service, but there could be classification of outer metro areas of the capital cities as DPA.
Thanks, Senator Ruston. It being 11:02, the committee's now going to suspend for morning tea. We'll resume at 11:17. AM, the committee will now resume. Just to do some tidy up, I understand the senators who have requested the Organ and Tissue, let me make sure I get the name right, Authority, have agreed to place their questions on notice. So unless there's any senators at the table seeking questions from them, we're happy to dismiss that agency.
We'll let the officials know from the OTA that they can go. Yep.
Okay. And then we will be returning to questions to the National Rural Health Commissioner and working through in that order. So, Senator Ruston, I understand you had further questions for the Commissioner?
Yeah, look, and I'm happy to come back to Mr Williams and Ms Shakespeare around the whole DPA workforce shortage issue, but I'd just be interested to get your views, Professor Stewart, on the decision in July to expand the DPAs into a number of outer metro areas, and whether you have any comments as to what the impact of that has been or might be into the future on rural, regional and remote workforce, particularly IMG.
So, Senator, I suppose my views about the effectiveness of the DPA really predate any decisions that were made this year. As you're well aware, we have not been able to turn the tide on rural health workforce. And despite the DPA being very much focused on rural and remote areas, it hasn't delivered a strong rural health workforce. And so I don't see there being a great impact of changes to the program that have been made this year.
So I'm just going to quote to you from a release from the Rural Doctors Association of Australia from Megan Bello, who's the president, saying that, you know, she was extremely, or that the RDAA was extremely disappointed to see Labor persist with this policy change despite strong opposition from rural doctors. So I suppose my question to you is even though it didn't solve the problem, are you suggesting that Dr. Bello's concerns were unfounded, that you don't believe that the expansion of the DPAs into peri-urban and outer metro potentially could have a negative impact?
I share Dr. Bello's concern that it could have a negative impact. I'm waiting to see what the impact is. I think that the situation is far more complex, and we try to reduce it to simple, cause and effect. But what we do know about rural health workforce is that there are many different contributors to people's decisions about whether they work in a rural community or not.
So in terms of your in your role around an assessment as to whether this or any other initiative that's in place or changed or removed or put in place in relation to rural, regional and remote workforce, do you have a role in analysing those impacts?
So my role is to engage with key stakeholders in rural and remote health and to listen. I have heard specific instances where health services have lost a doctor who has decided to move to an MM2 or one location. But I'm yet to see a nationwide impact of such movements. It's really easy to focus on that loss and not see it in the context of the broader rural health workforce.
Look, absolutely, and I wasn't suggesting for a minute that this was going, the only thing that, was going to impact on rural, regional and remote Australian workforce. But, I mean, I suppose it's just interesting to date, we've had comments, from people in Huonville in Tasmania with, a situation, West Coast and Woodner in South Australia, the TriStar Medical Clinic closures that have seen all of their IMGs, almost without exception, that haven't been picked up by other clinics have gone, they've got the opportunity to go back to the city. And I just sort of wondered who is undertaking the assessment around the movement of this workforce and when are we likely to see that?
Can address that, Senator. We are monitoring it very closely. Yeah.
That's correct, Senator. So we are closely monitoring movements in doctors, overseas trained doctors. So the changes to the DPA arrangements came into effect 21st of July. So we've only really got a few months' worth of data to look at this stage. So I think we need to continue to closely monitor what's happening. But to date, the movements that we're seeing are within normal ranges.
Okay. So when the decision was made to make this expansion on the DPAs, did the department do any analysis on what the potential impact might be on workforce movements from areas of extreme and critical need into areas of high need? And did you provide that advice to the Minister?
So many of the changes that took effect in July implemented election commitments. The department did not advise on the development of those commitments, as you'd expect. We've certainly done a lot of analysis in terms of preparing for the changes. And as I said, we're monitoring the impacts in terms of flows of doctors between different locations.
Minister, I'm just wondering, given that you come from rural and remote and regional communities, whether you would have any idea as to whether there was any research or consultation undertaken by rural, regional and remote communities, of which I know you very passionately represent, as to the impact of the decision that came into effect in July on those communities?
Senator Ruston, not in terms of the decision in July, but I am constantly out on the road with regional rural areas and speaking to, largely in my area, the Aboriginal community controlled health sector. And there is no doubt that we have to look very closely at the workforce issue, and not just in health, but right across the board. Tourism, you know, the roadside stops that we're at. So we just, we're very aware, and we're certainly on top of it with trying to see what we can do.
So in your travels, have you had any concerns raised with you about the potential impact of DPA's changes on rural, regional and remote communities that you've been speaking to?
Well, as I said, no.
Okay. Right. Clearly they're not speaking to you. I would have thought they would have been.
Well, you're asking me about their concerns on it, but they haven't raised any with me.
No, absolutely, and that's absolutely fine. So, to the best of your knowledge, there was no consultation specifically about the changes undertaken in the rural and remote communities that you spend a lot of time in?
No, I've understood your question to be whether I personally have received that kind of information on my consults, and the answer is no.
So, all right, well, I'll ask the question again. Are you aware of any consultation that was undertaken with rural, regional and remote communities before the decision was implemented?
No, I'm not aware.
You're not aware? Okay. Would it be possible to take on notice then, Minister, to find out what the basis of the decision was and whether the implications on rural, regional and remote communities were taken into account when the election commitment for changing the DPAs was made, and also be interested in your views as to the concerns that were expressed by the Rural Doctors Association of Australia.
Yep, happy to take that on notice.
Yes. Yeah. Just finally, before I hand over to Senator McKenzie, because I think she wants to, is Professor Stewart, do you undertake a holistic sort of mapping around workforce shortages, and particularly around vacancies in rural, regional and remote Australia? Or is that something that the department does?
That's something that the department does. My role is more consultation and engagement, and from that engagement formulating advice for the department.
So in the formulation of that advice from the consultation, have you formed a view as to what are the driving factors around decisions of medical graduates, for instance, to become a rural generalist, or just more generally, what are the things that you believe in your consultations are the barriers to Australian health professionals operating in rural, regional and remote areas, and what do you think would be the most advised thing to do, or advised things to do, in order to alleviate the problems that you have found in your consultations?
The rural health workforce shortage has been a long time coming, and as you might expect from that, there are many contributing factors. I think that one of the major issues are that Our health professionals are largely educated in universities, and many of those universities are placed in large urban centres. If we want health professionals to work in rural and remote communities, the best predictor is to have a student who came from a rural or remote community. And if you have the university in the large cities, that's immediately a barrier to many rural students to move to the city. It's a financial barrier and a social barrier. Australian governments of all persuasions have invested over the last 25 years in the Rural Health Multidisciplinary Training Program that has gradually built in an iterative process a lot of knowledge and infrastructure to increase training in rural and remote Australia. I certainly in my role am contacted quite often by overseas agencies, people wanting to learn from what Australia has learnt about education in rural and remote Australia. So educating rural origin students, giving them frequent, well-supported exposure to clinical attachments in rural and remote areas so that they understand what rural practice is and what the benefits are and how to manage the difficulties. Then they need a clear line of sight to a training pathway for their postgraduate years so that they can specialise in the skill set to deliver care in a rural and remote setting. So in medicine we have the National Rural Generalist Program. In allied health we have an allied health rural generalist program that has been developed and is expanding. And in nursing, one of the Deputy Rural Health Commissioners has led work on the development of the National Rural and Remote Generalist Pathway for nursing. I've got that name a little bit wrong. It's RRNG. Yeah. And so we recognise that people are far more likely to go and work in rural and remote when they understand what the skills are that are needed, when they have experience in rural and remote communities, and they're familiar with it. It's not a scary environment. Then we know that it does make a difference if you recognise financially that skill set. So that leads me to the next issue. In the last 20 years, general practice in Australia has become one of the specialties that is far less attractive to new graduates. And I think that underlies a lot of our difficulty in attracting medical graduates into rural and remote Australia. Because really what we need, the majority of our doctors in rural and remote Australia, we need them to be general practitioners. We particularly need them to be rural generalists. And we are working hard to develop that national rural generalist pathway. So there are a lot of different ways that we are approaching the issue. So I've spoken quite a bit about the medical pathway. I think that we ignore or don't talk enough about the shortage of allied health practitioners. And I feel that that's because the way that healthcare has changed in the last 50 years has been to call upon a whole team. But that whole team has not existed in rural and remote Australia. So in a small town that has just lost their doctor, they'll come knocking on your door saying, we've lost our doctor. But if they've never had an allied health practitioner, they don't come saying, we haven't got an allied health practitioner, because they don't have an understanding of what could be provided by that. I've been leading work on identifying what a rural multidisciplinary health team does. That's the Ngaya Bar Gadan consensus statement, and I believe that that will help give communities an understanding of what they need and therefore what they should be planning for. I could keep on talking for hours, but I'm sure that Senator Smith wants me to stop.
Ruston's time, so.
Yeah, no, not at all. And look, I'd be really interested to get some more information about, innovative models of care, particularly around that whole, multidisciplinary approach in smaller communities, and how you can come up with innovative models that allow you to still do that when clearly a little tiny town can't afford, 16 medical specialists, but there are ways and means in which that can be delivered. But look, really appreciate it. I'd cheer you off all day if I had the time, but I will see to my colleague, Senator Mackenzie.
Just before we get there, can I just get a sense from senators at the table? We obviously haven't started outcome 1 yet. And it is 11:30, so can I just get a sense? We've got a lot of officials here waiting and not at work.
It's a really annoying standing order, as I recall, as a former chair. But yeah, we've still got questions. I've still got questions.
We're just trying to get
That's fine. Just trying to give an indication to officials because they're waiting around all day. So if you can provide me some advice, that would be great. But otherwise, Senator Mackenzie, you have the call.
Thank you so much, Chair. Thank you, Anne. Great to see you, Commissioner, in your role, and Secretary Murphy too. Congratulations to both of you. I would like to ask, has the Health Minister met with you since the election?
I've met with the Health Minister on a number of occasions at face-to-face in different committees, and met with the Assistant Minister for Regional Health on a regular basis.
Great. Good. Thank you. In terms of the HECS, waiving of HECS for medical and particularly doctors, I'm interested in what mechanisms around breaching of those obligations would have. In the past, obviously, there have been schemes where medical students would give a commitment to go to rural and regional communities, but then they would be, we always said it was not successful because the students would write a letter to somebody and get out of it very, very easily. And so that onus of responsibility back to both the taxpayer and the broader needs didn't actually occur. What mechanisms should be around to sort of ensure that the old bonded arrangement works this time round?
Shakespeare's probably best.
So the HECS Help scheme that was announced, I can't remember which update, I'm sorry, but it's in the last 18 months, is subject to the passage of legislation still, so it hasn't started. And the legislation still needs to be considered, obviously, through the Parliament. And I think the final form of that will probably impact on compliance arrangements around it. But what advice within the department would you be considering to make sure we don't get the same outcome as we did last time, where basically you write a letter that you've got a boyfriend now that lives in Melbourne, you don't need to go to Mildura? So in the way that it was envisaged when the program was announced, the HECS forgiveness would actually occur when people were working in rural areas. So it wouldn't be the case like the scheme that we had, I think, about 10 years ago, that people just got the payment and then they didn't. Right, so they might have used it for a television or something rather than HECS deaths as well. Well done. Thank you. Now, Minister, just following up on one of Senator Ruston's questions. So the implementation of Labor's election commitment, what was the methodology or evidence that that particular policy was based on?
I'm happy to take that on notice for you, Senator Mackenzie.
Could the department assist?
Well, again, we have no role in determining.
No, that was an election commitment made.
Yeah, but
I know how thorough you are, Mr.
Our advice
Murphy.
was that it was based on the significant evidence of shortages in outer metropolitan areas and, you know, GP practices under serious pressure, and a desire to make a commitment to address particularly some of those MM2 areas that were seen to have significant GP shortages. But that's all we were told. We were not involved in the developing the election commitment.
And I think there was a parliamentary inquiry this committee held that looked at.
No one's debating, as Senator Ruston said, high need versus crisis. No one's negating that there is a high need in peri-urban areas. But Minister, surely the Labor Party, before they made that election commitment, assessed the impact of that election commitment on the very communities you yourself represent, I represent, the types of communities that Senator Ruston indeed grew up in.
Look, I'm sure there's information there that we can provide to you. As I said, I'm happy to take that question on notice. I mean,
but you don't know.
Well, you know, you guys had two health ministers,
Senator
and you
McKenzie,
still
the ministers
don't
don't have it on notice. So
yeah, it's so typical, right?
So I'm happy to
No,
bring
it's so
back some
typical.
questions on notice.
Okay, Minister, we've just heard from the Health Commissioner the importance of training country kids in country places, and that is actually a key reason why the health shortage exists, with the data does not lie. There have been cuts in the budget handed down a couple of weeks ago by the Labor Party, that a wet lab in Mildura that would actually assist in the training of allied health professionals has been cut, that $27 million commitment with Southern Cross University in Coffs Harbour that was to actually train allied health professionals in regional New South Wales and provide a clinic facility for that community has been cut, and that another project, which was a partnership between La Trobe University and Goulburn Valley Health in Shepparton, to train again allied health professionals, particularly a nursing workforce, has been cut. Can you confirm that those three projects have been cut from the budget?
Senator McKenzie, I'm unable to confirm that because
Really?
I'd like to have a
It's
look.
budget estimates.
I'd like to have a look at it, but what I can say,
Could you do that
with
today?
the portfolio areas that I have, that we've certainly injected significant funds into areas of employment of 500 Aboriginal health workers. So I'm more than happy to get back to you on the questions that you've asked.
I would appreciate that today, given we're in budget estimates.
Senator
And
McKenzie, the minister's indicated she will take it on
Chair,
notice. Can we move to
yeah,
the next question,
thank you,
please?
Chair, I'm able to ask my questions, and I find it
I'm
incredible.
asking you to
I
ask
find
the
it
question.
incredible.
Senator
that here we
McKenzie,
are
I
in
have the
budget
call.
estimates.
Senator McKenzie, I have the call. I am asking you to proceed to your next question. If we keep the dialogue to a minimum, we'll get through the content quicker. McKenzie, you have the call. Senator
I find
McKenzie.
it incredible that here we are in budget estimates and the government cannot answer very simple questions, because we were told that the government was going line by line through all these projects.
Senator McKenzie, can
what
you
they were going
rephrase
to
it as a
keep in
question,
and what they were
please?
going to throw out. And I cannot get a simple answer to a very simple question that actually goes to the heart
Senator
of the crisis
McKenzie, can
that
you
we're all
rephrase it as a
experiencing out
question
in
to the
regions.
minister,
I
please?
have said I'll take that on notice. Senator McKenzie, I notice you get very excited about all of this.
Well, it's
I
my
wish you
people
would,
that are actually can't get to a doctor.
Senator
Really? And what
McKenzie,
about
the minister is
First
finishing
Nations
her
people
answer.
who also need assistance in this space?
No one's arguing that, Senator
Oh, really?
McCarthy.
Really? Because
No
Senator
one's
McKenzie,
arguing.
Senator
There's a
McKenzie,
reduction,
Minister
and also I'm happy
McCarthy,
to take that on
Senator
notice.
McKenzie and Minister McCarthy, I have the call. I will suspend the committee if you do not allow me to take the call and allow me to manage this committee's work. You will let the minister finish, Senator McCarthy. You will let the senator ask her question. Senator McKenzie, you have the call.
Commissioner, you went in your remarks to the importance of facilities such as I've outlined. Are you aware if the Labor Party has cut those projects and commitments in this budget?
I'm aware of ongoing funding for the University Departments of Rural Health within the Rural Health Multidisciplinary Training Program. I'm not aware of any reduction.
We're not aware of any specific. We're just following up, Senator. But
Thank you.
we will investigate whether we're not aware. I'm not aware of any formal cuts in the budget to measures. So we will find out.
It's cuts to facilities that were being committed to in the March budget, but facilities that were going to go to training of young people.
We'll find out and come back to you.
I'd really appreciate it because I can't get a straight answer.
We may need to check with the infrastructure.
Yes, you
portfolio,
probably will.
But we're unaware of health measures.
No, I appreciate that, but the Commissioner was very clear that health can do everything they can, but without actual facilities on the ground in rural and regional communities, we can't train country kids locally to practice locally.
So there have been some additional investments through the recent budget to assist with the training of medical students.
Building facilities?
So yes, there's funding for a new medical campus for James Cook University in Cairns, which includes CSPs, which are the training places, but also capital and recurrent costs of supporting that as well.
Great, thank you. I'd really appreciate that. Thank you,
Chair.
Senator Ruston.
Chair. Does anyone else have questions for the National Rural Health Commissioner?
No, I don't, but can I just put on the record the amazing work that Professor Stewart does, and thank you very much for that work.
Sorry, Chair. I've got some questions in from her and Senator Davey, who can't be here, that she wanted to ask.
On the National Rural Health Commissioner?
Yes.
Sure. Go away.
Okay.
Go away. Away you go. He's probably...
It's all good, Chair.
I'm allowed to ask you that, probably not the other one. Please, Senator McKenzie, continue.
Senator Davey would like an update on how the Murrumbidgee employment model trial is going, and has it been expanded to other regions?
So the Murrumbidgee, we often refer to it as the Murrumbidgee model. It's a single employer model whereby the general practice trainees are employed by the Murrumbidgee Local Health District throughout their general practice training. That model enables the junior doctors in training to continue to access the leave entitlements, and such as maternity leave and sick leave, etc., and superannuation, whilst they are in their general practice training, because it has been identified that during general practice training, as a trainee moves from one practice to another, with each move they lose advantages. And we are told by junior doctors that they take into consideration that when they're thinking about whether they want to become a general practitioner or another specialty. So the Murrumbidgee model has commenced and is fully subscribed, and that's about all I can tell you about it. I've spoken to some of the junior doctors who are employed within it, and they're happy, but it's very early days, so we certainly don't have any outcome data. That will take some time. That will take the full 4 years to see, exactly what happens with that. 4 years of general practice. Sorry, rural generalist training, because the Murrumbidgee model is particularly designed around rural generalist training. So that specialised field of general practice training specifically for rural practice.
Yes, thank you. So my understanding from Senator Davey is that Labor said they would expand this model to other regions. Has that occurred yet, or any consultation?
There are a number of other sites around Australia that are investigating and in discussion as to how they would run a single employer model. There are some that are actually being run but not using that terminology.
So there was additional funding in the recent budget to support expansion of these trials, but I might turn to my colleague to talk about where those are. We have got some extra ones underway now.
Yeah, hi Senator.
Hi.
Happy to give you an update of the existing trial as well. So as of now, there are 7 participants on the single employer model. And that's across Wagga, Gundagai, Temora, Cootamundra, Deniliquin and Narrandera. Wow. And we have a maximum capacity of 20 rural generalist trainees through this program, and that, as the Rural Health Commissioner indicated, we have 4 years through which that program will be rolled out. We've got a second trial in the Riverland Mallee Coorong Local Health District in South Australia that is currently being in development, and as indicated as well, the current government has committed to an expansion of the models across Australia, and it will be it's currently in negotiation with states and territories as to where those might happen, but there should be by January next year around where we can undertake applications and make assessments of where the next trials might be undertaken.
Thank you. And just my final question, thank you, Chair, sorry about the double dipping. Commissioner, one of the issues when I was last in this area were the colleges. And we were trying to make sure that colleges would prioritise rural and regional experience or practice as part of a requirement for certification. How's that going? I thought we only got 2.
I think if you came back into the area, Senator McKenzie.
Oh, they were the days.
You would notice that there has been change.
Great.
The specialist training program continues. Some of the colleges are very active in establishing rural training programs. Not all, but there has been a good deal of progress.
If you on notice could give me a naughty and nice list, that'd be great. Thank you, Chair.
Thank you, Senator McKenzie, and I do apologise for misspeaking before. Love your company here, so please stay as long as you would like to enjoy our company as well. Do any other senators have questions for the National Rural Health Commissioner? No? Okay, thank you. We will move to the National Health Funding Body. I understand the opposition will be seeking the call. No, they didn't. Only. If you're ready, Senator Steele-John, we'll go to you first.
National Health Funding Body?
Yes.
Oh, thank God. Lovely.
Senator Steele-John, you go.
Thank you, Chair. All right. Now, I think this question will probably go to the Minister to kick us off. Are you aware that both the AMA and state health ministers have requested the federal government continue the 50-50 funding arrangement with state hospitals?
I've certainly heard about it, and I've certainly seen much of that in the news, but nothing to me directly.
Has that been, I would assume that the health minister is aware of those requests?
Look, I wouldn't assume anything, but I am definitely happy to take that to the health minister for you.
Senator, I think I should say that they're specifically referring to the COVID National Partnership Agreement, which is a 50-50 funded measure, which terminates at the end of this year. Government has made no final decision on COVID response measures terminating at the end of this year. That there is still a process for government to look at those measures and see if any of them may or may not be extended in some form or another. So I wouldn't say that there's been a firm decision of government about the COVID measures expiring at the end of this year.
So just to be specific, when you say the COVID measures, you're referring to the...
Well, there's a range of COVID measures expiring this year, but
case,
the National Partnership Agreement is the only agreement at the moment that has a 50-50...
In relation to hospital funding?
Yes, in relation to COVID-related hospital funding.
Yeah. Well...
There is not a 50-50 split under the National Health Reform Agreement, as I'm sure Mr White can explain. That's a different split, but the 50-50 thing relates to COVID-related hospital expenditure.
Which we still very much have in this country. And in this context, and just as we've sat here as a committee, Queensland's moved its COVID advice level to amber. We have had, I know the WA government, many state and territory health ministers have said very clearly to the federal government that they wish that funding to continue. I'm wondering why, Minister, when knowing just how vital this funding has been, particularly in places like WA, where just this week we've heard harrowing reports of over 2,000 deaths a year being caused by emergency wait times. Is the government ending this arrangement on New Year's Eve?
Thank you, Senator Steele-John, for your question. And just following on from Mr Murphy's response to you, we realise that in terms of hospital funding, that the NHRA agreement is due to expire in 2025, and the ability to negotiate in preparation for that is going to take place as of next year. So in terms of the process for us reaching an agreement, that is obviously going to start next year. But in terms of your immediate response for what's going on in hospitals, I have no doubt that Minister Mark Butler is watching that very closely and working with the respective ministers of each state and territory.
Well, I would expect him to be, and what he would see, as I said, in WA context, is a health care system. I think even to say that it is on the brink is probably understating it. As I say, the 2,000 deaths figures linked to emergency wait times is extraordinarily concerning to me.
It is absolutely concerning,
and it
should be to everyone. So
it is.
Yeah.
It is absolutely, and I'm sure it is similar in terms of the stress of the system in the Northern Territory and in many other healthcare systems as well. If I understand you correctly, what you have just said is that the funding, the partnership will cease. The government is seeking to negotiate a future broader agreement. Is there a timeline for the conclusion of that negotiation?
So the NHRA goes to 2025. The government health ministers have agreed to bring forward a review of there's a mid-cycle review that was planned, and that is going to be undertaken to have a look at some of those issues that might play into the next agreement. But government's been pretty clear that the NHRA in its current form will serve its term till 2025. But I think the issue around the 50-50 funding, that's not in the NHRA. It never has been. That's specifically related to the COVID National Partnership Agreement.
Yes.
And as I've said, that government has not made any decision about COVID response funding beyond the end of this year, and that's still a process under government consideration.
So then that's a process under government consideration. When will that consideration conclude? Because you have a very definite date for the end of that process.
Can I just jump in? Sorry, Mr Murphy, but obviously this has been a problem that has been a long time coming. And one of the critical things that we placed in coming into government was the need to take the pressure off the hospitals. Obviously with our strengthening Medicare and some of the other election commitments we've made, we are investing $235 million to commence the establishment of 50 Medicare urgent care units. So, Senator Steele-John, I guess my response here is, yes, we know there has to be the agreement and to look at the 50-50 that you're specifically asking about, but we also are doing and providing other measures in the health space to relieve the burden on hospitals.
Well, we have simply in WA alone 2,000 deaths linked to wait times last year. That's just WA.
Just in the last 12 months.
Just in the last 12 months. And if you took that across the nation, the figures, I'm sure, would be really shocking to the committee. Are you anticipating a reduction of services being required in hospital settings?
Senator, if I may, and with the Minister's permission, just to be clear to the committee, that 2,000 number is based on an extrapolation of research-related matters. It's not an actual number, so I think we should be clear of that. There's no question that emergency departments are under pressure around the country, and we've seen that for quite some
Absolutely,
time.
no question.
But I just caution using that number as if it was a fact. It's not a fact. It is something that has been put forward by the emergency department doctors in that report, based on research findings from other places. So I just thought I'd point that out to the committee.
And they would very much know. So again, I would take you back, Minister. Are you anticipating a reduction of services being required in hospital settings?
No, Senator.
So you're not anticipating a reduction of services being required in hospital settings?
No, I'm not. Certainly in line with my previous response that we're doing everything we can to assist the pressures on hospitals by improving other factors in the healthcare space.
So you have decided to cut the funding of hospitals provided by the federal government on New Year's Eve, and yet you are not expecting a reduction in service needs.
So the core funding of hospital senators is not being cut at all
No,
on
the
New Year's
end
Eve.
to the COVID partnership
Well,
agreement.
and as I
there
said,
will be a material reduction in the amount of money provided by the federal government to
As
states and
I
territories.
said, Senator, that the
That's just a
government has not made any decision about
Well, you
COVID.
have decided to end it on New Year's Eve. That's when it ends.
That's what it's currently terminating, but there has been no
Yeah.
final decision about terminating COVID measures made as yet. There's still a process of government to consider those.
Yes, but you have just said, Minister, that you do not anticipate that after New Year's Eve there will be a reduction in service demand, and yet your government has at this point committed to end that funding on New Year's Eve.
I have committed to the fact that we are going to do a lot more to reduce the pressures on hospitals. That's been my response to you, Senator.
So have you taken any steps, has the department taken any steps to model the impact of the ceasing of the COVID funding on elective surgeries that may have been pushed back?
Senator, we have provided advice to government, and government is considering those measures terminating at the end of the year, and government will make its decision in due course, but we've provided advice on elective surgery, on all matters related to hospitals. So I can't say any more than that. These government processes are still under consideration.
How much do you expect the federal government's contribution to hospitals across the country will decrease by in 2023?
The government's contribution to hospitals under the NHRA, as Mr White can say, is determined on the activity that is done by the states and territories, and we have an agreement that has some caps and a funding formula, and if they do the work, they get paid.
But actually
for
under
the
the COVID measures, which is what that's the line of questioning I'm pursuing with you.
Yeah.
So under the COVID measures, what's the decrease after?
Well, that's speculative, Senator, because we haven't, as I said, we haven't determined. Government has not made a determination on what will happen with the COVID measures beyond the end of this year. We can go around this circle a bit more, but there's no firm decision been made yet.
I suppose my frustration, Minister, is that your government has made a clear commitment, stated in the budget papers, that this additional COVID funding will end on New Year's Eve. You may say to me that you haven't made a final determination about what will happen after that point, but to healthcare workers working right now in emergency departments, they've got one set of certainty that money right now, which in some situations is helping them keep their heads above water, is ending, and no certainty on what will come after in relation to that additional funding. And you haven't been able to give me a timeline as to whether and when they will have that certainty. Is there any timeline for the conclusion of the government's consideration as to when, as to what the future of this additional COVID funding may be?
That would go to the process of government, which we can't divulge the process of of Cabinet and its committees, but it's I'm sure Minister
for the Minister.
I'd like to just clarify, though, we have given you a timeline, Senator Steele-John, in terms of the National Partnership Agreement. So that is a timeline I have provided you. And, certainly I take on board the concerns that you're raising, but I do reiterate what we are trying to do outside the areas of the hospitals in the meantime. And clearly this is a space that no doubt you'll keep following us up on.
Senator Steele-John, I'd like to share the call around soon.
One last question and then
Please
that's
proceed.
it. So you are cutting this funding. You're cutting this funding. This funding ends on New Year's Eve. What do you expect people to do, Minister, on New Year's Day?
Senator, I think I've said on a number of occasions there is no certainty
Mr.
around
Murphy,
that. The reason, can I just say one thing? The reason government
Senator Steele-John and
delayed this
Professor Murphy,
decision was because...
It does, excuse me, gentlemen, it does not help to speak over each other. Senator Steele-John, Professor Murphy's, I think, seeking to genuinely answer your question. Are you happy to let him proceed with his answer? And then I'll come back to you for a follow-up question to the Minister if you require. Professor Murphy.
So I think I just provide some clarity, Senator. The reason government decided to make decisions whether or not to extend these measures later in the year was because government wanted to take into consideration the prevailing epidemiology later in the year. And as you know, now we are in another small COVID wave, so that will factor into those decisions of government, and those decisions will, I believe, happen over coming weeks, and certainly in enough time to provide notice to affected people. But we can't go into cabinet processes. But I do think it's incorrect to say that all this COVID money will stop on New Year's Eve.
Senator Steele-John, I will answer your question. Thank you, Mr Murphy. Can I just remind you that this always was a temporary measure in terms of COVID. And, we do know it's going to expire on the 31st, and we will continue working with the states and territories in terms of that funding.
So this
Steele-John.
COVID, just to follow up on Mr Murphy, like what you've described as a small COVID wave, that is having an impact right now in our community. Are you, like, the fourth wave of COVID-19 is here right now. Are you saying that there is the potential that this funding may be extended?
I'm just saying government has, and I think they've made it clear that these measures are under consideration before they expire. I can't speculate on what the decisions of government will be, but I'm certainly, though, there is a process. It was a very deliberate process to look at the COVID response measures funded by the Commonwealth as close as possible to the termination date, so that we can get feedback from Professor Kelly and the experts on what the public health situation is towards the end of the year. So there has been no final decision, and we just have to await that process of government.
So I'm
Senator
hearing that
Steele-John.
Mr Murphy could suggest...
Senator Steele-John, I understand the opposition is seeking the call for this witness. Is that still correct, Senator Ruston?
No, I don't think so.
Well, they were requested by the opposition, but if you no longer require them, that's fine.
I'll send a message around to my colleagues.
You can continue, Senator Steele-John, then.
Thanks, Chair. So what I'm hearing from you is that Mr Murphy could provide evidence that would speak to the need, could provide epidemiological evidence to yourself and to the government that would speak to the need of Professor Kelly. Apologies. Speaking to the need to extend the COVID arrangements. But what I've just heard from you, Minister, is that the measure was temporary. So are you saying that if the epidemiological evidence speaks to the need for an extension, it will be extended?
Well, let's be clear. When all of this occurred at the time, it was temporary in relation to COVID. So let's be very clear on that, Senator Steele-John. But that is not to say, and as I've already outlined, with the Health Ministers' meeting, in terms of Mark Butler meeting with states and territories and ongoing discussions, to add to Mr Murphy's comment about Professor Kelly, well, clearly if something eventuates in the meantime, I'm sure there will be a different direction.
Okay. Well, look, I, on behalf of the emergency workers of WA and of the entire country, really hope that very soon the government is able to provide them with more certainty than ongoing discussions will let you know. Because the stress level and the fear among that work and the extent to which they have burnt out is absolutely profound. And as I say, they have one set of certainty, that the funding arrangements for COVID will end on New Year's Eve, and nothing beyond that currently.
Senator,
in terms
you directed
of those
as a question,
additional measures.
please.
That's it. Thanks, Chair.
Thank you. I'll just confirm we have no other questions for the National Health Funding body, and we can move to APRA.
Can I just seek some clarification? I have questions in relation to health funding. I was thinking I would be directing them towards the department. They were along a similar line that Senator Steele-John was around the make-up to the funding arrangements between the states and the territories, both in terms of activity-based funding under the partnership and the COVID measures. Are they best directed to...
Well, if it's NHRA funding, it might be best for Mr White to be here for them, but because he's the expert on NHRA and how it works. He's not, and if the COVID response money does go through the funding body as well, but so you could, I think it might be worth him staying. Why do you have your questions?
Yeah, sure. So my questions were more around the two different lines of funding that exist in the budget. One in relation to the hospital national partnership agreement on the hospitals, which is the activity-based funding, and also the funding that remains in place for 22-23 in relation to COVID measures. So in relation to the funding profile in the National Reform Agreement, I keep so many different titles for things, the changes in the funding there that show quite significant discrepancy just depending on which state and territory. So we've seen, in New South Wales, a $1.4 billion change in the profile over the 4 years of that funding to hospitals. Victoria, I think 1 billion, 1.4 billion in Victoria. There's a heap in Western Australia of decrease, and then we've seen other states and territories where that funding has increased. Now, I understand obviously that it's an activity-based model, as you pointed out, Professor Murphy, but I'm sort of interested to understand where the provision has been made in the budget, because the budget papers are very clear in a number of places that it is anticipated that there will be an increase in hospital service activity over the coming years. Where the provision for that is, I mean, is it something that's in the contingency reserve? How is this budget accounted for the fact that there is a clear acceptance that there will be an increase in hospital services over coming years?
Senator Alison Essex, Acting First Assistant Secretary, Portfolio Strategies Division. The figures in the budget reflect the activity and the advice of the administrator as to the activity that the states have indicated that they will undertake. The funding formula, as Professor Murphy has indicated, is in the National Health Reform Agreement, and that flows through. It's not a capped program, so that flows through in the budget each time the estimates are updated by the states and territories, or when reconciliation happens, which happens at the end of the financial year. The budget figures and estimates are adjusted at that time.
I certainly understand that. But what I'm seeking to understand is that clearly we've had quite an anomaly in the last 3 years, to say the least. I'm sure, Professor Murphy, you've got different names for the COVID pandemic, that clearly have messed up the way our hospitals have had to operate, and would clearly have messed up in how activity is reported. So, I mean, everybody acknowledges that, and I'm sure, Minister, that you'd be acknowledging that there has been a significant impact of COVID on the hospital, how hospitals have operated. So what I'm seeking to understand is that this isn't business as usual. We've got a situation where we've got massive deferred care, we've had no elective surgery, our hospitals have been operating in a completely different way for the last 3 years than they normally do. In the budget papers, it clearly states on a number of occasions that there is no anticipated decrease in demand for hospital services. So I'm just seeking, what is the mechanism by which the Australian public, when they read the budget of this government, and you're obviously the funding authority for this budget, to know that that has been provisioned for, despite the fact that, you can sit here and tell me it's an estimate's variation, I get that. But the reality is we know it's going to be there, so why hasn't it been provisioned for?
So, Senator, I think the budget papers show the funding going up every year. The challenge is the estimates variation for this year, which, as Ms Essex said, is based on the current estimates provided by the states and territories. Now, that's not the final position. The estimates are calculated by Treasury on the basis of what the states and territories say they think they will do. Some of those states are now revising those estimates, and some of them, they're not sure. Some of them have put, they can code some activity under the COVID NPA and some under the NHRA, and they're looking at the balance of that. So you've got to look at the whole holistic picture, because they are getting money under the COVID NPA at the moment. But those estimates, as Ms Essex said, no one's cutting. There's no funding cut. If they do more activity,
I didn't suggest that there was a funding
but
cut.
if they do the activity, the funding will be there.
Yeah.
So and the estimates will be adjusted accordingly.
But my point is, Professor Murphy, that we are living in extraordinary times.
Yeah.
Because there is a mechanism by which I'm assuming that the states and territories have to report to you. They don't just pick a number out of the air. They will have a set of guidelines, well, I'd hope they do, that tells them how they have to report on this activity-based funding. You know that activity-based funding has been significantly distorted. We all know it's been significantly distorted. So where in this budget does the hospital funding that we know is going to be required for the hospitals, where is it contained in this budget?
Senator, perhaps I could assist in just talking through a little bit, and Mr White, I'm sure, will assist me as needed, but in talking a little bit about how that funding is calculated.
No, I know how the funding's calculated. I'm asking you, where in the budget is the provision for a demand that you say is there accounted for?
So, Senator, if you look at the budget papers in 2024, 2025, 26, you'll see an increase in funding dollars in each of those years. The effect in the 23-24 year is because of the reduced estimates in the base, which then flow through to each of the estimates, each of the estimate years in the forward years. If the hospital activity for each state and territory increases, then that funding will increase because they are funded, as you've noted, on the basis of the activity that they undertake. And that activity-based funding is based on a measure of the activity units that colloquially called the NWOWs.
Yeah, I get all that. But I'm just trying to understand, every year, if you do an analysis of the National Health Reform funding from the budget in March and the budget in October, in some states and territories, every single year the funding goes down, and in totality the funding goes down. Now, I understand why that's the case there. All I'm asking you for is to tell me where else in the budget that there, I mean, and it won't be 2.4 billion. I mean, we're probably talking $5 billion in the sense of we admitting that there's been no elective surgery, deferred care. I'm just seeking to understand where in the budget the funding to states and territory hospitals is contained, because it's clearly not going through the National Health Reform.
Well, Senator, it's a demand-driven program. If the activity increases, the estimate's variation is based on the estimates at the moment, but the money will be provided if the activity is done. That's the way this works. The estimates variation are simply that, an estimate at the moment.
And as Ms.
Just
Professor Murphy...
Before you go on, can I just go back to Professor Murphy? I don't think I'm disagreeing with you that that's the case. But what I'm asking you is, if we are to have any faith that these budget papers actually represent the true position of expenditure on hospital service funding, you would like to think that there would be a provision in here in some way, shape or form. It may well be in the contingency reserve. I mean, that might be where it is. I mean, I don't really mind, but the narrative is extraordinary circumstances. We know there's going to be a significant increase in demand for a whole heap of reasons in the need for hospital service funding, and there is not provision for in this budget at all. And you're just merely saying to me, oh, well, don't worry about that, it'll get fixed up later. We need an accurate reflection of the finances of the government. That's the purpose of estimates. And I'm seeking to understand whether this government has actively, because it has been able to, through the mechanism of activity funding, completely ignored the potential for $2, $3, $4, $5 billion over the forward estimates not to be contained in this budget, because they've chosen not to account for something that they have clearly stated is going to occur. That's all I'm asking.
I think, Senator, Treasury are responsible, obviously, for the estimates variation and the estimates formula and making or not making provisions. So I think the Treasury officials, I think they've had their estimates, but they'd be very happy to talk about the methodology they use for creating the estimates. But we provide the activity-based estimates from the states and territories provided. They then do the estimates variation and they construct those papers. So.
Yep. Okay. Look, clearly we've got a significant underestimation here. I think would be fair, maybe to you, Mr. White, as the head of the funding authority. Is it part of your role to understand from where we are sitting today what the likelihood of the additional funding variation in these estimates is likely to be over the forwards, or is that not something that you do?
Yeah, Senator Shannon White, CEO of the NHFB. The forward estimates modelling is the purview of the department. What I could offer over the last 3 years is certainly activity estimates from the states based on the contracts that they sign between state governments and local hospital networks. And different states have projected different activity levels over those different financial years. Some have assumed things will go back to normal, some have assumed a level of softness that would continue to occur, and so those estimates in activity have increased and decreased depending on the particular state. So we've certainly provided our best advice on where things are at based on what we were advised by the states and territories as a starting point for the forward estimates.
So Professor Murphy, have you provided advice to government what you think the likelihood of the cost of that increased demand that clearly you must have advised? I mean, you would have had input into the health component of this budget, and in there is some very clear narrative around the fact that there isn't expected to be a significant increase in demand for hospital services going forward, notwithstanding the reason why these figures are like they are. Have you provided advice to what you think? We certainly have provided
advice to government on public hospital activity, but I think on budget paper 3 on page 17, I think it shows very clearly that the payments to support state health services increase each year over the forwards. So the budgeting does anticipate continued growth in public hospital funding over each of the years of the forwards.
Okay. So so what page was that?
Page 17 of budget
page
paper
17.
3.
So is that increase in funding across the broader health payments to states and territories, does that take into account the distortion that has occurred in the National Health Reform
I'll get
funding
Mr McCormack,
line?
who's the numbers man, to...
Paul McCormack, First Assistant Secretary, Financial Management Division. As colleagues have explained, it takes into account the estimates that are provided by the states and territories, which are based on their best understanding of the future at a point in time. So it takes into account the ons and offs, the ups and downs, which you characterise as distortions. But they are estimates, and they'll be reconciled over the course of the year to actuals. And
Look, I'm not disagreeing around the accounting practices. I'm sure they're very standard. What I'm trying to understand is, do you, with your clever accounting hat on, do the figures that are represented in terms of the payments to support state health services as well as the National Health Reform funding arrangements collectively take into account the likelihood or the increase in hospital services that have been outlined are going to occur in these budget papers? Or is it remaining silent and are you waiting for an estimates variation to come in, which you think is likely to come in? Is it in these budget papers or isn't it? Because, I mean, it's impossible to tell from reading this.
so I would expect there to be estimates variations in every fiscal update. And
look, I know you've got to be careful how you answer the question, but the reality is we know that between March and October, there is $2.4 billion less in the hospital funding arrangements over a 6-month period. Now, clearly, every other indicator would suggest that there will be a continuing increase in demand on services. In these budget numbers that you have in this budget document, is that 2.4 million plus whatever increase is likely to occur over this period of time contained in any budget figures in this document, or are you expecting over the next 4 years to be a $2.4 billion plus additional cost to the Commonwealth because of increased hospital services?
So the figures as published obviously take into account that $2.4 billion, which is spread over the forward years. So
where would I find that?
Well, you find it in those bottom line figures on page 17, and you also find it referenced in budget paper 1, and I haven't got it with me, so I can't tell you exactly the page number, but it's in budget paper 1 where it lists the material estimates variations, the ups and downs. It's around about page 95, give or take, from memory. And that's where it talks about the $2.4 billion downward estimate.
94.
Senator Ruston, you've
94,
had the call for 15 minutes, and I know
I'm
other
not good with
senators are
numbers,
seeking
Senator.
to ask questions of APRA, so can I ask you to wind up this block of questioning? We'll, of course, come back to you after Senator Roberts.
Well, you can go to Senator Roberts, but I will be coming back to this.
That's fine. We'll bring...
I'm interested to understand, it appears to me maybe Mr McCormack and Professor Murphy are likely to be better placed, so I'm not sure whether we need to keep Mr White, but I'll let the department and you decide whether they're...
Unless there are specific questions under the NHRA funding, probably not. In terms of Mr White doesn't create the budget estimates, they're a creation of Treasury, the budget papers, and we work with them.
Well, I was going to go to the COVID funding.
Well, we'll come to outcome 1 shortly. The committee agreed earlier to conclude with APRA before we proceeded with the remainder of APRA 1 and the remaining agencies. So if that's still the committee's preference, we will continue with that, and we will come to outcome 1, noting that we were meant to move to outcome 2 at 3:15. So if we could have APRA to the table, please, and Mr White, you are welcome to leave. You are also welcome to stay. I feel I need to be clear to everyone now. So, Senator Roberts, when APRA at the table, you have the call.
Thank you, Chair, and thank you for being here today, especially Mr Fletcher. My questions go to who is responsible for a number of events in recent years. I note, Mr Fletcher, recommendations 9 and 11 of the April 2022 Senate Community Affairs references Committee Inquiry into Administration of National Scheme. Can AHPRA confirm whether the General Practitioner Registrar, Dr William Bay, is still indefinitely suspended under Section 156, Immediate Action Powers? He has been since 17th of August 2022 for posing a serious risk, apparently, to the safety of the Australian public for questioning the safety and effectiveness of the COVID-19 vaccines.
Senator, I'm going to be very careful about what I say about current matters, partly because there are very strict confidentiality requirements in the national law, and also because I don't want to prejudice any ongoing investigations or inquiries we have. I might just ask Dr Jamie Orchard to join me, the General Counsel from AHPRA, and he can advise on the specific, what we can say specifically about the practitioner you've raised.
Let me get on with the next question then. It continues with Dr William Bay. Can you specify what risk this doctor still poses despite him not being accused of any harm against patients or there being a single patient complaint lodged against him, especially in consideration of recommendation 9 of the recent Senate report that I referred to a minute ago, where the committee recommended that notifications accepted by AHPRA be limited to clinical cases relating to patient safety, and to recommendation 11 to improve timeliness of resolving the notification process?
So, Senator, the only thing I'm going to be able to tell you about that particular practitioner is what's on the public register. I won't be able to talk about the reasons behind that, and I'm just needing to confirm his current status.
Well, while you're looking for that, how many health practitioners, doctors, have had their registration suspended for questioning the safety or efficacy of the COVID-19 vaccines?
Jamie Orchard, General Counsel of AHPRA.
Oh, Mr Orchard, is it?
Yes, sorry.
Thank you.
I've just lost my name tag. I'll find that in a moment. Senator, just in respect to Dr Bay, he has been suspended. He has been suspended pursuant to Section 156 of the national law. So that's the immediate action power. So he remains suspended at the moment.
Are you aware that he has not been accused of doing any harm against patients, and he has not had a single patient complaint lodged against him? Second question was, in light of recommendation 9, which I'll read, the committee recommends that notifications accepted by AHPRA be limited to clinical issues relating to patient safety. He's not done anything like that.
Sorry. Well, Senator, again, we're unable to comment about the reasons for
Okay, well, let's get on to question 4.
On immediate action. Well, can I just make the point that a suspension is an interim measure and it has to meet a threshold in terms of a risk to public safety or a public interest consideration. It is an appellable decision, so if a practitioner believes they have been treated unfairly in the decision-making of the board, they can appeal that to a tribunal.
And what are the chances of that, given the complexity and what's been going on? How many health practitioners, doctors, have had their registration suspended for questioning the safety or efficacy of the COVID-19 vaccines?
So, Senator, I did provide the data this morning, but I'm happy to repeat that. So there are 28 practitioners who have been subject to immediate action. So, as I say, the interim action we take while we investigate further. Of those 28, 11 were suspended in relation to conduct related to the spread of misinformation. So, for example, things like claiming that COVID-19 was fake, claiming that the vaccine program was government-led mind control. 10 were suspended in relation to failure to comply with things like failure to comply with public health orders, serious or at times fraudulent behaviour, also things like fake vax administration, or indeed concerns about large-scale exemption certificates not consistent with the guidance from ATAGI. and 7 practitioners have not been suspended but have had restrictions placed on their registration which either cover things like requirements for additional supervision or limitations in relation to what they can do around issuing vaccination exemptions or their prescribing.
How many have been threatened or warned directly?
What do you mean by threat? We don't threaten or warn practitioners.
How many do you think have been affected by what's been going on with doctors and nurses from AHPRA?
Well, again, just going back to information I provided earlier, we have dealt with, in the financial year 21-22, 1,303 notifications.
I'm talking about the doctors and nurses who are cowed into silence and will not speak up.
Senator Roberts, can I ask that you phrase this as a question for the
I'll move
officials
on.
to answer,
Thanks,
please?
Chair. Can AHPRA specify exactly who they take direction from? I want to know who is responsible for what's going on. The Health Practitioner National Law Act 2009 states that AHPRA and the board's members are appointed by and its policies are set by the Ministerial Council. Who is responsible for AHPRA's decisions ultimately?
So the Ministerial Council comprises all of the state and territory health ministers and the Commonwealth Health Minister, and they have certain accountabilities under the national law. Among other things, they appoint members of the AHPRA board, and they also appoint members of the 15 national health practitioner boards.
And I understand Yvette Darth is the chair of the Health Ministers' meeting, and Brad Hazzard is the Secretariat. What role does Federal Health Minister Mark Butler play in this oversight?
So Minister Darth is the chair of the Health Ministers' meeting. Brad Hazzard is actually the New South Wales Health Minister, and the Commonwealth Health Minister is a member of the Ministerial Council.
So no special role?
He is a member of the Ministerial Council.
You've been head of AHPRA since its inception in 2011. What role do you play?
So I am the CEO of AHPRA, so I'm responsible to the board of AHPRA, which is the board of corporate board of AHPRA, for the work of AHPRA as the administrative arm of the National Registration Accreditation Scheme. I think it's important to clarify, Senator, that AHPRA is not the regulatory decision maker in relation to, for example, notifications about health practitioners. Those are decisions of national boards, again appointed by the Ministerial Council and comprising both practitioner members from the profession and community members.
Let's come back to that. What directions have been provided to AHPRA by the Health Ministers' meeting to date and by the guilds, the boards, the medical profession?
So under the national law, the Ministerial Council has the ability to issue a policy direction to the boards and to AHPRA. It can't be about an individual practitioner, it has to be about a policy issued. There have been 4 policy directions in the life of the national scheme. One related to the financial arrangements for the co-regulatory arrangements in New South Wales that was back in 2010. We've had one in relation to the outcome of the accreditation systems review that was commissioned several years ago, and there have been 2 that relate to what has now become amendments to a national law, but essentially around the primacy of patient safety in the work of the scheme and the regulatory decision-making of boards.
What is the relationship between AHPRA and yourself with the AHPPC, the Australian Health Protection Principal Committee, that I understand Professor Kelly chairs?
AHPRA has no direct relationship with the AHPPC.
Can AHPRA please detail all sources of revenue it receives and whether any of these sources of revenue are from pharmaceutical corporations or international lobbyists, including the US-based Federation of State-Based Medical Boards or the International Association of Medical Regulatory Authorities?
So, Senator, our funding is predominantly from the registration fees that each of the health practitioners pay on an annual basis. We receive no funding from pharmaceutical companies, and we've received no funding from the FSMB in the USA.
Senator Roberts, we have multiple senators with questions for AHPRA. I just wanted to check in with you. I'm happy to come back to you with a call, but how many more questions do you have?
I've got 3 questions here.
Okay, well, I'm happy for you to finish, and if that concludes your block.
AHPRA's COVID position statement, dated the 9th of March 2021, essentially tells doctors that the government's public health messaging is more important, even where it conflicts with scientific evidence, informed consent, the primacy of the doctor-patient relationship, and the health and well-being of medically contraindicated Australians. If a doctor comes to the view that public health messaging is in conflict with evidence-based medicine, should they follow AHPRA's statement or their own code of conduct?
So, Senator, the joint position statement on COVID-19, which we released in March 2021, is in fact not a statement from AHPRA. It is a statement from all of the 15 national boards supported by AHPRA. And as I said earlier, those boards comprise both practitioner and community members. At the time, it was a response to queries that we were getting about practitioner obligations in relation to COVID-19 vaccination, and that was a time when we were seeing, for example, mandatory requirements for healthcare professionals working in healthcare to be vaccinated. The statement essentially aims to make clear how national boards apply existing regulatory frameworks in the context of COVID-19. So it's important to note that many of the obligations in that statement are not new obligations. They predate the pandemic and they are actually reflected in the codes of conduct which each of the national boards have for the professions they regulate. And at the core of it is an expectation that I think reflects the expectation of the community that health practitioners use both their professional judgment and the best available evidence in practice, including when they are on social media. I think it's important to also note that the statement also recognises that some practitioners may have a conscientious objection to vaccination, and again that reflects provisions in the codes of conduct, and it sets out clearly what a practitioner needs to do in terms of telling their employer, complying with any of the relevant, at the time, public health directions and laws, and also ensuring that their patients and consumers have referral options.
Thank you. Have you seen the open letter to AHPRA from Australian allied health practitioners, nurses, midwives and doctors?
I think I've probably had several letters from them, Senators. I don't know if you're referring to a specific piece of correspondence.
I don't have the date on this one, but they're basically saying that you are doing this, AHPRA's doing this. So how could they have been so confused?
It may assist if that could be tabled to enable the officials
I'll bring it back after the break. It's got notes on it.
Could you bring it back after Senator Ruston's questions? Because it is the committee's intention to dismiss AHPRA.
I'll resume with that.
Okay, Senator Ruston.
Thank you.
It's all right. Just while Senator Ruston's getting ready, for the information of the rest of the senators at the table, it is my intention after we've concluded with AHPRA to return to outcome one more generally. Senator Ruston.
Thank you. Just quickly, just to finish off on some specific questions around the AHPRA model before I move on to some more specific questions. I'm just wondering, following on from Senator Roberts, so who ultimately is AHPRA responsible to?
So, talking about AHPRA, the organisation. So, because there's a lot of moving parts.
Well, you?
Yeah, so I'm responsible to the board of directors of AHPRA. So they could fire me if they chose to. They could hire a new CEO if they chose to. And that board of directors is appointed by all of the health ministers. But the work of the scheme more widely has certain accountabilities to the Ministerial Council. So if I can give you one example, if a national board is setting a registration standard which sets out the requirements for registration in a certain profession, then ultimately that has to be approved by the Ministerial Council.
Okay. So if you want to do anything outside of the agreement of your corporate plan, how would you go about seeking to make a change to your activity?
Well, do you mean, just to clarify, in terms of our remit within our law? Because obviously the first point would be, is it lawful in terms of what our national law allows us to do? So the national law is a reference point, clearly.
I'm hoping that you're always acting within the law, although some of my colleagues might argue otherwise. Okay, so look, give you an example. So okay, what would happen if there was a suspected misconduct within AHPRA, Well, okay, let's be really mean. What would happen if there was an allegation of misconduct against you? What would happen there?
So if there was an allegation of misconduct against me, that would obviously be something for the board of directors of AHPRA, so the AHPRA board, to decide how they would want to deal with that. We do have, for example, and it may well be that they commission an independent investigation of that. If it had come as a public interest disclosure, it would be dealt with under our public interest disclosure arrangements. And I would also note that we have an independent ombudsman for the work of AHPRA and the boards, the National Health Practitioner Ombudsman and Privacy Commissioner. Although she wouldn't look at employment issues per se, she would certainly look at any concerns that were being raised about the way that we were implementing the requirements of the national law from a process point of view.
Yeah. So, in terms of the departments in relationship with AHPRA, if you were concerned as the Federal Department of Health around some regulatory aspect of the health system, what is your ability to interface with AHPRA?
So we have a very close working relationship with AHPRA. So, for example, my department is working very, very closely with AHPRA around the cosmetic surgery issue at the moment. So, but ultimately, any particular, if we wanted to set AHPRA on a different course, like cosmetic surgery is a good example.
We're going to that in a minute.
Hey?
We're going to that in a minute.
Yeah. Well, we then, through Minister Butler, we would go to the Ministerial Council and say we think that AHPRA needs to do more work around regulation of cosmetic surgery. The Ministerial Council would then instruct AHPRA to do that work. So ultimately, the Ministerial Council is the body, but at a practical level, we work very closely with AHPRA and on a range of matters. And again, the other good example at the moment is the issue we talked about earlier about migration and processes for registering overseas trained doctors. So I don't know whether Ms Shakespeare, do you want to add anything more?
No, I think you've covered that.
Yep.
Dr. Murphy.
So, I mean, like, would the department ever investigate the actions of AHPRA?
If we had serious concerns, obviously, if someone came to me and said, accused Mr Fletcher of impropriety, we would take that very seriously, and I would probably go to the board of AHPRA and investigate it. But we generally have been pretty comfortable with AHPRA. We are certainly very keen to look at some of these regulatory processes around overseas trained health professionals at the moment, and ministers have been, I think, particularly concerned about cosmetic surgery, and they have been driving a reform agenda there. And AHPRA's very responsive to the direction of the Ministerial Council, because ultimately they're the boss.
So have you undertaken any investigations into AHPRA recently?
No, not that I'm aware of.
So the Commonwealth Department of Health would not initiate or conduct investigations relating to AHPRA. AHPRA is established under state and territory
Well, that's in
legislation.
complete conflict to what?
We would raise, as Dr Murphy said, concerns through the Ministerial Council.
Okay,
we wouldn't directly do it. No. I said I would. If an allegation came, we would take it through. We'd take it to the right level.
Do you receive any money outside of your registration fees?
So as I say, main source of income is registration fees. There are also, which is renewal. There are also application fees. Sometimes we do get costs awarded in relation to actions that we take in tribunals, and we did receive some targeted funding through the Commonwealth Department of Health in relation to some workforce, some surge workforce initiatives during the height of the COVID-19 pandemic.
So the only funding that you've received from the Commonwealth or from the states and territories has been related to particular project work?
That's correct, yes.
Okay, right, fine. Okay, so moving on to cosmetic surgery. So, I mean, I suppose the simple question is, Mr Fletcher, do you believe that there is a public expectation that when somebody is going to have invasive surgery, that the person who is purporting to be the surgeon should have surgical training in excess of the MBBS.
Senator Russell, can I just confirm you're not asking for Mr Fletcher's opinion? You're asking for a policy?
Well, I mean, he is the regulator, and he has to regulate this sector. I mean, I'm not asking for his personal opinion.
Senator Russell, could I just ask you to rephrase it, just to assist the committee, given we're not to ask officials their opinions? Could you rephrase it, please?
Mr Fletcher, do you have any evidence to suggest that there is a public expectation that somebody who is undertaking invasive surgery would have a qualification in surgery in excess of the MBBS qualification?
Senator, what I could comment on is the fact that the independent review that we commissioned clearly showed that there was a lot of confusion for the community about the education and qualifications of training of people who were offering cosmetic surgery services. The review has actually recommended the development of an area of practice endorsement on registration, which would set minimum standards and training requirements, which would then allow a practitioner to have an endorsement on their registration indicating that they've met a certain requirement around education and training to undertake cosmetic surgery. And I also note that health ministers collectively have agreed to protect the title surgeon as well, so that will become a protected title in the national law. So we think all of those things are very helpful measures because what's very clear when you look at the cosmetic surgery industry is that there is significant information asymmetry for consumers, and the more that we can help people make safe choices about the practitioners they see, I think the better it is going to be for the community.
The independent review into the Australian cosmetic industry, I note, doesn't use the word surgery. It says an independent review into the Australian cosmetic industry. And yet one of the recommendations of that review was that we have a cosmetic surgery enforcement unit. So I'm just interested to understand I know it's a detail around nomenclature here, but the review was silent and has been, makes no recommendations in regards to the term cosmetic surgery, does it?
So the review wasn't a review of the cosmetic surgery industry, widely. It was specifically looking at the question of medical practitioners who undertake cosmetic surgery and what needed to be done to improve the safety of those services for the community. And then just the cosmetic surgery enforcement unit, which we've established within AHPRA, was one of our major responses to the recommendation of the review. So at the time of the review was aware that there was a consultation occurring about the question of protecting the title surgeon. So the review didn't look at that specifically because that was a different process being led through government. But it ultimately made the recommendation about creating the area of practice endorsement, which would be an Australian Medical Council accredited requirement, and we've accepted that recommendation, and we're working with the AMC to get that endorsement in place.
So is the Australian College of Cosmetic Surgery and Medicine accredited by AMC?
Not to my knowledge, no.
You don't think you should know that?
Well, it's not.
It's not.
It's not an AMC registered specialist.
Okay, thank you.
Senator Ruston, I'd like to share the call around. Can I just confirm, do you have a few more in this block, or I'll return to you?
I've got a ton more on this block, so if you want to share it around.
Senator Roberts.
Thank you. I tabled that copy of that letter, the wording of it. AHPRA's position statement, dated the 9th of March 2021, essentially tells all doctors, Mr Fletcher, that the government's public health messaging is more important, even where it conflicts with scientific evidence, informed consent, the primacy of the doctor-patient relationship, and the health and well-being of medically contraindicated Australians. If a doctor comes to the view that public health messaging is in conflict with evidence-based medicine, should they follow AHPRA's statement or their code of conduct?
So again, Senator, just to clarify, this is a statement across all of the 15 national boards for each of the regulated health professions supported by AHPRA. What the statement says is that health practitioners should use their professional judgment and the best available evidence in their practice, and that is entirely consistent with the obligation on registered health practitioners that was in place prior to the pandemic. If concerns were being raised about how a health practitioner had exercised their professional judgment, we are required to assess those concerns, but we assess each of those concerns on their merits. We would certainly look to the public health advice of each of the state and territory jurisdictions in the Commonwealth. We would look to ATAGI, we would look to TGA.
The question was, should the doctor if he comes to the view or she comes to the view that public health messaging is in conflict with evidence-based medicine, should they follow AHPRA's statement or the doctor's code of conduct? That is the question.
So if a practitioner was brought to our attention as someone where there was concern about what they were doing, as I say, we would look to those established forms of advice, and we would also give the practitioner an opportunity to explain on what sources they've drawn the evidence that they've based their clinical decision-making on before any decision is made about whether regulatory action is needed.
So maybe this is why you're not answering my question that I've asked now twice. This is a legal opinion that we've attained. As statutory rules, the codes of conduct for each health profession always prevailed over the 9th March statement from AHPRA, where practitioners were always legally required to observe their code of conduct first and despite the AHPRA statement. Wherever there was inconsistency between the AHPRA statement and the codes of conduct, then the codes of conduct prevailed, and the inconsistent portions of the AHPRA statement were truly invalid and nugatory at law. AHPRA never had any legal basis for those portions of the statement that were inconsistent with the codes of conduct, where AHPRA's threats and intimidation were inconsistent with the paramount guiding principle of the national law, being Section 3A. The health and safety of the public are paramount.
Sorry, Chair, can I just ask a question of that? Senator Roberts, you said you had a legal opinion. Do you have a source, or where's it from? I'm sorry if I missed that earlier.
No, I didn't tell you where it's from. It's from a former barrister who's been working with a group of lawyers.
But we have nothing in front of us to
No, you haven't.
show where it's from?
No.
Okay.
I'm just reading out a legal opinion.
Yeah, well, we don't
So that tells me you're encouraging doctors to breach their code of conduct.
Senator, I might ask Dr. Orchard to respond
Can I
to that.
just, if it may assist the committee, we're reading from documents. It probably would assist the committee members to have a copy of those documents if they're things you're prepared to table. I appreciate you're seeking to table this. The committee is just will make a decision on that at some point in time. Ultimately, it's up to the witnesses if you choose to answer, but if it assists, it might be something you look to do. Senator Roberts.
The question is a simple one. Which prevails? AHPRA's order, the gag order of March 9th, or the doctor's code of conduct? That's all I need to know. That's all doctors need to know.
Senator, if you have a look at the public statement that was made in March, the 9th of March statement, it specifically refers back to the code of conduct and gives it primacy. So if there was any concern about the conduct of a practitioner, it would be by reference back to the code of conduct as opposed to the position statement. The position statement explains how practitioners might conduct themselves in order to comply with the requirements of the code of conduct.
Why is it then that so many doctors and nurses are terrified of speaking out? Terrified. Why the others have resigned from their professions after 30, 40 years because they're afraid that AHPRA will get them? Why? What have you done, Mr. Fletcher, or what has AHPRA done to put that fear into doctors of not giving the best advice in their own professional medical opinion?
Senator Roberts, your questions are bordering on asking for an opinion. I'll let the officials answer it, but I just remind committee members that we aren't to ask officers for their opinions. You can ask them questions relating to policy, relating to expenditure, relating to portfolios. Mr. Fletcher.
Senator, I can only repeat what I've already said, that the statement, which is consistent with obligations in the Code of Conduct, essentially requires health practitioners to use their professional judgment and best available evidence in practice, and practitioners who are doing that have nothing to fear from AHPRA. And even those who are brought to our attention where there's a concern, they will always have an opportunity to explain the basis on which they've made their decision, and that will be taken into account in deciding whether any regulatory action is needed.
There are many, many doctors who are terrified of you guys. So let me go on to
Senator Roberts, please, if you could pose...
That's fact.
This is not a forum for debate. It is a forum to ask questions and a forum to hear answers. So please, I ask you with respect, Senator Roberts, to pose these as questions to the witnesses.
Thank you, Chair. Let's go on to... I'd just like your confirmation or otherwise of some of these statements, please. Matters on the health front shifted... You were with AHPRA from the start, 2011, Mr Fletcher. Matters on the health front shifted up several gears with the coming into force of the National Health Security Act 2007, the Commonwealth. The National Health Security Act has delivered the Commonwealth Government extensive new powers. States prior to that had the power over health. Powers and authority over national health policy by essentially establishing a fourth tier of government composed of the leaders of the states and territories and the federal government, specifically with the Commonwealth Chief Medical Officer as the head of Australian Health Protection Principal Committee and the Prime Minister head of the National Cabinet. Is that correct?
It's not really a question for Mr Fletcher, I don't think, Senator, with respect. Professor Kelly is the chair of HPPC, and we can talk about biosecurity and that stuff, but that's not relevant to AHPRA.
Minister, could I put that on notice? The question to you, please.
Could you just repeat the question so we can make sure we get what you want?
Matters on the health front shifted up several gears with, I'll read it, coming into force of the National Health Security Act from the Commonwealth in 2007. The National Health Security Act has delivered the Commonwealth Government extensive new powers and authority over national health policy by essentially establishing a fourth tier of government composed of the leaders of the states and territories and the federal government, specifically with the Commonwealth Chief Medical Officer as the head of Australian Health Protection Principal Committee and the Prime Minister as the head of the National Cabinet. So I'd like that confirmed or otherwise.
I can answer that question, Senator. Professor Paul Kelly, that none of those arrangements that you've just mentioned are under the National Health Security Act.
Okay, thank you. By entering into a treaty in 2007 with the World Health Organization, commonly referred to as the WHO, where the name of the treaty is simply the International Health Regulations 2005. Is that correct?
There was an instrument of the World Health Organization called the International Health Regulations 2005, to which Australia is a signatory. I'm not really qualified to state whether that was a treaty or not, but I could take that on notice.
Okay, thank you. And to be clear, the International Health Regulations are World Health Organization regulations, where the WHO is a body that receives most of its funding from private sector groups, most of whom have extraordinarily deep connections and investments in big pharmaceutical companies. Is that correct?
I'd have to take on notice the funding of the World Health Organization. There are others perhaps in the room that can assist with that.
I think that's probably, we'd have to provide details, but the WHO receives a large amount of government funding. It does get some money from philanthropic organisations such as the Gates Foundation.
With connections to big pharma companies?
Well, connections, it doesn't receive, to the best of my knowledge, direct income from big pharma, Senator, no. We can take it on notice and provide you a statement of the WHO funding.
Thank you. How do you listen to doctors, and are you aware, Mr Fletcher, that many are leaving the profession? Young doctors, the future of the medical profession, have had enough of AHPRA. That's what they're telling me, and they're leaving.
Well, I'm sorry to hear that you're getting that feedback, Senator, but our data would show that we are not seeing any significant trends in terms of medical practitioners leaving registration. So, for example, choosing not to renew their registration or moving from a practising to a non-practising form of registration. And in fact, year on year, we have seen an increase in the number of registered medical practitioners in Australia. Indeed, across all of the registered professions, we've seen an increase. We do routinely survey medical practitioners and other health practitioners who are subject to our regulatory processes, and we certainly look very closely at that feedback and seek to make improvements to our processes, because we recognise, particularly when you're subject to a notification, that it can be extraordinarily stressful for a practitioner, and so we want to do everything we can to make sure that we minimise that stress wherever possible, whilst obviously maintaining our core focus on public and patient safety.
So last question, Chair.
No worries.
Thank you for that. Who would be the one person responsible for what AHPRA has been doing? Would it be you as the CEO?
Well, I have certain responsibilities as the CEO. The board have certain responsibilities. Each of the 15 national boards have responsibilities in terms of regulatory policies and standards, and likewise the Ministerial Council has certain responsibilities. I'm very happy to provide information that sets out those accountabilities, because they are clearly set out, if that would be helpful.
So who would oversee the gag order that went out? What doctors are referring to as the gag order of March 9th, 2022.
Well, Senator, it wasn't a gag order. I don't accept that characterisation.
As I said, doctors are referring to it as a gag order.
That statement, that joint position statement, was supported by all of the 15 national boards of each of the regulated professions.
Could we have the names of the heads of those, please?
Certainly.
Thank you. Thank you, Chair, and thank you for being here today.
Senator Roberts, can I just confirm you're finished with your questions for
Yes.
AHPRA? Lovely.
Yep.
Senator Ruston.
Senator, I think Senator Reynolds just had a couple of questions, then I'll take us home if that's what the plan is.
Senator Reynolds.
Thank you very much, Chair, and good afternoon. I've got my first questions relate to an inquiry that you'd be aware that the Parliament did in 2018 into transvaginal or urogynecological mesh. I know certainly the Secretary will be aware of that inquiry.
Yes, Professor Skerritt is online from Dublin.
There we go.
He's probably the person to deal with
So
that.
I've got questions for both, but I might start with AHPRA. So are you aware? You're aware of the issue surrounding this mesh? Is that right?
In general terms, yes.
Okay. So as I understand it, it's, for those who don't know, it's there's transvaginal mesh, and there's also vaginal tape implants, which I understand are pretty much the same. Professor Skerritt, have I got that right?
Thank you, Senator. John Skerritt, Head of TGA and Deputy Secretary. There are different devices used. The ones that were of greatest concerns were those that were applied transvaginally. There are other means of applying tapes and meshes for gynecological repair, especially when there's pelvic prolapse.
Thank you. Now, in the timeline that was provided in the report by the committee, and I'll come back to where we're up to with the outcomes, but it said the timeline started in 1996, where the first urogynecological meshes were approved for supply in the US, and then in 1998 approved here in Australia. And then there's a long timeline and quite a often sad history of what's happened to many women. But I just want to go back before that, because it has come to my attention that, in fact, trials on women were appear to have been happening in Australia as early as 1988. Now, this is one for AHPRA. A question: are you aware of a Dr. Peter Petros? Is that name has come across your radar before?
Senator, I've previously indicated I'm not in a position to comment about individual practitioners beyond what's on our national register.
Okay, I might actually just ask you a question on notice up front, if you can come back with as much information, because I've let my fingers do the walking in Google, and he is prolific in terms of claiming to have, in terms of the tape, been the inventor of the tape, and also had IP for it, and has clearly made a lot of money on that and mesh over the years. But he's also been deregistered. He's also been subject to numerous successful malpractice claims. I see Dr. Skerritt is nodding vigorously. So I just want to draw your attention to some quotes from Dr. Petros that I'd ask you to take on notice and look into. So Dr. Petros said that he conducted animal studies at Royal Perth Hospital in 1987. 13 dogs have Merceline vaginal tape implanted and then removed after 6 weeks. and he reported that 10 out of the 13 dogs developed abdominal, excuse me, I can tell I'm not a doctor, abdominal tummy sinuses, but the dog's white blood cell count remained normal and they didn't develop a fever. And he went on to the other things that I can't pronounce. So he clearly did animal studies on his tape in 1987. Then he talks about he did his first human studies in 1988 to 1989 on 30 women with stress incontinence. Now, he didn't name the hospital, but my understanding it was a hospital in Perth's northern suburbs. And he said that women were given the prototype TVT, which was his proprietary tape, instead of the mercinol tape that he trialled on dogs. And at the end of the 6 weeks, he made a number of reports about what actually happened, and he made no mention of physical or mental impacts of the women more than 2 weeks after. Now, I've had anecdotal advice from people in Perth who were at the hospital at the time that, in fact, many of these women suffered significant disabilities and permanent impacts from that. Now, that would tend to indicate that here in Australia, work on this type of mesh and remedies for women with this particular problem started much earlier than when it was approved in 1998 by the TGA. Now, so just that's the background to this, and come back to APRA if I could. So for animal studies, obviously there are different regulatory requirements about conducting studies, but going straight from I'm not asking for an opinion now, but I want to ask this on notice, then going into human studies on women. Now, even in 1989, what would have been the requirements for a surgeon to conduct a clinical trial in these circumstances?
So, Senator, I might answer that, and it's probably a question for the department rather than APRA. Whilst a registered medical practitioner who does undertake research misconduct could be subject to regulatory intervention from APRA, the regulation of human research is a very different issue, and we've got officials here who are involved in that space. But essentially, to do a human research trial like that, you would need the approval of a Human Research Ethics Committee, and presumably the relevant hospital in Perth, if this was, I'm not across this material at all, but I'm talking hypothetically here, you would need a Human Research Ethics Committee approval, and that committee would require a lot of information, including the results of the animal studies, and if there were in a research study to be misreporting or underreporting of adverse events, that's very serious research misconduct, and that misconduct would primarily be dealt with in the local hospital by the governance structure of that hospital. And as I said, if it's a registered health practitioner, it may play into their registration status. But essentially, if you've got concerns about the way human research was done, if you could direct it to the department on notice, and we can undertake inquiries with the Western Australian authorities.
I will do that, thank you, Professor Murphy, because my understanding is that there was no ethics approval process whatsoever, and that the women were discharged and their complaints ignored, and the doctor concerned moved on, and it was nothing else happened.
Sure.
So if you can take that on notice, and I'll provide what additional information I can. We can take that up with the WA health authorities, who would be the relevant people. Please.
The colleagues just check. So in fact, Dr Petros's registration was cancelled by the New South Wales Tribunal in 2019 with a finding of professional misconduct, and he is not currently a registered medical practitioner, and we can certainly share with you the tribunal decision, which is in the public domain.
Thank you. That would be very helpful. And if you could, and I understand there's been actions against him in other states, including in my home state of Western Australia and possibly Queensland.
Senator,
Senator,
it's John Scarrett here. We have to be careful to make sure we only release findings in the public domain, but there have been some other legal and administrative appeals tribunals issues relating to those products, and we're again happy to share what we have in the public domain. And this often covers several states.
Yep. Look,
and
thank
his
you. I won't.
cancellation is Australia-wide. It's
Thank-
not just New South Wales.
No, look, thank you very much. So if I could just leave that on notice with the three of you, and I'll provide what other information that I have, but if you could come back and provide further advice
Noting
about...
that we'll require the cooperation of WA Health to investigate.
But if you don't get that, then that's something that we can
sure.
pursue separately. So thank you. Have I got time for my second?
Yep, you do.
Thank you very much, Chair. The second one I want to come to is Lyme disease, or tick-borne bites or Lyme-like disease, as it's variously called.
The term I think we're still using is debilitating symptom complexes attributable to ticks.
Thank you.
Discats?
Or medically unexplained symptoms as well. So there are many and varied terminologies for this. Can I just ask, first of all, perhaps from the department's perspective, Professor Murphy, are you on notice able to provide an update on the implementation of the recommendations from our 2018 report, the second report, where that's up to? So that's the first thing. And if you could also answer, when people go to their doctors with a tick bite, and under the MBS, what schedule can that be treated under?
We can. I imagine would be treated under a general consultation MBS item. There'd be no specific item, I think, for a tick bite unless there was some particular intervention. But let's take that on notice.
If you could, thank you for all the various manifestations of
and Professor Kelly has got carriage of this disease. I passed it over to him 2 years ago, and he is very happy. He'd be happy to answer that on notice. Yep.
And also medically, I think it's now called, medically unexplained symptoms is a categorisation. So if you could also include that as well. Well,
there's a broad church there. Obviously, where a subset of that is the tick bite associated symptom complexes, but there are a range of others as well. So we'll certainly respond on that.
Thank you.
So,
and
do you want to say anything?
Yeah, I can happily answer some of those questions now,
Thank you.
Senator. Thank you for handing that over to me, Professor Murphy. DSCAT is what we're using, debilitating symptom complexes attributable to ticks. We've had a lot of work, as you know, including the inquiry in 2018, and very good engagement with various peak bodies that are interested in this particular matter. In terms of funding of research, there's been $8 million that's been allocated for research into this issue since 2018, and that included a one-off $200,000 grant to the Lyme Disease Association of Australia in 2019. So and that's continuing work that's been associated with that. In relation to the actual inquiry of this committee, recommendation 1 has been completed. I won't go into the details, but happy to
put on notice.
Do that.
Great,
yeah.
thanks.
Recommendation 2 is progressing. That was in relation to the research, as I mentioned, and then the guidelines and so forth has also been completed. Anyway, maybe it is best for me to put it just to table the update of all of the recommendations, but essentially almost all have been completed, and the ones that are progressing are, in my view, progressing well.
Thank you. Have you got the figures available on how many Australian patients have been referred to infectious disease specialists with potential tick-borne diseases from 2016 to 2022?
I'm not sure that we'd be able to have that information, but I'm certainly happy to look at it and provide something on notice.
Thank you very much. And also in terms of the, I think either whether it's DSCAT or MUS, in terms of the Better Care in Australia's Healthcare Plan 2022 to 32, in section 3, this is one for notice, but detailing foundations of reform, my advice is that this is not sufficiently addressed. So if you could just come back about how MUS and DSCAT is actually now treated and what the plan is.
Certainly, Minister. And Senator, I think the other issue that you haven't mentioned, but I'm sure we will get onto later in the hearings, is long COVID.
Yes.
there is a lot of overlap in many of the symptoms and issues that people are suffering from at the moment, with different names. So the two you've mentioned and long COVID, I think, would be chronic fatigue syndrome. All of those things, there's a lot of similarity there. Yes. And one of the key similarities is the difficulty of diagnosis. Certainly myself specifically and the department in general do recognise that these are real issues for real people, and there was some media coverage of a recent press conference that suggested I did not believe in it, and that is not true. I do know that all of those things are issues for real people and causing real suffering. And so I think the current parliamentary inquiry in the House of Representatives into long COVID will no doubt assist us in some of those issues, and particularly teasing out where there are differences, but also, probably more importantly, where there are similarities.
That's very good. Thank you, Professor Gully. Just one more question. I've got a lot of questions, so I'll just put them on notice, and if we could come back. But one for APRA. Are you aware of complaints that have been made over the years, including in 2 community affairs reports, about the conduct of doctors in relation to how they treat patients who attend either thinking they've got Lyme disease, a Lyme-like disease, or a tick-borne, now DSCAT bite? Has that come across your radar in the past?
Yes, it has, Senator.
Could I ask you on notice if you could report back to the committee about the types of complaints and the types of conduct that have come to your attention, and any guidance you may have issued to doctors, either specialists, infectious specialists, or GPs. So if you could provide the sum total in relation to Lyme that you're able to, that would be much appreciated. Thank you.
Thank you.
Thank you, Chair.
Thank you, Senator Reynolds. Are there any further questions for APRA? Okay. Can I get an indication from you, Senator Ruston? We will be breaking for lunch at 1:30. Do you think you are able to work through your questions before then, or will we require APRA to stay after the lunch break?
My track record's not great. I'll try, but I think there's every chance that we may need to get Mr Fletcher back for a few minutes.
Please proceed. I will stop you at 1:30.
Yeah, sure.
Thank you.
Sure. So back to the cosmetic surgery inquiry recommendations and the like. In September, Minister Butler announced that the Medical Board would be embarking on a process of endorsement around the credentialing of medical surgery by adding an area of practice or in terms of an endorsement on a medical qualification. What was the rationale behind doing that when I would have thought there clearly exists a pathway for specialist plastic surgeons? I mean, they have an accredited college. So I'm just interested to understand why we are having, or what was the rationale behind coming up with an endorsement on a base qualification for to enable somebody to undertake an activity that wouldn't normally be accredited under a different mechanism.
So, Senator, the area of practice endorsement was actually a recommendation of the independent review. So essentially the Medical Board has agreed to act on that recommendation, and essentially an area of practice endorsement is really a regulatory tool, and the reason why the review recommended that this was needed was because of the absence of any minimum qualifications or training requirements in relation to medical practitioners who are undertaking cosmetic surgery, and so the endorsement is a means by which those standards could be set. As I say, it's done through the Australian Medical Council, so they're independently verified, if you like, and accepted by the Medical Board of Australia, and then they would appear on the public register. So a consumer who was thinking about undertaking cosmetic surgery would know whether somebody had that endorsement on their registration. I think it's also important to note, Senator, that this is part of a wider package, and ministers have also decided to amend the national law to protect the title surgeon, and there's substantial work occurring through the Medical Board on essentially strengthening some of the existing guidelines that there are for medical practitioners who undertake cosmetic surgery.
So what's the difference between a cosmetic surgeon and a plastic surgeon apart from the qualification that they have in terms of the procedures that they undertake?
So plastic surgery is a recognised area of specialty. So
I know, I'm just asking what's the difference in what they actually do?
Well, at the moment, the way it works currently, any medical practitioner could call themselves a cosmetic surgeon and could potentially undertake cosmetic surgery. Obviously, the expectation is that they do that within their skills and competence and their education and training, but at the moment there is nothing that stops them doing it, which is why the measure around protecting the title stops them calling themselves a surgeon, and which is why the area of practice endorsement, as I say, would then highlight those practitioners who are undertaking cosmetic surgery having met requirements around minimum standards of training and qualifications.
I'm really still at a loss to understand why we are talking about this still when, you know, clearly the word surgeon, I think every Australian understands that the word surgeon needs to be protected. So in protecting the word surgeon through the Ministerial Council and the direction that will obviously follow into national law, will that prevent somebody who is currently calling themselves a cosmetic surgeon from practising plastic surgery without the necessary qualification to be a plastic surgeon?
So ministers will need to decide in framing the legislative amendment which current areas of specialist registration would be allowed to use the protected title of surgeon, and that's something I know the Ministerial Council is looking at. Once that's legislated, it would be an offence under the national law for somebody to hold themselves as a surgeon if they didn't have one of the areas of specialist qualification that allowed them to use that title.
Mm-hmm.
It wouldn't stop someone undertaking cosmetic surgery, but they could not call themselves a surgeon.
Can you unpack that for me? Somebody can undertake surgery on someone's face, invasive surgery, and you have no power as a regulator to do anything about that if they don't call themselves a surgeon. I can call myself a cosmetic interventionist and undertake invasive surgery, and you have no power.
Well, we would certainly have power to act on that if what was clear was that your performance in undertaking those procedures fell below the standard that was expected, or that you were practising in a way that was outside your education and training and competence. But this is what the review highlighted, that currently any medical practitioner could call themselves a cosmetic surgeon and undertake cosmetic surgery. That will in part be addressed by restricting the use of the title surgeon by amending the national law. The area of practice endorsement will further help by making clear what the minimum standards of training and education are for people who get the endorsement on their registration, and I say that will be publicly available. But the national law doesn't allow us, except in a very few specific cases, to prohibit somebody from undertaking a certain practice.
So what has been the resistance for APRA not making a blanket recommendation that the use of the term surgeon should be protected under national law? None of this endorsement stuff, but that it needs to be protected, and in order for somebody to be able to call them a surgeon of any variety, they need to have the endorsement of their of the AMC and obviously the relative college that needs to be accredited with AMC to be able to do it. So I really sort of can't understand why, you know, what is the logic behind saying somebody can be a cosmetic surgeon, even with these extra things that have been recommended that you're proposing to do, and they're not required to have the necessary qualifications that exist under the College of Plastic Surgeons and the necessary qualifications that sit with that. I mean, it seems quite anomalous to me that you can call that your organisation as the regulator is going to, I suppose, water down what I think the Australian public think they're currently protected in relation to a surgeon, instead of just saying you can't be a cosmetic surgeon, because a cosmetic surgeon is a plastic surgeon in everybody's mind unless you are a plastic surgeon. I mean, what is the resistance for APRA not to go to that point? I mean, what's the logic?
Senator, I'm perhaps just again and restate what's in place. So we welcome the fact that ministers have decided to protect the title surgeon. We think that is a good step for all the reasons that you're saying. The fact we think it makes sense for this area of practice endorsement around setting minimum standards for training and qualifications for people who work in, who want to undertake cosmetic surgery or cosmetic practice, because we want consumers to make safer choices. We're not trying to, outlaw an industry here. We just want to help people make safer choices. I think it's premature at the moment to speculate on whether that is going to be a lower standard. It may well be a higher standard, and that's the work the Australian Medical Council are doing at the moment as the independent accrediting body, looking at things like what are the required graduate outcomes or the outcomes that you'd expect of somebody having this endorsement, what are the sort of required training inputs. And once that's established in the form of an accreditation standard, which will be approved by the Medical Board, that will then also be reflected in a registration standard approved by the Ministerial Council, and then programs of study who believe they can meet those requirements will be able to apply for accreditation. But I don't think we should assume it's going to be a race to the bottom.
Well, no, that's where we are at the moment, I would suggest.
Well, that's the point of the endorsement, to actually, because this issue of minimum training and qualifications is not a new issue.
No, but I mean, I think we're being a little tricky on the words, but I still don't understand why APRA haven't come out and said you can't be a cosmetic surgeon unless you're actually a plastic surgeon. I don't understand your resistance, but clearly that has been...
We don't have the power to do that, Senator.
You could be recommending it to the ministers.
Well, we support the protection of the title surgeon, and we provided advice to ministers to consider around what we think the scope of that should be.
Yeah, but what your recommendation of that scope could be is actually around an endorsement and not actually using the existing endorsement that exists within the plastic surgeon's remit.
It may be, Senator, that most people, to get that required endorsement, they may have to show a level of training which is consistent with the plastic surgery qualification of the college. That's to be determined. But the challenge is that there is no, any surgeon, an orthopaedic surgeon, is in theory could do cosmetic surgery at the moment. They're and call themselves surgeon. The only APRA can regulate them if they practice clearly outside their accepted training, experience and scope of practice. Most medical practitioners work very responsibly within the training that they have, and don't even though the basic medical qualification. GPs do surgery. Lots of rural GPs do surgery. They can't call them. They're not fellows of the College of Surgery, but they do training. They do skin cancer surgery. Most doctors are totally responsible, work within their training and scope of practice. The challenge is that this industry, to be frank, is very different, and it needs a separate and special regulatory approach.
Senator Ruston, it's now 1:30, so we'll be moving to the lunch break. Do you require APRA to join us after the lunch break? Okay, we now suspend. See you at 2:30. (2:40). The committee will now resume. Just to give people in the room an indication of what we are intending to do as a committee, is we will be dealing with the agencies listed under outcome 1. So there's 5 more minutes, I understand, for APRA, and then there are a number of agencies listed under outcome 1. We will be finishing consideration of these agencies at 4 o'clock, and then we will be moving to the policy area of outcome 1. Can I just make sure that's clear to everyone at the table? I will be seeking to move the call around quickly so we can move through these agencies. I ask for your cooperation so we can get through as many of them as possible. If you haven't indicated to us who you need to speak to from those agencies, grateful if you could let the Secretariat know or myself, but to facilitate the work of the committee and us running behind, that is what members wish to do. Is everyone comfortable with that who's here? Okay. Thank you. Okay, we'll be commencing with APRA. Senator Ruston, you have the call.
Thank you. And we should be able to deal with this very quickly. Professor Murphy, you made a comment before the lunch break that you believe that there was every possibility that the accreditation or endorsement process for cosmetic surgeons under the various activities that are currently on foot could well see these particular practitioners qualified in excess even of a plastic surgeon. I'm just seeking an absolute guarantee from Mr Fletcher that this will not mean that existing people who call themselves cosmetic surgeons will be grandfathered into the new arrangements without undertaking the necessary accreditation.
So, Senator, as I say, the Australian Medical Council is doing the work as the independent agency to set the requirements for accreditation, and I would not expect that there would be grandparenting arrangements. There may need to be some sort of transitional arrangement as those new requirements are implemented, but I would not expect that there would be grandparenting arrangements per se.
Okay, so you can categorically rule out that this quote is not correct. There are some people who are currently doing cosmetic surgery whose training and experience would warrant grandfathering, and there are others whose training and experience might not. But clearly there will be some people who will be so well trained and experienced and qualified that they can be grandfathered.
They would have to meet the new standard to get that endorsement of practice. So there may be some people who would meet that new standard when it's established. But I think what Mr Fletcher's saying, ministers are clear of the view that to get this endorsement of practice, you would need to meet the new standard set by the AMC.
You'll need to be accredited to that standard.
Yes, to get that endorsement of practice, you would need to demonstrate a level of training and qualification and that is sufficient to meet that standard. Yeah.
Accredited training.
Yeah, well, the training has to be determined by the AMC. They are looking at what that means. Yeah.
So is the AMC potentially considering, that qualifications could just be based on, or that accreditation or endorsement could just be on the basis of experience?
Now, what the AMC are doing are working out what are the requirements, both in terms of the educational program and the sort of graduate outcomes, if you like, that would need to be met in order to be accredited. And then once that standard is established, it would sit in a relationship with a registration standard that would be set by the Medical Board of Australia and approved by ministers, and then providers who think they meet that requirement could apply to be accredited, and if they were accredited against that standard, that would mean that people who had undertaken that training program could then have this area of practice endorsement on their registration.
Well, I put to you that the person who said that quote was the head of the medical board.
Well, I think the point to make, Senator, is that if you don't have the endorsement, it doesn't mean that you would necessarily stop undertaking cosmetic surgery.
I think that Australians would be very, very concerned at the lack of clarity that you've been able to provide here today, that cosmetic cowboys will be off the market. I think you have only served to make me think that there is going to be an ongoing process of being able to shortcut one's way to a qualification that will enable you to cut up someone's face. And so I remain very concerned and put on the record that I'm very concerned. Final question, Mr Fletcher, will you be making yourself available to attend estimates into the future?
So the Ministerial Council, who are accountable to when we sought their advice in relation to the invitation to appear before the Senate estimates, agreed to do that we should appear on a one-off basis to aid transparency. If there was a future invitation for us to appear before a Senate Estimates Committee, we would, I think, need to go through a process again of confirming that health ministers were comfortable with us doing that.
Well, Chair, could I put on the record that I will be requesting that APRA attend future estimates hearings, particularly as I would like to find out what's happening, because we've only got a 4-week process of consultation in relation to this very serious issue, and I'd like you back here in February to answer questions about how that consultation and rollout has occurred, how we've gone in changing the national law in relation to the use of the term surgeon. So if I could put that on the record now.
Thank you. I'm going to go in order. So Senator Rennick.
Hi guys. My first question is in regards to the number of deaths reported by the ABS last year. Total deaths last year were 171,000.
Oh, sorry, Senator Rennick. Are you addressing questions to APRA?
No, sorry. No, I was TGA.
TGA, okay. So APRA, I think you can go.
Okay.
I understand we've exhausted all questions for APRA. Okay.
Thank you.
Thanks for coming.
Thank you.
Yeah, so we're going to be dealing with that now. So just to be clear, all of the outcomes, all of the individual agencies listed under outcome 1, which we haven't already done, including TGA, that's what we're dealing with now up to 4 o'clock. So I'll be moving through in short blocks. Yep, that's one of them, or if you have them for other agencies under outcome 1. So sorry, Senator Rennick to the TGA, please go.
Okay, sure. Okay, so last year, 2021, we had 171,298 deaths. 2020, we had 162,592 deaths, which was about 2,000 less than 2019. The rate of deaths increased in May by about 1,000 a year, so it jumped by 1,191, 987 in May, 1,577 in June, 1,396 in July, and 495 in August over the prior months. Now, the reason why I'm targeting on last year's increase in deaths was that there was very little COVID in the community. Well, there was the outbreak in December, but between May and August, there were 13 deaths from COVID in July and 90 in August and none in May and June. So has the Department of Health / TGA looked at the increase in deaths in 2021 over 2020, and have they actually done a temporal association between the date of vaccination and the date of death in those people that passed away?
So, thank you, Senator, for your question. I'll start, but I'm not sure if John is... John's still on. So just in the general issue of death, I can just say that we do look at excess deaths, which I think you're referring to there in terms of the Australian Bureau of Statistics figures. We do look at it by month, we do look at it by year. In 2020 and 2021, Australia was one of the very few countries in the world, I believe it was 5, we were one of 5 that that did not have increased excess deaths throughout that entire period. I think it's important to take the whole year because of the seasonality of death rates.
No. I know where you're going.
Yep.
Excess deaths and actual deaths. I'm talking about actual deaths. I'm not talking about excess deaths, which is modelled over 5 years. I'm talking about the actual numbers.
Yep. And
I've adjusted it, so there was next to no population growth last year. So there's no, trying to average it out or seasonality. This was a constant increase of over 1,000, approximately 1,000 with the exception of August, because there was a big jump in August in 2020 because of the deaths in Victoria.
That was when there was a COVID outbreak in 2020. New South Wales in particular. So I think in terms of deaths, I think the 2020 and 2021, I understand what you're saying about the comparison with previous years, but it's not that's not modelled. That's actual numbers
exactly
of deaths.
Right. And I deal in
actual
actuals.
numbers of deaths. Yeah, I deal in actuals too. So that I just wanted to clarify that, but I think your question specifically goes to adverse events following vaccination. I think Professor Dr. Skerritt is best.
I will touch on adverse events later on, but I want to know what the temporal association, so the time between the date of vaccination and the date of death, and I've just had it confirmed by the ABS that they can do that data because everyone had to download a digital certificate if they wanted to go anywhere. So it should be possible to track date of death back to date of vaccination and then establish a temporal association between vaccination and date of death.
So I'll turn to Professor Skerritt because he's the one that can talk through the process that we go through in relation to that.
Okay, I've talked through the process of identification of causality with deaths before, but just on the Australian Bureau of Statistics numbers, on their website they emphasise that they cannot be used as official estimates of
Sorry,
excess
Could we have the
mortality
volume
turned up?
turned
for
up?
that
Yes.
period.
Oh.
Sorry?
Just the volume, Mr. Scarrett?
Broadcasting is just adjusting your
can you-
volume.
Sorry, can you hear me?
Yes, that's great. Thank you. Continue.
Oh, good. So the Australian Bureau of Statistics emphasise on their website that the statistics that they put out cannot be used as estimates of excess death. And during that period, a number of actuarial experts have come out and emphasised that if excess deaths were due to vaccines, the actual increase in deaths would have been on the younger people. And if you look at the age breakdown of those excess deaths, they are largely in the over 75s. As far as your other measure, that can be done. Of course, looking at a time lag between vaccination and death doesn't necessarily infer causality.
No, I realise it doesn't necessarily, but it might infer causality. And can I say between April and July, the major cohorts that were vaccinated were the older people. And you're right, it's the older people who've actually had the rapid increase in deaths of about 10%, because the younger people are all locked down, so their death rate fell because they weren't having workplace accidents. So I'm familiar with that. But yet again, you've got a responsibility here, given the jump in deaths from May onwards. You cannot rule out that it was from the vaccine, can you?
We look at, as I've indicated before, we look at every death that is reported as potentially being temporarily related to vaccination, and we refer those that are of particular suspicion to a committee of external experts. In that data, there were also increased numbers of deaths that were attributed to cancer, dementia, and ischemic heart disease. And of course, during lockdown, there were fewer other infectious diseases because of social isolation. So the ABS statistics have not been seen by, as I say, by any of the professional groups, such as the actuaries who make a living out of doing this, as being associated with vaccination.
Well, have you done a correlation between the date of death and the date of vaccination? Just a simple yes or no. Have you actually established the time
For
between...
the cases where there are deaths reported, we do look at the date of vaccination.
Well,
and we don't see a correlation.
Can you please provide a copy?
1 week and die the next.
Can you please provide a copy of of those deaths, date of deaths and date of vaccination, please? That should be.
We'll provide our analysis.
Okay. Second question is in regards to lipids. Last time I spoke about lipids, and you said they were like the normal lipids in an everyday sausage. You might in your breakfast, in everyday sausage. Well, that's not what Pfizer has said. They're on their very own website. They have said that the lipids used in these vaccines isn't an everyday lipid that is readily available, and that they actually had to come up with a new type of lipid. It's a cationic lipid, and it was the one that basically contained the that was the lipo nanoparticle. And it's well known that cationic lipids can disrupt the mitochondrial cellular respiration that's responsible for consuming oxygen or producing energy. And they're known as reactive oxygen species. My question to you is why did you say that these were normal lipids in the vaccine when they're ionised lipids that to change their characteristics completely from hydrophobic to hydrophilic, that can transfect any cell and doesn't rely on an ACE receptor to enter the cell, hence increasing infectivity?
So first of all, lipids and lipid nanoparticles do not rely on ACE receptors to enter cells. I think you've got your biochemistry confused, Senator. There are 4 lipids in the lipid nanoparticles, 4 different lipids. 2 of them, as I indicated earlier, are naturally occurring bodily lipids. So in the lipid nanoparticles, we have cholesterol and we have diasteryl phosphatidylcholine. Now, both the Moderna and Pfizer vaccines do contain 2 other lipids. These lipids have been used in a number of other products. And for example, the Moderna 2 lipids have been tested and shown not to be genotoxic in bacterial and mammalian cell lines. Now, there are globally recognised standards for testing pharmaceuticals that all countries adhere to, from the International Conference on Harmonisation. And the levels of lipids in these nanoparticles are below the threshold for toxicological concern for genotoxicity from the International Conference of Harmonisation.
Okay, thank you.
That all OECD countries align with.
So,
move the call around. I'm doing 10-minute blocks to try and get through as much as we can
Okay.
by 4 o'clock. I was going to pass to Senator McGrath. It's Senator McGrath's time, so Senator McGrath, you go, please.
Thank you. I've got questions to the TGA also in relation to vaping. How many authorised prescribers for nicotine vaping products are there as of today's date?
Okay, well, thank you, Senator. As I've advised earlier, the term authorised prescriber is frankly highly misleading because any of the 130,000, I think we heard from APRA earlier today, any of 130,000 registered medical practitioners in Australia can prescribe nicotine for vaping. What an authorised prescriber can do is prescribe for any number of individuals, and so therefore it sort of simplifies the process. Now, as of the 15th of October, so these numbers unfortunately are almost a month out of date, there were 1,353. So I would guess there's probably about 1,400 to 1,500 by now. But I've got this special authorisation to prescribe for any number of patients in Australia.
Okay. In February this year, I put a question on notice asking what engagement the TGA had with social media companies around the unlawful advertising and supply of nicotine vaping products. And your response said that you'd had preliminary discussions with Facebook. Have you since engaged with any other social media platforms?
Oh yes, the engagement, in fact, it was not on nicotine, but on melanotan, which is quite a dangerous tanning product promoted on social media. We have very close relationships with all the major social media groups, whether it be Alphabet, whether it be Facebook, whether it be TikTok, and I'm sure I've left a few out. So we do three things with them, Senator. Firstly, we identify the sorts of products that we ask them to flag and to use their algorithms to block with keywords such as nicotine or melanotan or bodybuilding, or you can imagine. Now, those keywords aren't foolproof because there's other words that are used by people to get around it. The second thing is we flag suspicious or worrying posts to them, and generally they take them down. The third thing we do is we meet with them every couple of months to talk about compliance priorities.
Okay. On your website, you state that TGO 110, which I understand to be the Standard for Nicotine Vaping Products Order 2021, you state it'll be reviewed 6, 12 and 24 months after its implementation. It's been 13 months since implementation, and I understand no reviews have been released. Can the TGA provide details of what reviews are currently being undertaken and how the reviews are being conducted, and can the TGA also provide a breakdown of when these reviews will be released?
So, Senator, this has been an active area of discussion with the Minister and government ever since the May election. And indeed, a range of things have happened, including on the 30th of September, Minister Butler convened a round table of vaping experts to discuss potential requirements for policy and regulatory reform. So, in a way, those consultations, and he has also given a commitment to public consultation on possible reforms, and he's also given a commitment to consultation with states and territories and healthcare professionals and community groups. So that process has actually supplanted the idea of getting an independent group of academics to review the process. There's a view by government that the urgency, the dramatic increase in youth vaping needs to be addressed with a matter of urgency. And so currently the plans for next steps are before the Minister, and a decision hasn't yet been made of exactly what will happen when.
So who was on the round table? Sorry, can you state who was on the...
I'll take the full list of attendees on notice. I imagine they are public, but we may have to seek their consent through the Minister for their names to be released.
Sure. And since I last asked the TGA back in February also, and it was a question on notice, it's SQ 22000180, have there been any further discussions between the TGA or the Department of Health with the Department of Home Affairs about the volume of disposable Chinese-made vaping products reaching Australian shores and into Australian schools?
There have been. It is a major problem. And again, one of the things that will be considered by the Minister is whether there need to be further changes to the approach taken at the border. But as I say, that is current. All these things are before the Minister to look at what steps he wishes to consult with the states and territories, consumer groups, healthcare professionals and the public on in the coming months.
Thank you. And I asked the question on notice also back in February, and it was SQ22 000173, that the TGA stated in its reply, testing for prohibited ingredients is not performed if the product does not contain nicotine. Of the 126 products where nicotine was detected, 42 products, 33%, were found to contain one or more prohibited ingredients. Of the 126 products that were found to contain undeclared nicotine, 22% of these products originated from China, 0.8% originated from Hong Kong, and the remaining 77% were of unknown origin. So I think we can take from this answer that of the offending products where country of origin was stated, 96.5% came from China, and of those 126 products, 39% contained at least one prohibited ingredient. So I'm just going to assume, and please correct me if I'm wrong, that all of these products were disposable nicotine vaping products and came from a handful of Chinese manufacturers, Gunpod, iGet and HQD, the same vapes that keep turning up in schools. So if we know that China is accounting for over 90% of offending products and roughly 40% contain harmful ingredients, why not just ban the importation of Chinese vapes, or at least ask the Australian Border Force to set them aside for the testing before they're released?
Well, as I've indicated, measures on, for example, on whether the requirements of TGO 110 should be strengthened and whether there should be further actions at the border are under consideration by government. So I can't comment on particular policy options, Senator.
So you also stated the answer that you don't test for prohibited ingredients where nicotine is not detected. Well, and you may have touched on this, but who then is responsible for testing those products for prohibited ingredients?
We base our testing on intelligence. So as you've indicated, we've found a number of prohibited ingredients in certain vaping products, but the initial screening that we carry out is where we suspect there may be nicotine, even though it's been hidden or not declared. So we don't have a blanket approach, it's intelligence-led. Our resources do not permit us to test every vaping product for every potential ingredient, and so it does have to be driven by even such things as mining the dark web, looking at internet, looking at social media, looking at prior testing and talking to other countries, including Interpol. So we gather a lot of intelligence, and that has to direct our testing because we just don't have resources, and I doubt anyone would, to test every product for every substance.
But I suppose where I'm coming from, if prohibited ingredients such as Diactel are exponentially more harmful for people than nicotine, does the fact that the TGA has no interest in testing for the more harmful and banned ingredients make this regulatory regime self-defeating?
No, I didn't say that. I said we use intelligence, and so the same way, even with a prescription medicine, if we've got intelligence that it's a reputable supplier, and you've talked about some companies having a particular risk, if it's a reputable supplier, we are less likely to chase those other ingredients if we've found earlier that their products, or others globally have found that their products are free, for example, of diacetyl. And of course, the concentrations make the toxicity. So as I've indicated, it's intelligence-led, merely because nobody has the resources to test every product for every substance. And the same applies for prescription medicines, never mind vaping products.
Okay. One more minute, Senator McGrath.
Okay. I suppose, why should this not sit with a regulatory body that has regard for the safety of all products rather than those that just contain nicotine? Surely the ACCC is better placed to run this than the TGA, because I'm concerned that there's such a narrow scope in relation to the responsibilities in terms of the testing of these products.
So TGA only has a legal remit for when products are therapeutic goods, either medicines or medical devices. Under Australian law, a non-nicotine containing vaping product is not a therapeutic good. Now, government is considering what it should do about the regulation of non-nicotine containing vaping products. And as I've said, however, the deliberative process prior to a consultation is underway, Senator. So, and of course, it is up to government what agency is responsible for what function.
I do have more
There's a call
questions, but
on.
anyway,
I'll try and come back to you, Senator McGrath. I'm going to Senator Canavan next.
Thank you, Chair. I've got some questions on vaping, but I just want to follow up on Senator Rennick's line of questioning there. Just on the provisional mortality statistics of the ABS, I mean, obviously running at a rate 17% higher than the historical average. What is the Department of Health's or TGA's view for why that's occurring?
Professor Kelly should probably.
Well, maybe I could
I might start, Professor Skerritt. Thank you for the question.
Go ahead, Paul.
Yeah, thank you for the question, Senator. I did refer to Senator Rennick's question earlier about 2020 and 2021. 2022, different story. As you've pointed out, we are now in an excess mortality position. Now, some of that, of course, is due to COVID-related deaths from people that have had acute COVID. And I will point out, as I did to Senator Rennick on the other night, that vaccination has been an absolute game changer in terms of protection against
I've got
those
very
deaths.
limited time, Professor Kelly, so I more want to focus on the question I asked. I haven't
So
mentioned vaccination, just why are we running at excess deaths?
So part of that is due to actual COVID deaths,
Yep.
But there has been, and I think Professor Skerritt referred to this earlier as well, there has been an increase in other causes of death. Dementia, cardiovascular disease, respiratory illness and so forth, many of them are up. We're still investigating why that may be. It could be partly due to people not receiving best care for their chronic diseases through the last couple of years because of the COVID effect, indirect effect of COVID.
Lockdowns.
And it could also be due to longer term effects of COVID itself. So that these are.
So is there a
issues of
team
long COVID.
investigating this within the Department of Health?
Absolutely, yes. We're looking very closely at that at the data, and we're working with our other agencies. And there's a specific process that I mentioned earlier in relation to the parliamentary inquiry on long COVID and the commitment from Minister Butler to have a plan in relation to that.
Are you planning to release publicly the findings that that team makes about excess mortality?
So some of that information will be part of our submission to the other inquiry in the other part of this building. But then, yes, there will be further work. We're also doing some excellent work with Victoria at the moment. I'm not sure if my
I might leave it there. Sorry, just because I've only got 10 minutes.
Anyway, there will be data.
And timing of this, when do you expect to finalise conclusions?
In terms of the course of death?
Like, have you set your team on what answers by this date? Or,
so I'm not sure if Mr. Gould is here, but he could answer that question.
If you could make it quick, I am sorry, but just...
I think he might be in the other room.
I do have some other topics.
Oh, there he is. Yeah.
So, Philip Gould, First Assistant Secretary for the Health Economics and Research Division. I have a team at the moment who are looking at a range of linked data sets to help us better understand causes of death across a range of conditions, including COVID-19. It's really important when you do this sort of analysis that you take into account.
Sorry, Dr. Gould, I just wanted an answer to when you might conclude that work. I'm really sorry, I wouldn't normally be this abrupt, but just given I've only got a bit of time.
We have an ongoing program of work.
So no end date at this stage.
We will make information available.
Okay, I appreciate that. I did want to turn to vaping, probably more to Professor Skerritt. Thank you. I'm just referring to some recent data collected by the Cancer Council, which finds only 8.6% of Australians that use liquid nicotine in vaping products have a prescription, or effectively complying with the prescription model. Have you done any work? Does that statistic sound about correct?
We have had those figures quoted to us. We don't have any way of verifying it, but clearly it shows that there is still an unacceptable level of nicotine vaping products getting to our children and adolescents. And so this is why the Minister...
Hang on. No.
So
my question didn't mention children or adolescents at all. It's simply of the 500,000 vapers in Australia, vast majority of whom are adults, only apparently 1 in 10 or so have a prescription. Is that? Do you have any work on the compliance with your regulation?
we don't have any information on the number of people who might be obtaining it illegally.
I mean, it would seem to me that the current regulation, and look, just anecdotally, you know this talking to people, that a lot of people aren't getting prescriptions. It's not exactly working. And isn't there a situation here where a regulation which is not being complied with is actually helping create the conditions for a black market, which does generate those outcomes you have referred to earlier, of having it more accessible for younger Australians?
Well, I don't know how it creates a condition. The question is whether we have the appropriate framework in place. And that's why, as I said, the government, soon after election, wanted to look at how it could be reviewed, because their major concern are children and as us principals and parents, very concerned about children and young adults and adolescents accessing it. So the framework is being reviewed.
I completely accept that. I don't think anyone would disagree that having these products accessible to young children is reprehensible and should be combated. The issue here is how effective the current regime is, and it doesn't seem that effective at all. Just turning to, there was a question I noticed from Senator Abetz. It's SQ 222-4080, and that was asking you about this. I think you mentioned the review after the election, but there was also, in reference to his question, a 12-month evaluation. You referenced that you would do an initial evaluation after about 12 months of the prescription model. How is that evaluation progressing?
Well, as I indicated earlier, very soon after the election, we met several times with the Minister to look at what was working, and as you've indicated, worries about access by children and young adults, and it's going a different direction, as I indicated. So the Minister brought together some experts in the field and is considering next steps at the moment. So it's going that direction rather than an independent review, because the urgency of making sure our children and adolescents do not access nicotine for vaping is extreme.
And so that initial evaluation you referred to in Senator Abet's question, that's redundant now. You're not progressing that at all. That's what I'm taking away?
Well, that response was prior to the change of government, and the Minister is looking at alternative approaches.
Okay. Also, another answer to Senator Abet's, this is SQ 50s, in fact, 3. It was regarding illicit vape sales to young Australians. The TGA said, and I quote, "It does not accept responsibility for the unlawful supply of NVPs, nicotine vaping products, to children." I mean, so I just was a little bit shocked at that answer. Are you saying you have no responsibility to regulate or ensure that? I'll be very clear. I'm not trying to blame you for all provision of these products. Obviously, not your fault, but I would have thought you'd have some oversight here.
Regulatory framework. So, Senator, within the current regulatory framework, it is intended to stop access to children and young adults. But clearly it is insufficient. It's not working well enough at the moment.
I agree.
Because children and young adults can go to tobacconists, they can go to convenience stores, they can buy product over the internet. And so there are many ways around the current regulatory framework, which is why the government is reviewing it. But TGA is not standing there in the street corner.
I agree completely. And given the time, I've got some other questions I'll put on notice, but I would just say again, it seems to me we should focus our enforcement efforts on the young, not on the old, and not on consenting adults. I've got some questions.
That's where we do, Senator.
I've got some time. If I've got time, I've got NHMRC. Sorry to be jumping around a bit, but I'm trying to facilitate the committee as much as possible.
Appreciate it, Senator Canavan.
They are in this block, are they? NHMRC? Oh, are they? Should I come back? Then I don't want to. Oh, hang on. Seems to be they're
And if the agencies can just be aware, we are moving through all the agencies listed in outcome 1, not in order. Okay.
When we're ready.
think we're ready.
Okay, thank you. I'm just referring to an article back on the 24th of June 2021 in The Australian. It was titled Greg Hunt Orders Review into Risky Wuhan Research. In that article, the Minister is quoted or referred to as saying that the NHMRC has been tasked with undertaking a review of gain-of-function research that might be conducted within our government or our policy in regards to it. Could you give an update on that review?
Yes, thank you, Senator. I'm Professor Anne Kelso, Chief Executive Officer of the National Health and Medical Research Council, NHMRC. Senator, we completed the review for Minister Hunt and provided him with the report in March, and it went up on our website on about the 8th of April 2022.
Okay. Did that... I apologise then, I haven't been following your work as closely as I should. What did that find? Are we doing any gain, or have we done any gain-of-function research in Australia?
The review examined Australian government-funded research in Australia over the last 10 years.
Okay.
We had a committee from within government and an expert advisor review all potential projects, reviewed 6,000 projects funded by NHMRC, the ARC, undertaken at CSIRO, undertaken around the country. And out of the 6,000 found 17 projects where there was gain-of-function research that could be considered of concern. And so we examined whether all of those projects had the appropriate regulatory controls and whether there had been any incidents that could have been of concern, and everything was in order.
Did any of those 17 involve researchers either from the Wuhan Institute of Virology or researchers who had been researchers at the Wuhan Institute of Virology?
Not to our knowledge, the Wuhan Institute of Virology wasn't a named participant in any of those 17 projects.
Did any of those 17 relate to coronaviruses?
I don't recollect myself whether any of them were to do with coronaviruses.
Okay, we can take that on notice. Is gain-of-function research allowed? Is it legal under Australian government guidelines?
A great deal of very useful, positive gain-of-function research is undertaken around the country. It's an essential technique in modern molecular biology, and in fact a great deal of what we know about viruses, about the current coronavirus, SARS-CoV-2, the procedures that we use to make, for example, the AstraZeneca vaccine for COVID-19, these have all used gain-of-function research techniques.
And possibly the creation of SARS-CoV-2?
No,
well.
gain-of-function research of its nature involves the
possibly it could have led to the coronavirus pandemic.
Not to my knowledge, and there's no evidence that any work was done in Australia.
Okay.
Senator
and finally,
I just need to share the call.
What are their guidelines? Is there guidelines around when researchers in Australia do gain-of-function research?
Yes, and the report that is on our website outlines the very wide range of regulatory processes that are in place, from ethics all the way through to the work of the Gene Technology Regulator.
I'll come back to this, I'm sure. Thank you very much, Chair.
Senator Canavan, I'll come back to you if I
can
before the
tea
tea break.
Today. I'm at another estimate.
Senator Roberts. Thank you, Senator Canavan.
Thank you, Chair. Thank you for being here. Can you tell me how many medicines have been approved under the provisional approval pathway during the COVID period, 1st of July 20 to date, please? My numbers are 13 vaccines and 6 drugs. Is that correct?
Sorry, thank you, Senator. Are you talking specifically about COVID treatments and COVID vaccines?
No, just any vaccines, any drugs that have been approved using the provisional pathway.
I will start with COVID vaccines and treatments. There's been 7 COVID vaccines and 8 COVID treatments. I'll just check whether I've got the numbers for other medicines during that period, Senator. So you're talking about the provisional approval pathway.
Yes.
So, okay. So from the 1st of July this year, there's been 5 provisional approvals. From the period 1st of July 2021 to 30th of June 2022, there's been 23. That would include those COVID treatments, but what it does show is there's a lot of other medicines, such as cancer medicines, such as medicines for rare conditions, that are also approved. In financial year 2021, so from 1st of June 2021 21 to 1st of July 2021 to 30th of June 2022, there were 5. So over the period you're talking about, that would add up to 33.
Thank you. How many drugs have been approved under the normal process during that same period? Just a number.
During the same period, I will add the 3 financial years, and I'll check my mental arithmetic. 36 this current financial year, 117. These are either new approvals or new indications approved, and 95 the year before. So it is a percentage of them, a significant percentage, but not most of them.
Thank you. Is the maximum provisional approval period 6 years? Because it can take that long to get a drug approval under the old approval system.
So a provisional approval is only valid for 2 years, and then the company either has to come back and show why they cannot obtain all the data within that period and apply for an extension.
Is the maximum provisional approval?
And they can apply for a further lots of 2 years.
Is the maximum provisional approval?
So overall, the maximum period is 6 years, but it's not 6 years off the bat.
Thank you.
It's written in law, but it's 2 years
Thank
off
you.
the bat.
It's 2 years with extensions. How much money do you
With possible extensions, they're not guaranteed, Senator.
How much money do you save pharmaceutical companies by switching from full approval to express approval? I understand it's hundreds of millions per approval.
It actually costs the pharmaceutical companies more in regulatory fees for provisional approvals.
No, I didn't say regulatory fees. How much are you saving there? How much are you saving the pharmaceutical companies by giving them express approval or provisional approval rather than going through the 6-year period of getting proper approval?
It's not a 6-year... No, you've misinterpreted the system. It's not a 6-year period to get full regulatory approval, Senator.
It varies. I accept that.
A company can put in most of our approvals are submitted straight as to a standard approval, especially, for example, if it wasn't a public health emergency or it's a drug that already has other ones in the same category. They're submitted as a standard approval.
So what I'm talking about is if they have to do dedicated trials for their drugs, how much, because I understand that can be hundreds of millions of dollars. How much time would they save? How much money would they save by going express?
We would not give a provisional approval to a medicine unless if there were clinical trials.
How much money does it save? How much money does it save doing if they do a provisional without doing a formal normal approval process? How much money does it save a drug company?
I don't believe there's necessarily savings. The situation will be different in every drug, but it's really important to emphasise there were very extensive clinical trials for the vaccines and treatments that have been through provisional approval.
My understanding is that it can cost hundreds of millions of dollars to get the full approval process in tests. Without the dedicated trials, they can save hundreds of millions of dollars per drug.
I don't necessarily agree with you, Senator.
Okay. When does the provisional approval for Pfizer expire?
So the 2-year period will be 2 years from the anniversary of the first approval. I would emphasise that in certain countries,
so what is that date?
The products are now fully approved.
What is the date of provisional approval expiring?
The very first approval for 16 years and over, the 2-year period finishes on the 25th of January 2023.
Thank you. Is this the approval process for the I've got here in front of me a document called the Australian Public Assessment Report for Tozinamerin from Community Pfizer, December 2021. Is this the approval application for the paediatric version of the Pfizer vaccine?
No, it is not. What an Australian Public Assessment Report is, it's a summary of the assessment that we did of the application. The actual application, and you mentioned Pfizer, is over 220,000 pages of paper for Pfizer for that particular group of vaccines.
Thank you. Can I reference page 61 under, quote, limitations of the current application data? It says, and I quote this, safety follow-up is currently limited to median 2.4 months post-dose 2 in cohort 1 and 2.4 weeks for the safety expansion cohort, end of quote. What is the safety expansion cohort?
Okay, so remember also this was going back at the time of approval. We now have hundreds of millions, actually more than 1 billion people who have been vaccinated with that vaccine, and experience going on since December 2020 when the first vaccination was done. The safety expansion cohort is in a clinical trial where individuals are monitored closely and the data reported back to regulators for periods of months leading to years after their vaccination.
Thank you. Did you recommend this substance then based on 2.4 weeks of safety testing, or did you get more in? And if so, over what period? How many months?
No, so remember the initial approval from TGA was based on that 2 months of follow-up, but we also had the experience of other countries that had more than a month before started mass vaccination campaigns. So when we approved Pfizer on the 25th of January 21, we were in almost daily contact with the British, who by that stage had vaccinated some millions of British people by 25th of January 2021. So real-world evidence played a very important role in both the approvals and in the ongoing safety monitoring of these vaccines.
So you relied on data from other countries, and you relied for periods of months, merely months. So it can't be more than 6 months because there's a gap between application and approval, and to give time for collection of data and analysis. So this should be years of data before we start putting this kind of stuff into our children. Yet it's months.
I disagree in the context of a pandemic and a public health crisis. Regulators globally felt that it was appropriate to do initial approvals.
You're the Australian regulator.
Several months' data.
You're the Australian regulator.
Yes, and so as the head of the Australian regulator, I would do precisely the same if I had my time again. The alternative would have been to leave Australians unvaccinated through the course of 2020, 2021 and 2022. And there would have been tens of thousands of more Australian deaths, Senator.
Can I then reference a letter from the Commonwealth Department of Health signed by Radha Kiani, Director, Governance and Coordination Section, in which the department makes this claim. It's this letter here on the 4th of November 2022, just last week. Quote, "A large team of technical and clinical experts at the TGA carefully evaluate the data submitted by the sponsor. A treatment or vaccine is only provisionally approved if this rigorous process is completed. This document concerned the use of Pfizer Stage 2-3 clinical trial data in support of their application for provisional approval. Did the TGA check the Stage 2, Stage 3 clinical trial data from Pfizer? Did you check it?
We did check the phase 2 and phase 3 clinical trial data from Pfizer, and we also took it to independent external medical experts as well as consumer representatives.
Thank you. Referencing Freedom of Information number 2289, in which the applicant requested a copy of the Stage 2, Stage 3 clinical trial data, and the TGA responded, quote, "The TGA does not hold any relevant documents relating to the request." End quote. And that was the request for Stage 2, 3 clinical data, trial data.
I believe, without seeing what's in your hand, I believe that you asked for individual patient data rather than the phase 2 and phase 3 clinical trial data. I can give you my word that we assessed the phase 2, phase 3 clinical trial data. Otherwise, what else did we do? Look at the colour of the label on the bottle. That is the main thing our team of several dozen clinicians look at in reviewing a new vaccine. The phase 2 and phase 3 clinical trial data, it is a centrepiece, Senator.
The Freedom of Information request then asked for, quote, "any documents confirming the process of analysing this data to produce a decision, including meetings, notes, dates and times," end of quote. And again, the TGA replied, "We have no relevant documents." That's a quote. Did you review the Stage 2 or 3 data or not? And if you did, why did you tell this Freedom of Information applicant you did not have these documents? Which document is the lie? One of them is.
Senator, I don't have that document in front of me, so the FOI, so it's not really, we can review it on notice, but we reviewed the phase 2 and phase 3 clinical trial data at length.
Senator Roberts, this really needs to be the last one so I can share the call, please.
So I just want you to think about this and confirm it or otherwise. And the trial data contains sufficient proof the vaccines were safe and effective, sufficient to meet the criteria for provisional approval. Is that correct?
Correct. Yes.
Thank you very much,
Thank you,
Chair.
Senator Roberts. Senator Cadell, you have the call.
I want to go back to vaping if I can. I think probably Mr Skerritt, is it still the advice to government that nicotine vaping products should not be sold in Australia except through prescription?
Yes, it is, Senator.
Thank you very much. I come from a different point of view. I am a non-smoker, never smoked a thing, don't do it, have advocated against big tobacco donations. I heard this research about that. I think Senator Canavan, over 90% of people vaping in Australia are not doing so through legal means or had trouble believing that. Do you, once again, you think that's a possible number? You won't speak, you haven't seen numbers, but is that possible?
I think it is quite possible because it is very easy for people to break the law. And the question is, how can the system be strengthened so that our children and young people don't get access to nicotine vaping substances?
Okay. Do you accept that all of 2 of the OECD nations have legalised and regulated tobacco vaping products for sale without prescription?
That is a fact, and I think Australia should be very proud of what we have done in vaping, the same way we should be very proud with what we've done in plain packaging of tobacco.
What information do we have that these other nations, including New Zealand, which regulated in February, don't have to base this decision?
I think we are in a situation where in some of these other countries the horse has bolted, and the impact on youth vaping rates and on smoking rates is evidence. I was recently in the US with US FDA, and their tobacco centre is essentially playing catch up to a system where they've had an explosive increase in the number of young people vaping. And now by trying to almost in retrospect regulate products on the market and take products off the market that, for example, may be particularly attractive to young people, they are playing catch up, but they're also caught up in the courts with that.
Mr. Skerritt, is it your testimony that the horse hasn't bolted in Australia? Over 90% of users do so illegally. I'll get the point, Madam Chair. I know no one in Canberra. I've been here for 3 months. 10 kilometres from here in 10 minutes today, I was able to buy a nicotine vaping product without knowing anyone. The horse has bolted. You surely can't say it hasn't.
No, I think that the government is currently considering what they can do to manage this problem for our children and young people. So we could put up white flag and give up, but I don't think that is the view of the government.
But I'll put another point. My son, 16 years old, president of his SRC, Lachlan, his brother, 13 years old in the SRC, they are fundraising to try and buy vape detectors for their bathrooms because it is rampant in their school. They can't stop it. It is too late to lock the gate on this. You're saying we got in early. We haven't, surely.
I disagree that it's too late to lock the gate. If we give up like that on all matters to do with public health, Australia would still have the smoking rates, for example, that we had in the 1970s.
If we make it financially viable to do illegal acts and create illegal activity in Australia, surely they will not care if they sell it to kids, if they sell it to people, or what they do. Is that not right?
Well, there needs to be mechanisms whereby those breaking the law can be more readily detected, and it is practically harder for people to put out vaping products. So, for example, we have vaping products at the moment with rainbows and unicorns on them that surely appeal to adolescents. Do we need to have something that's a prescription medicine with rainbows and unicorns? They're the sorts of things that are being looked at.
I had a choice of purple haze, berry blast, melon madness, bliss berry, melon heaven, pink lemonade today. It's surely...
Well, should we have flavoured products? These are things that need to be considered and consulted on publicly.
Okay, I take that.
Because
now,
they do attract young people, those flavoured products.
Have young adults or children died or suffered serious health effects with vaping in Australia?
There have been poisonings of toddlers due to nicotine vaping products. There is evidence, and again, I know that there are various studies on their way to being reported, of respiratory and psychological and other impacts on teenagers and youth with vaping. I think it would be dangerous to assert that these are harmless products. In fact, there's been a fair bit of media from parents and from the children themselves indicating that nicotine is not a benign substance.
Do we think that these babies and young adults are getting prescriptions and buying this from New Zealand legally?
No, they're getting it, as you say, from tobacconists, from convenience stores, over the internet, various mechanisms. And the question is, how do we enable people who appropriately want to use nicotine vaping products under their doctor's supervision for smoking cessation, but stop our children and young people gaining access to them because of the damaging effects of nicotine on developing adolescents.
Mr. Skerritt, I am not pro-vaping. I am anti-bad laws. This law has failed. This law is failing. It is time to look at other solutions. I accept that there are other, we'll talk about looking at what the new government will do, looking at tightening up this stuff. But if this situation exists in the next 6 and 12 months after this change, will you commit to reviewing, looking at regulation in Australia so these products, as harmful as they may be, can be regulated in a more effective way and constrained through better retailers than they are now?
Well, if they are prescription medicine, it's inappropriate for a retailer to produce them. You don't go to a 7-Eleven to get morphine, for example. I do give my absolute commitment that we are looking at better regulation of these products, because the regulation certainly needs to be improved. It's not good enough now. And that is what's before government for decision on what to consult on.
Okay, I urge you to just think, it's personal experience and everything like that. I couldn't believe I could get this so quickly. So thank you for your time.
Yeah, I agree. I could get it in 10 minutes. I agree with you, Senator.
Oh, this is Canberra. Who knows what we could get now, but here, anyway. Thank you.
Thank you. I owe you a coffee for getting through your block quicker than planned. We're going to go to Senator Steele-John now. I think Senator Steele-John's seeking the COVID task force.
No, I'm seeking the TGA first.
TGA? Okay. But we'll let the COVID task force know they'll be required shortly as well. Senator Steele-John, you have the call.
Thank you. All right, so to the TGA, I'd bring you now to the interim decisions in relation to psilocybin, sorry, and MDMA, released, I think, on the 21st of October 2022, where the delegate opposed the rescheduling. MDMA and psilocybin are illegal in most Australian jurisdictions. Do you know which states or territories have permit exemptions so that patients can access these substances for medical use?
Thank you for your question, Senator. States and territories are enabling access for supervised clinical trials. However, very few jurisdictions are enabling their access through the Special Access Scheme, but they are available for clinical trials. The view of the scheduling delegate and on the advice of the advisory committee was that they seemed to have considerable promise, but they were not yet shown to have a place in therapy, and that there were some major trials underway globally that we expect will have results in the next year. And they are always open to reconsidering the decision if more evidence comes to fore. But at the moment, in most jurisdictions, they can be accessed. Sometimes they require a special permit from the Director General because of their scheduling nature for clinical trials.
Mr. Skerritt, I just want to check that I heard you properly over the line. Did you say that most states and territories have special access exemption schemes?
No, I said clinical trials exemption. So most states and territories...
Yes.
But it does, in some states and territories, it does require an additional permission from their Secretary for Health or from their police department because of the nature of the substances. So they are not easy to access in clinical trials, but there are clinical trials underway.
And to your understanding, Mr. Skerritt, is it the case that every state and territory has such a clinical trial access process?
It does vary between states and territories. And as I've indicated, some of them are extremely challenging and that you have to go and get a separate narcotics permit. Others are more straightforward. And so I wouldn't say that there's clinical trials underway in every state or territory. The main clinical trials that are being looked at are ones being conducted in the US and in Europe, because they're the bigger trials.
Yep.
And there are some very large ones that will be reported on in the coming year.
So just to clarify, to the TGA's knowledge, every state and territory has a process. It's just that in some states and territories, it's more difficult to access than in others.
They have a process, but in some states and territories, it does require either a formal regulation to be made or a formal permission to be obtained from either the Director General of Health and or the Commissioner of Police. So I wouldn't want to say it's as simple as doing a clinical trial for other substances.
Okay, so when you say that there is a regulation that has to be made, which states and territories are you referring to there?
I'll have to take that on notice, Senator, because the system is changing, but we can take that on notice to advise on, because we always would like to check with the states and territories if
Yes.
we're reporting current things under state and territory law, but it's still accurate. So can we
yes.
take that on notice for the situation in each state and territory?
But I would say that if there is a state or territory in which a regulation is required, but it has not to this point been created, that would mean that as of now, there wouldn't be a process until that regulation had been created.
Some states and territories can make regulation, not legislation, which has to go through a parliament, but some states and territories can make a regulation, for example, based on a brief to their health minister. So what I suggest we do is that we document the situation in each state and territory for you, Senator, on notice.
Okay. In relation, going back to the delegate decision, the delegate stated that the therapeutic, in the ruling, that the therapeutic value of psilocybin and MDMA had not been established, was yet to be established, yet the submissions to the open submission process included letters from leading experts that stated clearly the therapeutic value has indeed been established. These experts include Professor Arthur Christopoulos, Dean of Monash University's Faculty of Pharmacy and Pharmaceutical Sciences. In addition, 100% of submissions from registered health professionals supported it, 97% of researchers and 99% of public submissions. Could you please share with me the evidence, therefore, that could you share with me first the qualifications of the delegate who made this decision?
So we have several scheduling delegates, all of whom have for medicines, all of whom have medical qualifications as well as postgraduate qualifications in various areas such as public health and pharmacology. But we have several delegates. The delegate acts as a direct delegate of the Secretary in making that decision and in looking at the evidence, but they also act on the advice of the Advisory Committee of Medicine Scheduling, which comprises medical doctors, again, public representatives and representatives of the states and territories. And while they do not formally vote, there was not support among the Advisory Committee for rescheduling.
Yeah, Mr. Skerritt, I understand that is the case in the general sense. I'm referring specifically to the delegate who made the decision in relation to psilocybin, which was released, the result of that decision was released on the 21st of October, 2022.
Yep. So
in
that
opposition
particular
to the,
delegate.
Yeah, so that particular delegate, I want to know the qualifications of...
That particular delegate has is a medical doctor with 3 university degrees, 20 years of experience in pharmacology, as well as postgraduate qualifications in public health.
And does that include a psychology or psychiatry degree or qualification?
So the delegate was informed by advice by both the Australian Psychological Society and the Royal Australian and New Zealand College of Psychiatrists. So the 2 peak bodies for psychologists and psychiatrists, and both of those bodies were strongly opposed to down-scheduling psilocybin and MDAA. So the peak bodies for the psychiatrists and the psychologists both strongly opposed down-scheduling. So that was where the psychiatric and psychological advice also came from.
So we've got a situation here, Mr. Skerritt, where we have leaders in psychedelic medicine research, health professionals, consumers and members of the public who have significant qualifications in this space, made submissions to this process in relation to the rescheduling of psilocybin and of MDMA. And again, I'll put to you the 100% support rate from the registered health professionals who submitted, 97% of researchers, 99% of the public, and yet the delegate made a determination that it should not be rescheduled. Can you share with me what research, evidence or otherwise the delegate took into consideration that led to their decision?
Yeah, so first of all, I think your statistics are a little bit misleading because, as I've indicated, the Australian Psychological Society,
in what way,
thousands of psychologists.
In what way is that statistic?
In what way they are the peak representative body, the APS.
No. In what way was those statistics misleading?
Because you said 100% of health professionals supported rescheduling, and I've said the two peak
that made
bodies
submissions to the inquiry.
Psychologists opposed it. Well, the Australian Psychological Society and RNNZCP also put submissions in, and they represent some thousands of health professionals. That's what I was picking you up on, because we have two peak bodies that were strongly opposed. I'm just telling you how it is. I'm not giving a personal opinion.
Senator Steele-John, I'm about to hand the call over.
So
just going back to the research that they relied on, beyond those two recommendations, the research that was relied on by the delegate in making the decision.
So the delegate went through all the published papers on clinical trials, looked at the size of that. I should also add that we commissioned an external review, which is published on our website, of the research on the efficacy of these products. And it concluded there was promising work, but not conclusive work. So we have commissioned an external review of the medical literature in this area.
And that was taken in, you commissioned a review and that was what they relied on, in addition to those recommendations?
We paid money for the review, Senator, yes. So we commissioned an external review of all the research. The delegate also looked at any research that had been published in the period since that review, and also looked at the submissions. And most importantly, took the advice of the Advisory Committee for Medicine Scheduling, which was essentially unanimously opposed to rescheduling.
Essentially, was there a dissent on that?
As I said, they don't vote, so it's only what you hear at the meeting. So they don't work by voting.
Sorry. Senator Antic, you have the call. Then I'm coming to you, Senator Pocock. We're going to the tea break at 4. Thank you, Senator Antic.
Thank you, Chair. This is a question for the department broadly. Is it still the department's position that the COVID mRNA injections are safe and effective?
Yes, Senator.
It is?
It is, yes.
Can I ask this question then of Professor Kelly? In January 2021, you said the words as follows in relation to the AstraZeneca vaccine, quote, "In terms of preventing death, it works 100% of the time. In terms of preventing severe illness, it works 100% of the time." You still stand by that?
That was at the time, and I think this is very important, Senator, that at that time, that was the information we had in front of us. Subsequently, it hasn't been exactly 100%, but it has been very high protection, to the point where we have real-world data here from Australia, because I know that you are in favour of that, and I will share that with you. So, in the current wave that we've been experiencing in terms of, in the Omicron era since the beginning of this year. In cases with an illness of onset from the 15th of December 2021 to the 4th of September 2022, the proportion of cases who have died is more than 22 times as high in unvaccinated people, that would be any vaccine, including AstraZeneca, compared with fully vaccinated people aged 12 to 49. Over 32 times as high in people aged 50 to 69, and over 14 times as high in people aged 70 and over. There's a further halving of the death rate when you get to the third and fourth doses.
Can I ask you this? The previous Senate estimates hearing, Professor Kelly, you said to me that in relation to my suggestion that the COVID vaccines don't prevent transmission, which of course is a key plank of the mandates, you said that was, quote, not a true statement. It actually was a true statement, though, wasn't it?
No, it was not a true statement in my view, Senator.
In your view, or according to the science?
That would be my view based on the science.
So
there is an effect on transmission.
But there is no
several publications on transmission.
Yeah, there are many publications which say it has no impact on transmission. So
There are many publications that say there's an impact on transmission.
Well, what is that impact? We went through this last time. What is it in real world terms?
So it decreases. It is lower now with Omicron and lower with Delta. With the original ancestral and first couple of strains, the impact on transmission was significantly greater. It wasn't as great as the impact on infection. And on notice, I'm happy to give you a list of the 7 or 8 articles. Quite recently, a study using Omicron BA1 and BA2 still showed that there was reduced transmission for people who had a booster compared with only 2 shots. And so we're still seeing some impact on transmission, but I need to emphasise the vaccines have not been approved for an impact on transmission. It is not in the approved product information.
Well, in that case, you would agree, therefore, that the instigation of mandates across the country was a nonsense.
So, Senator, I would firstly say that mandates are no longer the case from a public health point of view. They were for 18 months. There are still some in some workplaces, I will admit, and that those mandates were largely an issue for the state and territory authorities, not for us here at the Commonwealth.
Can I just move to a slightly different topic now? Earlier on in the day, Senator Waters used the phrase pregnant persons twice, and I think in response the department used the phrase birthing clinics. Is it the position of the department that men can get pregnant and give birth?
Senator,
I'm sorry to do this to you again.
Yeah, I mean, really.
But we need an answer. You are the Department of Health, but people put a lot of emphasis in this.
And you need to get pregnant and give birth, you need to have a functioning uterus. So whatever you call someone, and it's generally very unlikely that someone who is a man would have a uterus and give birth. So I think that's all we can really say.
So only biological women can get pregnant?
Well, you have to have functioning female reproductive organs to get pregnant and give birth, yeah.
Which would limit it only to women, presumably? No? Okay. Have you ever been pregnant?
Okay.
Okay, so no, in any event, I'm sorry, I haven't quite finished. I haven't I've just got another question, Chair. I was actually going to ask the same question to the TGA, but I expect, because in fact when the TGA responded to me about a question in vaccination and pregnancy, the term pregnant persons was used. So, Professor Skerritt, do you want to have a go at that one? Does the TGA consider that men can get pregnant and give birth?
I think the Secretary has given the biology lesson that you have to have a uterus in order to become pregnant and carry a pregnancy through to full term, and therefore you have to be biologically female. Different language is used because obviously individuals may choose to represent themselves as different from their birth gender. So that's why we talked about pregnant persons. But I think it's pretty obvious you need to have a functional uterus to be able to carry a pregnancy.
Right. Okay. Minister, if it is ultimately found that there was nefarious conduct with the data or in relation to the safety and efficacy of the vaccines, will the Australian government honour the indemnities given to pharmaceutical companies in relation to any future court action?
Senator Antic, I'd like to take that question on notice.
I thought you might do that.
Okay.
You might do that.
Was that your last one?
Oh,
Senator
look, I could
Antic?
go on and on about that, but I've got a neonatal test for myself, so got to go and check myself
Appreciate
out.
the assistance
Just
you're
want to
providing
be clear.
the
I just want to be
committee.
careful.
Thank
You never know when a
Senator
bloke can get
Antic.
pregnant.
Senator Pocock, I'm coming to you. Can I just allow Senator Whish-Wilson wants to just place a question on notice, and then I'll come to you, Senator Pocock, for your block.
Just on notice, I was wondering if you could give us an update on the number of people, because I understand this would be updated every day by the TGA, the number of people who have accessed the SAS or AP Schedule 8 medicinal cannabis scheme.
Happy to do that on notice. I could give you an indication.
If you're happy
it's
to take
about
it on notice, that would,
for medicinal
unless you've got it quickly.
Yep. Well, it's about 300,000 all up for a special access scheme for medicinal cannabis products. 300,000, Mr. Chair.
Great, and I'll put some more detailed questions on notice. Thank you.
Thank you very
That's
much,
excellent.
Senator Bush-Wilson. Senator Pocock, you have the call.
Thank you, Chair, and thanks for your time today, yesterday, day before potentially. I've just got a few questions for the Australian Digital Health Agency.
Can I just ask, Chair, Professor Scare, it's 5 a.m. in Dublin. We'd like him to be able to go to bed. If there's any, are there any more TGA questions?
I will confirm in the tea break. I understand we've got about a minute just before we get to the break. I'm doing my best to release you, Professor Scare. I'll have some advice to you as quick as possible.
Thank
Senator
you.
Pocock.
Sorry. We'll get in relation to the Digital Health Aid to get the experts to the table.
Hello.
Hello.
To start with, I'm interested if you know how much this My Health Record system has cost to date.
Amanda Cattermole, Chief Executive Officer, Australian Digital Health Agency. Thank you, Senator. There's probably several elements to the question because the My Health Record system is sort of part of a national digital health infrastructure that's been running for a decade now. So I can sort of provide you, if you like, with the broad elements of what that looks like, and roughly, it's hard to sort of disaggregate exactly all the pieces, but I can walk you through.
If you want to take it on notice and just send through the info, that'd be
I can
great.
happily do that. I can give you the sort of broad brush, but given the time, I'm happy to take it on notice because the My Health Record has a number of elements around it, including authentication processes and criminal terminologies that together make up the system. So I can do that now, or I can do it on notice given the time.
On notice is fine.
Okay,
Thank you.
terrific. Thanks, Senator.
And my understanding when it was set up, one of the things that was talked about was how it would be useful in an emergency situation.
Yep.
Do you have stats on what percentage of ED doctors are actually looking at My Health Records?
I do indeed, Senator, and thank you. That's exactly right. That is indeed one of the things that we've seen more and more as sadly we've been facing a number of emergencies in recent years that we're starting to see that use an uptick. So I can take you through some specifics and then I could provide you with more detail as you wish.
That'd be great, thank you.
If you take, for example, the Lismore floods or things like the moment the Queensland border opened, for example, the uptick in the use and viewing of the record, so for example by pharmacists who are needing to support people who might have had their medications information, went up exponentially at those moments to sort of, in the sort of 400% and 500%. So it upticked at the moment it was needed and then, moved back to sort of more normal levels once that emergency was not there. More broadly, over the last 2.5 years, given the circumstances that we've had with the pandemic, we've seen exponential growth in the use, viewing use of the record, both by consumers but also by clinicians right across the health system. And that's quite sustained. So we've seen, if consumers, for example, up sort of 200%, GPs 140%. I can give you more detail, but we've certainly seen that emergency environment has created a significant shift.
And do you have the percentage of visits to the emergency department where the doctor's looking up the...
I've got public hospitals. So yes, that's pretty good proxy. So certainly around 99% of... 95% of public hospitals are registered for the record. And I'm sure I can quickly find you exactly what the percentage is in use. So year on year, in terms of viewing of the record, public hospitals are up 160%.
Starting from...
From...
Like what is that?
I'd have to take on notice, I think, Senator, where they were before. I don't know that I've got some raw numbers for you, but the raw numbers can be a bit hard because they're just humongous numbers. So, for example, the viewing of 1,700,000 documents were over the last 12 months. So
I'd love to know
they're hard to
the-
get hold of.
I'd love
What
to know
does
the
look better is the
proportion.
percentage increase. That's
Yeah,
exactly
how
right,
many-
because you can see it.
Senator Daniel
Yep.
Kay, First Assistant Secretary, Benefits Integrity Digital Health. So we've seen 22.2 million views in the last 12 months, which was up from 8.6 million views in the previous years in the public hospital context.
I really appreciate the numbers, but I guess I'm interested in, for every 100 visits to emergency,
How many?
how many of those patients have their...
I'd have to
their-
take that on
Okay, that'd be
notice,
great. Thank
Senator,
you.
yes.
And then the other thing I was interested on is diagnostic imaging providers. I was having a look on the website, and there's only 2 providers in the ACT registered with on the My Health record. Do you know sort of how many are registered nationally and are being integrated into the system?
Senator, I'll just see if I can give you... I've certainly got some increases here. I'll just see if I can give you providers, diagnostic imaging providers.
For time.
As a chair, Senator Pocock, you technically have a few minutes in your call, but grateful as efficient you can be.
Senator Paul Creech, Chief Program Officer, Australian Digital Health Agency. In relation to the exact number of diagnostic imaging providers that are uploading, I'll take on notice. The thing that we need to keep in mind, though, is a significant number, proportionally a significant number of diagnostic imaging providers are registered and connected with the My Health record. They don't always upload, though, and that is one of the issues that we're working through and have been over a number of years, working hard at the moment to drive that use. Specifically with the providers themselves, it's the same as pathology. Uploads are lower than we'd like, but they are growing, and they have grown significantly over the last few years, especially during the COVID period, not as significantly as pathology. We've seen pathology has really boomed the last couple of years, but DI has a little bit of work to go, and we're looking to get as many of those into the system as possible. ACT, especially, are 2 providers that don't upload as much as we'd like.
Okay. I'd love, just on notice, any sort of info.
And we've got, actually, I've got them here, but together, so I'll disaggregate them for
Great,
you.
thank you. And then just finally, because I know we're running very
Please,
short,
Senator Pocock.
I'm just wondering what progress is being made in getting rid of fax machines in healthcare. And if is there an end in sight? I note that
Excellent question.
there are a few coronial inquiries which actually point out that fax machines were a contributing factor.
I think it is a really big challenge. Doctors are one of the last bastions of the fax machine, mainly because secure
Maybe they
electronic
had shares or
messaging was the issue, and I think that's what we've all been working on. But I don't know whether you...
I think it's probably worth saying that in the health system, there's probably areas that are getting better. So, for example, primary care or general practice is probably reducing dramatically the use of fax machines. But we've got to do a lot more work in areas like specialists who don't tend to use as many digital platforms as we'd like them to. So, it's an area of focus in specific areas.
Do you know?
President Biden are very good authorities that they're going to get rid of fax machines, but at the same time they're going to write legibly.
Thank you. If you could provide on notice the percentage of GPs or other providers that are still using fax machines. And
I think we could certainly provide something on the proportion of GPs.
And potentially
fully
the strategy
digital.
to try and, given the coronial findings, if there is a strategy to find a secure, sort of acceptable, workable way to do it all.
Yep.
Thanks very much. Thank you, Chair.
Senator Pocock, are you finished with the agencies?
Yeah.
Thank you very much for assisting the committee. We have 2 senators with 2 minutes for you, Mr Skerritt. Then we're going to go to a morning tea break after we come to the Minister for an whatever tea.
It's morning tea.
Your morning tea, probably, Professor
Morning
Skerritt.
tea for him.
Whatever we choose to call the snack. So we're going to have a couple of minutes from Senator McGrath, a couple of minutes from Senator Roberts, and then you should be able to leave. Thank you.
Thank you. I've got 2 questions, and it's in relation to the review into paracetamol. And this is, I'm speaking on behalf of my constituents in Queensland, especially rural and regional constituents. So the first question is, won't the proposed restrictions unfairly impact on patients who require genuine pain relief and use paracetamol safely and appropriately? And in particular element of that is one of the options is to make modified release paracetamol prescription only. And in rural and regional Queensland, it takes some time to get an appointment with a GP, anywhere between 1 to 2 weeks, sometimes 3 weeks. How can those constituents of mine access appropriate pain relief, and aren't they being unfairly impacted upon by these proposals?
Well, thank you, Senator. I think we need to clarify the word proposal. Can I emphasise that TGA has no preferred option? Normally with medicine scheduling, an option is put up and we receive feedback on it. What we did here, based on this independent report, which looked at the consequences of 50 deaths a year due to paracetamol, was to put up a range of possible options without showing any preference in order to get feedback on them. So we are not championing any of those options. We're wanting to get feedback on them. And yes, if you had to go to a doctor, it's an additional step, but that's only one of a number of options. And of course, we've put forward no change to that option as well as to others.
Okay. The panel that you did commission made, as part of, I think, the 7 recommendations, made several non-medication related recommendations. So how would you be planning on implementing those recommendations if you were to adopt them?
So the non-medication related recommendations are beyond TGA's remit, but the panel, as well as my senior colleagues at TGA, have worked closely with Ruth Vine and others in the mental health area to look at whether and how some of those options could also be implemented. But of course, our role is in regulating medicines, and so that's why the consultation put forward the medicine-related options without expressing a preference for any of them.
Okay, I do have a lot of other questions, but in the interest of time, I will not hand back. So thank you, Chair, for that. I appreciate that. So thank you, Professor.
Thank you, Senator McGrath. We appreciate your cooperation. Senator Roberts.
Thank you, Professor Skerritt, and thank you, Chair. Now, I asked a question earlier, Professor Skerritt, about the number of drugs approved under the full approval process, the normal process. If you exclude the number of drugs that you said were new uses for existing drugs and medical devices, what is the figure for new drugs approved under the full approval process in the last 3 years?
It will be about 90, but I'll give you the exact answer on notice, Senator.
Thank you.
So we approve between about 30 and 40 new drugs a year.
Thank you. You also confirmed your view that the trial data contained sufficient proof the vaccines were safe and effective, sufficient to meet the criteria for provisional approval. And yet, after 18 months of analysing the data, some of the world's leading virologists and pharmacologists from UCLA, Stanford and here in Australia found the stage 2, stage 3 trial data showed the vaccine was associated with a 36% increase in serious adverse events. Out of every 10,000 people injected, 18 will experience a life-threatening or altering complication, and the vaccine should not have been approved as it caused more harm than it prevented. That's what they said. One of the papers, and there are several papers, is entitled Serious Adverse Events of Special Interest Following mRNA COVID-19 Vaccination in Randomised Trials in Adults. How could ATAGI review the data and conclude everything was fine, and then the world's leading experts on the subject in a peer-reviewed and published paper find the exact opposite? Did you approve the vaccine in a deal with colleagues in the pharmaceutical industry?
Senator, I think that's an offensive allegation, and we certainly did not.
You have colleagues in the pharmaceutical industry.
Pardon?
You have colleagues in the pharmaceutical industry.
I wouldn't say they're colleagues. We work with people. We also work.
That's what I mean. You work with them,
court, including the criminal court. So we work with people in the pharmaceutical industry. We work with other government people, but they're not colleagues in the sense of working for the same organisation.
Did you deal with that? Did you do a deal or an arrangement with the? I mean, it could be just provisional approval to get it through. Did you do that with the pharmaceutical industry?
No. That's an offensive and unfounded allegation, Senator, and I'd like you to withdraw.
Well, there are thousands of people who are dead, and we'll get onto that in the next session.
I disagree with you, Senator. There are 14 deaths associated with vaccines in Australia.
We'll get onto that next Senate estimates.
I look forward to it, Senator.
Yes, so do I.
Thank you, Senator
Thank you, Chair.
Roberts. The Minister has an explanation she's seeking to...
Professor Skerritt, go to bed?
Go to bed. Yes. Good night, Professor Skerritt.
Good night.
Good morning. Good morning.
I've got to send them home. Sorry, Senator McCarthy, please, just one moment. Professor Skerritt. Minister McCarthy, please make your statement.
Thank you, Chair. Earlier today, Senator Mackenzie asked me a few questions in relation to a wet lab in Mildura, a project with Southern Cross University to train allied health professionals, a clinic in Coffs Harbour, and a partnership between La Trobe and Goulburn Valley Health in Shepparton to train the nursing workforce. I've been advised that these are election commitments of the former government. These projects were not appropriated in the budget, but were rather commitments made throughout the federal election campaign by the now opposition. Thank you.
Thank you.
Chair, sorry, could I just add one thing too in response to one of the things I took on notice from Senator Roberts, just very briefly?
Yes, please. But while you do, sorry, Professor Kelly, if the NHMRC are still in the building, can they just make their way to the chair, because there will be 2 minutes for them when you're finished. Professor Kelly.
Oh, just your question about whether the international health regulations were a treaty. I've been informed that it is a treaty that Australia is a signature to. I would also like to formally state that it does not overrule any Australian law, but in fact has helped to strengthen our pandemic response throughout the last 3 years. Thank you.
Thank you.
Senator Canavan.
Thank you, Chair. Very quickly, thank you for appearing back at HMRC. Just I've had a look at this report now, the gain of function report. In that report, you haven't actually outlined these 17 papers. You're saying that you can't provide them because of potentially serious threats to the personal and professional lives of scientists. I mean, is there any specific threats? This seems remarkable. This is publicly funded research, and you're not, and involving potentially very serious risks to the public. Why can't the public know what was funded by the public into infectious agents?
Thank you, Senator.
Good question.
There are a number of people who've been working generally on virology and related topics as researchers around the country who have received serious threats and have had their lives threatened.
Did any of the researchers in these 17 papers receive threats?
I don't know the answer to that myself.
Take that on notice.
No,
I find this totally unacceptable.
Actually,
Could you take on notice what those 17 reports were from this committee, and keep in mind that obviously you would need a public interest immunity to not release it. These are publicly funded research. It involves infectious agents that potentially, and I do not accept your rationale before, potentially created coronavirus, this type of research. It's definitely a credible theory that this came from a lab involving gain of function research, and I think the public deserves to know where its money is going on potentially risky research. You cannot be laws unto yourselves, and this review to me smacks of the fox looking after the hen house here. You're reviewing your own research, and it's very, very defensive, the report. Now, finally, too, can I also ask, were any of the 17 reports, did any of those involve research on infectious agents that may increase pandemic potential or cause it to acquire pandemic potential?
I'll take the question on notice because I don't have the details with me, Senator.
Okay.
They were identified as ones of concern precisely because they fitted that definition amongst the 6,000 or so projects on infectious disease in Australia, which could potentially have, just because they were on infectious diseases, were in the scope for analysis. There were 17 that fitted the criteria.
Just to be clear, I'm drawing this distinction I think you did in the report, but I might not be using the correct terms. But in the report you said there are research involving infectious agents which could cause harm to humans, and then I believe there was a subcategory, if you like, of research involving infectious agents that could create a pandemic, effectively. And my question there was especially about whether any of those 17 involving infectious agents that could cause a pandemic.
That was the criterion for analysis. That could cause harm to humans.
Okay. Thank you, Senator Canavan. We will be breaking for a tea break. I am just going to formally advise that all agencies listed under outcome 1, excluding the COVID-19 task force.
There is no agency called the COVID-19 task force.
Oh, sorry. When I say agency, I'll read out the list I have.
Yeah. So the COVID-19 task force, I know that was listed as an agency by the Secretariat. There is no such agency. we have a range of COVID-19 functions, so the department can answer questions.
They can answer
about
under
COVID-19.
Outcome 1
and
policy.
a TARGI, we don't have a TARGI here, but a senior official who looks after a TARGI can answer questions on their behalf.
Thank you. Well, in that case, all the agencies are released. Thank you. We will be returning to Outcome 1 questions for the department after the break, which will be at 4:26. We will be resuming. We are now suspended. Thank you very much. Thank you for your cooperation, Senators.
Good
We're
night,
no longer
Professor
here.
Skerritt.
Good night, everybody.
So the committee will be resuming. For the assistance of those in the room, we have dealt with agencies listed under Outcome 1. We will now be dealing with the various program items under Outcome 1. We still have Senator McCarthy at the table. I'm going to go to the Coalition for the call. So Senator Rennick.
Thanks. I'll start with you, Professor Murphy, since you're the only one there. Look, I just want to follow up on Professor Skerritt's comments. Last time, in the last set of estimates, I think back in early April, Professor Skerritt said that the lipids used in the vaccine were the same lipids you have for breakfast. He's now just said there's 4 different types of lipids and they've been subject to genotoxicity studies. Now, in the actual assessment report, it said that there were no genotoxicity studies done on the vaccine whatsoever. And we've had this conversation before because you've been in the room. So I have a trust problem when the last set of estimates I'm told there's nothing to see here, they're just normal lipids. And now I'm told there's 4 different lipids. On the Pfizer website themselves, they talk about creating a new lipid in record time. You know, I have a serious trust issue here with Professor Skerritt constantly saying one thing and then that changes. I mean, you know, why should I trust Professor Skerritt when he says one thing and does another?
Well, Senator,
he says different things. He doesn't do another. He says 2 different things at 2 different times. He's changing his story all the time.
Senator, well, I mean, is there a question there or is that a statement?
Well, maybe it's a statement. Well, let's move on to the next one. The other night I asked you about, blood test, donating blood after 3 days, and you said that there's no reason why the spike protein would be in the actual blood. First of all, in the actual non-clinical evaluation report from the TGA, it actually says there was no actual testing of the spike protein in the clinic itself, right? So to say that you wouldn't know that it's in the blood, you wouldn't actually know that because there was no, as it says here, there was no distribution and degradation data on the S antigen encoding mRNA, i.e. the spike protein. So yet again, same question to you. You've come out the other night and said, well, it wouldn't be in the blood.
Yeah.
My question to you is, how would you know that if there was never any testing done on the spike protein, number 1, and a study published in May 2021 documented for the first time that S proteins were found in 11 of the 13 subjects as early as 1 day after the injection of, in this case, the Moderna vaccine.
In the blood, where, Senator? I mean,
in the blood.
Yeah,
it's a blood test.
Yeah,
so they found spike protein in the blood. So studies had found spike proteins in the blood as early as 1 day after the actual vaccine.
So, Senator, look, all I can say is that I'm happy to take that issue on notice again and get Professor Skerritt to respond on the full data set that we have around this issue. But I don't believe, I've not seen any evidence that spike protein is detected 3 days after vaccines in any studies that I've seen. But I'm not across all of the literature. And I think if it's a legitimate question, I will get the TGA to address it.
Well, you wouldn't find evidence because there was no studies done according to this TGA report. And that's the thing, absence of evidence is not evidence of absence. There's two separate things.
We don't know what evidence might have. We've had now billions of people across the world vaccinated with these mRNA vaccines. So there would be, you would think, that there might be some evidence there. But let's take it on notice and we'll come back to it.
Okay, let's go to another statement that's been made throughout the vaccine rollout, is that the vaccine was injected into your arm and it stayed close to your injection site. Now, granted, according to the distribution studies that was provided in the TGA non-clinical report, a lot of it did stay near the injection site. However, a lot went to other body organs. As a matter of fact, it went to numerous body organs, including the ovaries, the spleen, the liver, the lung, the brain, the eyes, the heart, the injection site. And in many of these organs, it was still increasing after day 2. So the lipid concentration had increased from day 1 to day 2, and the studies were stopped. Now, I cannot believe that you would stop a study after 2 days if the concentration of lipids was still increasing in the body organs before you rolled it out, because you would need to know just how high the level goes, how long it plateaus, and then how long it rolls out and then clears, it exits the body. So yet again, how can you justify saying that there was no, that the vaccine stayed close to the injection site when studies, and this TGA non-clinical report was prepared, I think, late December, January 2021, and yet people went on and said, many medical experts, and I'm pretty sure you guys may have even said yourself, that it stays close to the injection site when it didn't.
I certainly didn't say that, Senator, but Professor Skerritt may have done. We've let him go now. Again, take on notice to come back to you on that issue.
But do you, well, I mean...
all I can say, Senator, is that I have, as I said the other day, I have really strong confidence in our regulatory process, and I believe that and we now have real-world evidence of many billions of doses of these vaccines. We believe that they are incredibly effective and incredibly safe. As Professor Skerritt said, we only have, I think, 14 confirmed deaths associated with vaccines, and many of them were with AstraZeneca. So I really do have great faith in our regulatory system.
Can I just say, so did I until this particular rollout. So, have you actually read the non-clinical evaluation report from the TGA? Could I strongly recommend that you do? And I just want to raise a sentence that was in the top of page 8 where it talks about the S protein obviously goes inside the cell and it's processed by the ribosome, and it says that it suggests that the S protein is synthesised and processed within the endoplasmic reticulum for surface expression or secretion. Now, I thought the purpose of a vaccine was to destroy the foreign body that enters your cell, and yet this seems to be suggesting that the vaccine will go into your cell and then the protein that's created can either be put onto the surface of the cell, i.e. the membrane, in which case you will induce an autoimmune response to attack your own cells, number one.
To attack that protein?
Yep. Well, yeah, which sits inside the membrane, so on the membrane of the cell. So it's obviously going to take out the cell. The T cells will kill.
Not necessarily, Senator. It's a highly specific immune response to that protein. So it's not against the whole cell wall. It's against that spike protein.
Okay, that's fine, but that was never tested. So we don't know how the how the body's immune response is going to, whether it takes out just that spike protein in the membrane or it takes out the entire cell, right? And you don't know that because it says here you didn't do any testing of the S protein, the spike protein, step 1. And this is what concerns me, is that it can secrete. So the spike protein can secrete from the cell and then go back into your body. Now that's potential. I mean, we never know this because it was never tested. That could potentially lead to clotting, or it could lead to other issues if it starts to flow throughout the body.
And if that were the case, Senator, with many billions of doses given, we would have very good evidence of those adverse effects, and we don't have.
Okay, let's come back to the rise in diabetes, which is an autoimmune disease. That has risen by 20%. We have had a rise in dementia, which again is, if you've got the small spike protein going throughout your body, getting into your brain or whatever. So there is evidence that would warrant what I would call a red flag, whereby I believe that the TGA and yourself in the Department of Health should be looking at these increase in deaths, because, as I said, the 2 biggest causes of dementia, and which suggests that that's the spike getting out into the bloodstream, or an autoimmune diabetes, which is an autoimmune disease. So that could be creating some problems. Would you not? Potentially problems that should be examined closely.
We don't have any evidence of any association between vaccination, diabetes, or dementia. And we would have.
Okay, but you have signals. I mean, the whole point of having a database, a TGA database, is a signal ultimately, right? Yeah. You're right, and I'm not going to say that every report is definite proof of the vaccine injury. But when you have had such a spike, and albeit and I'm talking in rate of injury, not obviously when 20 million people take it in 6 months, you're going to expect some sort of spike, right? But I'm talking about the rate of injury, that would warrant a, that is a red flag.
There's a rate of reported adverse events. After careful examination, the rate of actual injury is very low. As Professor Skerritt said on many occasions, every one of those reports of associated symptoms are not evidence of injury. But I do think, Chair, that we perhaps should have explored this when we were with the TGA, and I would prefer...
Well, with all due respect, he should have been here. I don't, you know what I mean?
Well, we asked for his permission to go to bed because it's 5 o'clock in Dublin, and the committee agreed to do that.
Yes, Professor Murphy.
I mean, as in Australia for this particular estimates. I mean, I would have thought, his duty to accountability. I'm not having a go at you, Chair.
Apologies, Senator Rennick. I thought your questions could be answered here.
Oh, so do I. Yeah, and I think these guys need to take responsibility for the performance of the TGA. So I'm not, like I said, it's not with you, Chair.
Senator Rennick, it's coming to the end of your 10-minute block. Are you happy for me to pass the call?
Yeah, absolutely. Can I
Okay.
have another spin later on? That's all right. Yeah.
Senator Ruston, you have the call.
Thank you very much, Chair. Professor Kelly, earlier today, the Premier of Queensland announced that the Queensland state was moving from a green to an amber alert in relation to a spike in cases in COVID. Have you provided any advice to the Queensland government in relation to that decision?
No, Senator, I've not provided advice to the Queensland Government. They have a Chief Health Officer who provides that sort of advice. Their amber designation is really very much based on the Community Protection Framework, which was announced and made public on the 14th of October. That was an agreed position in the AHPPC of all the Chief Health Officers and myself. And also by the First Secretaries on behalf of National Cabinet. I'm happy to table that if you haven't seen that document.
Yeah, sure, that might be useful. Yeah. Thanks, Professor.
And if you table something.
So I'm just keen to understand, Professor Kelly, I understand from communications that there has been an indication that you do not, that no actions are required to date. Is that your understanding? That an amber alert doesn't require any enforceable mandated actions?
Not enforceable mandated actions, but as per the community framework, it would be equivalent to Tier 1. As when those copies come back, you'll be able to see what that is. Essentially, it's an alert, particularly in Queensland, for their healthcare workforce, and mask use is one of the key components of their amber. But it's also further advice to the general public about what they could or should do in relation to the current wave, and we are in a wave right now, including in Queensland.
Yeah. So I don't start coughing as soon as we start talking about COVID. I mean, like, really.
It's a standard thing.
Sneezing and blowing my nose. Am I to assume that the documentation that you've just provided is likely to give me the breakdown of what happens at different stages in terms of...
Yes, that's correct. Yeah.
Just making copies, Senator.
Yeah, no, that's fine. All right, well, look, I'll wait for that to come back before I ask any more questions around that. When the decision was made to end mandatory isolation rules a couple of months ago, did you provide advice to National Cabinet to that effect?
So I was requested, and again I'm happy to table the document. I was requested by the Prime Minister to provide advice on the day before National Cabinet, and he shared that with his colleagues in National Cabinet. That was subsequently made public.
Okay. And did you consult with the AHPPC before you provided that advice?
I was asked by the Prime Minister to provide advice to him on the day before National Cabinet, and so I did so.
Yeah, I absolutely heard you say that, but I just wondered, did you actually consult with the AHPPC in relation to the advice you were going to be given?
I did not, because of the time period.
Okay, but you would normally speak to your state counterparts, but it was the time frame that was you're saying is the reason why you were unable to do so?
Yes, that's correct.
Yeah, okay. I mean, it would immediately, I suppose, make me jump to the conclusion that the advice potentially could have been rushed given the time frame. Do you, in your expert opinion, do you believe a day or two would have been able to provide you with the opportunity to be able to better consult your advice with your state and territory colleagues?
I was asked specifically by the Prime Minister to offer my advice to him in relation to this matter, and a few days wouldn't have changed my mind.
Okay. So there was no instruction not to consult. You
No.
just chose not to.
There was no time, Senator, to do that.
Okay.
But I, you know, and I'm happy. I'll table my statement as well, just so you've got it in front of you. But there is consideration there of the reasons why, at that time, in the context that we were in the pandemic, that was an appropriate decision to be made. And the proof of the pudding is what we've seen. It did not lead, as some people suggested it would, into a major increase in cases over the weeks after that time.
Okay. So
The other key part of that advice, Senator, when you get to read it, is that that was very context and time specific, and that the key component was eternal vigilance to make sure that when we entered into a new wave, that we were able to recognise that and to alert the public, similar to how the Chief Health Officer and the Premier in Queensland has done today.
Minister, could you maybe give us some advice as to when that National Cabinet meeting was called?
Sorry, Senator, are you talking about the previous...
No, the National Cabinet meeting
National
that
Cabinet meeting, or
Mr
the-
Kelly provided this advice. Sorry, Professor Kelly provided the advice to.
Yeah, look, why don't you continue to pass Professor Kelly, because he provided that advice to that particular
No, I don't. I wasn't
cabinet.
asking about the advice. I was asking you about the time of the.
Well, that's what
calling
I'm
of the
saying.
meeting.
Yeah, if you're asking about when he provided the advice
No, I
and the
didn't ask that
timing
at all.
of it,
No, I'm asking you when the meeting was called.
Professor Kelly?
So the meeting took place on the 30th of September.
No, I asked you when was the notification provided that the meeting was to take place? I mean, when was the decision made to hold the meeting on that date?
I'd have to take that on notice and consult colleagues in Prime Minister and Cabinet.
Yeah. Well, maybe, Minister, you might like to take that on notice and come back to me and let me know the date the decision was made to hold that National Cabinet meeting. I just find it quite... well, it would be very interesting to know whether the meeting was called on the same day as Professor Kelly was asked to provide the advice, which restricted him having the ability to be able to consult with his state and territory counterparts before giving the advice that he provided to National Cabinet without consulting his state and territory colleagues, which I would suggest he has done on every other occasion that he's provided advice.
it is a matter for the Prime Minister in regards to National Cabinet, Senator, but of course I'll see what we can find out for you.
Okay, that would be great because obviously, I mean, to quote a close colleague of yours, a well-functioning National Cabinet should have been transparent and accountable with its decisions subject to scrutiny and oversight. I would suggest this has not been the case in this instance.
Was that from your Health Minister or the other Health Minister who was the previous Prime Minister?
No, that was actually from
okay, just
Minister
checking.
Katie
Just checking, because I
Gallagher.
know you had two Health Ministers, so I just had to check. Thank you.
Senator Ruston, you do have the call, please.
Yeah, no, I'm just wondering why the defensive response from the Minister at the table. It was actually from Senator Gallagher who made that statement, not anybody in the previous government. Just moving on to the Jane Holton report, just wondering where the government is at in relation to implementing the findings of the review.
Thank you, Senator. Many of those recommendations are already in progress, particularly the recommendation that we pursue a portfolio of vaccines and continue not to rely just on, and so that means consideration of further purchases when we run out, particularly of the Moderna vaccine, and government is discussing that now. So that was the principal recommendation from the review. There were recommendations about some of the governance structures, such as how ATAGI functioned in a pandemic, and that process is being looked at now with ATAGI in the department. Government is, I believe, intending to publish a brief response to the draft recommendations later this year. It's subject to the decision of the Minister, and that will probably outline in more detail the progress on the review recommendations. I don't know whether Ms Garrett has anything else to say.
Trish Garrett, Vaccine Operations and Data Division. No, I think that covers it all.
Right now, what's the fourth dose vaccination rate?
We'll get that. Whether Ms Garrett's got it up.
Do you want me to?
Yeah, if you've got it in front of you, Lucas, that would be good.
Senator Dr. Lucas Otoka, Vaccine Policy Implementation and Primary Care Response, I think it is. So at the moment, dose for coverage for 65 years and over is 74.7%. For people 50 years and over, 57%. For people 30 years and over is lower at 41.7%, but it's important to remember that ATAGI does not encourage people in the 30 to 49-year-old age group without other comorbidities to get the fourth vaccine. They allow them to receive them if they so choose, but they recommend people 50 years and over to receive them.
Okay, so of those people that are eligible for a fourth dose, how many in total have received it?
For those who are recommended, which is 50 years and over, 57% of those.
Okay, and you're saying that there is no recommendation for people under the age of 50 to have
for people between 30 and 49 years of age, and some other younger people, for general population 30 to 49 years of age, ATAGI has a permissive recommendation, so if they so choose for their individual circumstances can get it, but it's not recommended for that group. There's a small group of younger people, both in the 30 to 49 and younger, and that includes people with severe immunocompromise, disability with complex health needs and multiple comorbidities that are also recommended the vaccine, but it's hard to quantify that number specifically.
Okay. Professor Kelly, on the back of the information that Dr. Tok has given us, are you concerned at the rate of fourth dose vaccinations?
Look, in terms of third dose vaccinations, I'm very happy with that rate, particularly in the older age groups. Fourth doses can increase the protection marginally, and yes, I would prefer it was a bit higher, but at the moment, again, in those older age groups, as Dr. Totoka has mentioned, that's a very high rate, world-class rate, I would say, of fourth doses.
So you say it's a world-class rate, and I mean Australia should be very proud of many of the world-class things that we've done through the pandemic, and much of that credit goes to the people sitting in front of me. But I'm just interested to know, particularly given that we've gone to amber in Queensland today, I'm sure that's something that's likely to probably happen around the rest of Australia. So I'm just interested to understand what the government's preparedness is at the moment in relation to responding for what inevitably appears to be another wave of COVID, and is there any proposal in regards to encouraging Australians to maximise their protection through vaccination?
So it won't surprise you, I have another
piece of
statement
paper
to table. So on the 7th of November, it was actually published on the 8th, I think, is a statement from me, and I did some media earlier in the week exactly on this topic, so it's very important that Australians are aware that there is an increase in cases and that there are some things that people should consider doing, wearing masks indoors, if sick, avoid going to high-risk places and stay at home if possible. If sick and at higher risk of severe disease, to make sure that you have a plan to get treatments which are very effective, and most importantly, if you're due for a vaccine, to get that vaccine. So they're the points. Again, that's in that framework that would be the thing we would do in these sort of circumstances, and that's what we're doing. My colleagues in the States are also doing the same sort of messaging. In terms of further vaccine doses, and there's been some media around that today, maybe Dr. Totoka can talk to discussions.
Thank you, Professor Kelly. Yeah, there's been a lot of media, which always makes things interesting. ATAGI the Australian Technical Advisor Group on Immunisation is continuously reviewing the evidence and the emergent trends and epidemiological context here and overseas. So as part of the regular meetings, continue to review the booster advice. At the moment, the advice remains that, as you highlighted and as Professor Kelly mentioned, maximising dose 3 and dose 4 coverage for those who are eligible, and dose 5, as some people who are severely immunocompromised are already getting 5 doses because the primary course is 3, is the absolute goal. As Professor Kelly said, our 3rd dose and 4th dose rates are very high, but there's still a significant proportion of the older population that haven't had it. So at the moment, ATAGI's advice is firmly to stay up to date, which is a 3rd dose for the majority of people 16 years and over, and a 4th dose for people 50 years and over and others. But ATAGI continues to meet, and if there's evidence that there are requirements to recommend another dose for a particular group or others, that will be taken to government for decision, but that advice has not been provided.
So for those people who were early adopters because they were in the high risk categories when the 1st dose, 2nd dose, 3rd dose, 4th dose, what would be the time period, the longest time period since somebody who was actually on a program of vaccination when they would have had their 4th dose?
So given the timing of the original 4th dose advice, which back then was called the winter dose, as it was part of our preparation to winter, and that was an ATAGI change made on March 25th. There are some people who are just over or at the cusp of 6 months from their previous dose. The other important thing to factor here is that as we have discussed throughout this session, the goal of the vaccination program is to protect from severe disease, hospitalisation and death. And even though we do now have evidence that the protection from transmission and infection does wane relatively quickly because antibody levels go down, the cellular immunity, the immunity that is caused by T cells and B cells, provides more prolonged protection against severe disease, hospitalisation and death. What we're also seeing is that hybrid immunity, that is the mixed immunity from immunisation derived from vaccine and immunisation derived from the virus, also provides a very long and durable response. And recent serosurveys that were published a couple of weeks ago show that at least 2/3 of adults, and that's probably an underestimate, have had COVID recently, probably in the last year, plus high levels of vaccination rates means that we have a population with very high levels of hybrid immunity. What ATAGI is monitoring now is for those particularly high-risk groups who have had a vaccine or an immunising event, because another infection could be an immunising event 6 or more months ago, what the level of protection is and whether additional doses are needed, but are yet to provide advice.
Okay. So there's been no advice in terms of a 5th dose even to the most compromised in the population, or?
No, there hasn't.
So when would we, I mean, there are a lot of older Australians, I think, who probably took great comfort in the protection of vaccinations. When do you think, when do you think ATAGI is likely to provide advice one way or the other in relation to 5th doses?
So I can't preempt.
Should have asked them, shouldn't I?
I cannot preempt when ATAGI will provide the advice. I can definitely not preempt whether the advice there will be advice for a 5th dose at this stage or not. At the moment, ATAGI's firm statement remains that people should remain up to date with their vaccination. And based on the evidence that we have, an older person who's stayed up to date and has received the 4th dose still has great protection against severe disease, hospitalisation and death.
Senator, probably the other thing to mention, I think Professor Kelly mentioned it, that probably the most important added benefit in a wave like this is to make sure that those fully vaccinated older people have good access to antivirals, which is the next level. And we are seeing a very significant uptake now that this wave started in antiviral use. The antiviral use, since the indications were broadened recently by PBAC, we have one of the best antiviral uptakes in the world, and we're starting to see, it's in fact one of the best markers we have of the pandemic, that once cases go up, antiviral use goes up, and that probably, if you've had 4 doses and you're an old person who's vulnerable, it's probably a more important thing that to get access to antivirals than to consider another dose for which the evidence is not very strong at the moment.
And the effect of that of protecting against death is remarkably high and immediate. We know that people are getting antivirals on average less than a day after they get a positive test. And for people over the age of 70, this is Australian data, people over the age of 70 who receive a treatment within 1 day are approximately 63% less likely to die. And there is also a substantial benefit against hospitalisation. That's real-world data from Australia. That's the key message, and you'll see that it's a message in my statement earlier this week.
Yeah, the purpose of my questioning was nothing to do with antivirals. The purpose of my questioning was to understand what information has been provided to government in relation to their portfolio of vaccines and the redundancy measures that get built into it in relation to the procurement.
In relation to vaccines, Senator, there are plenty of vaccines. We have, a full range of vaccines available. All of our primary care vaccination sites, the vast majority of them are still active. People can get access to a vaccine same day, pretty much anywhere in the country now. Pharmacists have stepped up and are now doing about half of the primary care vaccinations. We're keeping all those points of presence going. I think you did mention communications, which is a challenging issue. We've had a lot of communications around vaccination. The community is pretty tired of it. Our communications more recently have been focused on the antiviral stuff, and that's shown a benefit. But I think the Minister is very keen that we keep promoting vaccinations, but more particularly we keep making it easy, accessible and free.
Senator Ruston, are you happy for me to share the call around a bit and I'll come back to you? There's just a couple of senators with shorter blocks and then I'll return. Senator Urquhart, and then I'll come to the two of you and then we'll go back to Senator Ruston.
Great, thank you. Professor Murphy, I might kick these to you and you can kick them wherever you want to go. So the former government released the Primary Health Care 10-year plan 2022 to 32. They also published Australia's long-term national health plan in 2019. I'm interested in the funding that was attached to those long-term plans. So can you tell me what ongoing funding measures for primary care were funded by the previous government to support Medicare to respond to the increasing pressures on the system?
I'll just see if Ms Richmond is... Mr Cottrell's here. Okay.
Simon Cottrell, First Assistant Secretary, Primary Care Division. So I can answer part of the question in relation to the Primary Healthcare 10-year plan. There were in the published version of the plan, the previous government had a foreword which listed all of the investments that were made towards that plan by the previous government. So I can provide you a link to that. I don't have it right here with me, but I can provide you a link to that or that information on notice.
Right, but can you tell me what the funding measures were? Like how long was the 10-year primary healthcare plan funded for?
So beyond the forward estimates periods as at the March budget, there weren't any specific commitments. So for 4 years from the March budget.
A 4-year plan with no, a 10-year plan with no 10-year funding, is that correct?
I think I've described the situation, Senator. So there were 4 years of funding commitments.
4 years of funding commitments for a 10-year plan. Did the department provide advice to the government or to central agencies regarding that rationale for providing that short-term funding?
The department provided advice at various times and iteratively to the government about what it might like to invest in relation to that plan, and the decisions taken were announced with that plan.
Are you able to tell me what that advice was?
Sorry, Senator. Deputy Secretary Tanya Rishnu, Primary and Community Care. As usual, we wouldn't reveal advice to governments.
I presume it was to not fund it for just a 4-year period, but for a 10-year period. Would that be a reasonable assumption?
As Mr Cottrell has indicated, we provide all sorts of advice in the normal course of budgets. Government takes decisions in due course. There were a number of programs and initiatives listed, as Mr Cottrell indicated in the start of that plan, and it was government's decision in terms of, how it would fund.
To just fund it
initiatives
for a 4-year term. So it was funded for 4 years.
So there were specific initiatives that fit under the plan that were funded.
Sorry, there were?
There were specific initiatives that fit within the reform picture of the 10-year plan that were funded.
But not all of it?
No.
Okay. Can I just go to just a couple of questions around My Health Record? So can you tell me why that digital health is so important to the future provision of healthcare for Australians? I know we had some questions on this earlier, but I just want to go over a couple of them. Why is that record so important?
It's a critical single point of information, but Ms Shakespeare is the expert and she will provide some.
Thanks, Senator. So it's a personally controlled record of health information. So the consumer who owns the record and their health data can decide which of their health professionals access it. It has the potential to allow people to provide different providers across different settings to get access to their health information so that they don't have to continually tell each of the healthcare providers all of their medical history. So it is very important that we make sure that the records are being used by different healthcare providers. So if you've got somebody that's going from hospital back into the care of their GP, potentially in aged care, they'll have lots of different healthcare providers, and it's a secure way of sharing health information with all of those different providers.
Okay. How frequently is it used? Sorry, I should rephrase that. Is it used by all GPs and health professionals and hospitals? Does everybody have access to it?
Very large percentages. I think GPs registered and using is above 95%, but I might hand to my colleague.
98%, Senator, for general practice, and quite significant use. I think it's around 96% in public hospitals, as an example.
Okay. And has My Health Record been adequately funded to deliver on the potential benefits?
So for the current financial year, the amount of money available for the operation of the My Health Record, this is through the Digital Health Agency, is $177.7 million.
And what's that been previously?
In 21-22, it was 221.2 million. I don't have previous years, but it will have moved around a bit.
Okay. And is that sufficient? Is that adequate funding?
So, I mean, at the moment, the My Health Record is, in terms of the technology platform, I guess, it's a library of PDF documents. It's not going to be what we need in the future to allow that objective that I mentioned before about being able to easily share information between lots of different healthcare providers securely. We will need additional investment to make it achieve those objectives and take it from the fairly antiquated platform that it runs on at the moment to something that is going to be truly interoperable.
Okay. All right. Thank you. Thanks, Chair.
Thank you, Senator Urquhart. Senator Steele-John.
Thank you very much, Chair. Back in August, the National Cabinet decided to amend COVID isolation from 7 days to 5. Was this a recommendation given by the Department of Health ahead of that decision?
Thank you, Senator. So that advice was given from the AHPPC, the Australian Health Protection Principal Committee, which I chair, the committee you've heard of many times before,
yes,
of all the chief health officers and some other experts.
So was that a decision that was given to the National Cabinet ahead of the actual decision being made? When was that advice provided to the National Cabinet?
Well, it was provided as part of the papers for that meeting, and apologies, I don't have the date, but the date you mentioned is the time when it met. Yeah.
So the National Cabinet then made the decision to remove all COVID-19, mandatory COVID-19 mitigation strategies. Was the recommendation to end the isolation periods recommended by the Department of Health ahead of their decision?
So this was covered in a question earlier when you were out of the room, Senator, and there's a paper that perhaps you could see, which is my letter to the Prime Minister dated the 29th of September, which was advice I was asked to give to him, and he shared that with his National Cabinet colleagues.
And what risk assessment was undertaken before the National Cabinet made the decision to remove all COVID-19 restrictions?
The circumstances and the rationale behind my advice is mentioned in the letter there, Senator.
Did not wanting to, I'll thank you and I'll take a look through the letter, but not wanting to just miss the opportunity to ask you directly. Did the risk assessment include projected years of life lost as a part of the calculation?
So the advice was based on the circumstances that we had at that time, which was a very low rate of cases in the community, very high hybrid immunity from a combination of high vaccination rates as well as previous infection, and the fact that we had many other modalities of control. I did very much point out, and this is crucial to the letter, was that was context and timing specific, and I made this commitment very strongly in the letter, and it was also part of the discussion around this decision, was that we must continue to look very closely at what is happening in our community and internationally with regard to new variants of concern, increases in cases, and particularly severity of illness, and to alert the public that was happening, if it was happening, and to have a plan about what should happen in those circumstances. So 2 weeks later, before that change in isolation period came about, on the 14th of October, the Community Protection Framework, which was discussed and agreed by all AHPPC members, came into being, and that's also been tabled in your absence. We can get you a copy of that.
Thank you. Just to clarify, so part of the advice that you provided, or that was provided in considering this decision, did include an assessment of kind of a projected years of life lost?
Not explicitly, no, Senator.
No, so it didn't include that. Did it include a projected figure around, or did it factor in the assessment of disability-adjusted life years?
Not explicitly, Senator, no.
Okay. That's worrying. How many disabled people have died from COVID-19 in the pandemic so far?
So, as you know, we've talked about this many times before. I can't tell you exactly that number. I can tell you the number of people that we know who are registered with the NDIS who have died during the pandemic, and that number is 196 up to the 30th of June 2022. I don't have more recent figures. People on the disability support pension, 394.
Okay, so before we go to the question of why you can't go any more specific than that, in terms of those two figures, is that overlap? Do those two figures overlap, or are they distinct?
Yeah, I believe there would be some overlap, Senator, but I'll take that on notice.
Can you take that on notice so that we can get
we do rely on a partner agency. There is overlap, yes.
Yeah, okay, thank you. Now, and we've talked about this before, but you do realise, Professor, that there are disabled people who do not access the NDIS?
I do, Senator, and I'm fully aware of that. I can only give you the information that I have. I know that our most recent figures for NDIS participants, again, 280 active cases, 26,706 recovered cases, and in terms of workers in that scheme, there have also been 192 active cases, 34,403 recovered cases, and no deaths in that group, but I've already mentioned the deaths, unfortunately, from the others.
Yes, thank you, Professor. So how many people do you approximate have been are missed in the statistics that you currently have?
I don't think that's an answer that's available to me, Senator.
Well, it's available to me in terms of I at least understand, and you will understand, that the ABS collects a set of data in relation to how many disabled people there are in Australia.
Yes.
Roughly 4 million or so. There's a significant gap between that figure and the figure that you've been able to provide me with today, isn't there?
So there were numbers of known positive cases of COVID, Senator, and so in terms of the denominator, I haven't used that, but my colleague may have further advice.
Yep, Philip Gould, the First Assistant Secretary for the Health Economics and Research Division. We work with the ABS to link a number of their data holdings, including the census and disability support payments, with their mortality database. Their mortality database is naturally somewhat lagged in terms of our ability to report on it, but through this linked detailed information we're able to get a range of definitions of disability, including identification through the census process as well as disability support information. So we are able to drill in to a fairly granular level at deaths with people with disability. And we can do so at quite granular geography as well. We've got an ongoing program of work looking into that, and we could provide you with more statistics around that on notice.
Minister, we have discussed this topic before in this committee, and I've been happy to disclose previously to the former Health Minister, and happy to do so again today, that I am somebody who is not an NDIS participant, and I've had COVID-19 a couple of times now. And there are many, many disabled people across the country that fit into that same category. And at the moment, were they to pass away of COVID-19, the Australian government doesn't have a way to count that figure. Is that a problem that the Health Minister is currently working to address?
Well, I'll have to take that on notice, because I don't know what the Health Minister is.
I think Philip indicated that that's exactly what we're working on.
And I think the point is that the more information and understanding the impacts of COVID-19, the better. So no doubt colleagues here can explain the works underway. I understand the point you make, but I think there are also challenges about how you would collect that data in your, unless you're going to disclose that in a way that is collectible by the government. I think that goes to some of the challenge,
I'm no doubt at all that it
Yeah.
is a complicated issue. The point that I make is that at the moment, the federal government has, sadly, only a very limited window into how many disabled people are contracting and suffering consequences, including death, from COVID-19. And that absence of data is a huge hole in informing the policy response of the government.
Senator Steele, John, I'm just seeking to share the call around.
Yeah, I can pause there, go to somebody else.
Thank you. Just so the committee's aware, I'm going to Senator Ruston now, and then I'll be coming in some 10-minute blocks after that to other senators. But Senator Ruston, you've got the call.
Thank you very much. Can I now go to the claims that have been made in the media recently around Medicare fraud?
Certainly, Senator. We'll get the officials to the table.
Okay, thank you very much. Obviously, there's been much made of an $8 billion claim of fraudulent activity by general practitioners in claiming Medicare. I'm just wondering whether the department has met with Dr Margaret Fowle about her report.
I might just start and then hand over to Mr McCabe, who has met with her even before the media allegations. I think we have not found any evidence to support the size of the claim that was made in the media, the $8 billion claim of fraud and billing errors. We do accept that a program the size of Medicare, there are elements of fraud, there are elements of billing errors, and there are elements of over-servicing. And Mr McCabe has a team of 350 people working on that issue. But Mr McCabe met with Dr Foe, we've examined the thesis, and we find it's essentially an assertion not backed by any evidence that we've seen that the issue is that large. So, Mr McCabe?
So I was going to say, Mr McCabe, following on from what Professor Murphy's just said, in your investigation of the thesis and your conversations with Dr Fowle, what would you suggest should be, the hypothecated figure or thereabouts of the level of inappropriate claiming of Medicare if it's not $8 billion?
So, Senator, I think it's been reported in the media, the ANAO did an audit into the Medicare compliance program back in 2019-2020. They actually recorded a number that ranged from 266 million up to about 2 billion of potential non-compliant claiming of Medicare. I guess an element of that could include inappropriate practice, and at a very high and small high end in terms of concern, there would be some fraud in that number as well.
It's a very large scope, 266 million to 2 billion. So I'm just interested in what the department's response has been to these claims. Has the department made any response to it?
The minister's.
I know the minister's done.
So just in terms of those ranges, it's based on information that's been provided to us by different consulting groups that have looked at fraud in similar programs, fraud and inappropriate claiming, I think. There's US programs, Medicare, Medicaid. I think the most recent report I saw about their programs estimated 6%. Some of the Boston Consulting Group and McKinsey assessments that we had done for Australia suggested between 1% and 4%, 6% in another report, 3% and 5%. So that's why there is a large range. So I just wanted to explain the context behind those figures. In terms of the department's work, we have an ongoing program of compliance. It's probably quite similar to other public regulatory functions in that we apply a regulated pyramid approach. We think most of the inaccurate or billing is not deliberate, it's mistakes, and so our approach there is to try and bring people who are not billing in a compliant way into compliance. So that's a range of education programs. And I can get my colleague to talk a little bit more about those. And they become more targeted as the conduct becomes more serious. So if there's inappropriate practice or fraud, we have very strict approaches to managing those. Fraud is a criminal offence, and we work with the Director of Public Prosecutions about those.
I don't mean to be. I'm going to have to ask you short any questions because I know the chair's going to be down on me like a ton. So just if you could provide me with details around what other compliance activities, I don't need it now, if you could provide it on notice, what other compliance activities and efforts the department undertakes obviously the PSR is a body charged with this particular issue, but I'd be keen to know what other compliance activities that the department undertakes in addition to the PSR's work in relation to compliance.
Senator, I just would say that Minister Butler has also, because of, public confidence potentially has been affected by these media claims, he's commissioned an independent review with an expert economist to have a look at Mr McCabe's processes and systems to provide assurance to government and the public that our compliance system is robust.
It's probably also worth mentioning, I mean, as part of that review, we're not going to have a look not just at the compliance program, but are there any issues up front in Medicare that might need tightening up in terms of how it's used, and also looking at the integrity of all the payment channels, just to make sure that if there are any potential gaps that they're closed as well, Senator.
Yeah, I mean, one of the other things that these media claims have made, that the department's not able to interrogate, data and detect fraud. Do you have a comment to that?
No, I disagree with those media claims. We do detect small numbers of fraud cases, but obviously worth lots of money as well. We have had, I think in the last, if I get to the right page, last financial year, we dealt with upwards of 16 matters before the courts, which resulted in over $24 million worth of matters being been prosecuted through the courts, Senator.
Yep. So, obviously, it's completely incorrect to characterise the department as being impotent when it comes to compliance enforcement. Yep, great. So, have you completed your review, Mr. McCabe, the one that the Minister sought for you to do internally?
So the Minister asked for two pieces of advice. One, broader background to explain all the things we do in compliance, and I think we just talked about some of that today, but also some advice on Dr Fo's PhD, just to really contextualise what's in that PhD and try to relate it to the allegations that have been put out there in the media. And I think it's important to note the PhD, as we've reviewed it, talked about potential non-compliance in the order of 1.5 billion to 3 billion. And talked about the most of the non-compliance related to doctors not understanding how to use Medicare. So the narrative in the media is quite different to what's actually in the PhD, Senator.
So those two pieces of work that the Minister commissioned you to do, the Minister's received them? Or?
The Minister has received them, Senator.
And have they been made public?
No, they haven't, Senator.
Do you know whether there's the intention to make them public, or maybe Minister, do you know whether there's any intention to make that information public?
Look, I think he's certainly spoken about the report he's received, which I think has led into this independent assurance review that's happening. I'll take that on notice. And come back to the committee, see what information we can provide. It may be that information is going to feed into this review somehow, and that maybe it's not the right time to release it, but I'll take it on notice.
Yep, that'd be great. I mean, certainly I have heard stories of the significant impact that it's had on medical practitioners and particularly GPs of these stories. Have you had similar correspondence that would indicate that a lot of GPs out there are finding these kinds of reports extremely distressing?
Certainly the peak bodies of colleges of GPs, the AMA, have reported to us, we have regular engagement with them, that they find these media reports distressing and concerning, so that they've certainly reported that on behalf of their members.
Yeah. The other thing, Senator, just to mention briefly, is that I've had a number of approaches from professional bodies and clinical colleges saying it would be timely for you to come and talk to our members about compliance and the risks that we have to deal with in Medicare as well.
Yep. And the other one, we've heard anecdotally at least that we've had practitioners that are resigning or considering resigning or retiring as a result of this, and particularly the retirements. Have you had advice to that effect as well?
Senator, we're happy to check what correspondence we have received. I can't answer that question now, but we do get a lot of letters from individual doctors, so we can check our records for you.
And finally, has the department done any communication that would, I suppose, alleviate this level of anxiety and concern that's been, that obviously has been generated by this, to make sure that the overwhelming majority of our medical practitioners and GPs particularly, we know, are doing an amazing job, and that the government and the department believe that this 30% or $8 billion claim is unfounded?
We've been asked about this by a number of different media news outlets, and we've provided information back to them along the lines that we've said to you today.
And Minister Butler did include in his media release about the independent review statements that the department had found no evidence to support the scale of the fraud. So he made a statement to that effect.
Okay, just obviously very concerning when we've got the GP crisis that we have at the moment, that we've got a situation where our GPs are under threat. Can I move back to the hospital funding that we were discussing a little earlier today?
And then they try and cut off their answers. I can't believe we're still in outcome one.
We are
Setting
thorough.
a productivity agenda in this committee.
Thorough.
Oh,
Minister.
thorough.
I don't need comments from you, Minister.
Sorry, just some external eyes coming in, that's all.
Let's continue.
It's all right. We have some quotes of yours here too for later.
Oh, excellent.
Yeah.
You've been saving it up for me, have you?
No, and I've been using some before, but we saved the best one for when you're here. So, look, thank you. Just quickly touching base back on the discussion around the national reform, national health reform money, and we'd established that the $2.372 billion was on the basis of the activity funding model, and then I put to you and the other colleagues in the funding authority, and your response was that there was another table on page 17 that actually showed an increase in funding, but if you that included in that other funding were also health infrastructure, which clearly is not about hospital services. It had Indigenous health in there, which obviously goes by a different pathway. So even accepting that there has been an increase in the other table, we still have a $1.114 billion decrease in payments to the states and territories over the 4 years. So I would put to you that it isn't this variation isn't contained anywhere else in the budget. So if you are able to provide me with alternative information that corrects what I'm thinking, but as I'm sitting here today on the advice that you gave me before, the net impact on payments to states and territories with the exclusion of COVID funding and infrastructure funding would still be well in excess of $2 billion.
Senator, can I just check your figure, your drawing comparison from the previous estimates?
From March until October. Is there something that's happened between March and October that would have changed that?
Parameter variation.
So I note that the table that we provided, page 17, the top line is the National Health Reforming Funding, which actually does show the increase that we talked about. The bottom lines, or the lines under that, are additional payments on top of that. So I think you can see the increase that's based upon the advice that comes from states and territories. Page 18 on the next page actually goes to the advice provided by those states and territories, gives the forward projections that lets us build, and the footnotes that are in the budget paper 3 actually go to and specifically draw out the uncertainty given the change in patterns of activities over the previous years. So I think it does show that increase.
I don't know whether you were listening this morning, Mr. Exel, and I acknowledged the fact, because of the activity base of the funding, that there was every likelihood, I could explain why the reform agreement was as it was. I was just seeking to understand why there was no provision made elsewhere in the budget, and I'm more than happy to prosecute these until the cows come home with you. Because there is definitely, no matter which way you look at it, and you can talk about changes of parameters and the like, there is still definitely not as much money in the budget for the states and territories as there was in March. So I just be...
Well, can I just jump in there? I can. No, I think I need to respond. In terms of government decisions, where government makes a decision, there are additional funds in the budget. In terms of the states and territories sending an invoice and us paying a cheque, that has varied because of the less activity. So let's just be clear about that.
And I'm very clear about
Okay?
that, Senator Gallagher.
Yeah,
Very,
well,
very, very clear. That
yeah.
was not the questioning this morning. You weren't here for it. I was just trying to understand why provision hadn't been made for a known increase in activity, and I accepted the fact that you said that it's activity-based funding. But anyway, look, could I just move on? And I'm happy to provide more questions on notice, of which you could provide me with some more details, because they are particularly complicated and confusing for somebody who's not an accountant. In the next financial, in this current financial year, there's some ongoing COVID funding, and there's been a change since March of an additional $886.3 billion that's gone to the states and territories in relation to COVID funding.
A million, I think. Was it?
Oh, sorry, 886 billion. They would be really happy if they got that.
Hungry, the states.
Yeah, millions, billions, whatever. $886.3 million additional COVID funding has been made available to the states and territories subsequent to the March budget. Could you advise what the basis of that additional funding is? I mean, what?
So, Senator, that, do you want to?
Senator, I think what you're referring to is an increase in the funding that's made under the COVID NPA.
Yes.
And so the parameters for that funding are set out in the National Partnership Agreement. So that would be expenditure that the states and territories had reported to the administrator, that they had, reported to the National Health Funding Body. And Ms Carl has joined us, who will have even more detail than I do. But the states and territories will have reported expenditure that is eligible under the partnership, that will have been assessed, and that will then flow to a payment under the partnership.
Yep, okay. So could you maybe explain to me why of the $886 million straight out increase in payment to Victoria of exactly $600 million was made, and yet in exactly the same period there was $94 million less allocated to New South Wales?
So,
Ms Carl can explain, the way this works. I think, yeah.
Yes, Secretary. Fafine Carl, Assistant Secretary, National Health Reform Branch. Senator, the way that the payments work under the National Partnership on COVID-19 Response is that the states and territories provide their estimates to the administrator, and then over time they can both change those estimates, and then of course there's a reconciliation process. What sometimes happens with those partnership payments is that the states don't always know exactly what they're going to need to do in response to an evolving pandemic. So sometimes they will have made a larger estimate earlier, and then they won't make an estimate, they won't seek further payment for some time. So that's actually what happened with some of the New South Wales payments. So New South Wales hadn't sought any additional payments, and that's kind of why some of those funding figures look different between the states. Whereas Victoria had recently sought some additional funding, and then that's been reflected in those estimates. That's very much changeable and will all get sorted out through the reconciliation process that makes sure that every jurisdiction has just been paid what they actually are entitled to. And as Ms Essex was explaining, the other component that went into the update for the most recent budget was also the current government's extension of that partnership funding agreement from the end of September to the end of December. So it has that, the update in the October budget reflected both our estimates for that additional part of the year, as well as the actuals that had changed in the period since March.
Senator Ruston, I'm seeking to hand the call over shortly.
I'll be 2 seconds.
Yeah,
just on this one. So, so would it be possible to be able to provide me with some information, because just to to read it into the Hansard, South Australia had a $92 million increase in their COVID funding. Tasmania had a $26.8 million increase. New South Wales had a $94 million decrease. Queensland had a $140 million increase. Western Australia had a $99.4 million increase. The ACT, $22.6 million. The Northern Territory went back by $800,000. And Victoria went up by $600 million. I mean, has the government made a decision, the federal government made a decision that Dan Andrews is going to have a train as well as $600 million? These figures are quite extraordinary, but I would
So
be
no,
really...
you didn't listen to the answer.
I did listen to the answer.
You did not. Well, you didn't, if you're going to run that line.
It would be really appreciated if we could get some more information, because it seems an
just gave you all the
extraordinary...
information.
No, you didn't give me the information.
Yeah.
You told me that there was a
It's-
mechanism. I'd like to see the advice, and I'd like to see more details around how that reconciliation process has occurred, because it seems extraordinary on the eve of the Victorian election that there is a $600 million round figure allocation to Victoria when every other state seems to have a proportional allocation. So
see how it
I'd be
helps in
keen
an
to
election
understand
context.
from the department about the process that sat behind that, to make sure that you can
Are
allay my
you
fears.
suggesting that hospital funding decisions where they're going through a national partnership and go through a reconciliation and checking process, which is the evidence that you've just heard, is somehow influenced by the timing of elections? Is that the allegation you're putting?
Well,
Because
indeed.
if it is, you should put some evidence out there to support that.
Well, I've provided the evidence.
No,
that's in
you
your
haven't. You've
budget
read out some
papers,
numbers and then you've made a whole range of unfounded allegations
Well, if
that
you'd
are
like-
not right when you've just been given the evidence you've been
Well, I
given.
haven't been given any evidence.
You
I
have.
have been given a piece of advice, and I appreciate that very much from the officials.
So you don't
but what-
believe the evidence?
But
is
I
that-
would like you to provide me with additional advice around the reconciliation process to satisfy myself. So thank you. very
Senators,
much,
I'd like to hand the call over now. Senator Roberts, if I can go to you. Senator Pocock and Senator Steele-John are also seeking the call, and then I'll come back to the coalition.
Chair, thank you. I'd like to table some data. My questions are for the Chief Medical Officer. Birth rates have taken a turn for the worse starting in July 2021, as provided by the Australian Bureau of Statistics. December 2021, the last month we have data for, births were only 6,659 against an expected 21,070. That's an almost 70% reduction in live births. This has never happened in the post-war period. It is happening now. Why?
I don't think I have an explanation for that, Senator, but I would
You're the Chief
say-
Medical Officer.
If I could just continue, in my answer to previous questions from other senators, I think it's somewhat disingenuous to take 1 month.
I'm taking
rather
the last
than
6 months, and especially the second last month, and especially the last month of 2021. It's already clear. This is not an accident. This is not a chance event. This is a dramatic decrease in births.
Well, I'll have to take that on notice, Senator.
I hope you will, and I've provided the data for you.
Senator, we're just making some checks on that document to check it's for
That's not
tabling.
mine. That's not mine. Oh, yeah, that's mine. Yeah,
So we'll
that's-
just,
that's
the
both
Secretariat's
sides,
just
yeah.
working on that. Okay.
This is a 6-month downward trend in live births, months below average births. It's not one outlier month. How mad does it have to get before you show any interest?
So I'm not quite sure what responsibility I would have in relation to births, Senator. I won't go into the reason why we have births, but I'm not sure that I have any influence on people's choice about pregnancy.
That's exactly the point. There's no choice. These people are not conceiving. They're having miscarriages at an increased rate, and they're not giving birth to anywhere nearly as many as in the past. Births have fallen 70%.
Mr. Roberts, Senator Roberts, I think we've got the document that you've sought to table. I think we'd probably be fair to allow people some time to just cross-check that. I think you've cited that it's from the ABS website. The point you raise, if it holds up, is an interesting one, which is worthy of some further
Thank you, at
information, but including just checking these numbers, I think it's right. I mean,
just quickly eyeballing it, Senator. No, it's less than 1,000 less than 2017. These figures do jump up and down. We do know that the pandemic has caused all sorts of issues in terms of health. I'm not sure that this is one of them, but thank you for pointing it out, and I'm very happy to come back with something on that.
This is coincident with the injections, not with COVID. It didn't happen in 2020. You're not telling the complete picture.
I mean, if this is birth data,
Correct.
it does take 9 months to have a baby.
Correct.
Just so there is,
And now we've seen 9 months after the injections were introduced, a plummeting to 7,000, less than 7,000 births, when we normally have around 24,000.
Yeah, I think it is right to just give people the
I'm happy
opportunity
to do
have
that.
a look at this data.
Happy to do that.
Without speculating.
Thank you, Minister. That's wonderful. So the other thing, though, following on from that, is this is a worldwide trend. Scotland has announced an inquiry into a 123% increase in newborn deaths. Yet Scotland will not investigate the vaccination status of the mothers because, quote, it could be used to harm vaccine confidence at this critical time. It sounds to me like we are doing the same thing here in your government, Minister.
Sorry?
Senator, if I may, there is data based on actual cases that shows vaccinated mothers have lower risk of preterm birth and stillbirth than unvaccinated mothers in the context of COVID outbreaks. We can provide that information on notice. And it's important to note that, as we all know, correlation and causation are two very different things. There's many things that impact birth rates, including different migration flows that we have seen in the COVID epidemic. As the Secretary and the CMO and the Minister said, we'll analyse that data, but we will also provide you with numerous studies that show that the importance of protecting pregnant, expectant mothers and pregnant women with the vaccines to reduce impacts on the unborn fetus.
Thank you, Mr. Toker. As I recall it, Britain has now stopped injecting pregnant mothers. As I recall it, Denmark is now saying they don't want to inject anyone under 50. As I recall it, Pfizer did not do testing on pregnant women. Also, are you aware...
Senator, I have to correct that record. That is you've jumped from 3 steps there. I think Dr. De Tocker has very clearly stated that it is a protective effect for pregnant women. I'd also like to just...
I disagree.
I would like to put on record for the committee the actual data from 2021 from the ABS. This is obviously, this would be provisional data, I would suggest, taken at a certain date. There's no sign there when you took that data, but here is the data as of the 25th of the 10th, 2022. From the ABS, Australia registered 309,996 births in 2021, an increase of more than 15,600 on registered births in 2020, and lifting the total fertility rate to 1.7 babies per woman, following a record low in 2020.
Well, we took it around the same.
Against your accusation.
We took it around the same time, Professor Kelly. What is the number of births for December 2021?
So I'll look at that, but I'm sure that what you've tabled, Senator, is provisional data, probably at the end of 2021 or early 2022. This is the updated data as of in the last month, 309,996, which would actually make 2021 the highest birth year right back before 2012.
And that makes sense because of the lockdowns for the first part of 2021.
Well,
what about
the
second half of 2021, and particularly the last 2 months? I understand that.
For the data is for the year.
I understand that. What about
anyway? I think it's probably.
So I think you need to check the first half and also the last half, and especially the last 2 months. What are the figures for December 2021, Professor Kelly?
Well, I'll look at that, Senator, and as I said, I'll provide that on notice.
Sorry, Senator, I also would like to correct the record. While Denmark has reduced the use of additional boosters of vaccine in under 50s, they still recommend the vaccine in people under 50 that are higher risk of severe disease, which includes pregnant women.
Which then raises issues about risk of the injections and versus risk of COVID.
which our authorities and the Danish authorities consider
I'll come to some.
they absolutely outweighed in the case of pregnant women.
I'll come to some papers in a minute that can contradict what you're saying.
Senator Roberts, just to give you an indication, I'll be seeking to move the call in a few minutes, okay?
Norway has just listed heavy menstrual bleeding as a Pfizer side effect, which makes sense. Our Danes database has 2,000 reports of the same condition from Pfizer. How does Norway's announcement not tell you where to start looking for that 70% reduction in births?
Well, I don't think we're accepting the 70% reduction in births. For a start, we've taken your table on notice. We've given you an answer from the data that's available on the ABS website. And, you know, if there's anything further to add,
Thank you, Minister.
we will come back on.
Let's turn to deaths. According to the ABS, you'll see the graph on the back of that page, provisional mortality has been above the long-term average for the last 12 months, and for the last 10 of those above anything Australia has ever seen. Why?
Well, we talked about excess deaths earlier, Senator, but the reality is in 2020 and 21, Australia was one of the few places in the world that had the opposite of excess deaths, less deaths than expected. But in 2022, we have seen over 10 million cases of COVID, and even though the case fatality rate has been low in comparison to previous versions of the virus, we have seen deaths from COVID, sadly. There's also, as we've discussed earlier today, been an increase in several different other types of disease that have led to death. Dementia, diabetes and so forth has been mentioned. So this is the experience that other countries have been seeing for the full pandemic. We've just seen it for this year.
I'm glad you raised COVID, because actuarial data to June 2022 shows the increase is only partly COVID, with a reduction in other respiratory diseases largely offsetting the increase in COVID deaths. The real source of these excess deaths are heart disease, such as myocarditis, and in neurological conditions such as blood clots in the brain. What's up with all the deaths from heart disease and blood clots?
Well, as I said, Senator, there's a range of things that have increased in terms of causes of death. And I don't know if Mr. Gould is still here, but he can perhaps talk to some of those things. He's been doing excellent work, as he mentioned earlier, with the ABS and delving into some of these matters, which are complex but important to understand.
Senator Roberts, just while he's coming to the table, I am seeking to move the call around after this.
So, Philip Gould, the First Assistant Secretary for the Health, Economics and Research Division. In terms of the excess death data that you're talking about, it is correct to say that there have been some causes of death which have experienced increases to higher than normal levels during 2021. They include dementia and diabetes in particular. There's not strong evidence that I have in front of me, but I can check this for you for the cardiovascular conditions that you're talking about.
Thank you. Last question for now, and I'll move on. The following data is from the Australian Bureau of Statistics, published in part as a result of a document discovery that I initiated a few weeks ago. In 2019, the year before COVID, the seasonal flu cost 4,126 lives. The next year, in 2020, Australia recorded 882 deaths from COVID and 2,287 deaths from the flu, for a total of 3,169 deaths. Almost 1,000 less than the flu alone killed the previous year. Then in 2021, 1,137 deaths were recorded from COVID and 2,073 recorded from the flu, for a total of 3,210. This means deaths from the flu, including COVID, across the first 2 years of the virus in Australia were right on the long-term average of 3,255. There was nothing unusual about the Australian death rate in 2020 or 2021. And yet the COVID substances, the injections, were given emergency approval. The only unusual thing about our death rate in 2021 was that it was at a 7-year low. This makes a joke of provisional approval granted for injections out of urgency. I'd like to know how this can possibly be justified.
Professor Kelly can answer that very eloquently.
Thank you, Senator. The effectiveness of our public health and social measures against COVID during 2020 and 2021, for the most part, and including in particular our border closures during that period, actually stopped flu entering the country and circulating in its usual way. You've quoted 2019, that was a particularly bad year for flu. There were over 300,000 cases in that year, and as I think you mentioned, 949 deaths from flu. In 2020, there was 21,000 cases of flu. Most of those were in the first 3 months of the year. We had no flu season during the winter and only 37 deaths. In 2021, 592 cases of influenza and 0 deaths. And then it rebounded this year, as you no doubt know. The issue that you've raised is an important one, though, because actually the same people, overall the same people that are at risk of severe flu are also those that are at risk of severe COVID. And so in a sense, one has replaced the other, you're quite right. But there's no doubt that COVID is much more, in the absence of vaccination and the absence of treatment, which is where we were back in 2020 and for parts of 2021, is far more severe. And that's why we've taken the steps we've taken. And I've already quoted earlier today the extraordinarily lower rate of death for those that are vaccinated compared with those that are not.
Okay, Senator Pocock.
So my question, I haven't got a question, but I just want to say you have not explained
Senator
why
Roberts.
we have low flu
Senator
and COVID
Roberts.
and yet high.
I've moved the call to Senator Pocock. Senator Pocock, you have the call.
Thank you, Chair, and thanks. You're still here. It's a massive effort. If I can just start in Budget Paper 4, on page 136, there's a table that shows $12.38 million associated with the Australian National Preventative Health Agency special account. I understand that this agency has been dormant since the early Abbott years, so I was interested in what the money's doing in there.
It has been, Senator, but it hasn't, to fully dissolve the agency would have required the passage of legislation, and that legislation hasn't happened, so it still exists as a legislated entity, and it does have to have its notional cash assets reported every year in our financial. Mr. McCormack can give you the full information.
Well, you've pretty well covered it, Secretary. It's an entity that exists in legislation but isn't active. The PGPA Act and associated regulations require us to report on it. We compile a set of financial statements for it every year and publish it in our annual report. The only transaction in those financial statements every year is the value of the audit work that the ANAO do to verify it. There is a cash reserve. But that cash reserve is associated with the special account that the ANFA had when it was active, and is not accessible in any way, shape or form by any other agency. Should Parliament consider legislation and pass legislation to dissolve it, that nominal cash amount would fall back into consolidated revenue. Okay. Until that happens. We are actually considering stopping reporting on it now that it's been more than 10 years since it's been in effect, and we have that option, but hitherto we've been reporting.
Did you say the ANAO still does reports on it?
The ANAO is the
on something
auditor.
That hasn't done anything for a decade.
It's ironic. They don't do performance reports on it, so the ANAO...
I hope not.
No, certainly not. The ANAO is the auditor of our financial statements. They audit all material agencies' financial statements. They do the ANFA. They wouldn't normally do the ANFA, but they just do it because
You'd hope it's a quick one.
We deal with it. The value is very nominal, and our Chief Financial Officer was very excited in the 2021 financial year to have ANFA be the first set of statements that were fully finalised in the Commonwealth, simply because there was only one transaction. Okay. It's an anomaly.
Well, if there's no plans for it, hopefully we can get rid of it at some stage. Can I just come back to the National Preventative Health Strategy? I know you took on notice how much of that, the percentage of that is COVID related. I understand you said that COVID is part of that. Could you outline exactly which COVID programs are part of that preventative health strategy, or counted as part of it?
So, thanks, Senator. I'll ask my colleague, Ms Street, to detail. I think the question that we took on notice was how much of the broad government budget is spent on prevention, and we talked about kind of various things that go into that. Sorry, pardon me. The AIHW reports on public health expenditure and prevention in particular. The last report in 2021 from the AIHW, all governments spent about 2.4% on public health and prevention in the 2019-20 year, so there's always a little bit of lag in terms of collection. But Ms Street might go into detail in terms of kind of how that's calculated.
Thanks. So Celia Street, First Assistant Secretary of Population Health Division. As mentioned, AIHW, Australian Institute of Health and Welfare, does the estimates, and what they include in that is things that are specifically on preventive health, immunisation and health protection get captured in that collection. So when we do, and the reporting that we've talked about in terms of there being 2.4 across states and territories, and ourselves, so 2.4% was 2019-2020. When we look at the numbers now, it's much higher because of the vaccination elements. But what we do include in those figures goes to things like, it does include screening behaviour as well, drug and alcohol, chronic disease, public health. So there's a number of things in there, but immunisation is one, which is the reason why we would see the figures for the last couple of financial years being significantly higher, but that will come out in the future reports.
Minister Gallagher, I know this is your area, but I'm just interested in the, just sort of thinking this through. If you said to most Australians preventative health, they would want money spent on that, like we can all see the benefit of that. My concern is that if a big chunk of that is just COVID related, like is it, I guess, yeah, Minister, is that should that count towards, you know, a goal to have preventative health that's hopefully leading to much better outcomes and a whole range of those other things that you mentioned?
Well, I mean, at a broad level, I 100% support more investment in preventative healthcare, and that was the work that Professor Kellery and I did 10 years ago, perhaps, in the ACT, where we tried to shift effort. But with the amount of resources available and the calls on, you know, it is hard. I'm genuinely telling you, it is hard to make. Well, you can make. You can do it over time. It requires a fair bit of time to shift focus, and that's partly because the acute system and the primary care system require so much investment. But I think Minister Butler, and you certainly have strong support around the room around looking at ways to increase focus in this area.
But to get to your point, Senator, the investment in vaccination is generally accepted as a good preventive health measure. I think the anomaly that you're referring to is that we've had a huge, big demand of COVID vaccination, which is distorting the report. But I don't think you would disagree that investment in, you know, normal polio, infant vaccination, they're very strong preventive health measures. So that's why they're counted. But we agree that it is an anomalous.
And it's potentially, one, it's obviously distorting how much you'd think we're spending on preventative health, but we're also potentially in this situation where if hopefully COVID isn't, there's going to be a massive drop-off, and then we're going to have to be scrambled to find that 5% by 2030.
Senator,
tough situation.
If I may, I'll just say that the funding in the October budget for the Australian CDC consultation that's kicked off.
Next question. Thank you.
The discussion. Oh, okay, getting ahead of you. The discussion paper was released this week. Firstly, to our state and territory colleagues, the health ministers, and so on, very key partners in this, of course. but more widely yesterday and then today publicly on the website. I don't have a copy here, but I'm happy to make sure that that's provided to the committee. But that has very specifically as a platform of the incoming government included many of the things that were in that previous agency that you mentioned and preventative health more broadly. So it's not just about infectious diseases, but it's also prevention and prevention of chronic disease as well.
Thank you. And on the CDC, is there what's the timeline like to establish?
So as I said, the consultation, the discussion papers there, we've done a lot of thinking and looking at what's here now and what we can learn from our experience over the last few years, but in particular in relation to pandemic prevention and preparedness and control. So that's happened. We've had good work and collaboration from international Centres for Disease Control, specifically in the US, but also in Europe and other places. That's been brought together into this discussion document with some key questions about where we should go to next. We've been tasked with a short timeline to get that back to Minister Butler for consideration, with a view to having further announcements at the next budget.
So not before June next year?
So that'll be in May. The budget, and then subsequent to that.
We've started work on that now.
Yeah, so there's no rest.
Okay, so
for the
second
finance
half of
minister.
next year at the earliest.
At the earliest, yes. But I think that, this is a potentially a very big change, and so getting that right is really important. And certainly feedback from the many stakeholders that are very excited about this. That we've been talked about it for my entire medical career. Certainly since 1987 was when the first calls for Australian CDC were made. Yes, it might seem like a long time, but I think in terms of these types of reforms, it will actually go quite fast. There may well be, depending on where the discussion and the consultation goes to, a need for legislation, for example, which, to form this entity, I'm almost certain it will. Yeah. And so that will obviously take time and fits into the agenda and will require support in the Senate. So happy to talk through that when it comes to that point.
Thank you. And
Senator Pocock, I'm seeking to move the call on shortly.
Sure.
How are you going?
Got one or two left. Thank you. And in terms of the role, do you envisage it'll extend to sort of looking at growing the public health workforce, sort of looking at where the gaps might be?
Workforce is absolutely part of that process, and my colleagues might want to talk to some of the work that's been done there specifically in public health workforce. Or not?
I'm happy to take it like that. Yeah. The other thing was whether it would have any responsibility for delivering the national preventative health strategy.
So that's on the table, but no decisions have been made. There'll obviously be a decision of government about how that works, and what goes into the CDC is a key component of the scope element, and there are specific questions in that discussion paper I mentioned around those types of things. But certainly workforce, chronic disease, prevention, health protection, all of these things are within scope at the moment, and then how that works through, and particularly about we don't want to miss the chance to stop gaps, but we also don't want to have create overlap, particularly with the states and territories. So all of those things are on the table now.
And Senator, I would just add, in terms of the preventive health strategy, obviously all states and territories and the Commonwealth have a role in that. So the CDC may have a specific role, but all governments will have a role in delivering on the actions and targets in that strategy. So in many ways that responsibility will be shared. And one of the kind of key elements of the preventive health strategy is looking at what is that public health workforce. Obviously, we've learned a lot through COVID, and the strategy actually goes to that issue as well.
Thank you very much. Thank you, Chair.
Thank you, Senator Pocock. Just to assist those in the room, we will be seeking just to go into the dinner break a bit to finalise a few questions. So Senator Steele-John's going to do a block of 10 minutes, and then I understand Senator Ruston seeking a block of 5, Senator Rennick is seeking a block of 5, and potentially Senator Roberts is seeking a block of 5, and then we'll be looking at going to the... Oh, apologies, Anna, I thought you did, but we'll be seeking to move to the dinner break quite shortly.
At what, 6:30?
At 6:30.
Okay.
And it will likely be a shortened dinner break because of that. We'll seek to provide
I
some
probably
advice.
I've got a couple of things to do, so I probably need 45 minutes for dinner.
Yeah.
I thought dinner was at 6 till 7, so we're going to have to just...
We're seeking to move through things as quickly as possible, so can accommodate.
Yeah.
I'll go to you, Senator Steele, John.
The settings that we're currently on in each state and territory rely on people taking personal responsibility and following the advice to wear a mask. What program is the federal government currently running to educate the community in relation to wearing masks?
So I think I'll take that one, Senator. It's related to the discussion I had earlier around the community protection framework. So at different points in the pandemic over the coming months, and there is a wave now. There will be other waves in the future. That advice will change, and we have a plan in relation to communications to switch on, more intense messaging around mask wearing when a wave is on. And so we mentioned earlier around the Queensland announcement today about an amber, what they call amber in their alert framework is very similar in that community protection framework. So we are increasing messaging around masks now.
Right. And what is your, just to clarify, there is a public communications campaign going on right now about mask wearing, funded by the federal government.
There's an ongoing communications campaign. I don't know whether Ms Belmano will come up and have a talk. We certainly have ongoing social media campaigns on those protection mechanisms, but Ms Belmano can talk to you about
I have. Apologies, I've forgotten my tag. It's Rachel Belmano. I was on before, First Assistant Secretary, People Communication and Parliamentary Division. So we have 4 strands of creative in market at the moment, and one of those is about COVID-safe behaviours, which includes mask wearing. The dominant messaging at the moment is around the oral antivirals, and for people to make sure they're having who are eligible to have those early conversations with their doctor, so if they catch COVID, they can get onto the antivirals quickly. But obviously, as the epidemiology changes, we change the balance in terms of the advertising.
So at the moment, of those 4 pieces of creative, I wonder, just for time, can you take on notice who is providing us with the information about those creatives and pieces of content spend, particularly in relation to audience that you're targeting?
Yep.
So the pieces of creative themselves, if you're able to provide them.
Yep, so they are we can definitely do that, but all of our creative is also always available on our website, but we can provide all the links and those things.
Yes, thank you. And about the information that informed those pieces of creative, and where you are targeting them in terms of the audiences that you're selecting. Now, are we encouraging the use of, does the creative encourage the use of high performance masks, P2s, N95s? Does it specify
So
that?
it doesn't, as you'd appreciate, the nature of an ad doesn't go to that level of detail, and these are either radio advertisements or digital advertisements, or in this case, some of it is sort of the posters that you see at bus stops and shopping centres, those sorts of things. So it doesn't go to the detail of the mask type. But obviously the department does publish information about different masks, and particularly the performance of different masks is something that the Therapeutic Goods Administration has assessed and published information on.
With respect, given that it's creative that you have created, you could have decided to make it specific to high performance masks. I've seen some of these ads and they say wear a mask, and there was a creative decision made there somewhere to say wear a mask rather than say wear a mask particularly of these types.
You're absolutely right. The issue though is that the advertising in this sense is not just about masks. It has a range of messages that we're trying to encourage people, including, for example, stay home when you're sick is obviously one of the great preventive behaviours people can take to avoid spreading COVID-19 and other illnesses. So it has a range of different messages. Within that context, going into the detail on the masks would have made it too complex. But you're quite right, it is a decision.
And particularly, Senator, if one were proposing broad community use of high-performance masks, it would be irresponsible to do that without current messaging that they are not effective unless they're properly fitted and applied. So whereas I think the general messaging is that any mask is better than no mask, certainly in terms of people spreading coronavirus. The high-performance masks are much better to protect the individual from getting it, but they do need to be, if they're not fitted properly, they're probably worse.
I'm aware of that, and I just in terms of time, but thank you, I do know that.
And we do have information that supports the proper fitting and selection of masks.
I also know that. Thank you. So could I just go to a question then of modelling for the upcoming wave? There have been several announcements made about this in this week particularly, framing us up as at the beginning of the wave. Has the federal government done modelling of what the next wave of COVID-19 infections may look like?
So the federal government has not done that modelling for the general community, but several states have done. They're all fairly, at a high level, have been made available to us. But realistically, Senator Steele-John, several months ago I predicted there would be a wave in November. I don't need modelling to do that. We've got real data and we've got real surveillance data now in real time. And so the usefulness of modelling in these matters is becoming, in my view, less important. But the real data that we have and understanding the vaccination rate, etc., is important, as well as looking at recent international experiences, for example, in Singapore in the last couple of months. I think that's what we will see. We will see a short, sharp wave. We'll see quite a lot of cases. I don't think there will be a major increase in hospitalisations at this point, but we are dealing with quite a large number of different and new variants, and so it is a little bit more difficult to predict.
Okay, but which states and territories have undertaken to model the current wave?
I certainly know New South Wales, Victoria, South Australia, and I believe Queensland. And possibly WA, but I'm not sure. So pretty much all of them, yes.
But the federal government hasn't?
Not at this time, no.
Okay, that is of a concern.
Well, as I said, Senator,
not if you...
we don't need, you do modelling you do modelling on two reasons. One is to look at when you're in a time of uncertainty, and we're in less uncertainty now. And secondly, when modelling can demonstrate what you need to do to decrease a wave, we know how to decrease a wave. So it's less important than it was earlier in the pandemic, in my view.
The majority of states and territories obviously disagree with you, but I'll move on because we are pressed for time and I must go to long COVID. Can you confirm the amount of funding that was allocated in your recent budget, specifically for long COVID research, supports or treatments?
I'm not aware of any funding specifically for long COVID, Senator, but we've had quite a lot of discussion around the MPAs with the states, for example. There'll be others that we'll be able to talk to that.
So no funding specifically for long COVID in the budget?
No, and the reason for that is, as mentioned earlier, that there is a parliamentary inquiry in the House that is looking to that. I think other countries, I'm sure you know, have made
absolutely do know,
made
yes.
money, but we, as part of our preparation for our submission to that inquiry, have had extensive conversations with particularly the US and the UK, New Zealand and Canada. In relation to long COVID, and several other countries in Europe actually, it's guesswork about what's needed in those countries. And as I mentioned earlier, long COVID is definitely a thing. I am absolutely convinced that there is long COVID. We do need to do something about it, but it needs to be based on information and data which we're working on at the moment.
Senator, I think it's important to note that under all agreements, the National Health Reform Agreements, NPAs with the states, we do fund the Commonwealth's share of all of those, the clinics that the states and territories fund, and some of them have set up dedicated clinics, which we fund our share, and obviously there is a significant MBS expenditure that obviously is demand driven, including chronic disease management items which can be used to get allied health treatment. So there is funding, and there's been a lot of previous funding through the MRFF for long COVID research through. So I think there has been funding, but in terms of, I think you're getting at treatment funding.
Well, no, my question specifically asked in relation to specific funding for long COVID research supports and treatments. Professor Kelly, you just referred to the work being done overseas as guesswork. Surely funding research specific to long COVID would in fact reduce the guesswork.
Absolutely, and there is $8.1 million that has been allocated specifically to long COVID research from the MRFF. There's others that have come from the NHMRC. There might be others in the room that can talk more specifically to those research figures. But just apart from that, there's been a very large amount of work done in the last couple of months within my own area and other areas of the department, trying to get a sense of what is actually happening in Australia. I think we, and I'm on record as saying this previously, that we do need to be cautious about extrapolating exactly from what's happened overseas because of our different experience here.
Professor Kelly, and again, I usually let you go for longer, but just for time and to clarify, the funding you just referred to through the NHMRC,
the MRFF.
The MRFF, is that for COVID research?
No,
specifically for long COVID. There's been $130 million that have been given to COVID research, vaccines, treatments, other elements.
There are some basic research projects in long COVID, and particularly $3 million to the Institute of Health and Welfare to get that important data that Professor Kelly was talking about that we haven't got. So
was that identified in the budget, or was that
previously allocated? The MRFF is an ongoing measure. So Ms. Somi can give you the details if you're right.
Hello, Marsha Somi. I'm the CEO of the Health and Medical Research Office. So just to confirm, there has been investments. I don't have the details of the project specifically, only to confirm it has been $8.1 million specifically for research to understand long COVID and the impacts on populations, particularly vulnerable populations.
Can you take that on notice and provide it to us?
Senator Steele-John, I need to hand the call over.
That's my end point.
Thank you. Senator Ruston, we're going to try and go to the dinner break at 6:30, guys.
Okay, all right, so it's super quick. In the March budget, there was $6.8 billion for medical research that was made up of 3.7 from the National Health and Medical Research Council, 2.6 from the MRFF and $500 million from the Biomedical Translation Fund. Can you tell me where I'd find that in the budget papers?
He knows his way around the budget papers.
So you're talking about the October budget papers?
Yeah, so I'm just trying to understand whether that's still there.
So definitely the funding is still available.
Okay.
I would have to look exactly where the
That's
figures
fine.
are in the budget table, but those funds are still remaining and available.
I'm more than happy for you to take it on notice if you can just...
Technically,
Yeah.
if there's something in the March budget that continues, it doesn't get repeated in the October budget.
No, that's fine, just to making sure that there was just... If you can just provide me with the whatever evidence there is to that's all. Wasn't a criticism.
Well, that is the evidence that it appeared in the March budget,
so
but it's not reversed.
Because it hasn't been reversed. Yep. Okay. Cool. That's fantastic. Thank you. In budget paper number 3 on page 30, there's a table about health infrastructure projects.
I only brought up 2. 1, 2.
So page budget paper 3, page 30, under the South Australian column, there's an amount for $4.3 million.
Senator, bear with me, I'm just trying to bring up the relevant page. Thanks. All right. Yes, Senator, I found it.
Okay. Under the notes, it says that this for providing funding to support the implementation of the Regional Cancer Treatment Centres for Radiation Therapy Program in Victoria and South Australia. Could you confirm that that $4.3 million for South Australia is for the Regional Cancer Centre in Mount Gambier / Limestone Coast?
I'm just checking on that, Senator. My apologies, Senator, I'm just having trouble locating the relevant brief. Senator, I'll need to take it on notice, and but we should be able to get back to you fairly
Okay, so
quickly.
yeah, if you can, in response, I just need to understand where the grant process is in relation to that, assuming, of course, that is the one, and just where the agreement's been reached with the South Australian Government in relation to co-funding. So if I could just get some information back on that, that would be great.
We'll get that for you on notice, Senator.
Thank you very much. Can I just go to a few questions on women's health?
Women's health.
Hi, Ms. Rishner, back again. During the election, Labor matched the Coalition's commitment to fund 20 new Gidget Foundation perinatal mental health and wellbeing services. In the budget, it appears that there's been a provision for 12 and not 20. Can you confirm that?
Thanks, Senator. So the commitment still stands for 20 Gidget centres. The funding allocation is for 12 with a trial at the end of it to inform, the ongoing development of the additional 8. And it also takes into account MBS costs to be able to fully support the perinatal mental health. Mr. Rodden may want to add.
Okay, so just before you go to that, can you just explain to me where the additional 8 exist in terms of commitment?
So there's a clear election commitment to 20 perinatal
But is it
centres.
contained anywhere in the papers as to, is it been provisioned for? Because in the papers it says only 12. So I'm just wondering whether, is it just we need to believe you there's another 8, or is there something that you can point to for me?
Mark Rodham, First Assistant Secretary, Mental Health and Suicide Prevention Division. So the original, so there are 12 provisioned in the budget, which comes to the original funding amount of the election commitment, because the election commitment or that envelope of funding didn't include MBS costs. So the way the Gidget Foundation's model works is it provides facilities to support clinicians to support people with perinatal mental health needs, and they then charge Medicare, so that then includes the Medicare costs. So there are the initial 12, as Ms Rishnu says, then an evaluation will inform the rollout of the following 8.
Okay,
so the government's committed to the full commitment, to the election commitment? Yes.
Okay, but there's
and the Gidget Foundation is aware of this?
Yeah, no, I'm aware that they're aware of it. I was just trying to find, there was some pointing into the budget paper somewhere where the additional 8 million, because you're saying that the decision to move from 20 to 12 was on the back of the increase in the Medicare MBS items that were going towards it, and yet I think on Tuesday night when we were talking about urgent care clinics, you said that there was no provision in relation to MBS and the additional costs of additional MBS items.
We're finalising the model for the urgent care clinics, whereas this is known, so it's and costed. Know how much it costs, and we've made the commitment. We'll evaluate after the 12 once, and the Gidget Foundation is aware of this. So full steam ahead.
So can I take from what you've just said, Minister, that if in your design and evaluation of the urgent care clinics, if it comes out that they actually are going to cost more per clinic than the 235 million, you won't be rolling out 50 clinics?
We committed to the 50 clinics. We went through this the other night.
No, I'm just saying, if you're going to compare apples for apples, there's no provision at all for the extra 8. You're saying you're committed to them. So I'm just interested that there is no provision for it.
But we'll do it carefully. We'll evaluate. We'll make provision. We'll do.
And then you'll cut them if
right.
that's the decision that you want to do. I don't think anyone can have any confidence that you won't.
No one's talking about cutting them, but evaluation is going to be an important part of the way we budget as well, to make sure that the money that's being invested is working and delivering the outcome. Like, that's part of the responsible budgeting approach that we're taking, which differs from the previous administration.
Well, if you're taking a responsible approach, then I don't know why you haven't budgeted for the 1220 if you're actually committed to doing them. But moving on to...
We're evaluating.
Yeah, you're evaluating, and you're evaluating the urgent care clinics, but you haven't taken into account the Medicare component of that. You're contradicting yourself.
No, we're not.
But
we're finalised. We went through this the other night on
I know we did.
We were very clear on it.
Yeah,
we
we
committed
were,
to the 50,
but you're not being very clear
We're committed
here.
to funding them, and yes, we will evaluate, but we'll also in urgent care settle the model.
Senators, I'm seeking hand over the call to Senator Roberts soon.
Okay, so moving on to endometriosis, and can I acknowledge Assistant Minister Carney, who very graciously yesterday acknowledged the commitment of the previous government in relation to the $58 million that was made available in the budget in March to support women with endometriosis. A very gracious gesture on her part, one that we don't often see, so I commend her. The two announcements yesterday were in relation to the pelvic pain GP clinics for $16 million and the MBS MRI rebate for $25 million, which adds up to just over $41 million. I'm just wondering, the remaining items that were contained in that $58 million promise in March, where are they, and is the government still committed to the delivery of those other items?
So, Senator, Ms Schofield will give you the detail, but once again, the commitment to the 58.3 is maintained. The announcement yesterday specifically went to the announcement of the expressions of interest around endometriosis and pelvic pain clinics and those elements specifically, but the overall package remains. So
And the
Ms
commitment to
Schofield can go
the
into
individual
detail.
items in that package remains. And whereabouts is that contained in the budget?
So they were part of, as the Minister
okay, so
outlined,
so nothing's changed. Great, thank you very much. And in relation to, you can cut me off.
Sorry?
You can cut me off.
We've got to go at 6:30 and we're going to try and get Senator Roberts a call, so Senator Ruston.
Okay, well, I'll ask one question in relation to the IVF deferred funding in relation to women or parents with cancer or genetic conditions to have their eggs, embryos and sperm frozen. That appears to have been deferred in the budget. Is that correct?
Senator, I'll go to my colleague, Ms Shakespeare, on that one.
Yes, Senator, to allow more time to work with the sector on how that measure is rolled out, so it's commitment to implement it. But the form that it takes and to ensure that it doesn't have a negative impact on people who currently have their embryos and other things stored, we just need some more time to work with patient groups and with the sector.
Okay, thank you. And finally, if you may need to take this on notice because I'm getting eyeballed.
No, we've got to go to dinner break now, so
in relation to Oncotype DX breast cancer testing, Could you please provide me some advice in relation to the MSAC process that has gone around that, why we still do not have access to it, and why you are spending clearly hundreds of thousands of dollars defending releasing documents under FOI in relation to that particular case? If you could come back on notice.
Senator Roberts, if you can ask a question in 1 minute, and then we're going to the dinner break.
Thank you. My question is to the Chief Medical Officer. The previous Prime Minister repeatedly said that Australia has no vaccine mandates. I'd like you to clarify something you said or alluded to earlier today about the states drove it. The Morrison-Joyce federal government bought hundreds of millions of doses of the injections. The federal government indemnified the states. The Federal Health Department provided the data and systems access needed for the states to enforce their mandates. State premiers said that their vaccine mandates are in line with the unconstitutional so-called National Cabinet. The federal government mandated vaccines in several departments. The federal government funded state restrictions that empowered the Prime Minister. In other words, the Prime Minister of the previous government enabled and drove the vaccine mandates. What I want to know is, what was your role in that breach of basic health principles, informed consent replaced with coercion, the doctor-patient relationship being invaded, and why were those vaccine mandates put in place when the Federal Health Minister at the time, Greg Hunt, said the world is engaged in the largest clinical vaccination trial? How can they force a trial, an experimental drug?
I'm just not quite clear what the question is there.
What was your role in that?
There's a
The
lot
question
to
was clear.
unpack.
It's a lot in there, so maybe take it on.
And it's probably been
take it
dealt
on
with
notice.
before. In
No,
a
it hasn't.
couple- Really?
No, it hasn't. No.
That kind of
I'd like you
vibe.
to clarify your role in driving or enabling the Prime Minister to drive those vaccine mandates around this country.
My role's been fairly clear and has been voiced in multiple Senate hearings over the last several years, and before me, Professor Murphy.
In relation to the vaccine mandate.
Senator Roberts, just let him finish the question. We're going to the dinner break. I'll allow
Take it on
Professor
notice.
Kelly to finish the question.
advised the National Cabinet.
Take it on
And
notice.
I chair AHPPC. There's nothing to take on notice, Senator. I'm the chair of the AHPPC. The AHPPC has advised National Cabinet. National Cabinet has made decisions in relation to vaccination. That's it.
Thank you.
Thank you. We will now break for dinner. 45 minutes.
To you. Earlier in the day, in a line of questioning in relation to APS Code of Conduct breaches, the agency sought to bring me back information. I was just wondering whether that information has been, and if so, could you bring it back after the dinner
Okay,
break?
after dinner. We're going to the dinner break now for 45 minutes. We will return at...
Still doing outcome one?
No,
we will
we're going to
provide
aged care.
advice to you very shortly. The committee's about to hold a private meeting, and then we'll be providing advice very soon
So
after
do you want
that.
us to hang around or not?
Oh, sorry, outcome one we're finished with.
No, we're going to aged care after the dinner break.
Right, so outcome one, people can go.
Outcome one, we are agreeing to release. We are holding a private meeting.
Okay.
We will advise you shortly,
More
but aged care
information
should be
later.
here.
Okay.
Mr Chair, can I just ask the PSR Director from the MBS is the only external official who's been hanging around waiting?
Yes, that's in outcome two.
That's in outcome
That
two.
can go.
So any other officials from outcome two?
The committee needs to hold a private meeting
Yep.
to look at the order of business. We will provide advice to you
But
in
the
about
PSR Director can go.
5 minutes. We'll provide advice in 5 minutes. Thank you. Katie Gallagher, Minister for Women, Minister for Finance and Minister for the Public Service, representing the Minister for Health and Aged Care, the Honourable Mark Butler MP. Minister, do you wish to make an opening statement?
No, thank you.
Excellent. I welcome back Professor Murphy, Secretary of the Department of Health and Aged Care. Professor Murphy, do you have an opening statement?
No, thank you.
Okay, thank you. Senator Rice, you have the call.
Thank you. Sorry, thank you. So I wanted to start with asking about where we're at with the development of the new Aged Care Act. So what's happened since the election, what the next steps are, what the timeline is. Kick off with.
Mel Metz, Assistant Secretary, Legislative Reform Branch, Senator. So the new Aged Care Act falls within the responsibility of my branch. Obviously the Royal Commission recommended that the Act should start mid-next year, which wouldn't allow a lot of time for parliamentary passage. So at this stage we're aiming to have the Act ready for introduction next year. The precise timing of that will be a decision for government. We're working on the Act and various components of it, particularly at the moment we're focusing on the rights aspect and the initial entry criteria for people. We're working with the Office of Parliamentary Counsel. There are a lot of different components that will go into the Act, so lots of different policy areas working on aspects of it. So the new Support at Home program, new regulatory model. So all of those aspects are being worked on simultaneously.
Okay, and what's been the consultation and engagement program up to date, and what's planned from here?
So we've been engaging very closely with the Council of Elders and the Aged Care Advisory Council on different aspects of the Act. They're really our initial point of contact. We've also got an expert advisory group that we've set up within the department with experts across areas ranging from human rights. We've got representation from Consumer Peaks on that organisation. Amy, Ms Laffin might have more information about that. But we've been engaging primarily with those groups at this stage.
Perhaps if you can certainly, Amy Laffin, First Assistant Secretary of the Quality and Assurance Division. Certainly we intend on having an exposure draft of the legislation prior to introduction, so that will largely be the consultation process.
Okay, so you'd be that far down the track before you had broad consultation?
As Ms Metz mentioned, we have been consulting on policy elements of the new Aged Care Act. So
with a fairly important group of stakeholders, but a fairly limited group of stakeholders so far.
But even, for example, on home care reform, which will form a large component of the new Act, there's been a separate consultation process on that. So if you break up those policy elements, each of those have had their own policy consultation processes.
I suppose I'm interested in the sort of overarching framework and noting the difference. I'm pleased that you said that focusing on what the rights-based approach looks like, because certainly the Royal Commission very strongly said that it had to be a rights-based approach, then that framing the reform agenda as one based on entitlement is essential. It should provide an entitlement to the support and care each individual needs to prevent and delay the impairment of their capacity to live independently. And the new Act must enshrine the rights of older people who are seeking or receiving aged care. A rights-based approach must guarantee universal access to the supports and services that an older person is assessed as needing. Do you feel that the Act that you are drafting is going to be consistent with those, with what's stated there in the final findings of the Royal Commission?
So the precise drafting might differ from what the Royal Commission said. We have to work with the Office of Parliamentary Counsel around exactly how that's framed, but in terms of having a statement of rights and that being the basis for the legislation, that's certainly the intention.
So the intention is a rights-based approach that would guarantee universal access to the supports and services an older person is assessed as needing. Is that's consistent with what's being drafted?
So that's correct. So if I just take you to the current Aged Care Act, the current Aged Care Act focuses on aged care providers. It focuses on the funding of those providers. So the big difference will be the new Aged Care Act being rights-focused, person-focused. So it'll be around how a person accesses care, won't be divided so much into the different kind of care models, but presents a kind of a single entryway and really focuses on how a person travels through the aged care system rather than focusing on the provider.
Yes, I mean, the reason I'm focusing on this is that sort of reading the statements of the final findings of the Royal Commission of saying, enshrining the rights of older people, elements of a core human right, the right of everyone to the enjoyment of the highest sustainable standard of physical and mental health. And yet if you read the page on the website about the new Act, it doesn't talk about enshrining the rights of older people at all. It places older Australians at the heart of the aged care system. It outlines the rights of older Australians, but it doesn't talk about enshrining the rights of all Australians to receive the care that they are assessed as needing. So I was just wondering whether, was that a matter of drafting, or is that a specific difference between the approach that's being taken as outlined in the Royal Commission and what's being drafted?
No, it's certainly our intention. And for example, we've already had some really initial conversations with the groups Ms mentioned on the objects of the Act and how we frame rights as part of that. But we're also talking to our stakeholders about having things kind of beyond objects, so that we can have rights in there that are not just aspirational but enforceable, to be enforceable, and how we need to put those and filter those throughout the Act. Working on general powers and other things like that, general duty of care, so how we reflect those rights then into enforceable provisions throughout the Act. So that's certainly something that we're working on.
Okay. And again, the purpose of the aged care system that the Royal Commission outlined, that the purpose of the aged care system must to be ensure that older people have an entitlement to high quality aged care and support, and they must receive it. So that's consistent with what you're drafting. Yep. Okay. Good. And so will you be doing any more extensive consultation beyond, the key organisations that you mentioned before you put out an exposure draft? Because I certainly know, being the portfolio holder for the Greens, that the number of stakeholders in the sector is enormous.
I think
quite different perspectives.
I think, Senator, it depends on the different areas of the Act that we're talking about. So the exposure draft will be the time where our stakeholders see everything as it hangs together, how it fits together in a consolidated view. But we will have, and we have been having, regular stakeholder consultations on various aspects of that, of the Act. So, for example, we're currently consulting on new aged care quality standards, so that gives a sense and a chance for our stakeholders and those interested to input into what those standards look like before they are then lifted and put into the new Aged Care Act. Likewise, the new regulatory framework, we've been consulting on that. That will then be filtered into the new Aged Care Act as well. So largely, to begin with, it's about those component parts that we'll be consulting on before bringing it together into the new Aged Care Act, and that's at the point of exposure.
And what's... obviously, exactly when it gets introduced will be a matter for government, but if we're working on a timeline of having the Act potentially being introduced in the middle of next year, what would be your timing on getting the exposure draft released?
We want to give people a significant amount of time to look at the draft, and then obviously we need a chance to make any changes as a result of that exposure. So,
Senator, what I'll say about that is that a number of the critical policy components of the Act are still under development, and so delivering an Act for introduction to Parliament in the middle of next year is unlikely to be possible.
Right. Okay.
So an exposure draft would be much more likely towards the middle of next year, and as Ms Laffin said, we'll be looking to have a significant period of time for people to comment on the legislation prior to introduction to iron out any potential issues before it's introduced to Parliament.
Okay, so that's useful information. So in fact, you're saying that we're not likely to have a new Aged Care Act in the middle of next year, that it's much more likely to be...
not commencing in the middle of next year.
The end of next year rather than the middle of next year.
Well, it might be, Senator, it might be before the end of next year. It'll depend a little bit. I mean, obviously, what we've found on the consultations we're doing on the home care reform component of our reforms, we've been out and got kind of quite definite feedback from stakeholders, and we're back out talking to them again off the basis of some of that feedback. So it depends a little bit on the kind of response we're getting from people around elements of the program, and I think that's true of the Act as well.
In terms of the consultation you're doing at the moment, again, sort of returning to the overall sort of framework and basically the underlying philosophy of the Act, are there are there some key issues of tension that you still need to resolve in terms of how the Act is going to deal with those, in terms of what the stakeholders are expressing to you?
There's nothing specifically I could identify, Senator. I think we've had good feedback from stakeholders and taken that on board.
Okay, so there aren't, I suppose he wanted to know and whether there are specific approaches that particular stakeholders are taking which are in tension with the approaches that other stakeholders are recommending.
There's no particular tension that I could identify, Senator, but we're in ongoing discussions with stakeholders about the approach.
Thank you. I can
do
finish.
10-minute blocks. I can do 15-minute blocks.
I'm happy
this is
to.
the committee.
Yep.
Senator Ruston, okay, Senator Ruston, you've got the call. I'll come back. That was 10 minutes, Janet.
Great.
Okay. Thank you very much. Can we come back to our workforce? So just wondering, have you got any further information in relation to the current projected workforce shortages in residential aged care across Australia?
Sorry, Senator, the current
shortages?
Oh, shortages. Over and above what we discussed on Tuesday night.
Yeah, so I'm just wondering whether you'd had an opportunity, because I was looking for enrolled nurses, nurse practitioners, registered nurses in aged care, and we just had a sort of a vague number of 10,000 somewhere.
Yeah, well, I think we can give you I think the gross number before we look at what we would call treatments, which is all the program effort we've got to generate RNs, was 11,800 RNs would be needed.
No, sorry, workforce shortages as we currently sit here now before we move to the changes in care minutes and 24/7.
Senator Eliza Strapp, First Assistant Secretary, Market and Workforce Division. Yes, that number that Mr. Lai just mentioned is the number before for registered nurses before all the taking into account pay rises and the other programs that we've got in place to plug those workforce shortages.
Sorry, maybe I'm confusing myself
that's the current gap.
Yeah, as we sit here today,
yes,
before any changes come into effect, because they don't come until June.
That's right.
As we sit here today, the workforce shortages for registered nurses in aged care is you're saying is 11,800.
Yes, so that takes into account. So that's the shortage. That's what we need, taking into account the 24/7 nurses.
Okay, no, sorry. No, that's not my question.
Okay,
my question is, right now,
yes,
if we disregard all the
future
changes,
change.
So what is the current workforce shortage?
Ms. Gleeson?
I'm not sure if we've got a figure, but
Yeah.
we'll check.
So, Emma Gleeson, Assistant Secretary, Aged Care Workforce Branch. So, if taking into account just the baseline gap, so that is in the order of 2,000 for RNs and nurse practitioners combined.
So 2,000 for nurse practitioners and
registered nurses.
Registered nurses is 2,000. So what is the date of that information?
Well, we're using the financial year 23-24 as our reference year, so that is what our forecast gap is in that year.
So the forecast gap in that year was forecast prior to any legislative changes?
Yes, that's correct.
Okay, so if there was 2,000 short and you're saying that there's 11,800, then one can assume that the changes are likely to be generating about 9,800.
So, Senator, the care minutes commitment, the 200 care minutes commitment, which was made last year, I think, from memory, last calendar year, is 8,944, so that adds to your 2,000.
Yep.
And then the commitment to 24/7 nursing that the current government has made is 869.
Yeah,
so
in
those
23-24 year
That's
figures.
right, yeah.
Yep.
So those two figures add together with the 2,000 to give you the
758
11,758 figure.
RNs and nurse practitioners.
Okay.
And so then, Senator, what we do...
So when you say you baselined it to 23-24, what was your starting point? What was your data starting point on which you built that? Because obviously you've built it to 23, 24, because that's when you're thinking these other things are going to come into place. I get that. So what was your data that you started with? Because, I mean, clearly you didn't start with 23, 24 data. So was it a workforce survey of a particular time? When did you, what was the date of the the starting point of your...
Okay, so the workforce data is based primarily on the aged care workforce census that we did in 2020.
So these are 2020. So in terms of the true baseline, it's 2020.
Yeah, that's correct.
Okay.
And then we apply growth figures to that to understand how the workforce grows without any policy interventions. And then over and above that, we look at the policy changes that are being made in terms of care minutes and 24/7.
Yep. Okay, so then on the basis of these figures, we're looking at an increase of around 1,000 nurses a year or thereabouts in subsequent years.
With no policy changes of care minutes and 24/7?
No. I think you've got your policy changes in here. If I'm looking at the table that I'm assuming you're looking at, which is the registered nurses and nurse practitioners, the supply and demand headcount in residential aged care facilities, financial year 23-24 to financial year 31-32.
I haven't got that full table in front of me. I've just got the forecast for the next couple of years. I'm not sure which table you...
table as used,
yeah.
Senator.
Yeah. So I suppose what I'm trying to understand is that you've used the 2020 workforce survey. So I'm assuming there's been some quite significant impacts on aged care because of COVID, and just wondered whether there's been any additional analysis on this to try and understand whether the impact of the 2 COVID years on workforce in aged care and all the other subsequent challenges that we've had in workforce have been factored into these numbers in any way.
I think that's what Ms Gleeson's saying, is that we have taken that original baseline census data and we have then extrapolated through to get to the 23-24 year, which is the year we're obviously trying to sort of look at that year, because that's when all of our policy changes take effect.
Yeah, no, certainly understand that. I'm just trying to... So when this table that I've got here, that was in... When was this compiled?
I'm not sure what table you're looking at.
Well, it's the same table you're looking at because you're using exactly the same figures.
I've only got the 23, 24, 24, 25 numbers in front of me.
Are you able to share that table with us, Senator?
Yeah, sure.
So we can see.
Are you sharing or are you seeking to table?
No, I'm going to share. I mean, I don't want you to have all my questions. I will, because then you'll know how to answer them.
Senator Ruston, where did you get the table from? Is it from a published document, or is it?
Yeah. It was something that was. I think it was. It's on the health.gov.au website, and it's called FOI 3902 Release Documents Question Time Briefs PDF.
The officials are nodding. Does that mean you have the document?
Well, we might be able to
We don't have it.
retrieve it, but
in front of us, no.
it's not here right now.
Okay.
But Senator,
All right.
I think...
Well, I'd just be really interested in terms of the development of these workforce numbers to understand, how we've got to them. I mean, clearly we're not disputing the numbers. I mean,
No. So, Senator, we're happy to kind of come back on notice with to give you the modelling, if you like, or the formula of how we've got from the baseline in 2020 when the survey was done to how we get to that 2023-24 baseline figure before we add the policy commitments and before we add the treatment. So we can give you the methodology of that, so you can see that we're taking into account various things.
Yeah. So during the implementation care reform bill in the Senate, Senator Watt had passage on behalf of the minister, and I asked him about these numbers around and whether there'd been any sort of pandemic sort of reassessment or remodelling in relation to the stocktake of numbers of current nurses that were needed in the sector. And he said that there was a health workforce report that was due in November.
Yes, Senator, I believe he's referring to the quarterly financial reports, which will give us up-to-date data on the number of staff in each facility and also the care minutes, so their care minute target, so we can look at how many staff broken down by direct care workforce and other workforce, and then what's their current care minutes target, or what are they currently delivering, and then we can look at what's the gap. So we can use that data that we're getting, and we only received that quarterly financial report last Friday on the 4th, so we can use that to look at where's each facility sitting at in terms of their care minutes, and then what's the gap with the staff that they've got.
So on that basis, I can assume you would have had one in August?
No, so this is the first time that this quarterly financial report is a new report, and this will be the first time that we'll get this report from providers.
Okay, so you should be in a reasonable position to be able to update your numbers over the coming weeks, given that you've got this report. So we should be by February, when we come back again, you should have a much clearer understanding.
Yes, that's right.
Okay, that's great. So will this be tabled? Is this report will it be a publicly available report?
So what we plan to do is, with the quarterly financial report, we'll be releasing a quarterly financial snapshot, which will include some of that information at a sector level, and that's due to be released in February of next year.
Okay. All right, so when you say a summary, what's the rationale behind not releasing the whole report? Is there information in there that's challenging?
You mean every report from every provider, the quarterly financial report?
So you must collate that into a final report?
Yes.
So you're releasing the final report?
So that will be the final report, but I guess I call it a snapshot because it won't be a huge document. I think we release every year we've just released a financial report on the aged care sector. This is a quarterly report that will be shorter, and I use the term snapshot because it will be, but it will include the information that so the full report will be included. It's just not we're not intending to be a really long report.
Yeah. Okay. So another comment that Senator Watt made during that passage of that particular bill was that he said that the sector would be relying on immigration to assist providers to meet their legislative requirements. Do you have a figure in terms of that 11,760 that is likely to be achieved through a migration program specific to the care sector for nurses and nurse practitioners?
I think we're estimating around 1,800 registered nurses. I'll just have to check whether we've got a similar figure for PCWs. I think we do.
But Senator, I mean, the one comment I'd make about that is that I think what we're doing is a sort of based on recent experience, a straight line out on migration. So that that will be a very conservative estimate on our part in terms of the things that contribute to meet the gap, the 11,800. So we've got a whole lot of treatments. Migration's one of those.
Yeah,
obviously.
no, I get that.
Yeah.
I get that.
So the 1,800 is a very conservative figure that we've put in.
Yes.
So there's 1,800 RNs and 1,800 nurse practitioners.
Yeah. Yep.
Yeah, that number, we often combine registered nurses and nurse practitioners into the one category.
Okay,
Yeah.
so is it 1,800 in total?
Yes.
That's
okay,
right.
cool. Okay, that's fine. So, and you've said, I think, Mr. Lai, on Tuesday, that you believe that the pay rise had been modelled at possibly 5,000 additional entries into as a result of the 15% pay rise?
No, I think I said to you that we thought after you apply the treatments to that 11,800 figure, that we thought the gap in RNs that we need to find is between 4,000 and 6,000.
Okay, so you're sort of halving the amount by the treatments that you've got on foot at the moment, which would include the migration, the 15% and other treatments that you may put.
And other programs which we can run through. I think it's useful just to sort of mention them.
Sure.
So firstly, with the announcement of the additional Commonwealth-funded university places, so the total announcement's 20,000 of those, with 2,600 set aside for nursing places. For nursing students as well, we're implementing a clinical placements program to facilitate high quality placements in aged care, to encourage them to return to the sector after they've completed their degrees. So we've got 1,400 places in that program at the moment. To support career pathways for nurses, we've got the Aged Care Scholarships program, which provides opportunities for nurses to do postgraduate qualifications, and also for enrolled nurses to become registered nurses if that's what they would like to do.
Do you have in these, and have you sort of broken down in these the kind of numbers that you think are likely to generate and when they'll be? Because I mean, obviously, if you're talking about a new student going in, there's a time lag, whereas existing students. So it can, in each of these initiatives, have you got a number of additional aged care nurses?
Yes, we have made estimates around that. We acknowledge there is some complexity with time lags in terms of the university pipeline, but we've put numbers against each of those.
Yes, that's right. So I think we mentioned the 1,800. We think the combined impact of all those programs, this is for registered nurses, is around 800, is an additional 800 nurses through those combined programs that Ms Gleeson just talked about.
Okay, that's great. So in your programs that you've put in place to try and encourage people into the nursing and aged care, what consideration was applied in terms of the modelling of the likelihood of the nurses that would otherwise have gone into the healthcare sector, who now may be attracted to go into the aged care sector? Has there been any modelling of a potential detrimental impact onto the supply of nurses into other sectors because of the initiative you're putting into this sector? Or is there a whole of sort of nurse workforce strategy in place?
Yeah, well, I think some of our initiatives are quarantine elements of larger programs, where we believe people will come to aged care. So there is a larger overall effort. So I don't know that we would be concerned that there's going to be a detrimental impact on the health sector.
Professor Murphy, I just wondered, given that you've largely got responsibility across the whole of the nursing workforce, whether there's any opportunity to be able to provide the same sort of data that we're talking about in terms of vacancies, demands and applications that we've just talked about what you think that the overall impact on the nursing workforce is going forward, and what the shortfall is and where it's likely to be.
Sure. So, Senator, I think we mentioned earlier on when the workforce people were here, we are doing, there's a national nursing strategy, and part of that is a nursing supply and demand modelling. It's quite complicated because much of the nursing data is held by hospitals, state and territory hospitals, private hospitals, and so unlike medical practitioners where we have pretty good data, we have to get that data from our jurisdictional colleagues, but they are on board with that stuff, and the project is happening now. I don't think it's got the answers you want yet, but that is definitely work that's underway at the moment.
Yep. Senator Ruston, are you happy for me to share the call around at this point? Have you got a few more in this section? Or?
No, I'm happy to go with the flow.
All right, Senator Pratt had a few questions.
I've got some questions
Sorry,
about...
Senator Pratt, I've done this a few times. I need to make a statement.
No worries.
Just to confirm, we've had informal conversations with the department, but the committee resolved earlier to release outcome 1 at the end of our questions for them. We resolved to consider outcome 2 at a spillover at a later date is what the committee is expecting to do. Just to bring everyone up to date. Thank you, Senator Liu. Senator Pratt.
Lou's fine, absolutely. Thank you, Chair. Implementing the Care Reform Bill, which has recently passed Parliament, it of course requires aged care homes to have nurses on site 24 hours a day, 7 days a week. When's that requirement active? And what's the expected benefit to residents in aged care homes?
Nick Hartland, First Assistant Secretary, Home and Residential Development Division.
I thought you said 3.
So
Sorry,
that requirement is active from July 23. And we'll just... Do you have evidence, or do you want me to talk about it for a second? Yeah, no, that's right.
So, I mean, the principal benefits are around the types, better access to the types of services that a registered nurse can provide. So, monitoring a patient's well-being, being able to give advice if the patient deteriorates at short notice. So, it's about access and preparation, preventing avoidable hospitalisations, and also supervising staff.
Certainly fits with the needs of many constituents that I've spoken to. Can I ask if it applies to all aged care homes?
Yes, the requirement does apply to all aged care homes, but there is a provision for some very limited exemptions for homes in rural and remote areas.
And in terms of those workforce shortages that are current and quite needy, how do you go about balancing the need for clinical care despite the need for an exemption?
So I guess there's a couple of elements to that. So the first thing about it is that the exemptions that are available are very strictly limited. So therefore, small residential facilities with 30 beds or less in what we call the M 5 to 7 area. So that's rural and remote, I think, is a good summary of that. The exemptions are time limited. They'll pick up about 191 providers could be eligible, which would cover just over 3,000 residents. Having said that, we don't expect that all of those facilities that are eligible would necessarily want an exemption. Some will wish to make an effort to supply nurses, but the principal aim of the exemption process is to ensure that facilities that would have a lot of difficulty approaching a nurse don't fall foul of the requirements of the Act and consider exiting the industry. Because
Okay, so how long is the exemption valid for?
It's for 12 months.
12 months.
Senator, there's also a supplement that'll be provided to smaller residential facilities with less than 60 beds.
That's right. Yeah. So that's right. So we should have started with the supplement. I think that's right, Ms.
No. I've understood your answers very well. So
and the other thing about just to complete the answer. Excuse me, Senator, for interrupting you. Just to complete the answer about the exemption, facilities will need to sign a statement confirming that they have in place processes to deliver safe care. So there are a couple of safeguards built into that exemption process if they choose to apply for it.
Yeah, just like happens in childcare currently.
I think that, Senator, just the last thing probably for completeness is that we're going to do some work to look at safe models of care, which, for example, some of our providers have raised the issue about whether it would be appropriate to have an RN on call supervising an EN in a facility, and so we have undertaken to do some study to get some clinical advice around how do you provide high quality safe care with a model that might be slightly different to that approach, and I think that'll be
so it could, for example, have an RN on call or letting families know and relatives know if there's an incident where there's not an RN on site. I'm sure there are lots of ways that you can do that. So, given that, it sounds like, and clearly that was our election commitment, there's a commitment to eventually meeting the 24 hours, 7 days a week nursing standard, even if there's a small number that don't initially. And in that context, what consultation has the department undertaken in developing the detail and delegated legislation for that exemption?
Mr. Richardson's been handling the development of the measure, and he'll be able to talk to you about the consultation arrangements.
Great.
Senator Mark Richardson, Assistant Secretary, Residential Care Funding Reform Branch. We've undertaken, I guess, extensive consultation. I don't have a list in front of me of all the organisations we've consulted with. I think we may have provided it at another hearing previously, so it is on the record. But we've consulted extensively with the sector.
Okay, and that's going to continue. And in terms of the delegated legislation, Will we get to see it before it's registered?
So the intent is that we would have an exposure draft of the legislation, the subordinate legislation, early in the new year, Senator.
Yeah, so that's subordinate to the legislation we've already passed, which would therefore also mean, for example, the original legislation came before this committee and the subordinate legislation will go before the delegated legislation committee, who will get in touch with this committee if they need to. What enforcement action will the Quality and Safety Commission take if an aged care home doesn't have nurses on site and it doesn't have an exemption?
So while Commissioner Anderson is coming to the table, there are a number of compliance layers to this measure. It doesn't all rely on the AQS, the Quality and Safety Commission. So there are also reporting requirements for this measure. Providers will be required to report if they don't have a nurse on site and they don't have an exemption.
Yeah.
If they do report that they don't have a nurse on site, the supplement won't be paid. We also have an audit process to check whether their reports are accurate that we're developing. And there's be access to complaints, which probably takes us to Ms Anderson's role.
Yeah. Thank you.
Quality and Safety Commissioner. Dr. Hartland's covered most of the territory. The subordinate legislation will be instructive in terms of providing some of the detail on which we will design our methodology, but we already have a number of compliance and enforcement tools that we will make good use of. Dr. Hartland has spoken about the fundamental requirement for providers to report. The first area of compliance is failure to report. If they're late reporting, then that needs to be understood. If they fail to report, that needs to be understood. That could fold into a larger risk profiling exercise that the department and the Commission would undertake possibly together. We are a risk-based proportionate regulator. We would understand a service or provider not just in relation to this particular piece of data, which might be the number of shifts for which they did not have an RN cover.
Yeah.
We would put that alongside the other things we know about that service or that provider, and then take measured steps to obtain any further information which might be necessary. It might be a misreporting error. It could be that there are a range of good reasons where we would satisfy ourselves the provider has managed the risk and there won't be a recurrence. Or if we are less than satisfied, we may push it further and take some regulatory action in relation to that provider in order that they would ensure that it did not happen again.
That's terrific to understand in terms of the systemic approach and holistic approach to that enforcement. So thank you. Thank you, Chair.
Thank you, Senator Pratt. Senator Rice.
Thank you. Okay, continuing on with aged care reforms and going on to the supported home reforms that we touched on in my last bracket. So look, I just wanted to start with what the current status of the supported home reforms is and whether there's more consultation being undertaken on them.
Yes, there is, Senator. So we released the discussion paper on the 18th of October. And that's open until 25th of November, so we're currently in consultation on the elements of that discussion paper widely with the sector. There'll also be future consultation arrangements around what we would call a co-design process with the care management function, which is new to the program. It's an existing function in the home care package program, but we feel that care management currently in that program's not working in the way that it should, so we're trying to redesign that, co-design that with the sector. There's a co-design process around an assistive technology and home modification scheme that's occurred that we're working through. We've consulted on the funding model and talked with various groups across the sector about IT and other aspects of the program. So there's quite an active process of consultation going on around the program.
So how much of some of the directions that you're heading in that discussion paper, how do they differ from where we were at under the previous government?
Yeah, good question. Thank you. I've had occasion to speak about that at conferences. So Look, I mean, what I've said at conferences and is that, look, the feedback on the discussion paper, you know, there were some elements that didn't attract a lot of comment. So the idea of better assessment and a new way of understanding people's entitlement, there wasn't a lot of consultation about that. There's still work to be done on it. There were some things like the case management, reforming case management and allowing consumers more choice, which were part of the previous approach, which were accepted. They need more work. But there was a lot of feedback around the flexibility of the model that was proposed in January and that it might not be able to be adjusted as the needs of older Australians change, and they can change quite quickly. And there was a significant feedback from some of the current CHSP providers, particularly transport, group social support, meals, and to some degree respite, although not quite as strongly, about the move to a fee-for-service model,
Yes.
which wasn't popular, I think you'd say. So the current discussion paper proposes some new arrangements that and asks for views about how to address that, and signals that that aspect of full fee-for-service model would be significantly changed in any future proposal.
Okay. Are you looking at potentially sort of extending the same approach under the ANAC funding model for residential aged care, potentially a version of that across at-home care?
My favourite topic. No, I mean, the ANAC, a full case mix model has been, we've assessed it a couple of times in this consultation process, but generally for what you would think of as the home care package segment of aged care. So there's a group that have proposed a funding model built around weighted activity units and a national price for CHSP services. That's not currently being developed by the department. We don't think it works very well. But some aspects of the issues that they were raising in developing that model have been taken on board in the discussion paper.
Right, okay. And presumably, so then what's the timetable? You've got the discussion paper out at the moment, so when's that open for consultation until?
The 25th of November. That's quite a short period, but we needed to feed into some considerations within government that we're working with our colleagues in the central agencies on. Having said that, it was our experience last time around, and every time we release a paper, there are people that come back to you post the consultation paper, and we would always listen to them. So if someone gave me a note on the 26th of November, it's not like I wouldn't read it.
Mm-hmm.
Sorry, the answer to your question is 25th of November, but with some leniency.
Some leeway. Okay, and then once that's in, would you then see yourself having some sort of more targeted conversations and consultations with sort of key stakeholders if there's, to work out, or once you've got some new proposals that have come out from the feedback on that?
There will be a process of discussing with government that will probably lead to some more fully formed proposals. And in any event, there are some things that, independent of all that, we'll need to work on. Sorry, Michael.
Yeah, so I think, just to mention, Senator, the government put some money aside in the October budget, around, I think it's 23.1 million, to do some other work around the new program. So a large-scale trial of an integrated assessment tool, the establishment of a service list advisory body, and commissioning the new independent hospital and aged care pricing authority to undertake a pricing study. So there's a range of other activities happening, as Dr. Hartland's alluding to, in parallel to that consultation process.
Yeah. And so then you'd be looking at, okay, so you've got your discussion paper out November, some further discussions with government, again, so potentially with stakeholders as well, once you've got some proposed way forwards.
Yeah, there are always, I think you observed that the aged care is a diverse sector earlier, and I'm pretty sure that the feedback we get will point in different directions, and then we'll need to resolve issues that arise from that, yes.
Yep. And then would you be looking at having legislation that's a component of the new Aged Care Act, or would it be separate legislation?
It'll be a component of the Act.
Of the Act,
Yep.
okay.
And so this is, in one sense, what we are doing in this is one of the consultation elements for the new Act, because it feeds into the Act. So.
Yep. And, I mean, I've certainly heard reports and heard from stakeholders that sort of the uncertainty of what's happening with at-home care has made it hard for providers to really feel to continue on a sustainable basis. I'm interested to know what support you're providing to providers given that ongoing uncertainty.
Yeah, well, look, it's obviously an issue. You know, the start of the program is still some time off, and you know, one aspect of what we'll be doing is, of course, extending CHSP arrangements. So that process is about to start, so that will give those providers, you know, a greater degree of certainty about their contracts for the 23-24. So I was trying to get my financial years right. 23-24 financial year. You know, at the moment, the best certainty we can give for them is being open about where we think the reform directions are, and so we're consulting pretty intensively, but we don't have a final decision. And of course, as you referenced, there are different voices about what the final process should look like, and so you know, a provider will be listening to that and not, you know, still not have certainty about the detail, and they're very hungry for detail, but we're working as hard as we can to get them that certainty, but we still need to kind of design the program in a consultative way. So it's
And presumably we're not going to have, you know, just as per the previous discussion, we're not going to have, you know, legislation that's passed through the Parliament that this will be a component of until sometime in probably the last quarter, let's say, of next year. So you're going
Second half of next year.
regardless, you're going to be going into the 23-24 financial year. You know, it's not going to be. There's not going to be something ready to go at the for the beginning of the 23-24 financial year.
And we expect that people want to see, notwithstanding the amount of consultation, and notwithstanding the fact that a lot of these providers have obviously had a voice on consumers during the Royal Commission itself. People want to see what the final outcome looks like, and you know, we expect to get extensive feedback once they see that in the overall new Aged Care Act in an exposure sense.
Okay. A further element of home care, and that's going to the implications of the Fair Work Commission decision that specify a 2-hour shift for workers, which we know that there's been, you know, quite a lot of upheaval and sort of people's care being upset because of that, my mother's included. So I just want, what do you feel have been the implications for home care packages of that decision by the Fair Work Commission, and what steps is government taking to support providers because of that?
So we gave providers, when this first arose, we sent out we talked with the peaks and talked with providers to understand the impact and issued some advice from them to them. This seems to have quietened down significantly over the last 6 months. I hear much less. We did see correspondence on it. This was a matter which, by and large, got solved by some good sense on the ground with providers. There may still be issues, and of course, if there's a consumer that's unhappy, then we're always, willing to hear about it. But the essence of our advice was that while the Fair Work Commission ruling was that they had to offer workers a 2-hour shift, that did not require that worker to spend 2 hours with a particular resident, and so the remediation of that was about some good sense scheduling of workforce so that a person could see a couple of people. If they had 2 people that needed 1 hour and they were quite close together.
And paying for their travel, which is quite a very sensible and reasonable thing to do, rather than some providers that weren't paying for travel.
Yeah. So this seemed to be an issue that caught fire on the basis of erroneous interpretation or advice that now seems to quieten down, but things do tend to catch fire again. So if there are consumers that are still feeling that they're not being fairly dealt with, then we're happy to have that relayed.
I certainly know that in some, my mother has got a whole amalgam of different services, just the way that it's working best for her, that she's ended up having longer home, where she was only having sort of 1 hour home care support, she's now got a couple of afternoons where she's got 2 hours, and other days that she hasn't got anything still. So it is still a bit messy.
And I think, Senator, frankly, that raises that other behavioural issue that we saw, which is that there should be a consent to change plan, and we saw certainly instances consumers coming forward to say the provider hadn't done that properly.
Yes.
So that's another thing, obviously, that we've kind of followed up.
Yeah. Okay. I've got time for another.
Well, I was going to.
I'm happy.
Russell, are you changing?
I'm changing
roles?
topic.
Yeah, we'll
Yep.
go to Senator Russell and then
Yep.
I'll come back to you if that's okay.
Yep.
Just following on the exemption discussion that you were having earlier with Senator Pratt, Mr Hartland, you made the comment that exemptions would be strictly restricted, that they were largely going to be restricted to MMM 5 to 7, which are remote and very rural. They were time limited, and you believed about 191 providers would be eligible for this exemption. Can you confirm that's all correct?
Could I just rephrase something? Not largely restricted to, entirely restricted to MM5 and 7, and for residential care facilities with less than 30 beds.
Okay, so...
only available in 5 and 7, only available to small residential facilities with 30 beds or less.
Okay.
Sorry.
So can I take from that you're quite a long way down the track in terms of the design of the exemption eligibility criteria and process for application?
Yes.
Okay. The Secretary, or maybe it was you, Mr Lai, made some comments around safe models of care. Are those safe models of care that look at the possibility of having, an RN on call and an EN on site, the part of the exemption process, or are they outside of the exemption process?
It's a separate process. Mr Richardson might speak to that, and I gave that example, and I should say that I'm not an expert on this either, and so I wouldn't want to hold that out as the model. We're actually asking, we're going to ask people with expertise what a safe model might look like.
Okay, so I'm trying to put this in the context of the 24/7 commitment. So can I assume that the models of care that are being looked at are to still deliver the same level of care, but by a model that may not necessarily strictly adhere to the 24/7 requirement?
So, Senator, as has been explained, the exemptions are limited to areas where there are chronic, issues, or there has been in the past in terms of workforce shortages. So we are undertaking, or will be undertaking, a consultancy to look at clinically alternative models of care, and like you have articulated, that may include things like nurses being on call. It may include telehealth and those sorts of arrangements as solutions for those types of issues moving forward.
So are these models of care a sort of a temporary process until the facility is able to ensure 24/7, or are they a model that may be applicable in the longer term?
They're a model that may be applicable in the longer term, Senator. So we'll work with, a body with expertise to be able to provide the advice on what would be a clinically safe model.
So who would that be?
We're looking at undertaking a consultancy with a university, Senator.
So you're not looking at, say, ACPA or one of those?
No, we're using a whole of government panel and going to some universities.
Yeah. So you could suggest that the commitment for 24/7 nurses in every nursing home in Australia, there is a deviation from that in terms of what you've just said to me, because clearly if we're looking at alternative models, and I'm not being critical of your...
At the moment we see the models as alternative models as only applying to that small exemption group.
So the standing rate.
Okay, so
Senator,
can I just take a
standing
step back,
capacity
Mr Lai?
is 8%.
Just take a step back. I asked in a question a minute ago, was this applicable only to the MM5 to 7s? And you said no, and now you've just said that it is. Could we get some clarity on which of the two statements is correct?
So the alternative models of care don't exist at the moment, Senator.
No, that wasn't my question. I said, will the ability for an alternative model of care be restricted to those that are in the MM5 to 7 exemption area, or will they be more broadly available? You said they were more broadly available, and you've just said they're only available to the MM5 to 7s with exemptions.
I apologise if I inferred it was more broadly available, Senator. That would be a future government decision. So we need to undertake that consultancy first. So how that would apply, where it would apply, would be a future decision.
Senator, I think Mr Richardson framed his answer in the sense of we're obviously the exemption applies to small facilities in MMM5 to MMM7 for a time limited period. We're doing the study, and Mr Richardson said those are the areas where we know we've previously had chronic workforce shortages. So that is the area where you would be concerned that possibly after the 12-month exemption that we might still have a problem or an issue that we need to solve, and that's what the study will look at.
Okay.
So that's clearly the context.
Okay, yep, okay.
I think I'm going to jump in here because I've been very patient for, more than half an hour listening to this, and the concern from Senator Ruston about the workforce shortages in aged care. But I would also say all of the work that's being done now is because of the neglect of 9 years of failing to deal with the workforce pressures in aged care. So I'm not going to sit here tonight, because I can see where this is heading, with criticism from you about the work that's being done to fix up the mess that you left in aged care.
Chair, could I just
Senator
ask?
Askew, are you seeking to call a point of order?
No, well,
I just heard you yell relevance across the table.
Okay.
Are you seeking a point of order or not? No.
I was being very relevant, and I am mindful that it's Thursday night of estimates, and everyone would like to get out of here. And there's been a long filibuster all day, and everybody's tired and cranky, including me.
Could I point of order, please? Point of order, please.
Senator Ruston, I'm trying to finish.
Yeah, well, I'm
the
trying to
word
make her
Senator
be quiet.
Ruston. Senator
Thank
Ruston.
you. Okay, my point of order is on the fact that I have sat here the entire day, as has every other member of this committee, asking relevant questions, and then to be lectured at the end of the night.
This isn't a point. This isn't a point of order.
Would it be possible for us to get back to questioning?
I just wanted to put it on the record
Senator
that
Ruston.
the
I have not
been
total
filibustering.
lack of credibility you have in this space.
I have not been filibustering.
Senator Ruston.
You have been. All day you've been
Minister
filibustering.
Gallagher.
Everyone in the building knows you've all
Senator
been
Ruston,
filibustering.
Minister Gallagher.
Everyone's been talking about it. It's obvious what's been
Senator
happening
Ruston
today.
and Minister Gallagher, I have the call. Thank you. It helps facilitate the work of the committee if we can return to our process of asking questions, giving answers, all of us listening to each other as we do that. Senator Ruston, you have the call for questions.
Thank you very much, Chair. And if I could return to my line of questioning that I can assure you isn't filibustering, and I am genuinely interested in the answers to these questions.
I was genuinely interested when you were in government for 9 years. And I'll leave it there.
Maybe you should get another lolly.
Senator Ruston, you have the call.
Well,
It's 8:21. Everyone's doing their best. Let's get on with it. You have the call. Thank you.
Look, thank you. I'm just trying to seek an understanding around the exemptions. I mean, I can absolutely assure you that I have no issue whatsoever in the proposal about providing 24/7 care for residents in aged care facilities. I have no problem with care minutes. I'm entirely supportive of this whole thing, so I'll get that on the record. But what I am interested in is making sure that with the best of intentions to provide that care, that we don't end up with a situation of the unintended consequences of exemptions not being available to facilities that genuinely need them, which of course would result in them having to close because no aged care facility wants to operate in breach of the requirements. So could I just expand out on the MM5 to 7? So taking it as, so how many MM5 to MM7, or so how many aged care facilities under 30 residents exist in MM5 to MM7 areas?
191 providers. I'll just check whether that's, I think that must be facilities.
Yep. So you're expecting that every single aged care facility that's in an MM5 to 7 with less than 30 residents is likely to apply?
No, and I'm sorry if I wasn't clear before. That's the number who would be eligible to apply. But I thought I said before that we didn't expect that all of them would apply for an exemption.
Do you have an idea of how many?
I'm sorry, I don't, Mr. Richards.
No, and until we go through that process,
Sure.
Senator.
Okay, so how many aged care facilities would there be in total in MM5 to MM7 areas?
I would have to take that on notice for a precise number, Senator, but I think it would be close to about 400.
Okay, and could you also, while you're taking that on notice, provide me with advice on how many aged care facilities under 30 residents would exist in other MMM areas, particularly interested in 3 to 5, so that we get a bit. So, if just as an example, if I was an aged care provider with 35 beds in an MM7, are you saying that I can't apply? There is no scope for me to apply?
That's right. The exemption's been, as I said, it's been tightly drawn. It's for small facilities in MM5 and 7. There's probably about 350, 400. We'll take it on. We'll give it to you on notice. But
yeah, okay,
very small facilities across all of the MM5 levels. Across all MM levels. That would include the 191. So. My mental maths isn't good enough to give it to you. I've got a table, but I can't add it up quickly enough.
That's okay.
We give it to you on notice.
On notice is good.
But the supplement process that we talked about, that applies across all the all the MMMs, and that's under 60 beds.
Yep,
so any nursing home anywhere in Australia under 60 beds will get the supplement.
That's right. So all of those ones in MM1 to MM5 that are 30 beds will be eligible for the supplement to help them get to 24/7 nursing.
So MM5 to 7 will be able to get exemption, and MM1 to MM4 will be able to get the supplement, or is the supplement going to the MM5s to 7s as well?
The supplement will go to all facilities. So all MM levels under 60 beds will have a supplement. If they choose to have an exemption, we don't pay the supplement, which would be logical, right? Because they don't have the cost. But if they don't have the exemption, then they'll get the supplement.
Is the supplement ongoing, or is it just a one-off?
It's ongoing.
It's ongoing every year. Okay.
And it's paid at different rates for MM1 to 4 and MM5 to 7.
Okay. Yep. Okay.
And different rates for different sizes.
Okay. Cool. During the legislation, the chamber minister also said that exemptions would be determined on a case-by-case basis. Sort of. Trying to understand, reconciling that comment with what you've just said, it sounds to me that that's not the case.
No, the provider will apply for an exemption and it'll be determined.
Okay, cool. All right, thank you.
Is that cool as in let's pass the call, or cool as in?
I'm easy. I'm happy to go with the flow.
Yeah, let's flow. Senator Rice.
Thank you. Okay. Let's flow then. All right. I want to ask the questions I've tried at about 3 different places over the last couple of days. And that's some reflection on the cutting of funding to Palliative Care Australia, the peak body of palliative care. No, and that's right. I know it's not this outcome, but in terms of the impact that has on aged care is very significant. And did the department consider the impacts on aged care when defunding the peak body?
So I think the peak body funding, I think the officials who look after that area just aren't here at the moment.
Yeah,
Senator,
but the peak body has been defunded.
There was a process that went through there was a competitive process around peak body funding, and there was a range of criteria but I haven't got those officials with me because they were
I
allowed
understand
to
it
go.
with a focus on preventative health.
Yeah.
Obviously, if you're in the palliative care and the peak body for palliative care, it's a bit hard to be having a focus on preventative health. Nonetheless, my question is, I mean, did the department consider the impacts on aged care when defunding the peak body?
I think, as I said, there was a process that was gone through to decide which of the people that were awarded that peak body funding were had a stronger or weaker case for it. It would be speculative to go through the details of that process without the relevant officials here.
But did you consult? Did they consult aged care stakeholders?
I'd have to take that on notice, Senator. Or can we get the officials back?
Okay.
Yep.
All right. With reference to aged care and from the perspective of aged care, how are you going to implement the recommendations in respect to palliative care, which, you know, the Royal Commission said high quality palliative care is essential to assuring that an older person can live their life as fully and as comfortably as possible? I'm sure we all agree with this. We are having a peak body that's being defunded, but it's not going to exist to draw expertise from.
Senator, they're one stakeholder, obviously, and I'm not...
Well, they're the peak body for palliative care.
Well, but we deal, like, I don't want to cast judgment because it's not my area, but, you know, sometimes we deal with peak bodies who are more or less effective, but we do have pretty developed stakeholder arrangements, and in particular the Council of Elders, which has been established, and the National Aged Care Advisory Council. And palliative care is important to us in aged care, and we do use those facilities, as well as regular discussions with senior officials in the state and territory governments who have a key role in palliative care. So, you know, I don't think it changes our commitment to be reaching out to stakeholders to talk to them about issues in that space. Now,
So
I can't comment about the...
You don't think it's going to have a gap?
Well, I can't comment,
in terms of...
Senator. I don't. I think, in fairness, I don't know the process that was undertaken.
I don't either. All I know is that you had a peak body for palliative care that had existed, that had brought together expertise and research and experts in palliative care, that has had funding and has now not got funding. And so I want to know what impact that's going to have in terms of your, the government's implementation, the recommendations of the Royal Commission of making sure that palliative care is absolutely there at the forefront. And, you know, properly resourced, that workers are properly trained, all of that expertise that's there.
Yeah, but, I mean, and again, I am looking for a note on it, but I think if we get relevant officials here, there is, if you go through a competitive process, which I understand went through, you don't usually consult with other stakeholders about the decisions you take. You go through the competitive process, as you know. And in palliative care, there are a range of providers. I mean, peak bodies don't necessarily provide services. They might provide a particular expertise but I know here in the ACT, there are a range of expert groups that provide palliative care services both into aged care and outside of that. And I'm sure that was part of the consideration, as it would be through a competitive grants process. But I think it would be fair to get the officials that are in a position to respond to that.
But I think, as Mr. Lai said, palliative care is an integral part of the whole aged care sector. All good aged care facilities will have palliative care approaches, palliative care training. That's one of the reasons we want more RNs in residential aged care, because they often are very expert in providing palliative care. It's a really important part of aged care. We completely agree with you. In fact, there's quite a lot of palliative care that happens in aged care, and the good providers do it very well. And whether that's, I don't know that there's necessarily a relationship between that peak body funding, but as the Minister said, we can come back to you on the peak body.
There's a reason for peak bodies, basically, because they bring together a sector, they bring together expertise and research, they enable you to be able to, draw upon that, and they enable other parts of the sector to be able to draw upon that expertise and research without it being, through being a provider or, a particular segment in the sector.
But I can't reflect on the process because I haven't been briefed on it. But if you go through a competitive process, that's what you engage in. Just because you're a particular group that does a particular thing doesn't necessarily guarantee you, in a general sense,
access to funding.
And again, I am not an expert in what that process was, but what I have been told was that the criteria for the process focused on a good focus on preventative health as being a really high criteria. Obviously, if you're with a palliative care peak body, that's not going to be something that you're going to score highly against. So, it just seems to be extraordinary given the focus for good palliative care to have the peak body have been defunded. Can I ask you to take on notice, though, if you...
Sure.
Whether aged care, the department, the aged care stakeholders, whether the aged care part of the department was consulted in terms of this decision to defund palliative care peak body. Okay.
You still have the call.
Yes. All right. So I now want to talk about a person who was brought to my attention, which I just want to use as a specific thing, a specific to talk about the general. So this woman was approved for My Aged Care in November 2021 to help her out once a fortnight for shopping assistance, domestic support. She can't bend or kneel due to problems. She was waiting a year for support and received nothing. She called some national organisations after My Aged Care told us that there was nothing they could do as they couldn't see any providers in her area to make a referral to. She lived in inner Brisbane. And the advocacy organisers then gave her a large list of providers to ring to ask for support, and she's contacted 17 of those providers and not one has agreed to take her on to support her, and only one willing to take her on, to take her name to put her on a wait list. So, I mean, what are we doing to address this issue of just the lack of ability to meet people's basic needs? Thin markets, but we're not even in a regional or rural area here. We're in inner Brisbane, where somebody is needing help and just can't get it.
So, I'm assuming from the description of the case that this woman was assessed as eligible for a CHSP service.
I don't know. I don't know whether it was a CHSP or whether it was a level 1 package or something.
Right.
Don't know.
So, if it was a home care package program, there's been considerable investment in that program over the last few years, and the wait times have reduced very substantially. So, if it was in that program, then that would be unusual, and I'd be suspecting that there was a kind of system error, but we would need to see the details of the case. If it was CHSP, look, in the broad CHSP program, the wait times to service are quite quick, so the median time to first service for new clients is 20 days, but there are some problems in some areas. I don't know whether Mr Herald will be able to give us some more detail.
Russell Herald, Assistant Secretary, Home Support Operations. So yes, we are aware that and so I don't know the specific case, obviously, that you're talking about, and if
I'm very happy to forward the details.
Yeah, and we can look into the specific case that it is.
But I wanted to use it in general. It's a specific case, but in general, that it's indicative of a problem.
Yes. So if the individual in question is Commonwealth Home Support Program recipient, it's a grant-based program based on the number of providers that we issue grants to at any given point in time, and availability of services varies depending upon demand, workforce availability at that point in time. Every situation, every location across the country is unique, so hence we'd need to investigate the specific circumstances of this case. But the general advice that we provide is if there are excess demand for services out there, there is available money funding in our budget for providers to come to expand supply. What we're not seeing is necessarily across the board providers coming and asking for additional money for other reasons, for instance, workforce and whatnot.
So are you suggesting that she should, so these 17 providers that she contacted, if it is a CHSP, who said no, they can't take her on, should be coming to you to ask for more funding?
Those providers can come to us to ask for more funding. Alternatively, CHSP is designed to access, 1 or 2 services a fortnight, a month, and people come in and leave the program reasonably regularly. They may have a service availability coming in
Well, there's
soon.
only one that was willing to put her on a wait list. So seeing that 17 providers, only one willing to put her on a wait list, that there was a severe undersupply of services in the area.
So, sorry, Senator, can I just ask, what was the service type? Did you mention that?
Look,
if you did, I missed it. But
Well, she was approved for My Aged Care, I'm told, for My Aged Care in November 2021. So actually, which would imply a package rather than
Obviously,
CHSP.
Senator, we'd like to take those details to follow it up. But I mean, I think what Mr. Harold's saying is that we would expect where our CHSP providers are finding that demand for their local services is exceeding their supply, that they would then come to us and say, look, we want to expand. We would work with them to do that. So we would be relying, and that's one of the limitations of the current model, which we're looking to reform. I think the second thing to say is if she went to 17 services and wasn't getting access, I think you mentioned advocacy, but certainly one of the things in the reforms that we're paying attention to is improving wayfinding for people and also improving support for people who might need assistance to get a service. And it's a suspicion that if someone's been to 17 services without success, that that's a person that might need help from an independent person to access a service.
Well, certainly, she called OPAN and the Queensland ADA after My Aged Care told us there was nothing they could do as they couldn't see any providers in her area to make a referral to. The advocacy organisations then gave a large list of providers to ring to ask for support.
Yes,
and
I think.
She had 17 that she rang, and only one was willing to put her on the wait list.
Well, you would be aware, though, Senator, that we are dramatically expanding the operation of OPAN and the number of independent advocates in the system for precisely this reason, because some people need a greater level of support to secure a service than others, and so that they play a very important role in doing that. So I think, it's hard to know without the details of the case, but I do think there are some things as part of the reforms that will address this specific situation and try and improve on it. Obviously, as Dr. Hartland said, we're also dramatically increasing the availability of places for people who live at home. And obviously that will go in large part to the adequacy and the timeliness of service that people get.
Okay.
Senator, if I can get the details, I'll get the
the
case team to look into it.
All right, I've got one other short one, and then I've got one for the Commissioner.
Sure, why don't you do the short one and then we'll pass back to Senator Ruston and then we'll go to tea.
Which was about basically somebody, this was a few months ago, who put their mother into respite care on a Wednesday and was told on the Friday that there was a multi-day COVID outbreak underway that the aged care facility knew about when they admitted his mother. And this person is obviously incredibly concerned for his mother. So my question is, what was that, what should have happened? How is something like that able to happen? Is there a requirement for aged care providers to notify people who are visiting or being admitted when there's a COVID outbreak?
So I think the first thing to say, Senator, is I don't think that they should have been accepting people in that circumstance, obviously. So, which probably goes to the lion's share of what you're raising.
So Senator Helen Greenberg's First Assistant Secretary of the Service Delivery Division. So our expectation would be that a provider, in the instance that they were experiencing an outbreak, would be taking the appropriate precautions to manage that outbreak, which in those instances would not be accepting new entrants to a facility regardless of the particular, whether it was respite or a new entrant for care, without appropriate consideration and mitigations in place.
So is that specified that that's, mandatory that that's the approach, or is it a grey area that this provider could say, oh well, I don't actually have to do that?
So I think as the pandemic has progressed, we have seen adjustments in the various directions, particularly those public health directions that are set by individual jurisdictions, in terms of restrictions on entry to a facility. Those have been modified over time. We are now in a different circumstance in the pandemic, and it's effectively a risk-based decision for a provider going forward. Most of those restrictions have now been walked back by individual jurisdictions. So there's no longer, for example, restrictions on visitation in the course of an outbreak, but the expectation is that appropriate precautions are undertaken to protect both residents and visitors and the workforce.
So it may be, Senator, that there would be a facility with, cottage accommodation or separate wings who could safely separate people out and eliminate risk of spread of COVID. But we don't know the case here. But it doesn't seem plausible that like a respite facility could meet that criteria. If they can't, then they shouldn't have accepted people.
And so I noticed that Ms Anderson has come to the table. So, if what then should people be able to do, what would the Commission have done in that circumstance?
Well, perhaps I can just start at a slightly different point. If someone were placed in that circumstance and they were wanting to lodge a complaint, we would take it very seriously. We would approach the provider and say, what's happening and why did you not disclose this to that individual on their way in? I mean, that's just plain common courtesy. It's also treating the consumer with dignity and respect. So whether we would find them in breach, whether they would actually be a non-compliance finding there is a moot point, and we would have to look at the particular circumstances. But I actually think it's disrespectful. And I think that they owe the consumer and the family of the consumer far more than they actually gave. And I think there would be justifiable complaint that we would act on the consumer's behalf.
What would the consequences then be to that service? I mean, you can say, yes, they're not being courteous, they're being disrespectful, but if you're saying that you don't know whether they would have been non-compliant, what would the consequences be to that provider?
That's the essence of it. We would have to determine what level of mitigation was in place, how extensive the outbreak was. If it was a single consumer and that consumer was isolated, the level of risk may actually be overall quite low. But the failure to disclose, I think, is significant, and we would certainly hold the provider to account for that. Now, there may be extenuating circumstances. There's always the possibility that on the particular day that this individual arrived or booked, the person who would normally disclose this was unavailable. These sorts of things do happen. If they're one-off and the provider can indicate through evidence that it was an isolated circumstance, then we might say, right, we just don't do it again. But if it's part of a pattern and we've had other complaints, or the provider cannot give us a satisfactory accounting of why it occurred, then there may be other courses of action available to us, including, for example, issuing a direction that they revise their plan for continuous improvement, paying particular attention to providing full information to those who are booking for respite.
Would there be any, beyond revising their plan, would there be any consequences or penalties to that provider?
As a risk-based regulator, Senator, we are always attentive to numbers of factors that attach to a particular action, and I cannot give you a categorical answer to that without elaborating the particular circumstances of this case.
All right, I've got another case that I'm going to bring to your attention when I get my next go.
Thank you, Senator Rice. Senator Ruston, do you want to take us through, and I'll just stop you at 9 o'clock so we can have a tea break then, if that's okay.
Great, fantastic. So I was just wondering if you could provide on notice the schedule of the supplement payments that you were referring to for the aged care facilities under 60 residents, because you said that they were different rates paid for different facilities and different areas. So if you could, is that possible to get?
Yes, of course. I believe they're on our website.
Yeah,
at the
I just
moment,
tried to look them up, but I couldn't find them. But that's not to say because I'm not the greatest Googler.
Issue, yes.
Yep.
Yeah, sure, okay. Of course we could.
Yep, sure. Thank you. In the workforce survey that was undertaken, it said that there was 20% of aged care facilities reported that they didn't currently have a nurse on site 24/7. Of those 20%, how many of them will be picked up in the exemption?
I'm not sure whether we can...
We could probably do the calculation, but we'd have to do a calculation for you, Senator.
Yeah. I'd just be interesting to know if of that number, because I mean it's obviously significantly more than the 191, where they were, what they looked like, what their makeup was.
I don't know whether we've got information about the location of the 80%, but I have a vague memory that the actual geographic distribution wasn't too bad.
Yep.
But I will come back on notice.
Yeah, that's great. So have you consulted on the model that you've put forward tonight so far, or is that something that you'll be going out doing
There's
short?
been some working groups that have assisted us in the design of ANAC that we've done some consultation with. Is
That's correct.
right? But we haven't had a broadcast consultation on this. You might want to...
We have consulted extensively, Senator. I think I gave evidence before. We have provided a previous hearing a list of the bodies that we have consulted with. I don't have that full list with me at the moment, but I'm happy to take that on notice and provide that again.
Specifically in relation to your model of exemption? I'm only asking about the MM5 to 7 decision under 30.
Yes, I can give you a list of bodies that we've consulted with on that.
Yep, okay, that'd be great. Thank you very much. So can I just ask, I asked on notice during when one of the bills was going through, if I could be provided with a list of all the rural, regional and remote nursing homes that had been visited personally by the Minister. I didn't receive that. Was that request ever passed back to you?
We don't know the Minister's diary.
You don't provide the Minister with a briefing?
We don't provide the Minister with it.
Okay, well, maybe Minister...
We don't manage the Minister's diary,
it was a genuine...
She's been very, very active in the aged care sector. I've seen just if you have a look at her social media account, you'll see how many aged care facilities she's visited. I would guess it's a lot more than under the previous administration, considering the output that she's managing to deliver in 5 months compared to the 9 years of the former administration.
So are you able to provide that information?
I
mean, obviously I don't expect you to know it. Is it possible to get that information?
I will consult with the Minister's office and see what can be provided, but my remarks are accurate. I have no doubt that she's visited more than the former aged care minister did.
That wasn't my question. My question
I'm
was...
making a point.
Yeah. Yes, yeah.
Because it's quite difficult to sit here and listen to the concern from the former government about what's happening in aged care when you had 9 years of not dealing with it. So,
Minister, we're going to be here for a very long time.
Well, I'm happy to be.
Yeah.
You know,
So,
I'm here 9 to 11 every day, so it doesn't make a difference to me.
Yep. So if you could perhaps take on notice, if you could get that information for me, that'd be appreciated, because I had asked for it and hadn't received it. And actually, talking about having asked for information and not received it, Mr. Murphy, Professor Murphy, were you able to get that information in relation to those code of conduct breaches I asked earlier?
Mr. Wan can provide an update on that.
Hello, Senator. Charles Warren, officer. I'll just pull up the advice that was provided to me. Okay. Since 1 July 2021, the department has received 3 complaints from external parties alleging departmental staff have breached the APS Code of Conduct. We have engaged external investigators for all 3. Clayton Oots for 2 matters, and Sparks Helmore for the 3rd. To provide, though, any further information at this stage would be inappropriate, as all 3 investigations are ongoing.
Okay, so you can't advise whether any of these complaints were against an official that has worked or is working in any of the minister's offices?
We would absolutely prefer not to provide any further information on any of the three, just at the risk of compromising the investigations.
Thank you.
Okay.
Okay, can we just move on to food?
In aged care, I hope.
No, I'm just a little hungry.
I'd like to move on to food.
Sorry, Senator Ruston, can I just clarify, move on to, what did you say?
Food.
Oh, food. Oh,
Well, not sport, sorry.
I thought you said outcome too, and I just got a bit confused.
Yeah, I'm just tricking you. No, I've only got 2 more lots of questions, so you never know your luck.
Day 182 of estimates or whatever we're at. Is
Yeah,
too
it's okay.
late
It just
to be
depends
tricked.
on Senator Gallagher's
Thanks.
behaviour from here on in, how long we're here for. Thank you. Obviously, one of the election commitments of this government was an improvement in food in aged care, and just wondered what work had commenced in relation to the food commitment of the election.
Absolutely. So, Joshua Malden here, Assistant Secretary, Quality and Assurance Division. So there's been a range of measures that have been put in place in recent times. So the first thing that's been happening is we've been looking at strengthening accountability, and so we've developed a dedicated food and nutrition standard which will better reflect the expectations of older Australians in relation to the delivery of food and nutrition and their dining in experience. In addition to that, we've strengthened reporting requirements. So we've mandated reporting against a number of elements through the quarterly financial report to make sure that aged care providers report expenditure on a range of metrics, including dietitian involvement, expenditure on fresh and processed food, and also food preparation models, so things like cook freeze, cook chill, cook fresh, those sorts of things. In addition to that, the funding uplift which has been provided through the basic daily fee supplement has been rolled in on an ongoing basis to all residential aged care facilities, also MPS and NATSI-FAC. And we've been improving transparency by continuing to look at what information we can publish in relation to service providers. So through the star rating system, which we hope to launch soon, we'll be looking at feeding in a number of elements which cover off food. So to give you a few examples of that, there'll be consumer experience, where we're asking residents, do you like the food here? Also a range of quality indicators where food has an impact on. So things like unplanned weight loss, falls and pressure injuries. In addition to that, service compliance ratings includes an element of regulation. So if food's picked up in that element, that'll also feed through. And in relation to care minutes that are reported through there, that can cover off food service staff as well.
And sorry, just to add one more thing, $5 million to the Maggie Beer Foundation to undertake sector education and training.
So has that been provided to her foundation as yet?
Not as yet. It was provided in the recent budget, and so we're currently working through the grant agreement process.
And so what has the Maggie Beer Foundation explicitly been asked to do for that $5 million?
So they're doing sector education, so working with aged care chefs and cooks on how to source, prepare and serve more nutritious and interesting food for aged care residents.
Mm-hmm. Yep. So in relation to the new food standards, when are they due to be in place?
So that's currently out for public consultation as we speak.
Mm-hmm.
Obviously, we'll be looking at feedback that we receive through that consultation process, but I expect those new standards will be in place in alignment with the commencement of the new Aged Care Act.
Yep. Okay. Just wondering, like in the process of doing this, has the government engaged, or has the department engaged with Dietitians Australia?
Yes, absolutely. I can confirm that.
Okay. And so what were the outcomes of that meeting? I mean, have they been used to inform your decisions around the development of standards and the like?
Yes, so they were really clear that there needs to be the involvement of accredited practicing dietitians, particularly in menu design, and so you'll see that that's been included as a specific requirement in the standards. We're also pleased to see that they were stating that they've had that outcome in the context of recent media. They're quite positive about the food and nutrition standard.
Yep. Okay. In relation to the $10 a day, so those aged care facilities that have, not spent the $10 a day or have spent less than $6 a day in food, how many providers to date at the moment are not meeting their obligations in relation to the $10 a day or the or as low as $6 a day?
So I might just provide some clarification around that. So the $10 provided to providers was provided to uplift care and services and can be used across a range of things, including staffing. But certainly the reporting requirements put a really clear focus on food. And so when we say that there's services spending less than $10 on food, there's not necessarily a requirement as such to be spending more than that. And we do need to be careful with that because there's a range of different food delivery models in industry. And actually we've seen quite good quality food delivered for reasonably economical prices where there's a really significant economical, scale of economy, if you like. So what I would say is that we have to be careful about reviewing the expenditure as it's an input measure and it is relevant, but we need to look at it in the context of the food delivery preparation model and then the outcome measures. So again, consumer experience, quality indicators and those sorts of things.
So you're telling me that a facility could reasonably be spending less than $10 a day on food per resident and that would be okay and they would meet standards?
Sorry, Senator, just to clarify that having said what Mr Meldon has said, we have referred those services that are spending less than $10 per resident per day to the Aged Care Quality and Safety Commission to look at amongst other evidence and information received.
So if my mum or dad are in an aged care facility and that aged care facility is spending $6 a day on their food, how do I know that?
So that will be an input as part of the quarterly financial report that Ms Stratt was talking about earlier. That will be released in February next year.
So what possible reason could there be not to provide the names of facilities that are not providing at least $10 a day of food for their residents? You saying that piece of information is not available?
Is that something?
Did you ask for a senator?
Is that something you'd agreed to to publish a list of names?
No, not at all.
Okay.
But Senator,
you just
you
seem
asking
shocked
for that?
about it. That's all.
No, I'm just interested to understand because, one of the things that the Albanese government was very strong on in their budget in
fixing up
replies
your mess in aged
was to deal with food in aged care facilities. It was one of the 5 platforms.
That's
and
right.
I'm just interested
So we're
in the
repairing the
additional
mess.
$10, the $10 a day amount. And so I'm just interested to understand, as from a transparency perspective, whether I, I was a family member of somebody in an aged care facility, would I be able to get access to data to understand whether that facility was meeting its requirements of $10 a day?
Senator.
Oh, sorry.
Yeah, no, that's okay. I can answer that. One of the bits of things that we're working on at the moment, which is consumer focused, is a report that will go that will be made public that will include details from each facility of the amount spent on food. So it will be public information that consumers can look up and will include a range of information, but it will include the amount that is spent on food per day and also a comparison with other like facilities.
All right. The committee's going to suspend now for 15 minutes. We'll return to you at the end of the tea break. We'll return at 9. We're continuing with questions in aged care. Senator Ruston.
Thank you very much. Could I just ask, in relation to, just following on just a couple of the last questions around food, what action is taken against homes where the department has, or the quality safeguards, Commission or whoever assesses this, where the food spent or the food is deemed to have been inadequate.
So, Senator, while Ms Anderson's coming up, just to restate that anyone who's spending less than $10 is getting referred to the Commission for them to follow up.
So maybe I could go back to you, Ms Anderson, to ask you how many facilities have been referred to you for this purpose?
Senator, we've had 2 tranches of information provided from the department, quarters 1 and 2 in the reporting and quarters 3 and 4. And in fact, I reported to a previous estimates on what we did with quarters 1 and 2, but just to recap, we received, I'm not sure, let me just see if I can find the number. We received 883 services referred to us of reported expenditure of less than $10 per resident per day. And that was in March. And then for the quarters 3 and 4, 691 services. And so an overall improvement between the first 2 quarters and the second 2 quarters. And there was some overlap, but not a lot. We looked at the 2 tranches of services. I mean, we've taken action in the first tranche, which I can talk about, but just looking at those services in each category, of the services referred in quarters 1 and 2, 37% had improved their expenditure such that they were not included in quarter 3 and 4. So 1/3 of the services were not in the second reporting period. About 2/3, however, did remain in that tranche of services referred to us. So 2/3 of the initial set.
So what action would you take if, given that in the first instance, say the 883 were identified, obviously 37% of them have undertaken action that would reflect the improvement that you would expect, whereas the other 2/3 haven't. What action would the Commission take against those other 2/3?
The point I'd start with is the one that Mr Moulton's already made, which is that there's only a weak correlation that we have been able to discern between reported expenditure on food per resident per day and compliance with the quality standards. And that is fundamental to understand. Mm-hmm. When we looked at the data which was referred to us in quarters 1 and 2, we identified 381 services which we, on our risk profiling, understood to be services at medium risk of non-compliance with the relevant quality standards. Mm-hmm. Now, that's not just expenditure on food per resident per day. We also took into account the complaints history, past record of non-compliance, and also, as Mr Walden I think also mentioned, the quality indicator on unplanned weight loss. Yep. So we took all that together and we understood that service with that constellation of factors, and we identified 381 who we identified at medium risk of non-compliance and 42 that we identified at higher risk of non-compliance.
Okay, so can I just ask, is that 42 that you're talking about, that they would have been deemed not only to have not spent the money, but they would have been deemed by your assessment that they did not meet an appropriate or adequate standard, as well as not meeting the amount spent? I mean, obviously there must be a standard that in here somewhere that's the trigger for you to decide whether this facility is seriously not looking after the nutrition of their residents.
Senator, just to be clear, I'm talking about categories of risk of non-compliance, not evidence of non-compliance, and there is an important difference.
Okay, so what about evidence of non-compliance?
Well, we visited 48 services, including those 42 in the high risk category. And we found evidence of non-compliance in 3 of those services in relation to food-related standards. And that goes back to what I was saying earlier in terms of the weak correlation between expenditure, reported expenditure, and actual evidence of non-compliance. In fact, what we found in some of the other services was evidence of innovation and consumers who were very pleased about their food and dining experience of that service. So I think we just need to be careful that it is a crude measure which is useful but not the complete picture when it comes to assessing food, nutrition and the dining experience for aged care consumers.
Well, I am at a bit of a loss to understand what, food has been such a big issue, and it was a particularly big platform in the election.
And a big issue for years.
Yeah, rightly so. Rightly so,
Neglect.
rightly so, Senator
Yeah.
Gallagher. Rightly so.
Okay.
So I'm just trying to understand that if you've got 883 reported as not meeting the expenditure standard that's been built in there, you've got 37% of those only having improved that expenditure standard between the first two quarters to the third and the fourth quarter. You've got 381 of those facilities that you believe that the quality standards are at risk of not being met, and 42 that you think are high risk not being met. I go once again back to as a family member or the like of these facilities. At what point am I told that there is a significant risk that my parent or loved one is not getting a standard of nutrition and care that I think most Australians would expect in an aged care facility?
Where we make a finding of non-compliance which leads to a regulatory action, that is a published report, and that is information which is imparted to consumers by the provider, and we may also be involved depending on the regulatory action we take. So that information is available. We would also increasingly look to providers to disclose this information, and indeed the new legislation recently passed as amending acts places additional requirements on providers to disclose far more about the way in which they are using taxpayers and consumers' funds.
Yeah, I'm not so much concerned about them disclosing that information to you. I'm concerned about the disclosure of the information.
No, this is public reporting required of providers. Senator, may I make one more point?
Yeah, sure.
From a regulator's perspective, what we're seeing is changes in behaviour by providers, and that's a good thing. So when you look at quarter 1, quarter 2, quarter 3, quarter 4, 35% in quarter 1 were reporting expenditure below $10, 31% in quarter 2, 28% in quarter 3, and 22% in quarter 4. That is music to a regulator's heart, because what we're seeing is providers who are adjusting their behaviour, making considered choices and resetting priorities to ensure that they are increasing their expenditure because they are required to report it.
Okay, so what I'm just trying to understand is at what point in time is Australia going to actually know, are you going to report the names of those that have been deemed inadequate since the $10 supplement came into place? I mean, at what point is this encouragement because they have to report to you going to be sufficient for you to be satisfied that they're taking action? If you've had, there's still a lot of providers that are clearly not meeting their $10 a day standard.
Who may be delivering a good consumer experience on food.
So why are we bothering with this if you don't think this
Because it's one important indicator of a suite which gives us a way to understand providers and the way they're managing this responsibility.
Okay. All right. Well, I'd be keen to understand when we see you back here in February about how we are going to provide this kind of information to consumers, because clearly this is a pretty useless piece of information from an FOI, because it's just black pages.
Senator, I would be very pleased to talk about this again. We are taking it very, very seriously.
Okay, thank you very much. Just finally on food, what regulatory action would be taken against somebody if they were eventually deemed by you to have been non-compliant and not responding?
If it were on food alone, then it may not reach the threshold for a non-compliance notice. It probably would require a direction from us to revise their plan for continuous improvement in relation to food and nutrition.
And if they don't revise their plan?
They are required to. That's the direction we issue. And we monitor...
Do they get a fine or anything?
Not specifically in relation to breaching a direction, but we can certainly consider regulatory action. Non-compliance with a direction from the Commission is taken very seriously and can lead to a more intensive engagement by us with the provider and enforcement action if the level of risk requires that level of response.
Okay. So how many providers have you named so far in relation to non-compliance? You said you listed them on the website, which I'll go and have a look at in a minute. For
we've not listed them under heading of non-compliance with food and nutrition requirements. If we prepare a performance report following a certain sort of assessment of performance, then it may be listed as a non-compliance within that performance report for that service.
So if I'm the loved one of somebody in one of these services, at what point do I get that information?
That is available online to everyone.
Once they've been deemed to be non-compliant. So if they got a direction, would I know that they'd been given a direction?
Senator, there will be that. Ms Strapp talked to you about the compulsory reporting that will flow through to consumers and their families. I think also we can take you through, if you like, the way the star ratings will work. So providers who aren't doing the right thing or aren't doing well, that will influence their star rating. So it will be quite transparent for people to see that they're not delivering the quality against their peers, and that will be available to consumers, families and the general public.
So the star rating actually goes through various elements of care?
We can take you through the detail.
Look, I won't hold it as up tonight. If maybe Ms Strapp might provide that information.
Oh, yeah, the star ratings is Ms.
Oh, sorry,
But
Ms.
certainly
Latham.
one of the factors is compliance.
Yep, okay. All right, well, I just sort of really keen to understand the transparency and how that's actually going to flow through to the individual families of people. Did you want...
Are you happy for me to pass the
Yeah,
floor
of
to
course,
Senator
of course,
Rice? And
yes,
we'll come
yes,
back.
of course.
Senator Rice.
Thanks, Chair. Hello. Now, my questions are to Ms Anderson. Yes. So, look, I just wanted to start off with just some broad statistics about where we're at with complaints to the Commission. So how many complaints at the moment have you got that are currently live?
I don't think I'm going to be able to answer that, Senator. Got lots of other data for you. I'm not sure I have data on complaints on hand. Happy to take that on notice and come back to you possibly within this session, because it's a piece of information that we look at very often. I just don't think it's in my notes.
Okay, that's a pity. I mean, what's the ballpark if it's information you look at regularly?
Well, it's probably what we carry forward from 1 month to the next, I suppose. I mean, we have input, we have output, and then there's an amount that we carry forward. I'm not
at any
going
one
to,
point in time.
Yeah, no,
yes,
I'd rather not guess, Senator. I will get the information for you, I promise.
Okay, all right. And what's the average time between when a complaint's lodged and is resolved or dismissed?
Well, we reported for 2021 that the average time was around 60... Oh, sorry, I beg your pardon. That our KPI is resolving 80% of complaints within 60 days, and we reported achievement against that KPI of 67% of complaints within 60 days, which is clearly well short of our expectation. The reason for that include that we have been paying particular attention to the longer run complaints, which are typically the far more complex ones to resolve. And when we close a long complaint, which has been with us for, say, 90 days or 100 days, it moves our average quite considerably. So the way in which the KPI is measured actually quite clearly pushes down that average with every long complaint that we close. As we are getting to the end of those longer complaints, we fully expect and have projected an improvement in our KPI. So that 67% should be turning around, though, it has taken a hit, and we're doing our level best, including increasing our staffing to get on top of the rising volumes.
Okay, so there's the rising volumes, but you seem to be indicating that you are reducing the number of long complaints that you currently have.
That's correct, Senator.
Yes. And look, I mean, if you could take on notice, or is this information publicly available on your websites of the length of time of complaints, perhaps into... No?
I don't believe we published that specifically. Very comfortable with providing that to you.
Okay, thank you. And what's the longest outstanding complaint?
I don't know, again, Senator. Some of the complaints have over 15 separate issues in them, and some of those issues are immensely complex. So we may resolve 13 of the 15 and then 2 issues enable or ensure that the complaint remains open until they also are resolved. We do have some complaints which are over 130 days old.
I'm surprised that you'd have ones that are considerably longer than that as well.
We probably do. I just don't have the chart in front of me.
Okay, so if you could take that on notice.
Yes.
So in terms of the providers who have particular, clusters of complaints, you obviously take a risk management approach, and you have, do you pay more attention to those providers? How do you identify those? Walk me through your process of, when do the alarm bells go off and you realise that this provider you're going to have to be paying more attention to, and what then happens?
Each complaint is logged in our system and becomes available for every other person within the Commission in terms of the work that they're doing. So every complaint that is received in relation to a particular service is logged against that service and becomes risk intelligence for a quality assessor, for example, who may be contemplating a visit or may have some visit scheduled, maybe a site audit for reaccreditation. And that data is scooped up and becomes part of their information brief, which gives them a line on certain things they look at, questions they would ask consumers, and so on and so forth. In addition to that, we also have a scaled sequence of levels in terms of the assessed level of risk of a particular complaint. And complaints which are assessed as being very high risk in terms of a consumer having experienced harm or other consumers possibly being exposed to the same harm, that complaint will be referred immediately to my quality assessment monitoring team, and typically they will stand up a site visit within the week. They will look at the detail, but typically, if it's referred with that sense of urgency about the risk assessment, it will lead to a very rapid on-site visit, and the quality assessors will assess the particular issue or do a broader scale assessment against the standards and reach conclusions about compliance.
Okay. Is information about complaints against particular facilities, is that made public in any way?
No.
So do you think it would be appropriate information to, know for the public to know? I mean, obviously it's the flip side of the star ratings, isn't it? That's, the star ratings would tell you that, okay, you've got 5 stars or 1 star, but...
Yeah, I mean, I think this is a difficult question, and as Ms Anderson would agree, I think sometimes complaints are a sign of a very healthy aged care provider. So where residents feel that it's easy for them to make complaints, that those complaints are heard. Often complaints, as I said, are a sign of a healthy service. So there is a bit of a balance there as to you know, what number of complaints makes a service a bad service versus, you know, and number of complaints doesn't necessarily reflect the severity of complaints. But certainly this is something we'll look at in the context of the new Aged Care Act.
I absolutely accept
Yeah.
that number of complaints isn't necessarily a good representation, but, you know, the sort of factors that, you know, you identify that you've got a cluster of complaints, I would have thought that that should be information that should be shared.
A couple of further responses, if I may. First of all, we have progressively made more information available about complaints over time, and we continue to keep this under review. I understand exactly your level of interest in this, and we've looked very closely at the ways we could do it carefully and sensibly so that we avoid the risks that Ms Laffan was referring to. But we nonetheless enable the transparency that you know, is obviously valued by everyone. I also would make further reference to what has already been mentioned, which is the obligations that now apply to providers to publish this material in the general domain, to make this information known. And complaints matters is squarely within the set of issues that is currently being contemplated for public reporting by individual providers. And that, to my way of thinking, is exactly where the responsibility should be. They should be the ones to disclose, because the governance responsibility and the leadership that we are looking for from providers to take responsibility for that and then to be...
But why would they do that unless they were compelled to do that?
Well, then there will be compulsion. There will be a mandation about publication of complaints, because we can say certain things about them, but if they say certain things about themselves, then they're being accountable to their consumers.
And so that's going to be part of the reporting as part of the star ratings, is it?
Not the star ratings. No. My understanding is it's part of the suite of areas that is being considered for requiring providers to report against.
Perhaps could you take on notice, just giving me the details as to what the process in terms of it being considered. I don't want to go into the details now.
I think that would be for the department.
Yeah. Okay. You note on your website that you may not take action where the issue is part of a coronial inquiry. I mean, how does that play out in practice? Do you stop an investigation if somebody dies and there's a coronial inquiry? Do you restart it again afterwards?
Well, we are very clear that we do not investigate the circumstances of an individual's death, because we don't have jurisdiction in that regard. We are more exercised by the quality and safety of the care which surrounded that event. And obviously, if it were a serious incident, then it's reported to us and we look at it from that lens as well. So we can continue our work. It really depends on the circumstances. There have been occasions of which I'm aware where the coroner and the work of the coroner has meant that we've put our work on pause. But in other circumstances, depending on our lens, what we're looking at, the way in which we would proceed with our work, it may be that it's sufficiently divorced from the interest and the legal coverage of the coroner that we can continue. But we are very attentive to not crossing lines, and we definitely don't want to, be at risk of contempt.
A case-by-case basis.
Yeah.
I did have a question which cuts across a question that Senator Ruston asked about where someone makes a commitment to you and then is non-compliant, then breaks that commitment. I've heard direct accounts of a provider making a commitment as part of the complaints process and then refusing to honour it. So what would be the consequences?
Well, if we knew about it, and I expect we would, either because there would be a further complaint or we would find out about it in a subsequent visit or some other regulatory activity, then their failure to honour their agreement to us would be a matter for us to consider as a regulator. And it would be an argument for escalating our regulatory action. It may not be the only argument, but it would definitely increase their risk profile for us and put them in a different category where we were less trusting of them as a provider. It would not go as well for them.
But would there be actual, in terms of that regulatory action, would there be actual penalties on them? I mean, what are the consequences?
I know what you're reaching for, Senator, but it's not a case of strict liability. We, as a risk-based regulator, we must be proportionate to the level of risk of harm.
Have you imposed fines or other consequences for people who have breached undertakings to you?
No,
Has it ever
Senator.
happened?
The
never
availability of fines, the availability of fines is very circumscribed in the current Act.
So that's never happened. So you know of people that you know of providers that have breached undertakings.
And we have doubled down in relation to those providers. They don't get away with it, Senator.
I mean, what are the most significant consequences that have been meted out to providers?
No, I'm not going to deal with anecdote. I cannot summon to mind a particular case. But I can say with confidence that our trust in them to do the right thing plummets, which means they move into a high-risk category, which means that we will be more inclined to take stronger regulatory action, which might look like a non-compliance notice, a notice to agree, or a sanction.
Okay, I now want to move on to a particular case that's been raised with me, which I have got permission to share. So I've got an email from them to say that I can share it, and I think it's been foreshadowed with you. I certainly let the Secretariat know that I was going to foreshadow it with you. It's the case of Alvin Barker. So do you know the details of this person?
Senator, I know you have permission to share it, but I do not. And that leaves me in a difficult situation. I feel very uncomfortable about talking about an individual case.
I think that's fair enough. Senator Rice, could you sort of take it offline and talk about it, or raise the issues? Raise the issues rather than
I'll raise the issues this is somebody who was entered an aged care facility with
the themes.
Entered the aged care facility without a significant medical issue that developed in the 2 months that they were there, and they ended up ending up in hospital. Almost had a leg they didn't have a leg amputated because the doctor decided they wouldn't be able to survive the surgery, and they died shortly. They went into palliative care and they died shortly thereafter. So the case was raised with the Commission, a complaint was made, and I have the copy of the response.
So the complaints around access to medical care or health care within the aged care facility, which
and certainly in the summary of the case there are statements saying that they weren't treated well, and that then there were various training and remediatory actions which then the aged care facility was required to undertake to make sure that they were doing more training with wound care so that this wouldn't happen in the future. Then at the very end of it, basically, for the reasons detailed above, I consider the provider has addressed several of the identified concerns. Given the ongoing action taken by the Commission to ensure the service becomes compliant with the aged care quality standards, I've decided to end the resolution process on the basis that the relevant provider for the issue has addressed the issue to the satisfaction of the Commissioner. And I have a copy of their performance report, and it's basically they're non-compliant. Overall assessment of this service that was done, they're largely non-compliant against all of the standards. Obviously the partner of this person was devastated, and I really, if they're listening, my heart goes out to them, and because it's an awful thing to lose your partner in these circumstances. They are unhappy because they don't see that there's been any consequences other than the provider having been, told you've got to do more training and lift your game. There hasn't been an apology. There's been no acknowledgement, that of any way, of any sense of, restitution for them that this, appalling treatment occurred at this service. So,
I think obviously, my sympathies as well for the individual complainant and their family involved in this. But I think if they are after feedback or information, then it's probably not going to be resolved in an estimates committee, but I'm
But
sure.
but it's the general point that I want to raise through this example.
Is it the general point, or is it the individual? Well, you're saying that they are not happy with the resolution, in which case there does need to be something else done on that front, because I think
it goes to, similarly as I was saying, in terms of fines or regulatory action, of you can have serious things happen, but people end up dying, and yet all that happens is that the provider is has to do more training, and that the complaint is considered to be resolved.
Senator, I think we have let that consumer down, and well, the consumer's family, in our failure to communicate adequately what we've done, because we've done a lot more than that, but we've not let them know, and I think that's a problem for us that we need to look at closely, because that complainant doesn't know fully the action we took. We received the complaints, and the very next week we stood up an unannounced site visit. We found them not met, non-compliant on 8 requirements under the standards, so 4 standards, 2, 3, 7 and 8. We also received a couple of serious incident notifications from the service, which were escalated within the Commission to our investigations team, and we actually undertook an investigation which provided further information about the non-compliance. We issued the non-compliance notice at the end of August, and the service gave us an undertaking to remedy, which is still on foot. The undertaking to remedy doesn't close until November the 28th. At that time, or immediately after, and I'm saying this in an estimate hearing that we'll get back to them, but anyway, they will undergo another visit. And we will find out what they've done. We'll find out how successful the training's been. We'll find out whether they've done the training, and now they've been forewarned they better get the training done in the next 3 weeks. And if they are at all recalcitrant or slow or less than fully enthusiastic about the remedy that they have undertaken to fulfil, then there will be consequences, there will be further action. But we did not let the complainant know, and I regret that.
Has there been an apology from the provider?
I couldn't say, Senator, I'm not aware of that.
So at this stage, there hasn't even been a requirement for an apology.
We don't have powers to require an apology, Senator. I mean, we talk to providers and we say, this person is genuinely devastated by what's happened. Do you understand what went wrong, and what are you going to do to put it right? And in that conversation, we would expect them to volunteer. Well, of course, we will talk with the complainant. We will have that conversation. You gave me 2 hours' notice. I don't have that bit of information in front of me. We may know that some conversations occurred, but I don't have it with me.
Okay, and I acknowledge, Ms Anderson, that you feel that you let them down, but to me it's deeply distressing that almost 10 months, in fact, when the letter from you came to them didn't include that information, and they are still feeling bereft and absolutely let down, and they don't feel that the Quality Commission is taking the action that should be taken that resulted in the death of their partner. So I'll leave that there. Thank you.
Thank you, Senator Rice. Senator Ruston. I'll just remind committee members we were due to come to our friends in sport.
Not till 10.
Yeah, well, it's 9:49. So I'm just letting you know we're getting there.
So I haven't overrun yet.
No, I'm just foreshadowing that that's where we're aiming to head. So to the officials kind of waiting patiently, we are coming.
Okay.
Senator Ruston.
Cool. My son's submitted his thesis. Can I just quickly go back to the exemption process in relation to 24/7? What happens if an aged care provider is either not eligible or is deemed not to get the exemption? They have been through a process of genuinely trying to hire the necessary registered nurses, have not been able to do so, what happens to them then?
Thank you, Senator. So the first consequence would be that they wouldn't be paid a supplement if they were otherwise eligible for the supplement, because they wouldn't have incurred the cost and therefore don't need the additional funding. They may also be referred to the Safety and Quality Commission, and Ms Anderson would...
That doesn't sound like a very scary thing to
thing.
happen
I
to
think the answer
you,
Ms
does it?
Anderson gave before was that it would feed into their regulatory assessment of the risks of that
When will
provider.
these consequences be detailed in terms of actions for non-compliance?
I think they're available in our publicity material already. I'll just check whether that's...
I couldn't
that's
find
the
anything
case.
when I went looking for it.
I think, Senator, those consequences, as Mr Hartland said, they would be referred to the Commission for them to undertake, I think, their existing processes.
Okay. Is there anywhere in the process a sort of a best endeavours defence in relation to being able to comply?
Well, if it got to regulatory action, then the regulator would look at the totality of the provider's systems and processes and the way they meet the quality standards as a whole. So what they're doing in a whole range of other areas to assure the quality of their care would come into consideration then.
And would the same processes be in place for non-compliance with 40 minutes of care when the ANAC model comes in October? Or are they a different set of...
they are slightly different.
Are they publicly available?
We've just released, we have material out on the 40 minutes of care. There's a difference in the sense that the well, they are different. They're treated differently. So the first line about the 40 minutes of care is that it feeds into the star rating system, as indeed does the 24/7. Sorry, I missed that before. Providers, as we discussed on Tuesday, was it? Providers will report on their...
I'm just asking about non-compliance.
Yeah.
Dr.
I'm going through the ranges. Well, non-compliance starts at a whole range of levels. So the first level of compliance is around the publicity and ventilating their performance against those standards. We also will develop a function to check that their reporting is accurate, and if the consumers will be able to make complaints, and in addition, if they don't meet their care, then they may well be referred to the Quality and Safety Commission.
Is that why additional funding has been made available to the Quality and Safety Commission, is because they believe that they're likely to be more referred because of an inability to meet these requirements?
I'm not aware of the Commission's funding, I guess, in relation to these measures. Sorry, Senator.
Senator, there's a capability review being conducted at the moment on the Commission, headed by David Tune, and the intention of that capability review is to look at the resources and capability and structure of the Commission to do the job that we're asking them to do with all of these changes in aged care. So that'll be certainly part of their... they're looking at the model, the resourcing model currently for the Commission. So one of the questions for them will be what resources and capability do they need to enforce these kind of measures that we're introducing. I should also say, just coming right back to the Act, that we are actively looking at the regime of compliance and penalties as part of the new Aged Care Act, and so possibly not in the last 5 minutes, but next time we talk, we're happy to take you through what's contemplated there.
So penalties for the 40 minutes, the ANAC penalties, or penalties for the...
Penalties under the Act, generally for non-compliance.
Non-compliance, so that could include 24/7 as well as the care
Include
minutes?
everything.
Okay. And so when did you say that they'll be available?
Well, we could start the discussion. I'm presuming you don't want to talk through it tonight, but we're obviously looking at the future of...
I think, I mean, my very strongest advice has been that the concerns that are out there at the moment is that there is still a lack of detail about eligibility, exemption, discretionary, which I believe sits with you, Professor Murphy, in terms of discretion to accept or decline an exemption, the rules around how that exists, the rules around what will occur in the cases of non-compliance, whether there will be any best endeavours defence associated with it. I know the sector is concerned about the bluntness of the tool that you're proposing to put in place for exemption. I certainly know that they would prefer it to be based on a circumstance as opposed to just a location or a size. So I think there's a whole heap of things here that I think are causing great distress to the sector because they don't know the answer. So the sooner that you are able to get that information out to them, I think that would be really super.
Dr. Hartland has said in relation to those things that the information is out in the public domain.
Well,
I was
haven't
talking more
received
generally.
the answers tonight for the questions that I've been asking with the greatest amount of respect, Mr. Lai, in terms of,
Well,
you're saying that this is going to be, the penalties are going to be contained in the Aged Care Act. I mean, the Aged Care Act hasn't...
I was making a more general point that your concern about what seems to be a concern from senators about a lack of repercussions for people who don't do the right thing is one of the issues that we're looking at in terms of the new Act. Dr. Hartland and Mr. Richardson have gone through for both 24/7 nursing and care minutes that how you comply and how you don't comply. Some service providers are concerned about this, but the whole point of these measures is to address the lack of quality and the lack of safety in aged care that was identified by the Royal Commission.
Absolutely.
And so we don't make any apologies for that.
Yeah, and look, I
Let's not forget
absolutely accept that, Mr. Lai, and I also accept that we just need to be careful in the process of getting to the outcome that I think everybody wants to get to your point, that we don't end up causing unintended consequences that actually cause significant distress to people who rely on these services. So can I just ask one...
That's not the aim of the additional investments.
Can I ask
it's to
for
improve the care.
just one more question? I asked on
Absolutely
Tuesday night about whether there was any modelling done in relation to the cost of the aged care pay rise. Can I just seek clarification whether there is no modelling or that the modelling is not available?
It's not modelling, it's a costing. Is that what you're talking about?
So I just a costing, but what was the basis? I mean, you don't just do a costing with nothing. You obviously have got some information on which to do a costing. So has the department done any modelling around the likely costs of the pay rise increase?
So the department's just received the interim decision. It's not a final decision from the Fair Work Commission.
Yes, no, I understand that. I'm not asking for the modelling. I'm just asking, is there any?
So we're going through the process of looking at that interim result, and we'll look at the different stages of result, and we will cost that.
Yeah. Okay, so can I just be really clear here? You have not, up until receiving the interim decision, done any modelling to provide costings.
About modelling.
Costings.
Yeah, okay, because they are quite different things, modelling and costings.
Would it be okay if I continue to speak to the official? I can speak to you all day, every day.
Well, no, you can't.
I can.
But I've been very constrained, considering the subject matter tonight and the approach you're taking.
I'm just wondering, just to be really clear, has the department done any costings prior to the receipt of the interim decision? It appears to me you're saying you haven't, and I just want you to be clear. Have you provided advice to the Minister as to the likely cost of a pay increase prior to receiving the interim decision?
We've provided advice to government to enable them to... The government's made provision, and the Minister said this on Tuesday night, made provision in the contingency reserve for this, and we have provided material as part of that government process, cabinet process, but we have not costed what we have received from the Fair Work Commission just last week. We're in the process of doing that.
And we need further information from them, which I think
Right.
there's a directions hearing in late November. But yes, the provision that we've made was costed.
So we do have costings. Okay, fabulous. Can I just ask you, and I'll put the rest of my questions on notice, there was a decision to change how deaths in aged care were reported in July. I was just wondering if you could tell us why it was changed.
Senator, I'm not specifically aware of a change in definition on our part.
Okay, well, I'll provide the rest of these questions on notice, but the way that we were reporting aged care deaths appeared to change in July.
I think we've changed the, Senator, I think we might have changed the frequency of reporting.
It's much, you can't get the same level of detail that you were previously
Is it
getting.
in relation to COVID deaths?
Yes,
in
yes,
aged
so, oh,
care?
sorry, yes,
Yeah,
of course,
okay.
yes, sorry, Minister. Yes, COVID deaths. So if you could provide me advice as to
think it's
what
the
the
timing.
change, the timing and the like, and how that, you know, what was the basis of the decision to make the changes, who made those decisions to change it, that would be really useful, but given it's 10 o'clock.
That was the decision of National Cabinet to move to weekly reporting, if that's what you're referring to,
Okay.
Senator. Yeah, but we can provide details, of course.
Okay, thank you.
I think Ms Anderson's seeking to return some information.
Yes, Senator Rice has just left. She was asking about complaints on hand. I wonder if someone can tell her. It's 1,835. Sorry, Senator. I did promise to come back to you in the session. You asked about complaints on hand. It's 1,835.
Thank you.
Thank you.
Thank you. Can I confirm with colleagues at the table that everyone's comfortable to move on from aged care? We can release the officials.
Yep.
Great. Thank you, officials.
Yeah, you get a vote. I don't get to go.
We are moving on now to outcome 4.
I have to stay.
So if you relate to outcome 4, this is not your moment to leave. We have some questions. We might just let the room clear.
Well, as much as I would love to stay,
Oh, you're out?
keep you company, I'm going to go. I don't need to be here.
Go. All right.
You've done a great job.
Thank you. Senator
Well
Rice.
done.
Thank you. We'll see you next week. All right. If we can have officials for sport at the table, please. I will be starting the call with Senator Ruston.
Yeah, we're not sending her a text message.
Mr. P. Yeah, of course. Of course.
There's an indication we're expecting them to get a lot of that. What has
Yeah, we'll just hand everything to you at this stage.
All right, Senator Ruston, let's kick off.
Okie dokie. Has the government done any modelling on the approximate costs of Commonwealth Games of hosting the 2032?
Sorry, Senator Ruston. I missed a critical function of chair, which was to invite an opening statement. Did I? No?
Would you like to say anything?
Is anyone seeking to make an opening statement? No? Great, excellent. Go on. Sorry, Senator Ruston.
Good evening, gentlemen, and thank you so much. What a rotten short straw to draw to get the 10 o'clock stint on a Thursday night. Has the department done any modelling on the approximate cost to the Commonwealth of hosting the 2032 Commonwealth Olympic Games?
Senator, Charles Warren, Chief Operating Officer.
Still here.
Yeah, still here. I kind of look after sport as well. We've got Andrew here, who's the head of the Office for Sport as well. And Andrew can jump in at any time because he's the expert. But in terms of the costings generally, they were all part of the host questionnaire that was part of the bid going forward, and in that Queensland went and gathered all the costs associated with the games, both revenue and the expenses. Part of that recognised that in terms of the philosophy of the Games, which was to try and minimise costs, that these provide venue costs, but and the running of the Games. The Commonwealth's part of all of that is at this stage there is no commitment per se. No decision has been made. In terms of the support that that the government provided at the time, the nature of it was in terms of the set of guarantees for things such as visas, taxation, security, telecommunications, of that nature. That wasn't quantified. It was just a guarantee that it would be provided.
So the Commonwealth's taking responsibility for security, immigration, visas,
Yes,
telecommunications,
yeah.
etc.
Yeah. So, and separate to that, there was a commitment of the previous government to go 50-50 in certain other costs, dependent on 50-50 in terms of governance. It was, and it was only for certain costs. So it was in relation to venue or non-transport and transport. So that was not costed per se.
So what you're saying is it was in terms of largely infrastructure, it was an agreement that there was a 50-50 split in the cost of the infrastructure that was required, as long as there was a 50-50 sort of split in terms of responsibility and authority over how that was expended.
That's right. Now, it was recorded as a contingent liability, though, because the costs are quantifiable. And it was not provided for because it's a contingent liability. That's correct. So that's kind of where we're at. The current government is in negotiations with the Queensland government in terms of contribution and governance.
Yep, sure. So obviously the sort of the centrepiece of discussion of recent times has been around the upgrade or whatever activities are going to occur at the Gabba Stadium. So what is the department's understanding in relation to the proposal in relation to the Gabba at this stage?
That's not a matter for us in the department or for the Office for Sport.
Who is it a matter for in the Commonwealth?
The infrastructure department is responsible for infrastructure arrangements, and in this instance, the initial correspondence around negotiations generally is between the Prime Minister and the Premier. So that come out of Prime Minister and Cabinet in terms of questions.
Okay. So would that also relate to the establishment or otherwise of an infrastructure oversight body that would sit within infrastructure or the Department of Prime Minister?
They'd be all subject to negotiations.
Okay. So in terms of the Department of Sport, what is our obligation in terms of, the Department of Sport's obligations or commitments in relation to the Olympic Games?
Our role would be in terms of coordinating guarantees. The implementation of those guarantees would sit with other portfolios. Secondary elements may be in relation to legacy arrangements.
Yep. Okay.
But none of that has progressed in any significant way. The Queensland government itself doesn't have they're working through their position on legacy.
Okay. Well, on that basis, I will put the rest of my questions in relation to this on notice and send them through the Department of Infrastructure and the Department of Prime Minister and Cabinet. Because clearly you're not going to be able to tell me about the relationship between the Commonwealth and the Queensland government in relation to the honouring of the commitment of the 50-50 infrastructure funding deal, unless the minister's got something to add to it?
Well, I think your questions have been answered. The negotiations are ongoing, and
so I suppose we'll just take a step back. I mean, at the time, and there was quite a lot of media around the agreement between the previous government and the Queensland government around the 50-50 funding deal around infrastructure. But I noticed earlier in the week the Prime Minister was saying that he hadn't committed to that, and I was just sort of wondering.
Well, that was your commitment.
Yeah, no, absolutely.
Yeah.
I'm
Which
not,
you made and didn't make provision for. So
well, I'm not moving away from the fact that commitment for 10 years' time. I was just that I noticed that your Prime Minister has
it was
moved
a commitment to
away.
share 50% of the costs of the Olympic Games, made obviously without any knowledge of what that would cost. That's how that agreement must have been reached. They must have had no knowledge
There
of the
were
costs.
numbers at the time.
Was
Minister,
there? Well, they didn't feature their way into any kind of budget paper,
no,
that's
they're
for
in
sure.
2032 and the like. So anyway, I'm just interested to know whether the government, whether the Commonwealth
We
is
are
committed
in
to
close discussions with the Queensland Government on infrastructure, well, on all aspects of the Commonwealth Games, funding, infrastructure, legacy and governance arrangements.
Commonwealth Games? Or
Sorry, the Olympic Games and Paralympic Games as well.
So to that point, and it may be to you, Minister, what is the status of the negotiations in relation to any Commonwealth support to Victoria for the Commonwealth Games?
Commonwealth Games, do we have any advice on that?
Well, we do. I'll hand over to Andrew.
Andrew Godfrey, Assistant Secretary, Office of Sport. There has been preliminary correspondence from Victoria, but we don't have much detail at all in relation to the full expectations of the Commonwealth there. There was earlier on an in-principle undertaking at the time of the bid to support with the operational guarantees, the same that we did for the 2032 Olympics and Paralympics, but we don't have any data on that yet, and so with the caretaker taking hold now in Victoria, I think we'll have to wait until after that process for any sort of meaningful data to come up in relation to what the Commonwealth may or may not, be asked to support in relation to 2026.
Mr. Godkin, in your experience in terms of these sort of major international events, what kind of time frame would you think would be a normal time frame to be seeking this? Because I mean, clearly the Commonwealth Games aren't that far away. Is the time that's left to be able to, effectively deliver on these games in 2026 sufficient, or is this
Senator, it varies a lot. We have a lot of major events coming up over the next 10 years, and hosted many in the past, and the timeframes vary a lot. Typically in the Olympic, Paralympic cycles, it's tended to be about 7 years. We've had, in this particular process with Brisbane 2032, the benefit of a longer time span, but with other events, sometimes they come at very short notice, and we're dealing with some at the moment that have been relocated from troubled parts of the world where we've had very little forewarning, and I'm aware of others that are in the wings there. So it does vary a lot. In terms of 2026, it is a reasonably short time frame, but we're well practiced in hosting these events, and so I'm very confident that they'll be very successful.
And just finally on the two lots of games, are the people at the table aware of the 10+10 strategy around sporting development? I'm assuming you would be, Mr. Perkins, interested in that, and just wondered what progress has been made around gaining more general sporting leverage from these two amazing events that Australia's been able to secure, and are you satisfied that the necessary funding and provisions are being put in place right across Australia to make sure that Australian grassroots sporting organisations and kids playing sport are going to get the best benefit from these two great events?
This is one of the priorities of Minister Wells. I've heard her speak about this every time there's been a discussion about these events, is the legacy outcomes and investment into those areas. So I can guarantee that the Minister is very focused on these.
So is the department and the Sports Commission engaged in this process?
I'll start and then I'll hand over to either Andrew or Mr. Perkins. From the department's perspective, for sure, we are working on a legacy framework that seeks to put in arrangements where these events would really generate outcomes across the whole range of government priorities, and that we're very deliberate about how you might do that. And part of that is ensuring that you get the appropriate information from event organisers and to be able to make assessments as to whether legacy activities will actually generate the legacy outcomes you're seeking. So that work is ongoing at present in terms of the events that we're talking about. Obviously, with the Commonwealth Games, we've got very little information around that, and to see where the government's role, the Commonwealth government's role may be, that still has to play out. To be honest, it's the same with the 2032 Games, but we've got a lot longer runway before then.
Do you have a view on the 10+10?
More broadly, absolutely, it's vital that when we look at these big games, that we try and make the most of the events and opportunities leading up to them, and that following it, that legacy plays out in a very real way.
Okay. Yep, sure.
Russ and Senator Pocock's seeking the call. Happy for me to- Senator Pocock.
Thank you, Chair. Thank you, Senator Austin. Thanks for your time. Mr. Perkins, I'm keen to bring it back to the ACT for a few minutes, if that's all right, and get an update on the AIS Arena and what work is being done, if there's a plan, what all the upgrades will entail, and if there's a timeline yet for that.
Thank you, Kieran Perkins, CEO of the Australian Sports Commission. Thank you, Senator. So in this last budget round, funding was confirmed for the upgrade of the arena. It's a total contribution across all measures of $15.1 million. That will predominantly centre around improved fire safety, replacement and upgrade of all electrical and lighting systems, HVAC upgrades and seating. At this point in time, tenders are being prepared to go out for procurement, and we expect at this point, considering that we're already aware that there's roughly a 40-week manufacturing lead time on lighting systems for a venue like this, that we wouldn't expect to be able to complete those works before the end of next calendar year, but we're certainly pushing very hard now that we're underway to have that work done as soon as we can.
Okay, thank you. And on the wider AIS plans going forward, from what I've read, I understand your preference is not to sell unused land around the precinct. That's correct? Yeah.
Certainly that question comes with a whole bunch of interesting complexities around the site itself, but while I know that there has been conversation in the recent history about the potential value that could procure, the reality is that while completed development of improved land could provide some funding of significant value, the actual land itself would not provide any sustainable outcomes or benefits. We also have a strong view that one thing that you can't build more of is land, and while at the moment our facility is using roughly half of the scoped environment that is part of the Australian Sports Commission AIS campus. We have quite a significant amount of work to do to modernise the site, to bring it up to current standards, to extend the industry capability and support that we would like to be able to provide, as well as currently working on how we would significantly improve the sustainability of the site. As it stands at the moment, we are a very significant power and gas user, which we would like to be able to wean ourselves off, and the utilisation of the land to do that is something that we would expect would require the vast majority of the developable space that we currently have to be able to implement those plans fully.
On the solar, do you have an idea of where that you'd want to put that on the site?
Senator, you're testing my geographic knowledge of the ACT at this point in time. Over the, I'm going to say the backside of the site towards Gungahlin Drive, where the land starts to slope dramatically, it does have a favourable sky directional view aspect. Thank you, Senator. That would be, at the moment, the type of proposed land that we would use for solar and battery farms. But we don't have a definitive plan on that at this stage. We do have some work being done to fully understand what our requirements would be and the best placement of those.
Would that potentially be a trade-off with future development if you committed that land to solar, or would it be sort of just using unusable land?
Our preferred preference is to go for the unusable space. As you would appreciate, when you start to look at wanting to expand sporting facilities, one of the largest users of land meterage is playing fields. At the moment, we have one FIFA five-star soccer pitch, as well as two other lower grade grass pitches, including availability for AFL and archery, and two synthetic pitches. We already know that that's not going to provide us all of the requirements that we need, and the cost of doing any major significant earthworks or impeding on or pushing towards the freeway would just not be viable or reasonable for us. So we would utilise the flattest, most easily developable land for that activity. And on the other side of the site towards Braybrook Street, where at the moment there is significant undeveloped car parking space, that's where physical development of a plan, and these are proposals at this point in time, you would appreciate, around things like an innovation hub would encroach on those spaces.
Is there an ideal or realistic timeline for a precinct redevelopment?
Yesterday. The reality is that, as I'm sure many would appreciate, that while 10 years for an Olympic and Paralympic Games hosting seems like a long way away, the reality is that the 8 to 12-year-old abled and para-athletes who are aspiring to represent their country are today in need of support to be able to deliver and be ready to compete and do Australia proud in 2032.
I don't want to put you on the spot here, but I've heard you say that a number of sports have contacted the AIS wanting to relocate. Are you able to share them, or would that?
Senator, at this point in time, they're exploratory conversations about mostly development pathways. I think that a lot of sports have, in their assessments of historical success, have been trying to unravel some of the previous sustainability of development of future talent that they've had, and that's been one of the things that has come up consistently for a couple of sports. The reality, though, is that our site and the work that we're doing is very much focused towards providing that continued support for national camp-based programs. We are the most accessible sporting site in the country, with facilities that enable all of the high performance sports that we fund to be able to not only reside and eat, but go through all of the training, recovery, sports science and medicine, technology, engineering and other requirements that they need, which is a significant part of the uniqueness of our site. This year, we are going to have in the vicinity of 175 camps, and these are all for high performance athletes. We don't do anything other than high performance at the moment in what are our lingering COVID protocols. With about this year, we should see just under 4,400 high performance athletes attend the site at different times for training and development programs. So from a utilisation perspective, we are already struggling from a capacity point of view, and any conversations that we would have about wanting to work with sports on a more permanent basis would need to come also with assessment of facility and funding requirements, which we have not explored at all.
Okay. And just finally, Bruce Stadium, Canberra Stadium, do you have a preference of developing it or selling it to the AC government? Where are discussions up to on that?
Senator, that's a matter for the ACT government and the federal government to have conversations around. Ultimately, the ownership and the long-term tenure of the facility and any funding that would be required to potentially upgrade or develop that space would need to be obviously negotiated and funded through those two parties. But we are involved in ensuring that there is good collaborative and strategic assessment of all of the facilities on the site and what their future value would be.
Thank you. Thanks for that. Can I just have one question for Sport Integrity Australia? Firstly, thanks for what you do. I was drug tested far too many times over the years, and I appreciate your... appreciate the professionalism and the work you do. I was just keen to get a quick update on the Australian Sports Wagering Scheme and where things are up to with that.
Yeah, thanks for your comments, Senator, and I'm glad we were effective in our testing, because I never saw you on the other side of the market. But the Australian Sports Wagering Scheme, we have progressed that to the point of identifying an operating model where the majority of the partners and through our extensive engagement have provided input into that. That is now subject to government policy decision when I take that back to government.
Okay. So there'll be a financial ask to make that happen?
There will be, yes, Senator. The matter was deferred until the next budget, so it's something that we're having a discussion with the Minister about in due course, okay. Around the next steps for the sports wagering scheme.
Okay. Is match fixing an issue? Like, are you coming across a lot of instances or allegations of it?
Senator, look, it's certainly a grave concern to me, particularly noting a lot of the gambling issues that are being identified with athletes. And when there's gambling, when there's debts, you're vulnerable. When there's organised crime infiltration in sport and associations, which are quite deep in, as you would be well aware of, in professional sports in particular, it certainly creates an environment where it's vulnerable to match fixing. There is intelligence to suggest that with our partnership, the Australian Criminal Intelligence Commission seconded into Sport Integrity Australia, and through a partnership with them, state law enforcement, federal law enforcement, and with the, in fact, the wagering service providers, we have a lot of data to be able to identify trends and risks. It's certainly the greater the gambling issues in sport, the greater my concern.
Thank you. And are you satisfied that the current laws allow you enough access to gambling companies' data, or that is that something that needs to be looked at?
The regulated gambling market in Australia, whilst it's it is, I would say, disjointed at the moment. Part of the sports wagering scheme is to bring that together and look at how the sports wagering providers and the professional sports utilise the income towards developing education and integrity programs. Certainly it will be enhanced by a sports wagering scheme and bringing those partners together, but there is significant relationships across law enforcement and wagering service providers where they willingly provide data for intelligence purposes. The real concern is the unregulated market. It's if you look at the unregulated betting market across the globe, in 2021 was estimated to be around 1.7 trillion euro.
Do you have a figure for Australia?
I don't have a specific figure
Estimate?
for Australia, but it's quite significant. And of course, the unregulated betting market means the Southeast Asia betting markets, which are of concern because it's in our backyard, and the more sports are streamed, the more there's a market, and particularly as we target the professional sports and we target hard in the professional sports with all the partnerships, the displacement effect moves down the chain to other sports that don't have capability. And that's certainly why we've embedded integrity officers with sports to build frameworks around match fixing, education programs and the like.
And just finally, have you had an indication from the new government whether you will receive funding in the next budget?
I've certainly had some discussions around my concerns around integrity threats, and already in my initial approach, I think you may have seen recently the Minister's announcement of a safety and sport division and enhancing our capability. Certainly it's been a very positive and very clear message to me that government supports a stronger approach to integrity and all the data that I'm putting forward. So I think we will see certainly sports wagering become part of the integrity framework.
I saw the Finance Minister nod, so I think you're set.
Well, I'm getting it from every committee. Like, I've picked up a lot this week of people
Thanks
going,
very
this will be
much.
coming forward to the next budget. I just sort of,
Be busy.
I slump, you know.
Thank you, Chair.
Thank you, Senator Pocock. Senator Ruston.
Hi, okay, on the homeward stretch. Just wondering, did the department provide a brief to the Minister in relation to Netball Australia's financial position in recent times?
Trying to recall whether there was a specific brief. I might have to just check back on records there, but there were certainly some interactions in relation to certainly with the office and with some of our partner agencies. That's yes.
Sure. Has the Victorian government reached out in any way seeking assistance with support for this funding commitment from them?
Not to the department, Senator.
Not to your knowledge. So they, clearly, if you might take it on notice whether there was any call, Senator Gallagher, to the Sports Minister in relation to that, and I assume there was no call to the ASC.
No,
Okay,
Senator,
thanks.
I'm not aware that there's been any contact.
Sure. Is the federal government aware of whether the Victorian government has made any requirement on the Diamonds to around their attendance in Victoria at particular national sporting events as a result of this sponsorship? So, for instance, that there will be more games played in Victoria than they would otherwise have been because of the sponsorship, and Victoria's claim on them because of this $15 million.
I think that's probably a matter to be more appropriately raised with the Victorian government. Like it's,
Well, I was
it's an
actually just-
agreement between the Victorian government and the
No, I
Diamonds.
just asked if they were aware.
So there's been no interaction with us on that, Senator. I certainly did see some media reporting at the time that there may be certain requirements, that came with that sponsorship, but we were not involved in any way in any of that.
Do you think the department or the commission should be seeking to find out details of this, given that it is our national team, just to make sure that the integrity of that national team is not compromised in any way because it's got a state-based sponsorship?
Can I just say, under the previous, would you have had the same concerns about the Hancock prospecting as well? When you have a sponsorship arrangement, it's between two parties, there usually comes with a bit of you know, for this money, we would like you to do this, or is it just the Victorian government you're worried about in terms?
No,
there's
just governments. I think it's
well,
just
there's a whole
the
range
unusual.
of sponsorship arrangements in sport.
No, I'm just asking a question. I mean, I'm not saying that I'm concerned about it. I'm just asking if the department's aware of it and if they would be concerned if that was the case.
Well, you were talking about I think the national interest. You
Well,
know,
I was
like,
talking-
are we concerned about the national interest?
Well, I think it's a
around-
pretty straightforward question. I don't know why you're quite so defensive.
I'm not defensive. I'm just wondering why you have an obsession with the Victorian government.
I don't
which
actually
has
have
come
an
up a
obsession with
lot
the
in the last-
Victorian
Yes, seem to. It's come up a lot in the last few days.
Well, hopefully we'll lose all obsession with the Victorian government very shortly. Can I just ask quickly in relation to the national curriculum and sport, and just wondering what the department's role is in encouraging a strong inclusion of physical activity in the national curriculum, and whether you've got any concerns about the level of sport that's being offered up as part of the national curriculum.
Well, I think the key initiative there relates to the Sporting Schools Initiative if we're talking about the school sector, which is administered by the Sports Commission. But beyond that, I don't think there's any particular comment we could make.
No, thanks, Andrew. No, Senator, at this point in time, from a funded program perspective, Sporting Schools is our main engagement, and that program certainly has been very ongoing and quite successful in the overall delivery that it's provided. Since 2015, there's been more than 13 million Australian children who've participated in that program, with about 10,000 participating every day. There's more than 9,000 schools across the country that are currently registered with the Sporting Schools program, and we expect that 550,000 students per term actually are involved. Very pleasingly, that 52% of the funded schools for the Sporting Schools program are actually in regional areas. So the breadth of the program's delivery is quite significant and successful. Noting though that is a program that's offered in after-school hour times and not in curricula.
So has the Department of Education sought advice from any of you in relation to the level of physical activity and sporting activity that would be an appropriate level within the national curriculum?
I'm not aware of anything in terms of the Office for Sport. I'm wondering in the context of the preventive health more broadly.
I'm not aware that there's... We can take that on notice.
Yeah, and I might put it on notice to the Department of Education as well, because one of the things that we have often heard travelling around is that there is a diminishing level of physical activity built into the national curriculum, particularly in high schools, which obviously I would imagine would be of great concern to you, Professor, in that we know that young people continuing to have physical activity as part of their daily lives is a very important preventative health measure.
Absolutely.
And so if you're not involved in the national curriculum as it relates to physical education, then perhaps you should be.
We'll take it on notice if we've had any interaction with
Yeah, great. Thank you. Chair.
Thank you, Senator Ruston. Does anyone else have questions for our friends at Sport?
Yeah, it's a piece of... I've got a half an hour's word.
Thank you very much for your attendance at our hearing today. We very much appreciate you being here late into the evening. This does conclude today's hearing. On behalf of the committee, I thank the ministers as well as officers from the Department of Health and Aged Care and agencies who have given evidence to the committee today. I'd also like to thank the Secretariat and staff and our friends at Broadcasting too for their assistance. I remind senators that the committee has agreed that any written questions on notice should be lodged with the Secretariat by Friday the 18th of November 2022. The committee stands adjourned.
Thank you.
Thank you, Chair.